10th Diacon, which we have started from 2012, is a national meeting for diabetes. We started with 2 days and then we changed it to for 3 days. Last 2 years we could not do it. It was on virtual platform. This year it is virtual plus hybrid. So yesterday it was full day from 10 o'clock and 10:30 when we have inaugurated. From 12 to 9 it was on a virtual platform. And today we have with us those who are here in person, the speaker as well as delegates, and it will be live telecast on our DocTube as well as on our DiaCare page on our Facebook Live and YouTube too. And plus all those registered delegates, they can listen from their home at their convenience time. This DiaCare Con we started in 2012. After the 2011, I have done the Epicon. But before that also for 5 years, I was doing a Diacon meeting. Primarily, it was a one-day meeting I used to do at Ahmedabad Medical Association Hall for Ahmedabad general practitioner in morning time, and in afternoon time it used to be a patient education program. That is how the journey of DiaCare Con started. I am really thankful for all those who have supported me in these years. One big thank for Dr. Shashank Joshi, who was always with me for this DiaCare Con. He was my chief advisor, mentor, as a program director, and every time he was there with me. And there are many persons who are always supporting me for DiaCare Con or Diacon. One was Hardik. He was associated with me, and now he is running a RX event and independent company, and he was with me since years. I would like to also mention the name of you like Dr. Urman Dhuru. Very few persons nationally know that how hard-working he is, and he was always there with me. Dr. Urman from RSSDI, whether Epicon or whether it is Diacon, whatever activity which I have done, he was always there with me and in execution as a real hardcore worker associated with me. Blessings from Dr. Atul Parikh, Dr. Mahadev Desai, senior persons. Today I have with us Dr. Kamlakar Tripathi, blessings from him, sir. And Professor A.K. Das, who is a program director for our program. I am really highly grateful to Dr. A.K. Das, who was always with me since last 10 years, and he could spare his very valuable time with us for 2 days. With this, Dr. Shrenik Shah, we lost him. He was a very close friend of mine. He was organizing chairman for 2011. And in 2011, he was organizing chairman, and unluckily, after 5 years, we lost him. It was sudden cardiac death. Dr. Shrenik Shah was a senior cardiologist, and on his name, in Diacon, we do regularly a Dr. Shrenik Shah memorial lecture. He was cardiologist, so I try to invite the cardiologist or somebody who is practicing as a cardiometabolic physician. We always invite to give Dr. Shrenik Shah memorial lecture. And this year we have with us Dr. P.C. Manoria, a very eminent cardiologist, and we will have formal introduction with them. Before Sanjeev had not come. I will request Dr. Dheeraj Verma to come on the stage to chair this session. Along with them, I will request Dr. Urman Dhuru, my close friend, and Sanjeev will join. Dr. Sanjeev had also come. Dr. Sanjeev Phatak, please join the stage. Dr. Sanjeev and Dr. Dheeraj Verma, who are chairing this Dr. Shrenik Shah Memorial Lecture. I will also request Dr. Urman Dhuru to join them and to introduce first about Dr. Shrenik Shah. So I will request Dr. Urman Bhai and Dr. Sanjeev Shah to remember Dr. Shrenik Shah and to talk few things about Dr. Shrenik Shah, and then I will request them to talk about Dr. P.C. Manoria or his CV. Over to Dr. Urman Bhai.
Good morning, everybody, and most welcome to DiaCare Con 2022. Just I finished my MD. Fourth year started, and I went to ICU as a senior registrar for the first time. Very, very serious, very, very sincere, and started taking around. And suddenly somebody just patted me on the back. Pass thai gayo ne? Then I moved back and saw the head of the department, Dr. Shrenik Shah. We have all heard Devanand. मैं फिक्र को धुएं में उड़ाता चला गया. Shrenik Bhai was one such personality. Down to earth, one of the most skilled cardiologist as far as interventional cardiology is concerned, and still never proud of what he was. Anyone, even the junior most resident, and he would be talking just like a junior most resident, and absolutely modest, always smiling. And yet, during my 2 month stay with him, he encouraged me to go for research work, and within those 2 months, we had couple of papers just within 2 months. It was very difficult for the rest of the people to understand that he was not only a jovial man, he was a research-oriented man, and he was very serious during examination or the discussion of the patient. He later on, despite being the fact that he was one of the topmost person in the most renowned hospital of Ahmedabad, that is VS Hospital, he was the senior most cardiologist at that time when I was in the 4th year. You will never realize when he is talking to the patient or when he is talking to the colleagues that he is so brilliant, skilled person, so much research-oriented and so much sincere. Probably he was a person having a very nice gathering, nice group, and you will hardly find a single person who would say anything abnormal about Dr. Srenik Pai. So we always used to call him Ajat Shatru. So once again I would thank Dr. Bansi because he remembers Srenik Pai every year, not only during DiaCareCon, but he had also a couple of programs arranged for him, especially one that I can remember was time management, which was also a strength of Dr. Srenik Pai. So just remembering Srenik Pai, who is still with us, and we always remember him. Thank you very much.
Now I request Dr. P.C. Manoria sir to come here, and I will also request Professor A.K. Das and Dr. Shashank Joshi, Program Director, to be here to felicitate Dr. P.C. Manoria sir. And I will request Dr. Sanjeev Phatak and Dr. Dheeraj Verma to read the citation for Dr. P.C. Manoria.
So it's indeed an honor to have with us Dr. P.C. Manoria, and the DiaCare is privileged to award Dr. Srenik Shah Memorial Lecture for the year 2022 to Dr. Professor P.C. Manoria. Dr. P.C. Manoria is a director, Manoria Heart and Critical Care Hospital, Bhopal. He is former professor and head of the Department of Cardiology, GMC Bhopal.
He is an honorary physician to His Highness Governor of MP. He is the past president of CSI, API, ICC, and past dean of ICP, ICMU, etc. He is a past chairman of Hypertension Council of Asia Pacific Society of Cardiology and past vice president of SARC Cardiac Society.
He was awarded Lifetime Achievement Award during the WCC PC 2008 by Bharat Ratna Honorable Shri APJ Abdul Kalam. CIO at New Orleans, USA, Mega Specialty Award during Multicon 2018 organized by International Board of Medicine and Surgery, USA 2018.
Sir is Master Teacher Award recipient of in Indian College of Physicians in 2019. Netaji Subhash Oration Award in Epicon 2002. He was also recipient of the Award of Excellence in Academics Alumni PGI Chandigarh in 1997, Dhanvantri Award, CIMI Con in 1997, etc.
He is organizing several national and international conferences for last 40 years, and he has organized World Congress Cardiometabolic Medicine in 2019 and then again in 2022 in Mumbai.
Sir has edited almost 33 books and has published 74 publications under his belt in various international and national journals. He has delivered more than 800 lectures in various national and international conferences also.
So it is our profound honor to present you with the Dr. Shrenik Shah Memorial Oration for the year 2022. Thank you, sir.
At the outset, I would like to thank Dr. Bansi Sabu and his team for inviting me to deliver this prestigious Dr. Shrenik Shah Memorial Lecture. Dr. Shrenik Shah was also my great friend. I first met with late Dr. Siddharth Bhai Shah, and I also participated in the Hypertension Society of India meeting, which was organized by him at Ahmedabad. I have been interested, can I have the first slide, please? I have been interested in cardiodiabetology and cardiometabolic medicine for the last 25 years or so. We published the first book on cardiodiabetology in API Kathmandu in 1996. And following this, we have published 5 more books. But Dr. Bansi Sabu always likes to have deliberation on newer and newer topics. So today, I'm not going to talk on cardiodiabetology or cardiometabolic medicine. The topic which I have selected today is a new one. I'm sure none of you would have heard on this. That is liver emerging as a big playground for cardiometabolic therapeutics. All of us know cardiometabolic diseases are rocking the entire world and are important contributors to cardiovascular morbidity and mortality. The peculiar feature of cardiometabolic diseases is they often conglomerate in the same patient. So it's not uncommon to have obesity, diabetes, MFLD, OST, and other diseases in the same patient. The most important thing is that the commonest cause of mortality in cardiometabolic diseases is ACVD, particularly acute myocardial infarction. And it is the desire of all of us, not even patients, that our heart should beat without blockages. And time and again, every day we see scores of patients asking us, do I have blockages in our coronary artery? What could be the simplest approach to achieve this goal? I'll be talking to you in a couple of minutes. Lipid management plays a very important role in reduction of cardiovascular event, but curiously enough, all drugs, rather most of the drugs, which decrease cardiovascular events, their site of action is not in the heart, their site of action is not in the arteries, their site of action is in the liver, and liver is emerging as a big playground for cardiometabolic therapeutics, which I will be alluding to. Most of the lipid modulating drugs, their site of action is in the liver. Liver is an important site for fat accumulation, and you cannot manage diabetes optimally without focusing on the liver. And some anti-diabetic medications also execute their glycemic action through the liver, and they have other benefits on the liver. So when we look at the lipid modulating drugs, what do we see? Statins, which are the foundational drugs for lipid management. Their site of action is in liver and not in the cardiovascular system. They inhibit the synthesis of cholesterol in the liver. Fibrates, which decrease triglycerides, they inhibit the synthesis of triglycerides in the liver. Bempedoic acid, which is a new blockbuster for additional lowering of LDL cholesterol in patients with ASCVD or HeFH. It also acts in the liver and inhibits the synthesis of cholesterol ahead of statins. PCSK9 monoclonal antibodies, which are the magic bullet for decreasing LDL cholesterol, the site of action is in the liver. Inclisiran, which melts cholesterol from the vessel wall, the site of action is in the liver. It inhibits synthesis of cholesterol, PCSK9 in the liver. Lomipatide, a drug for familial hypercholesteremia, also acts in the liver. It's an MTTP inhibitor and blocks the transfer of triglycerides to ApoB. Mepomarsin, which again is an antisense to ApoB, acts on the liver. Pelacarsen, which is likely to emerge out as a transformational therapy for LPA therapeutics induced cardiovascular disease, it also acts on the liver. It's an antisense to ApoA, decreases the synthesis of ApoA and therefore LPA. Evinacumab, which is a boon for homozygous familial hypercholesteremia, also acts on the liver, is an NGPLT inhibitor. And the beauty of this molecule is its action is independent of the density of functioning LDL receptors. PCSK9 monoclonal antibodies do not produce appropriate response in HoFH, but this is independent and therefore is a boon for homozygous hybrid. Gene editing, which is now coming in a real existence, is becoming a real reality. The site of action, the modulation is in the liver, and liver transplantation has been done in past. And now in the USA and other countries, fatty liver or NFLD is the commonest cause for liver transplantation. So you cannot ignore when we talk of cardiometabolic therapeutics in liver. Cardiodiabetology now is a well-developed specialty, but it seems that in times to come, we will be forced to create this new subspecialty of diabetes, that is cardiohepatology, because everything is mediated via the liver. So why we are so much concerned about lipids? The first reason is cholesterol never sleeps. It works 24/7 and executes its ravages on the cardiovascular system in terms of formation of plaque. And all of us know plaques are the major culprits for CVD. They put at risk of heart attack and stroke. Heart attack is the number one cause of death, and stroke is the number one cause of disability. The second reason why we are so much bothered about lipid management is that during the last quarter of century, lipids management has reached great strides. And what are these? When we look at the issue, can we stabilize the plaque by lowering LDL? The answer is a big yes, and we have data from several statin trials. When we look at the issue, can we reduce the plaque buildup by lowering LDL? Answer is again universally yes. That is, we can arrest the progression of atherosclerosis, and reversal trial is a beautiful example. High intensity atorvastatin showed that the progress of atherosclerosis can be arrested. And the third issue, can we shrink the plaque by LDL lowering, which means can we achieve regression of atherosclerosis? Answer again is a big yes. And the Glugov trial is a staring example. When you lower LDL cholesterol to 65, it results in arrest of progression of atherosclerosis. When you lower it to 50, it results in regression of atherosclerosis. And can we make the plaque disappear by lowering LDL? This is obviously an unresolved issue at the present state of time. Maybe this may be fulfilled in the future. So as a consequence of all this research in lipid management during the last quarter of century, a very dicta has emerged that if you want to live without CVD for 100 years, keep your LDL less than 70 throughout your life, which means after 20s or 30s. And many luminaries in the cardiology who are in 90s are having their LDL 35, 40, 36, and so on. So one of the simplest way to achieve longevity of life, free of obesity, it has to persistently keep your low. And one of my great globally renowned hepatologist, when I was talking about this, said if you maintain your SGPT, SGUT within normal, you can also live for 100 years, because if the liver remains healthy, the cardiovascular system is healthy. There's a close cross-connect between liver and the cardiovascular system. So messages are very clear, only it is to be followed if you want to get rid of these deadly diseases. Statins, all of us know, it inhibits synthesis of cholesterol in the liver by blocking the HMG coenzyme A reductase. It is the foundational therapy for lipid management. All of us are aware of it. But just to recapitulate, it improves endothelial function, delipidates the plaque. You can see on a vascular MRI or near-infrared spectroscopy data from the yellow trial. It also has an anti-inflammatory action, can pacify these hot plaques which are seen on a PET CT, promotes calcification of the plaque, lot of pleiotropic effects. But what is not widely publicized is it also decreases thrombogenicity of the blood. 1 out of 10 plaque rupture culminate into an acute coronary event. So it is the thrombogenicity of blood at the time of plaque rupture which is important. If you are on statin at the time of plaque rupture, the probability of a plaque rupture culminating into an acute coronary event can be minimized. And they have a legacy effect beautifully shown by the Boskep's and the other trials. Bempedoic acid is a new blockbuster for additional lowering of LDL in patients with ASCVD who has not achieved their goals, or for HeFH. And these are the 4 clear trials. Whenever you have a clear, be assured that this is a bempedoic acid trial. And again, the site of action is in the liver. It's a prodrug. It gets activated by ACVL1, as you can see. And this enzyme is not present in the skeletal muscle, and this is the reason why there is no muscle toxicity. It inhibits the enzyme ACL ahead of the statins, as you can see on your left. ACL means adenosine triphosphate citrate lysase, and inhibits the synthesis of cholesterol. These are the 4 landmark trials, and all of you are aware of it. And each trial has substantial number of diabetic patients, so this also applies to the diabetic population. LDL reduction with bempedoic acid, very easy to remember. If you are using on top of statins, because statins also act through the same pathway, it is 15% reduction plus minus 2. So you'll see all the trials. If you are using in statin intolerant patients, that is without statin, it will be 25 plus minus 2. And if you are using in absence of statin bempedoic acid, it will be 35. So it's very simple, 15, 25, and 35. And most of the trials, as you can see, show this dicta. The additional advantage of bempedoic acid is also decreases high sensitivity CRP, and therefore has an anti-inflammatory action which is beneficial. And unlike statins, this is not diabetogenic. Rather, it decreases blood glucose and also has a tendency to decrease weight. The only side effect being increase in the uric acid, which can be easily taken care of by drugs. Why we say bempedoic acid may be a game changer for lipid management? Because only 50% of patients with statin achieve their LDL goals. And if you use a triple combination, bempedoic acid, 180, ezetimibe 10, and atorva even 20, a publication from Australia has very clearly shown that the triple combo can reduce LDL by 63%. And if you are following the ACC guidelines for very high risk, 90% of LDL goal, 95% of patients achieve LDL goal less than 70, and if you are following the European, 58% achieve LDL goal less than 55. So triple combo is a great combo. In statin intolerant patients, never forget that some statin should be on board because statin has a lot of pleiotropic effects, and pitavastatin, never forget, in statin is the easiest statin, usually doesn't have a statin intolerant problem. So this triple combo again is a great combo for a statin intolerant patient. PCSK9 monoclonal antibodies, we know they are the magic bullets for lowering LDL. They also act on the liver. The normal function of PCSK9 is to get bind to these LDL yellow curly receptors, so that if they get bind to these receptors, the receptor is taken inside their cells and this undergoes lysosomal degradation and cannot be recycled. But if you neutralize it with a PCSK9 monoclonal antibody, as you can see, the receptors are free to bind to the LDL particle. The particle is taken inside the liver and is cleared off, and the receptor undergoes recycling, and there's increase in the number of LDL receptors. The reduction in LDL is phenomenal, 40 to 60% on top of anything, and they also decrease LPA. And this is translated to reduction in cardiovascular event. 4-year trial showing 15% reduction in the ischemic endpoint. Odyssey, post-ACS patient, again 15% reduction in the ischemic endpoints. And we have a panoply of PCSK9 trials in ACS, and we routinely use PCSK9 volocumab to affordable patients, and this results in marked diminution in cardiovascular events. The dicta is, if after an angioplasty you get recurrence of a cardiovascular event, the most common cause is your LDL has not been targeted to the appropriate level. Inclisiran, again, is a beautiful drug. It again acts on the liver, inhibits synthesis of PCSK9 in the liver, and melts cholesterol from the vessel wall. Is approved in the United Kingdom and several countries, likely to be available in the near future. But the problem is its cost. And a single injection, 300 milligram, lowers LDL by 50%, and this remains there for the next 6 months. So one injection, 300 milligram in 6 months is the way to go, and that's why we say the beauty of inclisiran is unmatched. 2 injections per year, but the cost is phenomenal. Again, lometride, which is for FH, also acts on the liver. It inhibits MTP and prevents the transfer of triglycerides to ApoB. So less VLDL means less LDL. Mepomersin, which is also a drug for FH, also acts in the liver, is an antisense to ApoB and decreases LDL. And this is again evanacumab, a boon for homozygous FH, also acts on the liver, and it acts even when the LDL receptors are not functioning, where PCSK9 does not act. All of us are aware of the reduced trials with icosapentaethyl carried out in patients with CVD or diabetes with risk factors, with hypertriglyceridemia 135 to 499. Great reduction in the ischemic endpoint, 25% in the primary endpoint, 26% in the secondary. But the problem is the benefit was seen even in triglyceride less than 150, clearly showing that lowering of triglyceride was not the mechanism of benefit in the reduced trial. There are several other mechanisms. Gene editing is emerging in a big way, and it seems that it is going to become a real reality in times to come. The first patient in New Zealand has already undergone a successful gene editing, a case of FH, and the Heart-1 trial with VERVE-101 is already in progress, and the plan is to treat 40 patients with FH. Gene editing is a big stick, because it's one and done, and you don't ever have to come back for treatment. So great therapy, but we'll see how it goes in future. So when we look at the evolution of lipid-lowering therapies at the present state of time, we have statins, which are the foundational drugs used in all patients as first-line therapy, and we have various combinations, ezetimibe, icosapentethal, bempedoic acid, fibrates. We have monthly or bi-monthly therapies, evolocumab, which is available in India, evenocumab. We have weekly or monthly pelacarsen, which is emerging as foundational or transformational therapy for LPA therapeutics, inclisiran biannually, PCSK9 vaccine is also being tried once in a year, and if this becomes successful, a booster dose every year will be the new way to target atherosclerosis, and gene editing is going to come in a big way, but let's see what really happens in the future. Now, anti-diabetic medications also mediate their action via the liver, metformin, pioglitazone, SGLT2, GLP-1. All of us are aware of it, that the metformin targets insulin resistance at the level of liver by decreased glucose output, also acts on the skeletal muscles. And SGLT2 inhibitors, which are the molecule of the decade, they also decrease insulin resistance, decrease inflammation, decrease FFA flux, and produce lots of benefit on the liver. And pioglitazone, which is again a time-testing molecule, a beautiful insulin sensitizers, also decreases liquid accumulation, decreases insulin sensitivity, and many other beneficial effects. It targets insulin resistance at the level of the adipocytes, also skeletal muscle. And GLP-1, again, receptor agonists, they also decrease glucose production. And as you can see, GLP-1 RA targets 6 of the 8 components of the ominous octet, and are wonderful drugs, only cost is prohibitive. So in summary, liver is emerging as a big playground for cardiometabolic therapeutics, and I'm sure cardiohepatology is going to emerge in a big way as a new specialty of diabetes in times to come, because you cannot manage or target diabetes without the help of the liver. Both are closely linked to each other. Most of the lipid modulating drugs for decreasing CV have their action on liver and not in the heart or the artery. You can arrest progression of atherosclerosis by lowering LDL to 65 and achieve regression of atherosclerosis by lowering LDL to 50. And if you keep your LDL levels below 70 for most of the life after 2030, you can live up to 100 years free of atherosclerotic cardiovascular disease. There is a great cross-connect between diabetes and liver. FFLD increases diabetes, diabetes increases FFLD. Diabetes cannot be managed without focusing on the liver. In fact, some of the globally renowned hepatologists say that it is MFLD which occurs first, that produces diabetes rather than diabetes producing MFLD. And many anti-diabetic medications, metformin, pioglitazone, SGLT2 inhibitor, GLP, also acts on the liver. So thank you very much for the kind attention. And I'll again like to thank Dr. Bansi Sabu, who's a very versatile personality, and I'm a great fan of his and his team. Thank you very much for your kind attention.
Thank you, sir. Thank you, sir, for the wonderful talk. As sir gave the crux of the message that if you want to live for 100 years without cardiovascular disease, you have to keep your LDL less than 70 with the liver enzymes within normal limits. I request this hall to give the standing ovation to the sir, PC Manoria sir, for his wonderful lecture. Thank you very much, sir. Thank you very much, sir.
It's my great pleasure to have with us Dr. B.M. Makkar, who will be our next orator for Diacare Gold Medal Oration. And to chair this session, I request our senior colleague from Ahmedabad, Dr. Mahadev Desai. Dr. Mahadev Desai is a teacher for me, and Dr. Jitendra Nagar, a very close friend of mine from DISA, and Dr. Sanjay Mendiratta from Jaipur for this prestigious oration to chair. over to Dr. Mahadev Desai to introduce Dr. B.M. Makkar. But before that, I will request Dr. A.K. Das and Dr. Shashank Joshi, the Program Director and Chief Advisor of the program, and I will invite Dr. B.M. Makkar to felicitate Dr. B.M. Makkar. I will request Dr. A.K. Das and Dr. Shashank Joshi to join along with Dr. Mahadev Bhai and Jitendra Ragar and Dr. Mendiratta. I will request Dr. Mahadev Desai and Dr. Sanjay Mendiratta to read citation for Dr. B.M. Makkar, sir.
Good morning, everyone. It's really a pleasure to welcome, and it's our proud privilege to honor this Day-2. It's privileged to award Day-2 Gold Medal oration for the year 2022 to Dr. Brij Makkar. He is an MD, FIMS, FICP, FRSSDI, FRCP Glasgow, Edinburgh, FSCP USA, and FSCE USA. Dr. Brij Makkar is Director of Dr. Makkar's Diabetes and Obesity Center, New Delhi. He is President-elect in RSSDI 2022, Honorary Secretary RSSDI 2017 till 19, ex-Chairman RSSDI Delhi, Charter Member in Executive Board Diabetes India. He is member in AACI International Committee 2014, 2016, 17, and AACE Professional Business Committee AACE DSN 2017 to 2020. He is course director of Advanced Certificate Course in Diabetes ACCD 2010 till date. His publication in books, national and international journals. It is our most profound honor to present you with Dr. O.P. Gupta oration for the year 2022. Signed by the organization chairman, Dr. Bansi Saab.
Thank you for that kind introduction. Good morning, everyone. It's indeed a pleasure to be in city of Ahmedabad, where I've been multiple times, and it is because of our dear friend, Dr. Bansi Sabu. And I'm truly humbled by this oration that I've been awarded at Day-2 Con. And also, it's indeed an honor to receive this from stalwarts like Professor Ashok Das and dear friend Shashank. So, today I am going to speak on can I have the slides? First slide. Yeah, thank you. So, Bansi wanted me to, talk on something different. And then I thought, let us have a different topic. So, I'm going to speak on management of diabetes, guidelines versus rationale. And I don't have any disclosure for this presentation. So we all know that poorly controlled diabetes is associated with a significant risk of long-term complications, both microvascular and macrovascular complications. And diabetes doubles the risk of acute coronary artery disease. Also, once the person gets events, the risk is doubled even further. Almost half the people with diabetes have uncontrolled hypertension, and diabetes is also leading cause of death worldwide. But when we are talking about all these things, when we are talking about diabetes, what we don't, understand is that we are talking about only poorly controlled diabetes. What about if it is controlled well? Well-controlled diabetes is associated with a long and healthy life, a normal life. So more important issue is how well we are controlling diabetes. We are always looking at the complications because we are presuming that person is going to be poorly controlled. And all the guidelines actually give us, therapeutic strategies which are focusing on that. So this is the latest guideline we know, and first-line therapy we always, have been seeing, I think more than a decade now, that there is a sequential therapy which is advised. You start with lifestyle intervention and metformin, and after that, the first thing is you look for presence of atherosclerotic cardiovascular disease or risk factors or chronic kidney disease or heart failure. So we are looking for patients who have already got damaged, who have already got heart disease or heart failure or CKD, and we are focusing on that segment of the population who is already having complications. We are not looking at the and if you look at it is not just diabetes guidelines, even the cardiology guidelines are focusing on that. But we are not looking at the larger part of the population which is having no cardiovascular disease or not many risk factors. And what we are doing about this? So let's see what we have in terms of evidence for management of diabetes. In last almost 10 to 15 years, we have had a number of trials, EMPA-REG, TCOS, all DPP-4 trials, all SGLT2 trials, all GLP-1 trials. Which is the population targeted here? The population targeted is the population who either had established atherosclerotic cardiovascular disease, CKD, or at very high risk for that. What about the new detected type 2 diabetes people or diabetes people who do not have the established complications? We know from the understanding of pathophysiology and pathobiology that glucose is an important contributor or important causative agent for causing both long-term microvascular as well as macrovascular complications of diabetes. So controlling glucose that way is paramount to management of diabetes. And this is a meta-analysis of 27,000 plus participants where 2370 events were recorded in terms of cardiovascular events, and they looked at how the good glycemic control or until early intervention matters. And if you see the people who had duration of diabetes which is less, or they don't have macrovascular disease or microvascular disease, are the ones actually benefit with glucose intensive control versus the conventional control. So we don't have to wait for these diseases, these complications to happen before becoming aggressive in management of diabetes. And studies have also shown that if you are leaving these people uncontrolled for 1 year, a A1C level of more than 7% lasting for 1 year gives you an increased risk of myocardial infarction by 67%, increased risk of stroke by 51%, increased risk of heart failure and composite of MI, HF and stroke by almost 62%. Now let us see what we understood or what we have learned from the long-term early intervention or intensive control trials. The first one was DCCT, and it clearly showed in type 1 people that intensive glucose control was associated with significant reduction in all microvascular complications. And as the A1C goes up, the risk of complications also goes up. Now look at the follow-up of DCCT. It is not just the microvascular complications. During the follow-up, we also saw there is a significant benefit in terms of reducing the cardiovascular events, and the cumulative incidence of any first event was lower by almost 42% if you manage these patients early with intensive glucose control. Similarly, we have data from UKPDS, 1% reduction in A1C gives you significant reduction in microvascular complications, and to begin with, non-significant reduction in macrovascular complications also. But 10 years follow-up from UKPDS, this reduction in macrovascular complications also became significant. Again highlighting the fact that early intensive control is the most important thing that we should focus. And this is the 30-year follow-up data from DCCT, and clearly showed that there was 30% reduction in the first of any of the predefined CV outcomes in people who were treated in the intensive arm, and there was almost 32% reduction in the occurrence of first MACE. Now, when you buy a new car, the important thing is, do you get it serviced regularly and maintain it nicely, or you don't service it? Because it is new car, do you neglect it because it is going to run fine for next 5-7 years, and once it gets dirty or it starts giving problem, then you start servicing it. So if you start servicing it right from day one, 20 years down the line, you still have a pretty good, well-maintained new car, though it'll look old, it'll be a vintage car. But if you don't service it, this is what you get. This is the people who develop atherosclerotic cardiovascular disease or CKD or heart failure or whatever. So a 60 years old patient with established CVD and only 7 years history of type 2 diabetes, there are two different kind of patients. So if you are controlling glucose in these patients who already have established atherosclerotic cardiovascular disease, it is like hoping that once nuclear warhead is detonated, the peace talks are going to prevent the further explosions. So look at the different aspect of diabetes. We have an integrated area of hyperglycemia, which is further going on to progress to development of risk factors and clinically evident CVD. Now, where we are looking at in terms of intervention in the trials, in the CVOTs, is this area. Actually, we should be looking here. And this is the area where it should be intervening. Now we move on to the understanding of how the hyperglycemia is caused, and DeFronzo gave Banting oration 2008 and first time changed our understanding actually that hyperglycemia is contributed to not only by insulin deficiency and insulin resistance alone, there are multiple mechanisms which are contributing to hyperglycemia. And since there are multiple mechanisms contributing to hyperglycemia, we need more than one drugs to address this underlying pathophysiological disturbances. So we need to have metformin or insulin sensitizer on board. We need to have a GLP-1 receptor agonist or DPP-4 inhibitor on board to address this. We need to, if we are using sulfonylurea, it is going to address only the insulin secretion. We need to have SGLT2 inhibitors to address the renal mechanism. So we need multiple drugs. But the problem is, once the person is diagnosed with diabetes, the first drug is initiated in more than half of the people only after 1 year. For first year, we are not even initiating therapy. This is the global scenario. But India, we are doing wonderful because the first drug gets initiated in most of the people. Almost 86% of the people get first drug initiated immediately. That's metformin. But what about the further intensification of therapy? Second drugs gets added again, after a delay, and more than 50% are getting only after 1 year of uncontrolled period, and there India is also not doing better. This is the study from Professor Kamlesh Kunti from UK, which showed that if somebody is already on one oral agent and A1C is in the range of 7%, the intensification happens after almost 3 years. If it is at 7.5%, intensification takes about 2 years to get. And it is at 8%, the intensification on an average happens at 1.6 years. This is with one drug. Now what if you are already on 2 or 3 drugs? The average time to intensification in uncontrolled people is about 6 to 7 years. So we are leaving these people These are all unserviced cars which are going to end up as badly damaged cars. We are leaving these people to wait for the heart to get damaged or kidney to get damaged and then start looking at the CV outcome data, how to manage these people. So in clinical practice, this is the same study. The average time to intensification after two drugs goes up to 6 years, which is actually really bad. And what guidelines recommend is sequential therapy, that you start with metformin lifestyle intervention. If the A1C goes above 7, then you intensify it. So what happens is between two intensifications, two add-ons, there is always a period of hyperglycemia. So we are exposing these people to hyperglycemic burden perpetually, time and again, and exposing them to the increased risk of damage to all kinds of complications. While we should be, focusing on keeping the A1C below the target level all the time through the course of disease to make sure that these people don't end up with complications. Now, when DeFronzo gave this Banting oration, I was also there, and ADA immediately, announced a grant to compare the DeFronzo's approach to management of diabetes versus the sequential therapy of diabetes management. And this is called ADDICT study, the efficacy and durability of initial combination therapy for type 2 diabetes. And this was a randomized trial, open label, where the pathophysiological based approach, the patients were given exenatide, glitazone, and metformin right from day one of the diagnosis of diabetes. And the second arm is the sequential therapy based on the A1C levels as recommended by the guidelines. And 24 months down the line, there was a significantly lower A1C level in people who were on the intervention arm or the triple drug therapy as compared to the sequential therapy. Not only that, there was again a better survival probability in people who were already on triple drug therapy right from day one as compared to those who were on sequential therapy. And now we have 6 years follow-up data, which was actually presented at ADA meeting 2018, and again showed that there is significantly better durable glycemic control if you are intervening early with 3 drugs as compared to sequential therapy. The A1C was lower by almost 0.7% this arm. Now we recently also had data from Verified trial, which looked at starting metformin versus metformin vildagliptin in new detected type 2 diabetes individuals, as recent as it could be, drug naive or at best treated with metformin for less than 4 weeks. So average duration of diabetes in these individuals was only few months, and average starting A1C was 6.7%. So if you look at the 6.7% A1C, one will wonder, according to guidelines, why we are treating them with 2 drugs. And they were treated and followed up, and the metformin arm, if the A1C went up above 7.7% on 2 different occasions in 6 months, then the vildagliptin was added. And if there was failure of control again, then they were again added to insulin therapy. What did we get? 26% better chances of sustaining a durable control over 5 years period as compared to the monotherapy arm. Now, does that mean that we are having better control, or does it also mean that we are possibly modifying the disease? There was a clear indication that there was improvement in beta cell function in people who were treated with vilda metformin arm as compared to metformin alone. And not only that, when we are looking at the side effects, there was significantly lower number of cardiovascular events in people treated with dual therapy as compared to monotherapy. Though this is not a CV outcome trial, but all the cardiovascular events were adjudicated. And there was almost 30% reduction in the risk of having a cardiovascular event in people who were initiated on dual therapy. And this is, mind you, all new detected type 2 diabetes individuals who had starting A1C of 6.7%. They didn't have any established risk factors or atherosclerotic cardiovascular disease. Now, this is a meta-analysis of, type 2 diabetes individuals who have been treated on vildagliptin metformin versus comparators. And this study, this study was done by Mark Evans in 2015, and this involved patients from all vildagliptin trials, and they tried to find out why these people are not getting CV outcomes, CV benefits. So they classified the patients into two groups: less than 65 years of age, so people with type 2 diabetes, younger age, lesser duration, and those who are already more than 65 years of age. In people who were more than 65 years, it was neutral, CV neutral, no CV benefit. But people who were less than 65 years of age, there was 37% relative risk reduction in first MACE. So, based on the Verify study, the ADA-ESD 2021 recommendation stated that whereas we previously stated there was limited evidence for initial combination therapy, the vildagliptin efficacy in combination with metformin in Verify trial provides additional information, and we now suggest that providers should engage in shared decision making for initial combination therapy in new detected cases of type 2 diabetes. This is ADA-ESD guideline 2021. And we have RSSDA guideline. We also recommend considering initial combination therapy, but only when we have A1C of more than 1.5, or in some cases where it is considered that single agent may not be able to achieve a target of A1C, we should initiate with dual therapy. So, to conclude my presentation, the rational or evidence-based approach to management of type 2 diabetes suggests that we should have early aggressive intervention to control glycemia. We should initiate with combination therapy so that we can prevent complications rather than focus on what after the complications have happened. We should look at normal healthy life for persons with diabetes rather than preventing events or reducing the risk of events after they have already got complications. Guidelines recommend sequential therapy even now, and they have been doing for more than a decade. And so there is an inertia within the guidelines. The guidelines are not willing to change the concept, moving away from the sequential therapy. It is time to move from the guideline inertia to early aggressive intervention and achieving good glycemic control for people with diabetes and to prevent events before they happen. Thank you.
Thank you, Doctor. Thank you, Dr. B.M. Makkar, sir, for your wonderful presentation and awakening all of us for early intervention and treat to target, not treat to fail. Once we fail, the HbA1c rises, then we add second as per the guidelines. But now the time has come to change this concept so that we can prevent and delay the complications in our diabetic population.
Sir, you have beautifully metamorphed with a car and said that we must start from day one about the maintenance rather than waiting for the 5 years.
That car slide, I must, tell everyone that it is a borrowed slide from David Strain. Right. We recently were doing a, international speaker program, and I liked that slide, so I borrowed it from him.
It's a beautiful metaphor for the stressing the point of maintaining from day one rather than waiting for 5 years.
Yeah.
Thank you, sir.
Thank you.
Thank you, Chairperson, and thank you, Dr. B.M. Makkar. Dr. B.M. Makkar is very busy. He came today early morning from Jaipur and going afternoon to Bangalore. So thank you, Dr. Makkar Sahab, for sparing your very valuable time with us and for this origin. Yes, I know. It's tomorrow Hyderabad, so very, very busy. Our President-elect of RSSDA. Thank you, Dr. Makkar sir. मक्कर सर को जो लेके जाना वही देना और सब भेज देंगे. So everything will be delivered at his home. Except this you can give. Now, next session is very interesting, and to chair this session we have with us Dr. Jitendra Patel. Dr. Jitendra Patel is a senior consultant physician, diabetologist, cardiologist practicing since last 29 years. He is also ex-president of our Association Physician of Ahmedabad, Dr. Jitendra Patel. Along with him, we have with us Dr. Pardeep Joshi. Pardeep Joshi is from Bhavnagar. Pardeep is my classmate from MBBS first year to MD Medicine, very close friend of mine. Dr. Pardeep is delivered many lectures in EPI and in RSSDI Gujarat chapter across the country and across the state. So now I request Dr. Jitendra and Pardeep to introduce this session, but this session is very interesting. We had kept all three Padma Shri in this session, and we have with us our very good friend Dr. Shashank Joshi, who will start with. Then we have with us Dr. Kamlakar Tripathi, a very eminent endocrinologist, diabetologist, nephrologist, unique number of degrees which he have. He is a professor at BHU. He was now retired. And then we have Professor Dr. Alka Deshpande, who is teacher for Dr. Shashank Joshi. So that's how this session has been made. So now I request to start, and I am requesting both the chairperson to start the session. Thank you.
Thank you, Dr. Bansi. First of all, hearty congratulations for Diacon and inviting me to chair the very important sessions of Padma Shri awardee, and for which we have three eminent speakers of the Padma Shri awardee sessions. And first of all, I would like to call Dr. Shashank Joshi, who is MBBS, MDDM, endocrinology and FRCP, FSCP, is consultant endocrinologist, Joshi Clinic, Lilavati Hospital, and chair IDF Southeast Asia. Also the president of Indian Academy of Diabetes and the former president of Association of Physicians of India, Endocrine Society of India, RSSDI, and the All India Associations of Advancing Research in Obesity. And Shashank Joshi was honored by the government India by awarding him the Padma Shri in 2014 in the recognition of his effort to the cause of medicine. And he has published more than 800 research articles in peer-reviewed journals and more than 100 books. So it's my privilege to chair the very important sessions of Sir you. And he's going to speak on the very useful topic of very less frequently discussed about the egg carbos last 25 years of experience. Over to you, sir.
So thank you so much, Jitendra Bhai, Pradeep, and welcome to the Bansi Sabu show. I call this as a Bansi Sabu show. So it's like welcome to everybody. The topic allocated to me is 25 years of acarbose in India. And with me I have a colleague of mine who is now in Ohio, but was a resident with me at KM Hospital when I was doing DM endocrine, when we did a phase 3 registration trial for acarbose in India. It's the first of its kind trial we did at the KM Hospital. So I'm reminded of that. And that time we used to have all manual records. Everything was physical. Consent also was very physical. There were only 3 translations. And that's the time we did this work. Acarbose session is sponsored by Bayer Zydus, and I have a conflict of interest with them. Though I'm not paid for this talk, but I do have a conflict of interest with them, and I have been associated with them for the last 25 years. So, you know, it's an agent with evidence base in Indian and Chinese population. If you go to China, the most prescribed drug in any category is not a multivitamin, like in India it is a multivitamin or a insulin. I don't want to take trade names here. In China, the most frequently used drug in any category of medicine is acarbose. I think after Chinese herbal medicine, they take acarbose. Everybody takes acarbose because they all have starch, and Indians also take starch. So in 97, it was approved for type 2 diabetes. It was in 99, the DCGI then approved it for type 1 diabetes as an adjuvant to insulin. Because a lot of our type 1 diabetics actually gain weight. And this starch blocker, acarbose, actually was approved in 99 by DCGI, and it was the first drug to be approved in pre-diabetes in India for IGT in 2006, because the Bayer German team actually did research trials for them. So it was approved for type 2 diabetes in 97, 99, type 1 diabetes 2006 IGT, and it also has a category B approval for pregnancy and diabetes. In fact, in Singapore diabetes guidelines, if you see its lifestyle, then it's acarbose, then is metformin, then is insulin for GDM. So it is very safe to be used in pregnancy. And across the world, acarbose was approved in 1990. It's approved in 117 countries, including US FDA, and is of course a very widely used alpha-glucosidase inhibitor, but unfortunately we have been using too much of Voglibose. This is the only, it's actually a biotechnology product. It is made through a fermenter, so it's technologically very expensive to make. So we know that how is a glucosidase inhibitor developed? You know, Professor Tripathi is going to tell you about another molecule, and he'll tell you a basic science. But we know that whatever we eat carbs, we eat fat, and we know that our metabolic control is all in the diet. And it's deeply ingrained in nutritional behavior. And we don't understand our diet very well. And which is why we get all this long-term type 2 diabetes is not under control. And we need to manipulate intestinal digestion and absorption. And therefore, enzyme inhibitors like glycoside hydrolysis in the intestine showed 50% reduction in postprandial glucose levels. Our problem is prandial glucose. Whatever you eat, whether it's breakfast, lunch or dinner, our prandial glucose goes up, and it's all our glycoside hydrolysis. And therefore, it is a very unique mechanism of action. Particularly, it is very important because Indians, we eat a lot of carb-rich diet, and alpha-glycosidase inhibition leads to delayed intestinal carbohydrate absorption. That's the first thing. It lowers the post-meal glucose. It reduces the need of insulin on the beta cells. It improves insulin sensitivity. And we also know that when carbohydrates are pushed into the lower intestine, they actually stimulate the K and the L cells to make GLP-1. So it's an inbuilt gliptin. It's the first inbuilt gliptin. And also if it goes further down, it causes symbiosis or gut microbiome. So acarbose is very unique agent because it not only improves the prandial glucose and insulin sensitivity, but also enhances physiological GLP-1 secretion and gut microbiota. So that data is very clear cut. How is it different from others, like Voglibose and Miglitol, because those are the other two? Because acarbose is involved in the degradation of disaccharides, oligosaccharides and polysaccharides. And we all know that the enzymes we have in the intestine are alpha-glucosidase, in the pancreas is alpha amylase, saliva is alpha amylase, and they compete with polysaccharides and oligosaccharides. So if you look at acarbose is the true alpha-glucosidase inhibitor because it inhibits various alpha-glucosidases in the order of glucoamylase, sucrase, maltase, isomaltase and dextrinase. And they also inhibit salivary, pancreatic amylase. While Voglibose data is not available on what enzymes it inhibits, it's not approved in more than 3 countries in the world, and no action on pancreatic and salivary, and it is only a disaccharide agent. And Miglitol has a little better data than Voglibose because it is inhibiting sucrose, glucoamylase, isomaltase, lactase and trilhase. It's again a disaccharide agent. It has nothing to do with oligosaccharides and polysaccharides, and that's why that little bit of flatulence you get with acarbose is very unique to it, and it has to be taken with the first morsel of food. So there's a big difference between acarbose, Voglibose and Miglitol, and that's what we need to recognize better. We also know that when you look at structure, the structural uniqueness renders acarbose as the only AGI which allows polysaccharides to enter the large intestine for the gut microbiome. Because acarbose is a bigger molecule. It's a pseudo-tetrasaccharide. While Voglibose is a very small pseudodisaccharide. And Miglitol is smaller. So acarbose is a unique alpha-glucosidase inhibitor with a different structure. And it is reducing the prandial glucose with an insulin-sparing action. Again suitable for the Indian diabetic patient. And it actually resurrects the first phase of insulin secretion. We know in type 2 diabetes the first thing to go, and that's why it was approved in pre-diabetes, was the early phase or the first phase of insulin secretion is resurrected by it. So we have 25 years of Indian clinical evidences of glycemic control with acarbose, metformin in acarbose, GLP-1 response, glucose variability, gut microbiota, and it is one of the early agents. Stop NIDDM trial was the first cardiovascular outcome trial on planet Earth, much before all these CV outcome trials came for all these SGLT2 inhibitors and GLP-1. So glucose control with acarbose is robust. This is a meta-analysis from the Cochrane review of 28 placebo randomized control trials, which clearly show that the A1C droppage is very, very robust. Up to a percentage, the fasting glucose and prandial glucose both are dropped substantially with the area under the curve, and this is more than 17-year-old data. And if you look at the 2013 meta-analysis on Eastern diet, which is our diet, on the Asian population, the A1C reduction with acarbose is 1.54%. And this is a meta-analysis of 46 studies, RCTs again. So clearly it works. It clearly also shows that it reduces the glucose under curve. And this data was again an Indian data which shows that the Gluco-VIP multinational real-world outcome study from India with 15,000 plus patients clearly showed that it works on the glycemic control. And Lancet in 2014 published this data, the March study, metformin and acarbose in Chinese initial hypoglycemic treatment, and which clearly showed that newly diagnosed type 2 diabetic patients who have an exaggerated prandial glucose response are very well treated with acarbose. And if you see the newer drugs, for example, DPP-4 inhibitors or SGLT2 inhibitors, head to head, the efficacy of acarbose is at par with both of them. So this is real-time data which I am showing you. And as I told you, acarbose was the first agent on planet Earth to have stopped NIDDM patient in prediabetes. And it reduced the development of new diabetes by 25% and increased reversal. It was the first remission drug, and normalized glucose tolerance by 35%. So it was a drug in remission. Also, it's an ideal combination partner. This is the initial phase 3 Indian study of acarbose to metformin. And Dr. Jairam, who used to be a professor at medicine at JJ Hospital, had published this study in JAPI long time back, almost 12 years back, clearly showing that when you combine it, acarbose with metformin, there is a synergistic effect. Compared to that, voglibose is much more weaker, and that data is available on clinical.gov, and they have not even published that data. And if you look at meta-analysis of alpha-glucosidase inhibitors, as it is a perfect second line after metformin, both in terms of A1C reduction and hypoglycemic events. So for all similar A1C reductions, there are differential hypoglycemic risks. And if you see the network meta-analysis of 62 RCTs with more than 32,000 patients, acarbose efficacy is similar to all OHs. Whether it's the gliptins or the glyphosines, head-to-head data, it's actually having an A1C drop higher than a gliptin or a SGLT2 inhibitor as well. The reason for that is acarbose has benefits beyond diabetes control. It has impact on GLP-1, it's an inbuilt gliptin. It reduces glycemic variability. It has a modulatory effect on gut microbiota and cardiovascular benefits. So acarbose enhances GLP-1 secretion because this is a publication from Japan which very clearly shows that when you have acarbose, it actually allows the various saccharides to go and stimulate the K and the L cells of the intestine to make GLP-1. This is the first data to show that after 60 minutes, area under the curve of GLP-1 goes up because there is unabsorbed carbohydrate in the intestine. And adding acarbose to glucose levels significantly improved breakfast and prandial peaks on 24-hour CGMs. And Dr. Bansi Sabu is also involved with me in some of these works on CGM profiles. So acarbose clearly decreases intraday glycemic variability. The time in range comes very, very elegantly when you add acarbose. You can see the MAGE is 20 milligram lower, the standard deviation is lower, and the overall time in range is better. And glycemic variability, even when you add acarbose to premixed insulin, which we often use in India, you can see the coefficient of variation, the MAGE, the standard deviation is statistically significant. The biggest advantage of acarbose today is its impact on gut microbiota. That flatulence, which is a socially unacceptable side effect, which voglibos doesn't have, actually is beneficial to the heart. You know, a little bit of abdominal gas is good for the heart is what they say. And this is Chinese data, 2 publications in RCT, where you can see, they say that you are not rich in how much money you have in your bank, but you are rich in what type of microbiota you have in your intestine. And you can see here very clearly that after acarbose treatment in a randomized double-blind crossover trial, there is a higher abundance of the genera like Lactobacilli and Dilister and lower the bad bacteria. So there is symbiosis, almost 40% of better bacteria are there. And these microbial alterations, because the carb in the lower intestine, facilitate gut symbiosis. And you get good mycobacteria and bad bacteria are gone. What is the evidence that acarbose has cardiovascular benefits? Well, the ACE trial, which was the cardiovascular evaluation in IGT, clearly showed it had a 5-point MACE. See, now most of our CV outcome trials are using hospitalization of heart failure as an endpoint and translating it up. While acarbose showed neutrality on 5-point MACE, cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for unstable angina, and hospitalization for heart failure. And for hospitalization for heart failure, it was statistically significant. So if you just use the ACE study and try to put it like a DAPA-HF, the data is as robust. It's as significant. So really, it had that impact, but they took the 5-point MACE. And you know that after the proactive study, people took off the non-fatal stroke completely. So acarbose also has data from the Myriad data to show that intervention with acarbose prevents CV events in diabetic patients. And the real world data published just 4 years back in the Endocrine Society Journal of the US showed if you use acarbose metformin, the incidence of stroke, atherosclerotic heart disease and myocardial infarction events is significantly less. Hospitalization due to stroke, 33% relative risk reduction. Hospitalization due to atherosclerotic events, 31% relative risk reduction. Hospitalization due to myocardial infarction, 34% relative risk reduction. So this is robust Asian data to show that it reduces that. And if you see the Beijing Community Diabetes Study, 10-year follow-up, acarbose reduced MI by 50%, all-cause death by 52%. So it is the most widely used agent in China because it has outcome data on myocardial infarction and all-cause death. And you can use it even inpatient. And this is data from the COVID world from again China, where they use inpatient metformin acarbose. It reduced mortality of COVID patients with type 2 diabetes. This is again right out of the stable from Wuhan. So this data is published from Wuhan. And Dr. Makkar is here still. Whether you see the IDF guidelines, the ACE guidelines, the RSSDI ESI guidelines, all the guidelines recommend AGIs. From India, Japan, Korea, China and Taiwan, because we are the carb countries. And we know we had done the starch study and we have shown that very clearly. So the key points are acarbose is a very, very good anti-diabetic agent. As a background therapy, independent of baseline A1C, independent of duration of diabetes, independent of BMI, independent of patient's age. It's a very good geriatric drug. It can be used long term. It need not depend on beta cell. It is useful on insulin resistance and can be used in all comorbidities. Thank you for a patient hearing.
Thank you, Shashank sir. It's always a delight to listen to you. Around 10 years back, I had problem, was getting restless in the OPD and consulted Bansi, but Bansi was Ghar ka chokra, so I didn't listen. He gave me your number. I called you at 11 p.m. You told me that call me at 11 p.m. For appointment. And you said all your symptoms are reactive hypoglycemia. You are in a pre-diabetic stage and start the acarbose. And that makes the wonder. So from the pre-diabetes, reactive hypoglycemia to the diabetes management, and now the post-bariatric hypoglycemia. Everywhere the acarbose is doing a great job. Thank you, sir.
Thank you.
Now, coming to the second talk of the Padma Shri Awardee session, for which we have Dr. Kamlakar Tripathi sir. and he is MD, DM, DNB, MNMS, Nephro, FISH, FIMS, FFRSSDI, FUPDA, FRCP, Edinburgh, ex-professor and head of Department of Medicine and Division of Nephrology, IMS, Banaras Hindu University, Varanasi. Total publication is more than 300, international publication around 200, 110 invited lectures and more 600 internationals, 100. International awards, 2 national awards and fellowship 10, and ex-president UP Diabetic Association and also chairman of RSSD UP chapter. He is a president of Indian Society of Wound Healing, Indian Society of Hypertension, Indian Society of Chronomedicines, and also research project of 10, total PhD supervised 15 and MD 16 DM2. Member Apex Body, New Drug Division, Ministry of Health, Government of India, CDCSO, and DGCI, Ministry of Health, and DGHS, Government of India, 2013 to 2020. And also on advisory board member of CCRS, Ayush, Ministry of Health, Government of India. So, sir is going to speak on the
MRSAs.
MRA, the newer topics, and over to you, sir.
Thank you. Thank you. Thanks to Professor Banting Sabu for making this mega event possible. I was talking to Dr. Joshi that I'm a sandwich between the two extreme brilliant scholar, orator. Dr. Joshi spoke just 15 days back, about a month back, on a newer molecule, and nobody can match his presentation. I'm too old to match his presentation, his skill, his oratory. Dr. Alka Deshpande is another Padma Shri Award. My contemporary, maybe I stand a little older than her. But Dr. Joshi becomes, every time I meet him, every month, he becomes younger by 1 year. We become older gradually as the days passes. We talk on the newer hope of another molecule about the renal outcome in type 2 diabetes. We understand when we were a registrar resident in the dialysis unit, about 1/3 patient would be having a diabetes, because most of the patient at that time dumped as a chronic kidney disease, end-stage renal failure, chronic glomerulonephritis. CGN used to be the diagnosis. But now we understand that more than 48.8% prevalence of CKD in type 2 diabetes patient across the population. Is 6 times higher risk of developing comorbid mortality because of the cardiovascular mortality. And that's the important. We can save the patient by doing dialysis, can prolong his life, could be patient transplanted even, but most of these patients succumb during dialysis or even post-transplant because of the coronary event, very bad coronary artery, 3 artery block, massive infarction. So 6 times higher risk of death. And this is what is happening. The risk of CV events in patients with diabetes increases as albuminuria progresses. I'll tell you in a moment why albuminuria is so very important as a screening point. And EGFR would slowly deteriorate. In diabetic nephropathy, otherwise also, even you don't treat or you treat, there would be slowly decrease in EGFR. 10% of EGFR would fall slowly over every decade. So 60 year if it is normal, 70, 80, 90, by the time you reach 90 year, you will have a reserve of hardly 60 to 40% in a healthy population. This is what would happen. The hyperglycemia at bad milieu would initiate microangiopathy, endothelial cell dysfunction, neogenesis, increased surface area, then hyperfiltration. And after 6th pathogenetic mechanism, you get stage 1 of CKD, that's the hyperfiltration, where the EGFR is high, followed by podocyte damage, membrane damage, and proteinuria. So the drivers which are important to drag you on the bad path are the bad metabolic milieu that would initiate the process. Then the hemodynamic changes in afferent and efferent arteriole. In pro-inflammatory cytokine, it's a debate when these inflammatory cytokine starts. However, they could start right from the day 1, attacking the tubulointerstitial damage, sclerosis, mesangial expansion, and then hypertrophy. We call it glomerulopathy rather than glomerulonephritis. This is the bad milieu. And there are 3 important JAK-STAT. Now we have a molecule which is going to answer this. We have neprilysin, NRF2, and Rho kinase, and the adhesion molecule. All these molecules start simultaneously. inflammatory cytokine, pro-inflammatory, the bad milieu, and the changes in the basement membrane, the transcription factor, and then the macrophage infiltration. The podocytes are one which initiates the story. And therefore, the albuminuria becomes one of the important points in the screening process. And this is because of the size of the albumin is about 120 Armstrong unit. The pore within the epithelial is about the 90, and the lumen, the distance between travel in the tubule, is about 100. So albumin cannot pass through in healthy basement membrane. It's only the damage of the basement membrane. So the older teaching was, it is the silo protein, you have a albumin, negative charge, they repel each other. Once you have a inflammatory changes in the basement membrane, the charges changes, albumin gets adhered to, and then it seeps through. So podocyte damage is the first event in hyperglycemia. People often ask, what is the first event? This is the first event in induced apoptosis. In high glucose increases reactive oxygen species and sequential upregulation of cytochrome. And this podocyte damage would initiate the activated cell, which would lead to destruction. This hyperactivated RAS contributes to the elevated intraabdominal capillary pressure. So that is the hyperfiltration. That is the stage 1, where the eGFR could be 140, 120, 130, serum creatinine still would be down, and this patient would ignore, or physician would ignore. This is the FOXO4. I want you to concentrate on this side. This is the FOXO4 on this side, which is responsible for the apoptosis, and also TGF beta, and there are the molecules being looked into. This is important, the epithelial mesenchyme transition. When podocyte dies, there is apoptosis of the podocyte. The good soldiers have died on the front. When they have died, they have left some message to the younger generation. And they transform. This is called mesenchymal transformation. The adhering mesenchymal cell goes to the mesengium, makes a good fibroblast, initiates fibroblast growth factor, so that now kidney can sustain the enormous change into the environment. That's called the mesenchymal transition. Why this is important? Because this newer molecule which I'm going to talk today is going to answer this particular onslaught. So we have drug long back, about 3 decades now, as inhibitor. Bogensen used for this, captopril, and then there was the more improvement. Then we have ARBs, we have SGLT2. Calcium channel blocker, dihydropyridine derivatives, have been existing for almost 4 or 5 decades. And they do decrease the proteinuria. So hemodynamic changes, then we have metabolic, better drugs, SGLT2, GLP-RAs, metformin, recently being talked, and then we had an inflammatory and fibrosis. This has not been answered. The inflammatory cytokine, the fibroblast growth factor, the laying of the fibrous tissue, and preventing the sclerosis, that not have been answered. So this is the proteinuria now, the hallmark. And the podocyte, the mesangial cell, the glomerular hyperfiltration, and the vascular ischemia all contribute in reduction of GFR. This is the progression. Podocyte damage first, proteinuria then, mesenchymal transition third, hypertrophy 4, renal fibrosis 5th, sclerosis, hypertension, and then stage renal disease. Long way to go before a patient comes to a clinician or be himself screened and find that his creatinine is up, or even albumin is there in the urine. Despite of 4 or 5 decades availability of RAS inhibitor drugs, ACE inhibitor, ARBs, is still only 16% risk reduction. Or when we add SGLT2 inhibitor, this becomes a little better, becomes 30% to 50%. So 50% patients have still been unanswered how to protect their kidney, how to protect sclerosis. This is what we are talking today, MR overactivation, which is a major driver in whole of the process. It's a receptor which regulates gene expression through cofactor. In renal disease, multiple factors overactivate: aldosterone, RAC, cortisol, and also the pro-inflammatory cytokine. This is what is the old slide, aldosterone. And we all have a drug for last 3 decades. Response for sclerosis, interstitial fibrosis, proteinuria, renal failure, of course, cardiac hypertrophy, endothelial dysfunction. On my right side, you have the steroidal mRNAs, like spironolactone, we have used it. We have eplerenone, which is being now used for last 10 years. On my left side, other side, you have a dihydropyridine, finerenone, which I'm going to talk today. And also the combination of the two and looking at their fate, how do they act, how they prevent the inflammatory fibrosis and take care of the... This is what the insult is going, because kidney perceive that the moment podocyte has been damaged, there is increased fibrosis, there is increased glomerular bed. Kidney thinks by nature, right from the day one, 4.5 billion years before the single cell was born, all biological cells, they think sodium is less to us. So they start reclaiming the sodium. You filter the sodium, you absorb 85% from the proximal tubule, you leave only 15%, even that is also being absorbed by the aldosterone from the distal tubule. So what does it do? It produces T cell damage, activation, blocks Th17, works on the macrophage, works on the fibroblast, works on the endothelial cell, smooth muscle cell, podocyte, and mesenchymal cell. So whole story in the kidney parenchyma, right from the vascular to the epithelial cell, is responsible for the damage by MRA antagonist. This is what the kidney damage would be. These receptors would be responsible for nephrosclerosis, nephropathy, cyclosporine-induced toxicity, and one of the very important issues for the transplant physician, proteinuria and stage renal disease. This is the story of the molecule being developed. We knew this is the DOCA, and there was a beautiful article early days, what is called DOCA escape phenomena, or aldosterone escape phenomena. You take animal, infuse normal saline, give the DOCA. There will be a stage by which the sodium will be absorbed. Subsequently, it would fail to absorb any amount of sodium. It was developed to 1943, and then now we have in 2016 and 19 this newer molecule over the eplerenone. So look at the beneficial property of MRAs, decreases mortality and hospitalization in CHF and acute heart failure patient post-MI, decreases BNP, anti-pro-BNP, improves on diastolic dysfunction, decreases fibrosis, arrhythmia which is induced by MRA, oxidative stress, and progression. So we have three: spironolactone, which is steroidal. This is cyclopentanoperhydroferrin 3 nucleus. Eplerenone, again the same nucleus, so it's at a disadvantage of rising serum creatinine, deteriorating renal function. But then we have a Bayer's non-steroidal finerenone, which is, has got a high selectivity and has only one problem of the hyperkalemia, otherwise normal. So what this new drug trial is, this is Fidelio and Figaro trial. These are two groups. One is Fidelio, where the eGFR is on the lower side, mean eGFR 4.3, but the proteinuria is on the higher side. This is the contrast. When kidney, the eGFR decreases, the proteinuria also decreases, and normal end-stage renal. In diabetes, it is reverse. In spite of decrease in eGFR, proteinuria continues to rise. In Figaro trial, on the other hand, you have a patient of the normal GFR, 7.8, little higher GFR, and proteinuria was less. This is 312, and more than 300 was the 51.2. So 50%, more than 50% patient in Figaro trial had proteinuria which was on the higher side. On contrast, 87.4% patient in the Fidelio trial had proteinuria on the higher side. So it was 10 milligram versus 20 milligram crossover trial studies. And the Fidelio DKD, which has a low GFR with high proteinuria, it was 5,134 patient. In Figaro, it has a 7,433 patient. The philosophy was that if you intervene the patient in Fidelio who had low GFR, high albuminuria, high proteinuria, how much you can prevent their deterioration. On contrary, those who had already been on the higher side of GFR with little proteinuria, and this was the comparative study. This was the maximum tolerated RAS therapy patient already took ACE, ARB plus any other drug and had reduction of primary kidney outcome by 18%. And this was looking at the Fidelio trial, and this is the great achievement, 31% from the baseline versus placebo, and this is secondary endpoint where it is the 24%. So secondary kidney composite at point was 24% risk reduction, and it was 31% on the albumin reduction. I said in the beginning, albumin seepage is the key factor in upregulating the fibrosis and end-stage renal disease. So it's important to refer the albuminuria rather than the serum creatinine. Looking at the CV death, non-fatal MI, non-fatal stroke, hospitalization, 4-point MACE, and when you look at this 4-point MACE, this was again 14%. When you look at the Figaro now, the other one, it reduced the risk of the primary CV point by 13%. So it was 18% in the first, 13% because this patient, this group of the patient, eGFR was relatively on the higher side. So there's no point in hitting a horse when it's already running. But when horse is tired, then you can care the horse and it would do the better performance. Look at the secondary outcome, and here is the point, that what you did not significantly reduce the clinical accepted more than 40% decrease in eGFR. This is what I was talking to you. Your GFR would continue to deteriorate. The question is how much you halt the progression of GFR. Now, when you look at the Finerenone trial of hyperkalemia, I said in the beginning, because this is the only molecule, there was little high potassium, but clinically this was not significant, and no death due to hyperkalemia and the incidence of treatment discontinuation or hospitalization due to hyperkalemia. In traditional eplerenone, when you use spironolactone, there is a problem of the hyperkalemia. More so when you are using ACE inhibitor, more so when you are using ARB, more so when you are using SGLT2 inhibitor. So this is what is the important issue. I'll come in a moment to the both. Initial part, whether you use SGLT2 inhibitor or you use AS or ARBs, there could be some drop in eGFR. This is what happened with Finerenone also. Initial year that could be drop, but subsequent year there would be significant improvement in eGFR. And that's a caution, and that's what you should look. This is the efficacy outcome, and Finerenone stands better for the kidney failure, end-stage kidney disease, sustained decrease in eGFR, as well as just from the cardiovascular non-fatal MI. 4-point. This is called fidelity. When you merged both trials together and you tried to work up the calculation, and this is what the answer is. Together, when you try to mix both, there is decrease in 14% CV death, 12% in non-fatal MI, 9% in non-fatal stroke, and then hospitalization. Overall, this is 22% reduction. Fidelity again, 23% risk reduction, and 57% eGFR composite outcome. That's the wonderful, even as good as any SGLT2 inhibitor or EMPA-REC trial, or this is the when you are using in combination with SGLT2. I said in the beginning, even these patients as ACE, ARBs, SGLT2 inhibitor, the reduction in albuminuria would be 32% from the baseline without SGLT1, and with SGLT1, this is 37%. So it scores again, 5% is scoring above the SGLT2 guideline. This is the summary slide now. Overall, there is 2.6-year median follow-up, so there is 17.8% risk reduction when it comes to the renal point, composite point. When it comes to the cardiac, there is 13%. So in patients with CKD and type 2 diabetes, treatment with Finerenone resulted in the low risk of CKD progression and cardiovascular death. This is summary. Finerenone significantly reduced 18% and 14% risk of coronary event. and also reduced 13% in Figaro trial, as well as 36%, and there's a significant advantage. So therefore, it is now included in the ADA guideline 2022 in patients with CKD who are at increased risk of cardiovascular event or CKD progression. SGLT2 inhibitor, a non-steroidal mineralocorticoid receptor antagonist finerenone is recommended. And for patients with type 2 diabetes and CKD treated with maximum tolerated dose of ACE inhibitor, finerenone should be considered to improve cardiovascular outcome. And both is level A. Thank you very much.
Thank you, sir, for our excellent presentation. So we have now one more weapon after the ACE inhibitors and ARBs to fight against the diabetic nephropathy. Our next speaker is Dr. Alka Deshpande, ma'am. She doesn't need any introduction. She did MD and FRCP in London, MNAMS, FIMSA, FICP. She is a Dean of Indian College of Physicians, consultant physician, former professor and head with the Department of Medicine, Grand Medical College and Sir JJ Hospital, Mumbai. 120 national and international publications, 360 guest lectures, authored 9 books and contribution to textbooks, and recipient of Padma Shri Award in 2001. She will be speaking in the Managing Hypertension in Diabetic Patients, New Guidelines. Over to ma'am. Thank you.
Honorable chairpersons and esteemed delegates, after eloquent speech from Dr. Shashank and Dr. Tripathi, I will be just reviewing the subject which is very well known to you all. Now, diabetes and hypertension are actually partners in crime. Type 2 diabetes and hypertension both are components of metabolic syndrome, as you know. Hyperglycemia and high blood pressure frequently coexist. Both enhance the cardiovascular risk. Treated inappropriately, they lead to serious complications contributing to serious morbidity and mortality. However, lowering blood pressure can substantially reduce the risk. Hypertension in diabetes can be of 4 types. It can be essential hypertension, hypertension consequent to nephropathy, isolated systolic hypertension, which is very common in diabetics, and supine hypertension with orthostatic fall seen in diabetes. Diabetes and hypertension, twin epidemics, as you know, 1 in 3 Indian is a hypertensive and 1 in 4 Indian is a diabetic. New diabetes is 2.5 times in hypertension. 20 to 40% of impaired glucose tolerance have hypertension. 40 to 50% T2DM has hypertension. The worst part is that only 25% of the hypertension is controlled in diabetes. Diabetes and hypertension, they will increase the cardiovascular risk by 3-fold. And that is why we are concerned. Now, we all know the common risk factors for both hypertension and diabetes. Insulin resistance. Now, insulin resistance is detected many years before the diabetes is detected. Insulin resistance, dyslipidemias, obesity, genetic predisposition, all these are common risk factors both for diabetes and hypertension, and there is an interplay between them. Actually, it is the central obesity which is the culprit, and the fat cells or the adipocytes, they go on swelling, and ultimately they are vulnerable to apoptosis. When the dead adipocyte get accumulated, the macrophages naturally are attracted there, and then there is a whole cascade of inflammatory cytokines. As a result, we get the further process, inflammatory cytokines, nitric oxide, and therefore we get inflammation. So atherosclerosis is mainly responsible for macrovascular diseases. However, endothelial dysfunction, vascular inflammation, vascular fibrosis, these will cause microvascular complications, and both together can cause cardiovascular disease. The same thing is shown in the other figure also, that diabetes and hypertension, there is hyperglycemia, there is an overactivity of RAS system, immune activation, as I said, and as Dr. Tripathi has very nicely shown, oxidative stress inflammation. Hyperglycemia per se will cause accumulation of advanced glycan products and rage, and both of them will have effect on the small and big vessels. We all know that the hypertension, the main two parameters are peripheral resistance and circulatory fluid volume. Peripheral resistance results from vascular tension. There are many factors which control the peripheral resistance. It is RAS, vasoconstrictors, vasodilators, activity of the sympathetic system, and vascular remodeling or endothelial dysfunction. Vascular remodeling in association with hyperglycemia, hyperinsulinemia, these are the triggers for vascular changes. Inflammation, oxidative stress, and dyslipidemias, they will all cause arterial stiffening, which increases the peripheral resistance, which is directly proportional to the diastolic pressure. Circulatory fluid volume, regulated by body fluid volume. It is affected by sodium balance, contractile force of the heart, which depends on the activity of the heart, sympathetic nervous system, and RAS system. Now, if there is imbalance at any stage of these factors, this will result into hypertension. Hypertension, as per the new guidelines, has been classified as follows. Optimal is systolic blood pressure less than 120 and diastolic less than 80 millimeters. Normal is 120 to 130 systolic and diastolic 80 to 84. High normal, this is a new category for all of us. This is 130 to 139 and diastolic 85 to 89. In other words, 140 by 90 is hypertension. So stage 1 is 140 to 159 and diastolic 90 to 99. Stage 2, 160 to 179, diastolic 100 to 109. Stage 3, systolic more than 180, diastolic more than 110. When I was postgraduate, 180 by 110, we used to call it as moderate hypertension. But now it is stage 3. And then there is an isolated hypertension, where the systolic blood pressure is more than 140 and diastolic is less than 90. Now this is the Indian data, which shows there are only 17% people who are normal. There are 50% who are pre-hypertensive, and therefore every visit the patient may come to you for many different reasons or presentation. Please check the BP, because we can pick up these people and start our intervention in the pre-hypertensive stage. So 50% are pre-hypertensive, 33% are hypertensive. That means 1 in 3 Indian is having hypertension. Before we initiate any treatment, we would like to know the clinical profile of this patient, and therefore optimal lab test which I would like to do is CBC, urine for evidence of proteinuria, fasting blood sugar, serum creat, eGFR, serum sodium, potassium, calcium, serum lipids of course, serum TSH, serum uric acid, ECG, and 2D echo. These are the minimum investigation I would like to do, and these are from the American Heart Society. Now, we can't give a blanket treatment to all the patient. So, individualized targets rather than blanket advice. So, consider the age of the patient. Also take the help of a score system and find out the cardiovascular risk for this patient. Consider the life expectancy of this patient, previous or associated comorbidities, overall treatment burden, and episodes of hypotension. At the same time, depending on his age, we have to also consider the drug side effects, expected cost, compliance, resources, patient's attitude, and support system. Now, support system and patient's attitude are very important, because most of the patients like diabetes, even hypertensive patients, are non-compliant to the therapy. As long as they don't suffer, they don't bother about it. What is expected with the treatment? Effective BP control, long-term CV and renal protection. Metabolically, they should be neutral. They should not increase the glycemia, should not worsen coexisting medical conditions and renal failure, compatibility with other drugs, and well tolerated and cost effective. So these are the parameters on which we will start the treatment. Non-pharmacological intervention, which are given by American Cardiological Association. If overweight, weight loss. That is the main point. No smoking or tobacco in any form, no alcohol. Restrict the salt intake, that is sodium, to 1.5 grams per day. If necessary, give potassium supplementation and regular physical activity, which is a must. So this is both for diabetes and hypertension, but in pre-hypertension, you can start immediately this intervention. Treatment strategy of diabetes and hypertension. If blood pressure is more than 130/90, the treatment is indicated. The target, what should be our target? The systolic blood pressure should be this BP more than 140/90. The target should be systolic BP 130, but not less than 120. So we should not be too aggressive to bring down the systolic BP to less than 120. If the patient is more than 65 years, systolic BP should be 130 to 139, and diastolic BP should be less than 80, but should not be brought down to less than 70. What is the treatment? We can use the RAS blockers, calcium channel blockers, diuretics. But ACE inhibitors and ARBs should not be combined together. Why ACE inhibitors? And ACE inhibitors is the first line of treatment in diabetes with hypertension because it lowers the BP, it has minimal side effects, they have no adverse effects on lipid metabolism, may decrease the blood sugar concentration by increasing the insulin sensitivity, decreases the progression of albuminuria, decreases the progression of retinopathy, and they have a unique cardiovascular benefit, and that is why we have been all along using ramipril and perindopril. Then calcium channel blockers, best to add on these to ACE inhibitors or ARBs. They are long acting, but not very useful in proteinuria. Diuretics, yes, these also we can use. They are more helpful in isolated systolic hypertension. But be careful when we are using in aged patients the hydrochlorothiazide. Always start with a very low dose. Low dose combined rather than increase if the target is not achieved. Best combined with ACE inhibitors or ARBs. Avoid combination with beta blockers. Avoid this in grossly uncontrolled DM. Chlorthalidone can be used if creatinine is less than 2. Loop diuretics if creatinine is more than 2. Otherwise, a low dose of hydrochlorothiazide will be good enough. Indapamide is also preferable. In resistant hypertension, in low potassium and in OSAS, aldosterone antagonist should be tried. And that is what Dr. Tripathi has very extensively reviewed. Beta blockers not recommended as first line for hypertension. In other cases, non-diabetics, yes, not here, because it masks the signs and symptoms of hypoglycemia. It impairs the insulin sensitivity. It increases the triglyceride level, decreases the HDL. So there are more adverse effects than the benefits. However, the newer beta blockers like carvedilol, nebiviolol, labetalol, and third generation beta blockers can be used, and we have been using it. Now, these are the recommendations from the European Society. Initial BP 140/90 and 160/100. And the second group is more than 160/100. Now, first is lifestyle management. For all the patients, like diabetics, we have to talk about lifestyle management. Then, in the case when there is, then we subject them for a urine examination. If albuminuria, and we decide our treatment based on the albuminuria. If the BP is low, that is up to 160/100 and no albuminuria, then we can start one drug, that is ACE inhibitor or ARB or calcium channel blocker or diuretic. If there is a albuminuria, then start with ACE inhibitor and ARB. If need be, we can add on the other drug instead of increasing the dose. If the initial BP is more than 160/100, start 2 agents. If there is albuminuria, then we should start ACE inhibitor or ARB and calcium channel blocker and diuretic. If there is no albuminuria, we can start 2 drugs of these 3 options. So that choice is left to you. But when it is more than 160/100, we must start with 2 drugs. If it is less than 160/100, start with 1 drug. And we must go on assessing the BP every time he comes. Now there are so many methods. He can keep his measurement at home. If he maintains a diary like blood sugar, then we can also know about his compliance. So ask him to keep it. If the treatment tolerated and target is achieved, continue the same treatment. If the target is not achieved and the BP is still high, then we can go on adding the drugs. And if there are adverse effects, we have to revise the treatment. What are the dangers of underusing beta blockers in diabetes? I told you beta blockers should not be used because of these reasons. However, withholding beta blockers in diabetes with CAD doubles the mortality risk. So if there is already a coronary artery disease, you can use beta blockers. Always use beta blockers in CAD, post-MI, left ventricular dysfunctions, tachyarrhythmias, heart failure, and with increased sympathetic activity. However, don't use the older one. Go for the newer ones like carvedilol, bisoprolol, and others. And then, when there is a resistant hypertension, you have tried all this, and still the BP is not controlled, then we have to go for MRAs, mineralocorticoid receptor antagonists. Dr. Tripathi has very extensively reviewed them. We had been using spironolactone and eplerenone. This new drug is finerenone, and there are extensive trials which are going on, non-steroidal MRA. The other one, esaxerenone, has been approved already in Japan. It has more selective activity. It reduces remodeling, fibrosis, and inflammation in heart, kidneys, and peripheral vessels, and therefore it is preferred in diabetes with heart failure, renal failure, and hypertension. Now the bottom line of DM and hypertension, I reviewed the management of hypertension, but bottom line is of course control the hyperglycemia. So diabetes has to be controlled with whatever way that we are treating the patient, lifestyle intervention, and then the oral drugs, even, and if need be, insulin. However, these two new drugs are revolutionizing our concepts. One is SGLT2 inhibitor. This causes plasma volume depletion. Because it causes plasma volume depletion, the circulatory load is decreased, and therefore it decreases the blood pressure. It also improves the arterial stiffness and endothelial dysfunction. It decreases the oxidative stress, preserves the circadian blood pressure pattern, and therefore SGLT2 inhibitor is a wonderful drug not only for diabetes but also for hypertension, and therefore now your prescriptions will change based on these two factors. And the last one is GLP-1 analogs. They act through incretin effect. They lower the sugar. Lowering the sugar itself is beneficial for treatment of hypertension. They are cardioprotective, they are renoprotective, and another drug which you might have been using is sacubitril and valsartan combination. So all these are the advances, and we have now so many drugs in the armamentarium. It depends upon us how judiciously and how selectively we use these drugs and control the blood pressure in hypertension. Thank you very much for your patient hearing.
Thank you, Alka ma'am, for giving a brief about hypertension management in diabetes patients. Now it will be a question-answer session for next 10 minutes. So I would like to call upon all the three speakers on the stage. My first question is to Dr. Alka ma'am. Which is the absolute situation among both the diuretics, hydrochlorothiazides and chlorthalidone, where you will consider chlorthalidone or where you will consider hydrochlorothiazide? Because we have enough experience with both the molecules. But in present scenario, where is the situations where you would like to score chlorthalidone over hydrochlorothiazides?
See, I have more experience with hydrochlorothiazide, so I will prefer it because of my clinical acumen. Chlorthalidone, as per the guidelines, when creatinine is less than 2 milligrams, not if the creatinine is rising. So would you like to add anything? Where is Dr. Shashank?
Sir, please come on the stage. Sir.
Out of the two diuretics, one which makes you diurese drastically and has more hyponatremia, that's bad for the elderly people. So that's one of the reasons why people are going back to the older, which is a slow acting and slowly taking out the sodium load. Second is the hypokalemia as well. So the strong loop diuretics, they would make a strong hypokalemia, a strong hyponatremia. The chlorothiazide, which is acting at the proximal tubule, would be thiazide-like diuretic, would be acting slowly, 24 hours, and therefore they would not have that much hyponatremia. So that's the reason why we are going back to the older molecule.
And my question to you, sir, any specific drugs to be avoided or cautions to be taken when we have to use MRA non-steroidal drugs for particularly looking to the hyperkalemia issues?
Only hyperkalemia is the issue, certainly is the issue. So what you have to be cautious of, you are using already ARBs and ACE inhibitors. They would increase potassium value. And the answer is that look at the doubling of serum creatinine. If serum creatinine doubles within less than 2 to 3 weeks, then you have to hold on the drug. If serum creatinine increases only by 10 to 20%, means it is to 1.8, 1.92, then don't stop it. Wait, I showed you the slide, initial 2 to 3 weeks, there will be drop of EGFR, so potassium can go high. But wait, let it not go more than 5. As long as it remains within the 5, it's acceptable. So that's the one combination which should be looked into.
Dr. Sanjeev.
So my question to both the experts, and if Shashank is also there, if patient is already on SGLT2, is there still a role of a thiazide-like diuretic for hypertension management?
SGLT2 is, initial part is bad because it takes a lot of sugar out as well as potassium out. So there is a shift into the intravascular compartment. Whereas diuretics initially would halt after a certain point, and then they would not be acting. SGLT2 continues to be, because it's a hygroscopic, sugar is a hygroscopic molecule, it will draw the amount of the concomitant amount of the water, so it would increase the risk of intravascular volume depletion. And this is the caution. Sick people having dehydration, having a lot of nausea, vomiting, and then they should not be added SGLT together with any loop diuretic, any strong diuretic for that purpose should not be used. You should hold on SGLT2 for that time being. SGLT2 inhibitor would be working to lowering the sugar in initial part as long as tubular maxima is up to 180 to 200 milligram. Once your patient is controlled on the sugar at least, then the non-glucosuric advantages of SGLT2 inhibitor would continue, but then there would be problem of the volume depletion.
Everybody is having nowadays
Yes, the
say on
question is,
SGLT.
if patient is already
No.
on SGLT2 inhibitor,
So I wanted your personal
Yes.
experience about SGLT2
they are
inhibitors.
great drugs, no doubt about that. But if SGLT2 already the patient is taking, is there any advantage of adding a thiazide diuretic for control of hypertension? Would it give additional hypertension?
Theoretically, I don't find any because already there is a volume loss because it is acting on the kidneys and there is a volume loss. So I don't think hydrochlorothiazide is a very mild diuretic will have any action. But I don't have any reports on this.
And sir, we have to keep a watch on HB. We have seen few patients getting HB more than 17 on SGLT2 inhibitors plus thiazide diuretics. So that is another problem. And ma'am, just the last question. You have pointed out about the beta blockers that newer ones are better. Any preference about the calcium channel blockers when we use it in
Any
diabetic
preference
patients?
for?
Calcium channel blockers.
Calcium channel blocker, CCBs.
See, if it is stage 1, stage 2, either you can use ACE1. Now the guidelines prefer as ACE inhibitors, but you can use either ACE inhibitors, calcium channel blockers, or diuretics also in stage 1, stage 2.
CCB has maximum evidence, level A, for last 20, 30, 40 years in protection of the heart also, as well as taking care of the blood pressure also, and the renal protection also. One of the standard postgraduate teaching question was initial days in 70s. Even you use a strong calcium channel blocker, this would also take care of the proteinuria, would retard the progression as well as would add to the cardiomyocyte protection. Only disadvantage is the pedal edema with the traditional calcium channel blocker. So the newer calcium channel blocker like cilnidipine, like benidipine, like the changes S-amlodipine, they have least side effect and the toxicity. So I would still keep calcium channel blocker number 1, followed by ACE ARB when it comes to the protection. See, ACE and ARBs, they are not very strong in reducing the systolic blood pressure. In HOPE trial, they reduced only 2.5 to 5 millimeter mercury of the pressure, even with the maximum dose of the 10 milligram of the ramipril. So disadvantage is still stays. But for potent reduction systolic blood pressure, answer is still calcium channel blocker, and that is the gold standard. It has a cardio protection, it has a renal protection. And I have one slide right now, I'm not talking, even CCBs have the advantage of blocking all the 4 channel, L and TB. Only it is the relative blocking which one supersedes.
I would only say this, blood pressure and sugar can be monitored bedside. But in all these patients, we should frequently measure their electrolytes because we really don't know what is happening. And many of these symptoms can overlap. So serum electrolyte measurement should be done.
Is there any question from, yes?
As new MRAs are acting on kidney and they are protecting it, and main mechanism is prevention of fibrosis, will it also be effective in heart failure?
Sure, it is. I showed you the slide. The fibroblast, it has an advantage, a specific action on the fibroblast also. It is the TGF which initiates the fibroblast action. So it does reduces the cardiac myofibrosis also. It has action on the cardiac myocyte. And even in congestive heart failure, this has been a drug of choice in the recent. And I have shown you the slide 4 bar diagrams. The non-fatal MI, stroke, even arrhythmias have been prevented, and in the last, the hospitalization because of the heart failure. So it does affect add-on therapy on pre-existing therapy with ACE and ARBs, finerenone can still be used.
If there is no questions, we end the sessions. And thank you very much, all the 3 speakers, for giving excellent discussion. Now over to you.
So, very good morning, all of you. Dr. Banshi and Dr. Malai has just handed over session to me. First of all, I am so thankful to all the speakers and eminent chairperson to have such a wonderful and excellent way of presentation. So thank you so much. Can we have a huge round of applause for all these 3 speakers and both the chairpersons? Yes. Thank you so much. And now the next session is going to chair by the 2 well-experienced chairpersons from the Ahmedabad. The first chairperson for this next session is Dr. Sunil P. Mehta. He's a consultant diabetologist and cardiologist, as well as also treating obesity and having experience of more than 33 years. And the second chairperson for this next session is Dr. Raghu Satyanarayan, senior consultant physician practicing for last 33 years and also received the Times Award for the best physician. So thank you so much, both the chairpersons. And let's have a huge round of applause for both the chairpersons as well. Yeah. Sir, over to you. I would like to request you to announce the next session as well as 2 speakers, those who are going to deliver the session.
So
over to you, sir. Thank you.
Good morning, everyone. We had a feast of lectures, and another one is also extremely good session. And I'll call upon Dr. Sunil M. Jain. He is MD/DM endocrinologist for PGIMR Chandigarh in 1995, consultant endocrinologist and Total Diabetic Hormone Institute, Indore. Key faculty of CME like PG, CDM for diabetes and PG-CAT for thyroid. He has conducted more than 80 clinical trials, including LEADER, SAVIOR, TIMI, CANVAS, EMPA-REG, Verify, and Carolina. Major interest in technology solutions of field of diabetes and thyroid and endocrinology. The contributed chapter in textbook of diabetes and endocrinologists. He is an author of a book, How to Get Most Out of Your Pump. He is going to talk on game-changing voyage of the peptide in pill, oral semaglutides. Over to you, Dr.
Thanks, chairpersons, and Dr. Banshi for inviting me. And this is my topic about oral semaglutide, which you are all aware of. This is a presentation which is prepared and supported by Novo Nordisk. Now, if we look at the management of diabetes after the discovery of insulin, for so many years, our all treatment were focused about insulin, whether it is stimulated by drugs or given exogenously. And then in last 20 years, we realized that there is another very important hormone, that is GLP-1. Though the concept of incretin was known since long, but it was 91, 92 around that time when the GLP-1 was first discovered, and this was a molecule which became very early in therapy. Just in 13 years it became a treatment, that was exenatide, which we are well aware of, and now this is the first protein hormone which has come as an oral pill. That is what is the biggest discovery which has happened, and we are now having a good experience of using oral semaglutide in last 7-8 months. So I'm going to talk about this molecule little more in detail. So we know that insulin and GLP-1 both are the good treatment options for treating our patients with diabetes with their individual differences and benefits. And when GLP-1 receptor agonists were launched first around 15-16 years ago, they were originally derived from the well-known Gila monster exendin molecule, and that's why they were exendin-based structures. And then subsequently, the human GLP-1 recombinant technology was created, and that's how now we have human GLP-1 based therapies. So in general, GLP-1 therapy can be broadly classified into exendin-based and human GLP-1 based. And why this classification is needed? Because in subsequent cardiovascular outcome studies, what has been observed is the benefit, the cardiovascular benefit lies only with human GLP-1, not with the exendin based, because those trials were neutral, while human GLP-1 based outcome trials had shown the cardiovascular benefit of GLP-1. And in this slide, you can see another important aspect, that is the molecular weight of different human GLP-1 based. And you can see here specifically that liraglutide and semaglutide are a smaller molecule. And that's how in this world, when we talk about a lot of other benefits, particularly cardiovascular benefits, and because of these advantages, it is the human GLP-1 based therapy which has taken over. And among them also, if the molecular size is small, it has its own additional benefit, particularly in terms of weight loss, which has been found more with a smaller molecule like liraglutide and semaglutide. We all know that the GLP-1, once secreted from intestinal L cells, it is inactivated very fast, because the 2 amino acids are removed from these GLP-1 by DPP-4, and that's how it gets inactivated. So these are the 2 molecules which were created like human GLP-1, but they are longer acting. Some modification was done and a fatty acid was added, and when this fatty acid added GLP-1, which is liraglutide, when it is injected, obviously now this molecule gets bind to albumin, and that's how it cannot be cleared so fast by DPP-4, and that's how it works nearly for 24 hours. And that's how once a day first-in-class molecule which we are using till last year was liraglutide. It is being is still one of the popular GLP-1 receptor agonist, but the big change was semaglutide. Because it is oral, and we all understand the importance of a injectable versus oral, the patient acceptance, etc., etc. And when it comes to oral delivery of protein molecule, I think the most fascinating is insulin. So many years we are waiting for a oral insulin, but we could not achieve yet because of so many factors in our intestine which interfere in the protein absorption. And that's how insulin, though we are working since long and we are listening about oral insulin possibility, but looking to all this information, I still feel that it will be a big challenge. While with GLP-1, since number one, we require a small quantity of GLP-1, and secondly, there is no need of connecting with the meals because insulin has to rise and fall appropriately. This condition is not required with GLP-1, and that's how it is always there is a possibility to create an oral GLP-1 provided some special things are done, and it was done with molecule semaglutide. And that's how it is possible to make it get through in a small quantity from intestine. Just few important points I want to show you here in this molecular structure, which we clinicians should understand. You can see here it ate one amino acid mentioned is amino butyric acid. This is not an amino acid which we have in our food. So this is an amino acid when it is changed here. This is the point where DPP4 enzyme works. And now you replace the amino acid. Alanine is replaced by AIB, so now DPP4 cannot work on this molecule. And that's how it becomes longer acting by lysine connected with fatty acid, made it further longer acting, and that's how its half-life is approximately 1 week. And this semaglutide was initially launched as an injectable preparation. Since half-life 1 week, because of these molecular alteration, so the injection frequency was also once a week. And then subsequently it was thought that can we do something, because this molecule is going to last longer time, then can it be converted into an oral molecule? So the next work started, and that's how this is a big discovery that we have now oral semaglutide available. And obviously there are many advantages because of its a very long half-life. So these are the various advantages. Now, how to make oral semaglutide possible? So another molecule that is called SNAC, or sodium aminocaproic acid, is selected, and these together are fixed up in a pill. And that's how it is made possible to have a desired absorption of GLP-1 in form of semaglutide. So this happens primarily with semaglutide, where this semaglutide and another molecule, SNAC, is combined in one pill. And that's how this oral semaglutide is available. We are all aware about the diabetes effects as well as cardiovascular benefit effect of the injectable semaglutide. If we look at oral semaglutide, it is exactly same molecule, just the mode of delivery is different. It is parenteral versus this is oral. And that's how this oral semaglutide is created. What this SNAC is doing? When SNAC is combined with semaglutide, SNAC is a molecule which has few specific tasks. It will increase the pH in the surrounding area. And we know that in the stomach there is a very low pH, and in that environment this protein molecule can be degraded by the enzymes lying there. So if patients swallow this pill, it is creating an increased pH in the surrounding region, and then it is causing a small transcellular absorption. So the semaglutide is not getting absorbed from intestine, duodenum, jejunum, no. Semaglutide is primarily getting absorbed from stomach, and that has been proven in various venous collection studies that the vein which is draining through stomach is carrying this semaglutide. Now, if we want that this protein should get absorbed. So since there are so many challenges in a protein absorption, that's how these recommendations are mentioned on the label, that this pill should be taken with a small quantity of water. And here they have tried different quantity, right from 50 ml to 300 ml water, a small 50 ml to up to 1 glass of water. Then different timings, that how long patient should not eat anything, 30 minutes, 1 hour, 2 hour, and these kind of trials have already been done. And after that, the conclusion was that if patient drinks or swallows this pill with a small quantity of water, which can be around 100 ml, and if doesn't eat for around 30 minutes, or now if time can be longer, if the time goes longer, absorption will be slightly better. And that's how these are the recommendations that we always instruct our patient that when they wake up in the morning, the first task is to swallow this pill with a small quantity of water, which is mentioned here, and not to eat or drink anything for 30 minutes. That's how this oral GLP-1 is going to get absorbed. And in Indian patients, I always ask proactively these questions to them, because many patients you will see in our practice will tell us that, doctor, when I wake up, I drink first 2 glasses of water. This is not to be done when a patient is prescribed oral semaglutide. They should take it with a small quantity of water, and after 1 hour they are free to do whatever they want. It's available in 3 dosing strength, 3, 7 and 14, and like with any other GLP-1. Other injectable also we always gradually up titrate so that there are GI tolerance is good, and the same rule is followed by oral semaglutide. It is prescribed with 3 milligram, then 7 milligram, and we can go up to 14 milligram. And we know that GLP-1 receptor agonist, apart from a very effective glucose lowering agent, they are very important weight loss agent, and that's how this therapy initially became primarily very useful for obese type 2 diabetic patients. And then subsequently, when the leader trial data came, then the cardiovascular benefit came up, and all-cause mortality and reduced MACE, etc., we are all aware of. And then subsequently, we are now getting information on these drugs in other benefits, including NASH, Alzheimer's disease. These are the new evolving areas. These are many areas where these drugs might have a role, and GLP-1 receptor agonist is becoming a very promising and important diabetes therapeutics, because it is going to take care of many aspects. Many pathophysiological defects can be rectified with the help of GLP-1 based therapies. This is all physiology. We know what GLP-1 is doing in our body. Just a very quick review of the trial data on oral semaglutide. And the trials which are done with the oral semaglutide were labeled as the pioneer trials. And a good number of patients, including patients from India, have participated. And I have also been part of few of these oral semaglutide trials, including now the currently ongoing cardiovascular outcome trial, that is the sole trial that also I am the part of. You can see here Pioneer 8, that was add-on insulin trial. This I was also part of this trial, and we did this around 3-4 years ago, and those days we had seen the benefit of oral semaglutide in patients of type 2 diabetes being treated with insulin therapy. So all kind of the trials, including comparison with SGLT2, even comparison with the injectable liraglutide, all these studies already have been done. And if you look at the dark blue line, the navy blue line, that is the HbA1c lowering effect of oral semaglutide. And you can see that if compared with any molecule, the HbA1c lowering effect is maximum in these studies. And interestingly, we can see that even when it is compared with liraglutide injectable, its effects was better. In the first row, fourth, you can see Pioneer 4, that was comparison with liraglutide also. And there are reasons for that. So it's a very effective glucose lowering agent. And obviously, higher is the HbA1c, more is the HbA1c reduction. And I consider GLP-1 receptor-based therapies as, in a good number of patients, equivalent to insulin therapy in terms of these are the most effective glucose lowering therapies. There is no doubt about that. And apart from glucose lowering and weight loss, now gradually we are learning that they had cardiovascular benefits, and these cardiovascular benefits already proven with most of the human GLP-1 based molecule, including dulaglutide, semaglutide injectable, and liraglutide. And the oral semaglutide cardiovascular trial, that is SOUL trial, is still ongoing, though we have some cardiovascular trial data from a small trial which was Pioneer 6. And then subsequently, now we are learning that because of their mode of action, they are beneficial in terms of hepatic, renal, etc. There are multiple mechanisms about the cardiovascular benefit, and as you are all aware, if you look any international guideline, they say that any patient who has predominant atherosclerotic cardiovascular disease prefer a GLP-1 receptor agonist with proven benefit. And with proven benefit means all these human GLP-1 receptor agonists which has shown proven benefit. There are multiple mechanisms, and these mechanisms are direct and indirect, including their direct vascular effects. So that's how these drugs are getting a place not only in diabetes management, but also diabetes and atherosclerotic cardiovascular disease, and there the prevention of recurrence of the atherosclerotic cardiovascular events. As far as the big CVOT is concerned, that is the SOUL trial, which is still ongoing. And it is already on since around 2 years. Maybe in next 1 or 2 years, data will be out once the event number reach. This is Pioneer 6 trial, which was on a smaller number of patients, done just to prove the cardiovascular safety, not the superiority, but in this trial it is cardiovascular safe. Though there is a decrease in cardiovascular event, but it is not statistically significant because the number of participants was less in this trial, and the objective of this trial was different. So this Pioneer trial had shown cardiovascular benefit, cardiovascular mortality benefit, all-cause mortality benefit, similar to the lines which we have observed in injectable semaglutide and liraglutide. We all know that GLP-1 receptor agonist had shown specifically a good benefit in stroke reduction. Why it happens? There can be multiple benefits, but one more hypothesis is there, which is vagal mediated effect apart from their other effects in terms of vascular benefits. So many cardiovascular risk factors can be taken care with the help of GLP-1 receptor agonist. One big barrier, particularly in our country, till was its being injectable. But now since this therapy has also become oral, so at least that barrier can be very easily taken care, and we know that in clinical trial setting, in real world setting, this weight loss can be any number. In clinical trial setting, this is the weight loss, HbA1c reduction, some reduction in systolic blood pressure, and reduction in central obesity has been observed. These are the all ideal patients for oral semaglutide. Anybody who wants a weight loss, good diabetes control, good cardiovascular benefit, somebody who already had a cardiovascular event, these are good candidates. And obviously there is no risk of hypoglycemia. So a good therapy for younger patients as well. and all these trials have shown benefit and safety, and this already I had discussed. So this is the positioning of oral semaglutide, and it feels that looking to the mode of action and convenience, and that's how they call it as a game changer molecule. I call it as a game changer because it is the first protein molecule which is now available as a pill. Thank you very much.
Thank you very much. Question answer will be keeping after the session. So next speaker, over to.
Yeah, good morning, everyone. First of all, I would like to thank Bansi Sabu for making me a chair here for this GLP-1 session. I'm here to introduce Dr. Mithun Bharatiya, and he's a member Royal College of Physicians, UK, CCT Diabetes and Endocrinology, United Kingdom, Edswiller Scholar from the Mayo Clinic, United States of America, FECSM Amsterdam, Zornio T. Newman Prize in 2013 for his work on diabetes, testosterone, and erectile dysfunction. He's an RSSDI Technology National Technology Task Force member, represents India at the Worldwide AGP Academy, Clinical Academy. He's a founder secretary of the Association of Clinical Endocrinologists. Dr. Mithun Bharatiya is going to speak on cutting-edge outcomes and life-changing experiences with oral semaglutide.
Thank you, sir.
Yeah, pleasure.
Am I audible? Okay. So I thank Bansi Bhai. He's always been a kind mentor and has always helped me everywhere. And thank the chairperson for the kind introduction. It's very difficult to speak after Sunil sir because the standards are very high. So we'll just make an attempt on that. So what I'm going to do is, I've been using oral semaglutide, and I'm going to bring my experience. And one of the toughest experience was, you see, my father is also a general medicine specialist. He's been practicing for 50 years. So whenever my mother is diabetic, so whenever I have to convince my mother for something, my father stands there. He said, 50 years we have been married, you have to bypass me to actually prescribe any medication for her. And we still love our parents, and we can argue with them, but we have to follow what they say at the end of the day. That's Indian values. So it's always, so that was my experience, and that's what I'm going to share about the questions I was asked and how I answered and my experience that has been going on with that. Sir has already set the stage, and Sir has talked about snack. So I'm just going to elaborate a little few things on snack. But when this snack came, it reminded me one day, because see, after MBBS, I call it third year syndrome. Third year तक जब तक पहुँचते तब तक लगता है क्यों लिया यार, life खराब कर दी. So then you realize मैं chemistry पढ़ सकता था. So when I saw snack, it realized कि मैं क्यों chemistry नहीं पढ़ा, because I can't even pronounce that in a fashion. So it will be one time I'll do that, sodium N8,2 hydroxybenzoyl amino caprylate. But for all practical purposes, we shall call that snack only. The reason why snack is very important, and I'll make a very clear analog as to how we can understand snack. Snack is like a सारथी. हम महाभारत में देखते हैं सारथी enemy camp से ले जाके मतलब पीछे कृष्ण जी ले जाके अर्जुन को ले गया, everybody needed a good सारथी, and that is exactly what snack does in the absorption of oral semaglutide, and it enhances the absorption, as already said, by creating a pit and reducing the acidity and reducing the breakdown of gastric enzymes, which has already been demonstrated as it passes through it. So the fact that snack is now absorbed with oral semaglutide, either be 3 milligram or 7 milligram or 14 milligram, the amount of snack that we give is always 300 milligram, and I shall come that to in a slide. Why is it 300 milligram, and why cannot we do Indian jugaad system of breeding the tablet in snack? Because we all refine that. Now, Sir has talked about 50 ml of water to 120 ml of water, and if you open the pack, it says up to 120 ml of water. Now, there is a problem. 120 ml of water का glass नहीं बनता. ठीक है, Indian scenario में glasses नहीं मिलते. Now, I am in an advantageous position कि हमारे यहाँ alcohol के packs के glasses मिलते हैं, यहाँ नहीं मिलता openly. तो मैं अपने पेशेंट को बोलता हूँ, और कोई भी 60 ml का पैक नहीं बनाया आज तक, मैंने देखा नहीं. जो अल्कोहल पीते हैं वो 60 ml बनाते ही नहीं है. 60 ml करके थोड़ा सा ऊपर से नीचे चला जाता है. तो मैं उनको कहता हूँ, यू यूज़ योर 60 ml पैक का ग्लास एंड थोड़ा सा ओवरफ्लो कर लो. यू आर स्टिल विद इन द रेंज ऑफ वॉट यू नीड टू टेक विद द वाटर, so that there is no confusion among excessive water or under water. I don't know, that might not work here, but here what you can use is a half a cup of water, which is roughly 60 ml, because a cup is around 140 ml, big in size of that cup. Now, there has to be a rationale. There has to be a rationale in life why we are doing it and why not that we are doing it. So first of all, the question is, why should we give it in a fed state and not in a always in a fasting state? Because the first question the patient asks us, sir, खाने के बाद लेना है या खाने के पहले लेना है? Some of the molecules it does not matter, but in here, if you can see, in the fasting state, the PP state, there was limited absorption or detectable exposure with semaglutide. And with fasting state, we need at 30 minutes, it reached statistical significance. So that's why we need 30 minutes of fasting state while taking this medication that are there. And as you can notice in all the slides, the gastric stasis is reduced in the first hour. So the peak value comes at 1 hour post absorption. And that you will see in all the curves that I show, at 1 hour it starts getting therapeutic level that is there. Again, the question of water, which we have already discussed, and there is lesser absorption. So there is lower plasma exposure with 240 ml of water, as well as lesser. So the best state is between 50 to 120 ml of water. Now, I was in a talk in Calcutta, and somebody asked me, sir, क्या हो जाएगा? ज़्यादा ले लेंगे, क्यों ले लेंगे? मैंने कहा, देखो यार, इंडिया में महंगी दवाई है. एक तो महंगी दवाई आप पेशेंट को दे रहे हो, और वो आपका दुश्मन है, क्योंकि आप उसको बोल रहे हो एब्जॉर्प्शन भी कम कराओ, पैसे भी ज़्यादा लो. So you give him, I tell them, patient, you are taking a very expensive molecule. Make sure you get the buck of your money back. And everybody likes that in India. जो दिए उसका पाई वसूली करना चाहिए. तो अगर आप 50 से 120 ml लेते हो तो आपको उसका मैक्सिमम बेनिफिट मिल रहा है, तो उसको क्यों छोड़ने का? 0.1% भी डिफरेंट हो या 0.05 का भी HbA1c का कुछ फर्क आए, तो उसको पूरा का पूरा अपने को लेने का है. सो दैट इज द रैशनल ऑफ दिस दैट इज देयर. Post-dose effect of 30 ml results in clinical. Now, as I said, why snack is 300 and why we shouldn't break it? Can it be broken? So they looked at studies with 150 and 300 at 5 milligram. They saw lesser absorption, as you can see, with 150, and similar lesser absorption with 600. So we ideally need 300 milligram to get the maximum effect of this molecule that is there. So what we do, I'm sure in SGLT2 or various molecules, 25 milligram, we say for cost effectiveness, you take half a tablet, or any tablets we advise them. If you take half a tablet, a snack is going to be 150 milligram. So the absorption is not going to be very good. And you should not split, crush, or chew the tablet as when you are giving. So with all this, I convinced my mother to take it. She took it next day, and she took it at 7 o'clock with all the instructions. 8 o'clock, I was called at the dining table. My mother बोली क्या खिला दिया यार, पूरा जहर है मुंह में. तो I was like, अच्छा. तो I called a few patients of mine. अरे ऐसा कुछ फाउल टेस्ट लगा? बोला हाँ सर लगा. तो मैंने कहा okay. So I told my mother. So then I realized I modified this scenario. See, snack is a little foul tasting and oral semi is foul tasting. So I said, how did you take it? She said, I put the tablet in my mouth and I drank 50 ml, 60 ml as you advised. तो मैंने कहा ऐसे नहीं करने का, जैसे because there is adequate lubrication, when you have already taken a sip of water, the contact time with the tongue will be less. So now I tell my patient, you take a small sip of water first, the tongue and the whole system is lubricated, then you put the tablet and you take. And then after that, there was no problem. So this was my learning lesson from my house, and with that, if they tell me this, you take a small sip of water, then you take the tablet, then the contact time with the tongue will be less, and the patient will not have this foul taste that is there. So that was a chance discovery that I happened, and when I went back to quite a few of my patients, they also suggested that, and that I was been able to modify. Now next question, we like to break rules. In India, rule में कोई नहीं चलता. हमें rule तोड़ने में बड़ा मजा आता है. तो सवाल हमेशा ऐसे ही होता है. तो उसका जवाब भी हमने को सोचना चाहिए. So why it's a half life? Why it has to be taken daily? You're saying half life 7 days. हम alternate day कर लेते हैं हम. Why can't we do that? And the reason with that is that if we look at similar exposure levels of oral and subcut sema, it results in similar safety and effectiveness and unaffected by mode of transportation. Now, this graph will clearly explain that. See, when we are taking 3 milligram every day, 3 milligram times 7 is 21, and 1% of that is roughly equal to 0.25 of subcut sema. If you are taking 7 milligrams, 7 times 7 is 49, which is equal to 5. That is 1% of that is 0.5. And similarly, 100 milligram ka 1 milligram of subcut sema. So to have the adequate plasma levels, we need to take that on a daily basis. Now, again, this slide is very important because if you look at at 3 milligrams, 7 milligrams and 14 milligrams in pioneer studies, the upar ka niche ka, it gets a little blurred. So whatever we are taking, the absorption may vary between 80 to 120% of oral sema. And that is why it has to be taken daily to maintain the steady state in the blood, rather than, which does not happen that much in subcut sema. But with oral, there is upper niche thoda blurring. That's why we need to take it on a daily basis. Now this is the absorption, distribution, elimination, metabolism. But a key point is that it is extensively bound to plasma albumin. And so one question which I get asked, so in patients who have low albumin, will this affect the molecule because it's extensively bound to plasma albumin? So I also work as a sexologist, and I get a lot of my patients who come when they have breakups, and maybe it's a boy or a girl, and they come and say, sir, ab to kya hoga? Ab to chhod gayi ya chhod gaya. तो मैंने कहा तालाब में बहुत मछलियां हैं, तो चिंता नहीं करने का. तो similarly, if you see, even though the albumin levels are low, there is a vast excess of plasma albumin sites available to each drug molecule. So it does not really affect, even if the albumin levels are low, the concentration in clinical practice. So it's very marginal. Next question is, India mein there is a one major problem that is always there, which is gas. हर पेशेंट को गैस का प्रॉब्लम होता ही होता है. I don't know how, but all of them patient have gas, and all of them are on some molecule or not. So now in this gas patients, which is around 80% of our patients, will oral sema be accepted, will be absorbed well or not? That is a question. So they look at the study, because stomach is a predominant site of absorption, and they look at there is no difference in the exposure of semaglutide in patients with upper GI disease. Still, when a patient comes with me and says, I always take a proactive history, do you suffer from acidity, do you suffer from gas, then either if it's too much, I ask for an upper GI endoscopy, but 70% of patient bolta sir endoscopy nahi karane ka. So I do an H. pylori blood test. This is my own clinical practice. If the H. pylori blood test is positive, I treat that before I start the patient on oral semaglutide, because I don't want a drug to be blamed for something which has nothing to do and they will not take that molecule. So that is one practice which I do if I find that is happening. The question is now, in patients with renal impairment, what should be doing? Is there any, what studies are there or not? So I looked up, and they looked at the study, and US FDA has allowed this, that in patients with the elimination route is via non-renal route, the studies that have been done could be sufficient. And so they look, as I said again, look at the first hour, always there will be a spike. And that will be in all slides of oral sema you will ever see, because the first hour it will really jump and reach the therapeutic level. So renal impairment does not appear to PK properties of oral sema following 10 consecutive once daily dose. So no dose adjustment is necessary in patients with renal impairment. In fact, Pioneer 5 has shown that the HbA1c and weight reduction in patients with moderate renal impairment happens without significant increase in serious adverse events, and it is safe. Second, is it beneficial? And there's a recent study, this is by subcut sema, but it's fairly similar, which has shown that there's improvement in albuminuria in patients with especially macroalbuminuria over 1 year, 50% reduction that are there. Similar, is it safe in hepatic? And similar logic is there, and they looked at, as you can see, the spike at the first hour, and they look at 10 consecutive days dosing, and they found that no dose adjustment is needed in patients with hepatic impairment. So next question is, our patient, we have a lot of polypharmacy. And so what we do is there any interaction with this polypharmacy, what is commonly prescribed? I said 80% of our patients have gas, so they will be prescribed in PPI. So does PPI have any interaction with oral semaglutide? So they look at data with co-administration of oral semaglutide. Now even the word co-administration, I mean that it was given 30 minutes after oral sema. That does not mean it was given at the same time. And they looked at it and they found that no dose adjustment is required if oral semaglutide is administered with omeprazole that is there. Now, I'll come to this and I'll go back to that. Again, they looked at thyroxine. Hypothyroidism is very common in Indian population, and generally we take it empty stomach in the morning. So we wanted to know whether there is an interaction. They looked at, though there is an increase in the 33% of total levothyroxine, there is the total area under the curve does not change, but patients are advised to monitor their thyroid function test when they are on oral semaglutide, and more data, Indian data will come. But here I have two problems that I face, and one sir has already said. Okay, a lot of our patients have this habit of morning taking 2 glasses of water, 3 glasses of water before they even brush their teeth. Now what do I do with these patients? And second problem I have, because as an endocrinologist, a lot of my patients are on thyroid. So what is a practical work that I do when I do that? So if you look at all the data of pioneer trials, they define the fasting state. Now fasting state has to be defined. What is fasting state? 6 hours, 4 hours, 8 hours, 9 hours. What is fasting state? So in the trials that we have is 8 hours fasting state. So you can fight as much as you can, but your wife always wins. So you can put the argument in front of your patient, but it is the patient who is going to do the choice. So if I have a patient who I have really fought very difficulty and got a thyroxine level and I've struggled, then I don't do this. I ask them, in India we have 3 meals, breakfast, lunch and dinner. Breakfast, lunch are close, lunch and dinner is apart. So I tell them, वो 5 बजे का जो आप लोग नाश्ता करते हो उसको छोड़ दो, 8 घंटे का गैप हो जाता है, you can take either oral sema, 8 hours gap, because that is fasting between lunch and dinner, if I've struggled with the thyroxine. Similarly, if I'm looking at the water, I would ideally tell them, you take oral sema, आधा घंटे बाद जितना पानी पीना पी लो, लेकिन अभी पेशेंट बोले मैं छूंगा नहीं सर, मेरा पेट साफ नहीं होता, मेरा ये नहीं होता, वो नहीं होता, नहीं भी होगा तो उसके दिमाग में वो अंदर रहेगा. So this is another way I have used in practical purpose, that I use this, the studies of 8 hours. That doesn't mean the study says morning 8 hours, lunch 8 hours, 8 hours. You do lunch and dinner के पहले भी आप कर सकते हो, but you maintain that. And this is my personal experience, this is not what Novo is saying. Again, warfarin, we suggest that you monitor the frequent INR, rest we have already discussed. Now, one question that I have often asked is, SGLT2 देना है या GLP-1 देना है, EMPA देना है, because patients you want to add a drug, do you want to give EMPA or do you want to give oral semaglutide? So it's like you have doing a T20 cricket match and आप से भाई विराट कोहली को पहले opening कराऊं या रोहित शर्मा को भेजूं, अभी कौन better batsman? It's very difficult to define. So ideally we would like to open with both in the fight of diabetes, कि दोनों को डालो, अपने को maximum हर जगह से benefit चाहिए. But if you look at head-to-head trial that still exists with us, the difference between oral semaglutide and oral EMPA at 14 and 25 milligram, you can see the difference of HbA1c is around 0.5%. Now, what is a 0.5% HbA1c? See, any oral anti-diabetic drug that we give reduces HbA1c other than insulin and GLP-1, reduces HbA1c by between 0.5 to 1%, as a rough kind of a rule, be it a gliptin, be it anything. So 1% is a Barndo rule, 0.5 to 1% is what we actually look at reduction. So this might translate, does it translate to one lesser medication that you might need in the future for the patient? I don't know. But this is what the trial 0.5% signifies. And there is a slightly better weight reduction in the Pioneer trial too. When it was compared at 0.9 kilogram, it was better. So overall, what I've done is I've shared my experience. My mother is presently taking it. She is well tolerated, and homeostasis of the house is still maintained. I still am there, and most of the patients are doing it. In fact, we have submitted a poster in IDF. We've been accepted to present in IDF. We've done a multicentric real-world 3-month study, which I can't process because we're going to present that in IDF, and the results have been very good. It's been multicentric from India, but I think it's a good molecule in patients, and counseling of the patient is very important when you are doing that. The only question that I'm asked at the end is, sir, ye bahut mehenga hai. Now, mehengai is very difficult to define. So, I remember when I was started my practice, you have to start practice, you have to go in rural areas. So, I'd gone to a rural area, and I was sitting in a pharmacy, we all start like that. And I was prescribing somebody, and I didn't know usko 20 rupiya ka. I was planning to prescribe some molecule, and looking at it, he had some yellow dhoti with some holes in it. मैं सोचा इसको लिखूं नहीं लिखूं, तो I asked him कि मैं 20 रुपए का गोली लिख रहा हूँ, आप सकोगे क्या? तो गर्म हो गया उसके रिलेटिव, कहता बाहर निकलो. मैं सोचा पता नहीं क्यों बाहर निकाल रहा है. बाहर निकाल के बोलता आपको सारी जमीन जो दिख रही है ना, ये सारी इसी आदमी की है. So we are biased sometimes by our physical appearance. जो शर्ट पैंट अच्छा से आयरन करके आता है उसके पास पैसा है, जो नहीं आयरन करके आता है उसके साथ पैसा नहीं है. So I think our bias should be removed. We should tell the patient whether the patient can afford it or not afford it. That is his viewpoint. I've got patients from Shillong. They say, sir, it is my problem how I afford the best medication, not your problem. Your job is to tell me, that is why I've come and paid your fees. Your job is not to make that decision for me. With that, I end my talk, and thank you very much for your time.
Thank you, Dr. Mithun. It was really nice. You presented in a brilliant way how to deliver the goods to your patients, and that was really nice. And we are here for question and answer session from the audience. Any questions? Happy to answer.
Mike?
These days we have patients with endoscopic balloons and endoscopic sleeves and even bariatric surgery. These patients are diabesity. So what is the data available on endoscopic bariatric procedures and bariatric surgery? And many bariatric endoscopists are using it as an off-label in balloon patient to enhance the weight losing effect. Your comments, please.
Sir, your question is regarding use of GLP-1 by bariatric surgeons, basically.
Semaglutide.
Yeah, oral semaglutide, as well as, in fact, my experience of seeing the prescription was more with the injectable preparations, because I have seen very often that post-bariatric surgery, when the patients restart gaining weight, say after 2 to 3 years, these surgeons prescribe liraglutide as an injectable preparation. Now, when it comes to oral semaglutide, if they have done a sleeve gastrectomy and the area from where the GLP-1 or semaglutide is going to get absorbed, that has been removed, and at that time if they are replacing with oral semaglutide, I don't think there should be any benefit. I am not aware about any data on this. But over a period of time, when these patients put on weight and the stomach size becomes again bigger, maybe that it may be helpful. But since the oral semaglutide has been marketed only few months ago, so I think we don't have that kind of experience. But yes, with injectable liraglutide, it's a very common prescription by them.
The second issue is that we know, just like SGLT2 inhibitors, GLP-1 also, the atherosclerotic benefits are not mediated by glycemic control. So don't you think the trial should be conducted in non-diabetic patients also, just like we have SGLT2 across from diabetic to non-diabetic subset?
So I think there is a scope, and like SGLT2 inhibitor trials have been done in non-diabetic population, but if you look at that non-diabetic population that is currently is specifically only heart failure. They have not done any selectively atherosclerotic cardiovascular disease trial of SGLT2 inhibitor among diabetics and non-diabetics. And my gut feeling is most likely SGLT2 inhibitor may not be that good over there as compared to GLP-1. And yes, there has to be a GLP-1 trial in diabetic and non-diabetic myocardial infarction and stroke, like this IRIS trial was done with pioglitazone. Yeah, that will be additional thing which will come upon when we will have this SOUL trial is already ongoing, which will be cardiovascular outcome trial, but not, sir, is specifically looking for non-diabetic population. Sir's question is non-diabetic population.
I have a question for either of you. How much amount of weight loss have you seen with 14 milligrams of oral SEMA in Indian patients? Your experience over...
So I've seen, if you average it out, so about 3 months data that we had. So if you look at the data that has been there, it's around 5 kilograms across the pioneer trials. So in our data that we have said, it's around 7.8 that we have got. That's 3 months data that we are going to present in IDF. But 6 months, we are going to get some data more in December. So but some are super responders, some are less responders. But as an average, if you look at it, 5 to 6 kilograms is possible.
It's so wonderful. As you said, how do you convince your patients? Because what happens is they lose weight up to a certain extent, say 7 kilos or 8 kilos, and then they stop at that. A 130 kilo guy who would lose about 7-8 kilos, and he stops at that. Even if he continues to take oral SEMA, the weight loss doesn't continue to happen over, say, 1 year or even beyond. Say, injectable lira also. So how do you convince your patients to continue beyond 1 year or 2 years and all?
So I'll make an analogy answer to that, sir. I have my son who is in class 12 and he will get married soon. He's a boy. In all real life, I would like him to get married to a girl. So predominantly the factor is that a girl. And then he might decide girls should be good looking, with more money, more rich inheritance, that is his choice. Now, similarly, oral GLP-1 is given for diabetic control. That's a sine qua non. That's a given. I am giving it for reducing glycemic variability, bringing more time in range. Because if you look at CGMS graphs, it reduces the cobra to a snake. The weight element is on top. So I am not giving that patient, and I think that is one of the reasons why Lira and Dula didn't take up so far, because they started talking about as a weight reducing agent. So I'm giving it as an anti-glycemic agent with a possibility of weight reduction, which is an added beneficial. So I don't have a cutoff of BMI, BMI 25, I will not give oral SEMA. I'm giving it for its glycemic predominant factor, and whatever I get in weight is an added bonus.
Sir, I have one answer, sir. Any chronic disease for that matter, whether it is hyperglycemia, hypercholesterolemia, hyperlipidemia, hypertension, any chronic disease, the treatment has to be continued. So that is one of the things, apart from the way Mithun just now expressed. So the answer to your question, with 14 milligram, we have found about 5 kg. But in South, we are having a trial of a supraphysiological dose oral. We are giving up to 25 milligram by Dr. Nitin Kapoor, and the weight reduction there has been almost equivalent to bariatric surgery. And he has found almost equivalent to the injectable 2.4. So it is supraphysiological dose in Pioneer 8, and that shows even much more. But people have tolerated it because it's an open label trial. There is no blinding. So people have taken and tolerated that dose.
So wonderful. So message is glycemic control across all the anti-diabetic drugs. GLP-1 agents are wonderful agents for glycemic control, even superior to SGLT2 inhibitors. A question, please.
Sir, the drug is a very expensive one. So in your experience, once you have added oral semaglutide, have you seen a reduction for the other OHAs, because that would translate into better economic this thing for the patients? And if so, how much time is required for that to happen? Because this reduces weight also and the good glycemic control. So maybe you need to reduce the dose of an OHA or insulin or whatever else the patient is taking. And my second question is that at what point would you like to introduce oral semaglutide? Early in the history of diabetes or somewhere down the line? Thank you.
So one thing which I've been taught is that don't try to repair a boat if it's not broken. So if the HbA1c is very good on whatever current therapy is going on and everything is fine, I'm not going to prescribe oral sema for the heck of it. We are going to prescribe oral sema if the diabetes is not well controlled. So the data that we are going to present in IDF, it shows a reduction of around 0.89%. Our data is 3 months. Multicentric, Bansi Bhai is also a part of it. Dr. Jyoti Dev is a part of it. Dr. Chawla is a part of it. So we have a lot of centers in India that we are doing it. So that's around 0.89%. So if your HbA1c is above target and you want to bring in target, you need another agent to bring the HbA1c by 1%. So why do you want to reduce other molecules? Obviously, if you're going to give this, you're not going to give a gliptin, because the same mechanistic of action is going to be a superior role. So that is one molecule will come out. Otherwise, I don't change the molecule, and then he monitors his sugar, and then if required, we will, take him off the other molecules that is there. Second question was?
At what time would you, early in the disease or somewhere down the line?
So we don't know what is early disease. I can say we talk about diseases when the patient was diagnosed. That does not mean when he had the disease.
No, like at diagnosis or somewhere down the line.
So diagnosis is he could be having diabetes of 4 years and come and now realize sugar kiya to usko pata chal gaya. So we don't know exactly when is it 2 years down, 4 years down, 5 years down. So whenever, as I said, when the patient comes to me, I tell them what the data is with everything. I laid out everything and let him decide. Who am I to decide? My job is to tell the truth to the patient and to support and guide him in his clinical prescription. That is my role, well defined, because I can't cure diabetes.
Sir,
so I am there to support him.
Probably she means early in HbA1c, and not the year wise.
So if it's a yes, so if you look at the data of Pioneer, if at the higher HbA1c, the fall is more higher. And similarly, what we have got in our 3 months data, if you've started at the higher HbA1c, the drop will be more. So if you have somebody at 6.5, 6.8, 6.9, you might, what will you achieve? You come down to 6.5. You're not going to go down to 5%. Though I have some patients who have gone down further. But again, the cost has to be defined by the patient. And if you start with the higher end, the drop will definitely be more than if you start at the middle or the lower end.
So a question to Dr. Sunil Jain, if you can. Any incidences of deep vein thrombosis with semaglutide increased incidences of deep vein thrombosis?
So as such, occasional rare kind of case reports, white kind of thing has been published, but there is no causal relationship. So at present, we do not have any good information. I don't expect as such direct, because there is no mechanistic way to cause, because for that way to cause any thrombosis, the drug has to have some effect on the clotting factor and thrombotic factor. So as far as we are not aware of, so these are, I don't think that at present there is any such kind of causal relationship information is available. Just one thing which we are aware of, since we are talking of DVT, we know that gallstone disease and GLP-1 receptor agonists always have a relationship.
Right. Thank you. I think we can finish the session and over to the next, please. Yeah, thank you very much. Thanks, everyone.
Very, very lucid way of presentation by both the speakers. And thank you so much, Dr. Sunil M. Jain, sir, from the Indore, and Dr. Mithun Bhartia from Guwahati. Also thankful to Dr. Raghu Satyanarayan, sir, for the nicely way of chairing the session, and also thankful to Dr. Sunil P. Mehta. Can we have a huge round of applause once again for all these dignitaries? Yes, thank you so much. So now it's time to move ahead for the next session. For this next session, we have a chairperson. He is someone who is head of the department and professor at Gujarat Adani Institute of Medical Science, Bhuj. And also he is an ex-president of APA, Ahmedabad, also carrying extensive experience of 35 years in the field of diabetology, none other than Dr. Jayesh Trivedi, sir. So I would like to invite Dr. Jayesh Trivedi, sir, to chair the session. Most welcome, sir. And we have also another chairperson for this upcoming session, Dr. Mohammad Riaz. He is MBBS and MD, also a medical director and a chief consultant physician and a diabetologist at Isani Diabetes and Multi-Speciality Center, Hyderabad. So most welcome Dr. Mohammad Riaz to come on a stage. Thank you so much, both the chairpersons. Now this session is hand over to you. I would like to request you to have a brief introduction of the speakers for this next session. Over to you, sir. Thank you.
We would like to extend our thanks to Bansi for a wonderful conference, and we are really obliged. And as a guest, he has come all the way from Hyderabad. I give all his privilege of chairing this session to him.
Thank you, Jay sir, for the kind words. At the onset, I would thank Bansi Sabu sir to give an opportunity to be the chairperson for this topic. Basically, this is an insulin symposium which will be dealt by three eminent speakers. One is Dr. Navneet Shah. Next will be Dr. Jyotitwa Dev sir, which is well known to everybody, followed by the professor, and everyone follows the footstep is Dr. A.K. Das. To start the ball rolling, the first speaker will be Dr. Navneet Shah. Sir has done MD in 1979 from GU University, and he is an ex-professor and head of the medicine, and he heads the Department of Diabetes and Endocrinology. Sir has been the director and Department of Diabetes and Endocrinology at Sterling Hospital in Ahmedabad. And sir is honorary diabetologist to His Excellency Sri Governor of Gujarat. And he has contributed multiple chapters as well as book publications have been done. And many papers have been published in JAPI and GMJ. And he was an ex-president of APA. Apart from it, sir has been awarded B.N. Malhotra Mehta Oration by IMA Ahmedabad in 2006, and he has also received a rotating leadership award in 1997 on behalf of Association of Physicians of Gujarat. I hand over the session to Dr. Navneet Shah sir, and he'll be speaking on human insulin, that is basically getting the best balances between the efficacy and affordability. Sir, the podium is yours.
Good morning, friends. And at the outset, let me thank Dr. Bansi for inviting me to speak on conventional insulins. Thank you, chairpersons, for your kind introduction. And I'm extremely happy to share the dais with people like MTech in diabetes, Master of Technology, Jyoti Dev, and the teacher of the teachers, Professor Das, who are going to speak after me. So thank you very much. And then now today's topic is little different. Everybody talks about the advancement, and then you had a kind of car like Fiat and Ambassador to then Marutis and now BMW and all luxury car. I am going a step backward. And there is a partly science and partly economics in the talk. So let us see what we want to say. The first thing which we know is that whenever we use a medication, we compare efficacy versus cost, whether this medicine is cost effective or not. So whatever you spend money, whether you get the enough return. And Dr. Varathia said about the return, so return is very important. We know everything about diabetes like global burden, and then we also know what are the typical Indian patients, their BMI, their beta cell dysfunction, high PPG excursions, and we are carboholic, like we have a very high carbohydrate diets, and that is what we have seen, and that is why we are on the top of the diabetesity epidemic. And all across the globe, I mean all across the country, north, south, west, east, our carbohydrate consumption is very high, and that is why we are also known as carboholic now. And around 65 to 70% of our daily energy comes from the carbohydrate, that is starch. So we are, as Dr. Shashank always said, that we are sarcopenic, where our muscle mass is less, our fat is high, and that is what we actually are facing, and that is why our protein consumption is less and our carbohydrate consumption is very high. Not only that, we are peculiarly postprandial sugar people. So most of the times we focus only on the postprandial glucose control. And if you see here the comparison between the Caucasians and the other populations versus Indians, then our postprandial excursion is more, and that partly because of the genetics and more likely to be because of the carbohydrate consumption. And again, we are absolutely in a either post-meal or post-absorptive state in 24 hours a day. Now, what is healthcare expenditure in India? So there are few studies reported the expenditure spent in managing the diabetes in India, like annual median direct cost in all across north, south, it is from ranging from 11,000 to almost 20,000 to in north it is very high, that is 45,000 Indian rupees. And annual median indirect cost of the treating diabetes is around 2,500 to 12,000 rupees. So that is very important, huge cost is involved. Believe me, when a parent comes to me and his child is diabetes and type 1, then it is equivalent to another child in the family. That is the cost of managing a diabetic child in the family. So it is a huge burden which we must remember. Again, diabetes management poses high economic burden, and 34% of the annual income of the adult type 2 diabetes patient goes in diabetes management. And this study was done with A. Ramchandran and et al. Long back in the year 2007. So there is a huge cost of managing diabetes is very important. Now we all know that insulin is one of the important hormones. Once Dr. Bhansali said that what is the most important hormone in the endocrine system, then it is insulin. If you don't have insulin, you cannot live for more than a certain period of time. All other hormone deficiency we have seen can last little longer than the insulin deficiency. So it is a vital drug, and some 5.6 million Indians must take daily to manage their diabetes and prevent the complication. However, the affordability of medication in general and for insulin specifically is currently of great concern to the people with diabetes, their families, and the healthcare providers. Another important thing is that most of the times, barring a few patients who have reimbursement from the government or from their organization, most of the patients, they spend their expenditure from their pocket, because in our setup, up till now, there is no reimbursement of outdoor medication to the patient. However, now we are hearing that some outdoor medicines are also going to be reimbursed. So that is very important thing. Those patients who are on an outdoor basis and taking treatment as an outdoor patient, their reimbursement is not that, so they have to spend money from their pocket. We know that insulin is needed. We know about the insulin inertia and the duration almost 8 to 10 years before starting insulin. Till then, we go for diet, exercise, drugs, and whatever it is. And then after 8 to 10 years of duration of diabetes, and with the A1C of more than 9%, it is the time where usually patients with diabetes are willing to take insulin. So that is a very important thing. But when we talk about insulin, why insulin is not prescribed frequently, and what are the reasons, which we'll now dissect little later. But remember, the 35% patients of diabetes require insulin therapy, and we know that those patients with a shorter duration, their requirement would be around 1.8% within 6 months, but as the time goes by, their requirement goes up. So here, if we break up, out of these 35% of the patients, the human insulin is around 70%, analogs are around 30%, and combinations are around 3%. As I said earlier, that 1.8% of the patients with duration of less than half year or 6 months required insulin therapy, but then when the duration goes high, above 20 years, almost 50% of the population need insulin. Many of the type 2 patients would need 2 injections in a day, and type 1, 3 or 4 injections in a day, and the insulin requirement would be around 5 to 1 units per kg in type 2, and it could be 1 to 1.5 units in type 2 diabetes per kg, and that is the cost would be around 2 to 3 vials depending upon the strength of the vials or the pens, and 6 vials per month respectively in type 2 diabetic patients. So it is the high cost of insulin dates back to the history. When insulin was invented in 22-23, then the Banting and Best refused to take the patent on their name for this insulin, because it is a drug which is going to be used for mass, and they forfeit their profits of royalty for this injection. So they sold the insulin patent to the University of Toronto for a mere $1. Look at the act at that point of time. And they wanted everyone who needed their medication to be able to afford it. Cost is a big factor around the diabetes. A study highlighted around 25% of the patients of diabetes confessed about the cost-related underuse of insulin, and this is clearly related to poor glycemic patients. So we know the insulin inertia is, there are many causes, but cost is also one of the important cause for patients agreeing to take insulin. Around 66% of these individuals also faced hardships in purchasing the diabetes equipment, suggesting wider cost barriers in the management of diabetes. So it is not the only insulin. They would need pen, they would need needles, and they would also need monitoring, and so many things are required for these patients. And poor glycemic control was more prevalent among the patients who reported cost-related underuse than among the patients who did not have financial issues. So cost is a very big factor. Now what happened? The people, because of the cost also, they cut down their insulin doses, they skip their doses sometimes, and there are so many things happening, and that also is a contributory factor for poor control of diabetes. When cost is high or not affordable, then there is a non-adherence, and then ultimately it leads to poor glycemic control. And 45% of the patients with type 2 diabetes fail to achieve adequate glycemic control below 7% in this situation. So medical adherence also is related to the high cost of medicine that we must remember. And that is why cost, non-compliance, poor glycemic control, percentage of patients being non-compliant ranges from 30 to 64% and 19 to 46% for users of OAD and insulin respectively. And almost 40% of the patient type 2 diabetes do not meet A1C goal, suggesting poor glycemic control, which could be still more. And now we have seen in many studies that 75% of the population of type 2 diabetes is not under control. So patients with diabetes involved in cost-related underuse of insulin are threefold more likely to have poor glycemic control. So consequences of poor poor insulin adherence would be inadequate glycemic control, increased morbidity, mortality, and increased cost of outpatient care, ER visits, hospitalization, and increased cost of managing complications. So the issue is now, we have seen the revolution right from the animal source insulin, which were not purified, to the human insulins, and then recombinant human insulins purified, and then now analogs. Everybody talks about analogs, whether it is short-acting analogs, whether it is a long-acting analogs, or whether it is a pre-mix analogs, and then also now people talk about the co-formulations. So what is important is that when we talk about, so those patients who really cannot afford the luxury insulin, which I would tell, or the costly insulin, if they are offered the conventional human insulin, it would be equally effective in efficacy, in side effects, and the other things. So that is a thing which we must remember, that cost is a very important factor. Here you can see that postprandial glycemic control was significantly improved without increasing risk of hypoglycemia, and overall control was similar in patients with type 2 and type 1 diabetes treated on either twice daily regimen with immediate pre-meal injections of bias. And if you compared with the human premix insulin, that was very slightly difference, which may not be having a p-value significance difference, but only numerical difference. So that this study was done by Dr. Boehm in 2002. Insulin analogs, is there a compelling case to use them? So what is important, that shall we use analogs only in all patients coming to us, or where we have to judiciously decide that this patient really needs analogs and this patient may do away with the conventional human insulin if cost is a constraint. So across the evaluation of all comparisons, only 15 of 64, 23% showed significant increase in lowering the A1C with the analogs than the human insulin. And the weighted difference was very small in comparison to analogs. So that is, this was published in Diabetes Care in 2014. Human insulin is cost effective and safe, and if you look at Diabetes Care article, the same article, it said that regular insulin is just as effective as rapid acting insulin analogs. Similarly, NPH is also not less efficient in controlling the diabetes in comparison to analogs like Glargine and Datamir. And so, there are two exceptions which have been mentioned in this article, that type 1 diabetic patients require basal analog insulin because they produce no endogenous insulin. It would be better to use insulin analog. And for those patients in the unusual occurrence of overnight hypoglycemia in type 2 diabetes who ingest bedtime snack, it may be helpful to prescribe an analog with rapid acting insulin before supper, and if hypoglycemia occurs early overnight, a basal analog will be useful. So hypoglycemia related to these things would be very useful, and we can also see the impact of treatment non-compliance on mortality, which can be seen from here, that those who are non-compliant have 1.6 times increase in all-cause mortality in these patients. We also know about the glycemic control in UK, PDS and DCCT, so we will not go in those details. But what is the global voice? Global voice is very strong, that Americans, high cost of insulin sends American to Canada, where it is 90% cheaper, to Mexico, where the insulin is cheaper. Parents did some protest to price gouging insulin manufacturers, and families across the border in search of affordable insulin went to Israel, Italy, Germany, Greece, Taiwan, and Canada, all countries where the insulin is bought for this patient. So very important thing is that the cost of insulin is not only for us, but for all, even the developed countries across the world, which is very important. And now, we are talking about the insulin, the biosimilar insulins and the other brands of insulin. Americans also talk about the generic medicine and generic drugs for reducing the cost of medicine. World Health Organization also recommends that insulin should be available at all times at a price the individual can afford and the community can afford. So that is very important. Even ADA recommendations also said about the same, that providers should be aware of rising cost of insulin, and this negatively impacts the adherence to the clinical treatment by people with diabetes. So addressing the insulin access and affordability, an endocrine statement also voices the similar concerns about the cost of insulins and availability of the insulin to the needy at an appropriate and reasonable cost. So this is also very important thing. Efficacy of human insulin versus analog, whether we are talking about the efficacy, whether we are talking about the hypoglycemia, whether we are talking about the nocturnal hypoglycemia, all these slides, they tell us that there is a marginal difference, and where those who cannot afford analogs, we should not hesitate to give them conventional insulin for having good control of diabetes. Efficacy of human insulin versus analogs also, we can see that there is some difference, but that difference, and if you look at the cost effectiveness, then this difference can be wiped out, and we can see that human insulin can be given. ADA statement on cost consideration. Consideration of cost is an important component of effective management for many patients with type 2 diabetes with relaxed A1C goal, low rates of hypoglycemia, prominent insulin resistance, as well as those with cost concern. Human insulin may be the appropriate choice of therapy, and clinicians should be familiar with its use, and this statement came in 2022. So that is a very important thing. Likewise, biosimilars, if you look at the cost of innovator, one biosimilar and the other biosimilar, there is 20 to 40% of the reductions in biosimilars also. Likewise, here also, if you look at the cost in India and cost in USA, there is a huge gap of the cost of insulin in both the countries. So, friends, sorry for this slide, but this also tells us the same thing. And so impact of biosimilar insulin on healthcare delivery also is seen from here, that there are more savings and better healthcare even with biosimilar insulins. So in summary, I would say that cost of insulin has been rising steadily at a pace several fold that of other medical expenditures, thus contributing to significant burden and hence and non-adherence to treatment. Advantage of reduced hypoglycemia of newer long-acting basal insulin analogs over NPH are only modest in actual practice. Similarly, no important difference in A1C and hypoglycemia observed with rapid-acting insulin analogs over human regular insulin. Therefore, consideration of cost is an important component of effective diabetes management in appropriate individuals. And lastly, for many patients with type 2 diabetes, those patients who do not need very stringent control, they can do away with little higher diabetes control. They can also be used human insulin instead of analogs. And achieving the best balance between the efficacy and affordability is the need of time for effective diabetes management. So, a car can take you where do you want to go, whether you travel in BMW or whether you travel in Honda. That is a story which we must remember. And thank you very much for kind listening. Thank you.
Thank you, Navneet bhai. As usual, you are always very good. Please, go ahead.
The next speaker, I think he doesn't require much introduction. He's a tech savvy, and I'm mesmerized and always follow his footsteps right from the third conference of ATT, that's Advanced Treatment and Technologies of Diabetes, where I have followed Jyotitva Dev sir. And he is basically an MBBS and MD, which he has done from Government Medical College, Trivandrum. Apart from it, he has done fellowship in endocrinology from Mayo Clinic, United States of America, and is the chairman of Jyotitva Dev Diabetic Research Center, which is at Kochi, which is well-known diabetic center, which I am aware of it. And he is also a managing trustee. Apart from it, he is an editor-in-chief of International Journal of Diabetes and Technology, and he conducts monthly diabetes education programs via by YouTube channels, which are one is named as Jyotitva Dev and second is Kesav Dev Trust. And he has published multiple papers, and every month he publishes internet-based free diabetes newsletter for almost more than a decade. And JDC is basically the center which Sir practices, is accredited to RSSDI, where Sir conducts certificate programs in diabetology for doctors. So podium is for you. The topic which Sir will be talking is basically in regards to benefit of timely initiation of interchangeable glargine in uncontrolled OAD patients in type 2 diabetes mellitus.
Thank you. Thank you very much, Dr. Muhammad Riyaz, for the kind words and for the kind introduction. So once again, thanks to my dear brother, Dr. Banting Sabu, for this kind invitation. And hello to everyone sitting over here. It sounds as if this is a very common title, and this probably you could have listened earlier too. But today, I am going to focus on something which is a continuation to what Navneet sir has said, and that is on cost-effective solutions for our own country. So we need to customize. All the patients are not the same. And we need to choose the best for our patients. We are all clinicians. That is the reason why we are here attending this conference. And this happens to us almost every day. Every second this happens to us. And a person is in front of you, and you are there as a doctor. And whom to blame? The hemoglobin A1C remains the same. Whom to blame? Is it the doctor to be blamed or the patient to be blamed? And I will say that in more than 50% of the cases, the doctor has also to be blamed for the high hemoglobin A1C, because we have our own limitations, we have our own the so-called clinical inertia, and there are multiple reasons why you are probably not going ahead with the next step in the management of diabetes. And this is that scenario. A 52-year-old female, thanks to Dr. Praveen, my dear friend from Biocon, for sharing this slide with me. And this is a lady with 8 years duration of diabetes, 8 years. And a classical case, a case which is in front of you in your clinic. And during the COVID times, during the past 2 years, the hemoglobin A1C has gradually gone up, and this has happened to many of our patients, many patients. So now, when we are with a person in our clinic, and sir is agreeing with me, the average hemoglobin A1C is around 9, 10, 11. So that is the scenario now, very common. And she says that she is obeying your command, she is exercising, trying to exercise despite limitations, she is trying to be adhering to the diet and the drugs, but despite all these, the so-called obedient patient, despite that, the hemoglobin A1C is rising. And she is on 3 oral therapies. She is on, unfortunately, the highest dose of glimepiride, already on very high dose of glimepiride, metformin is there, and the gliptin is there, along with other usual medications for diabetes. So luckily for her, the renal function, you can see it is normal. And there is early neuropathy. And this is also a representation of a fairly early person. So it is not an advanced diabetes, not advanced for all these complications to set in. So now is the time for you to prescribe a medicine. So you have examined the person, you have gone through the laboratory report, and now you are brainstorming. What should you be prescribed? What should be the change in the prescription? So should I be changing the dose of gliptin? Should I be switching over to another gliptin? Not necessarily, because the hemoglobin A1C, as you can see here, it is 9.8%. So even if you are going to change, nothing more is going to happen. So you probably will not be able to bring down the hemoglobin A1C to more than 0.25 or 0.3% further. And addition of a fourth agent. Remember the fact that the person is here before you believing that you are a good doctor. And she is already on 3 oral medications. And if you are going to start another one, if you are adding a 4th agent, actually you are not doing any justice to that patient. So the best idea here, the best option for you as a responsible doctor will be to go for insulin. Of course, you can send her for a counseling, you can send her to the registered dietitian, all these can be done. But the solution is you have to start her on insulin because she is already on 3 oral medications. And this happens to many, many of our patients. Why is my student failing in the examination? Is it because I am not a good teacher? Is it because she is not a good learner? Something to do with the syllabus? You have to find out. You have to find out the reason. But in my practice, and I know that in most of your practices, if the duration of diabetes is 5 years or approximately, I would say that 7 years or more, and if the hemoglobin A1C remains higher than 7%, it is better that you don't wait. There may be many oral medications available. There may be many, maybe generic medications available, and it may further reduce the hemoglobin A1C a little bit. But if you are a sincere doctor, who is aware of insulinopenia, progressive decline in the insulin secretory capacity of the beta cells, if you are aware of the glucotoxicity which can happen to the beta cells, go for insulin because that is the best and that is time tested. And insulin is now 1 years old, and that is the best remedy for diabetes. And it can be considered, insulin can be considered in multiple scenarios. And I will say that use your common sense. Use your common sense, and now you have multiple choices for insulin. You have expensive insulins, you have inexpensive insulins, you have human insulins, you have analog insulins. But in the presence, in the background of a persisting hyperglycemia, in the background of a person who is already on steroids or infection or pregnancy, don't wait. Watching and waiting is no longer tolerated in the management of diabetes. And let me ask you a question. Why are you here? You are here to learn something. You are here to learn something from Dr. Benchi's friends. And Dr. Benchi is conducting program all over the world. And why is the patient coming to you? The patient is coming to you because he could have gone to some other nearby doctor. He could have gone to an indigenous doctor nearby. But the person with diabetes is attending your clinic and is with you for your prescription because he believes that you are getting updated, you are learning a lot, you are updated with your knowledge, and he believes you as a doctor that you will give him the best. You will give him the best based on evidence. And that is where you have to be sincere with your patient. And the patient believes that you are a brilliant doctor who knows about the beta cell functional decline, and you are brilliant enough to provide the person not just short-term outcomes, but also better long-term outcomes in diabetes. Because this entity is very, very important. Long-term outcomes in diabetes after 10 years or after 20 years of onset of diabetes. And here is the conflict, whether you should be starting insulin late or early. If you are starting insulin after the onset of a retinopathy or a neuropathy or a cardiovascular disease, of course it is very, very late. It is very late. You have to start insulin very, very early in diabetes. These are, because I have included only one of our own studies, and this we have presented at the AS meeting long ago. And this is from our electronic medical records, telemedicine data. And just 57 patients followed up for a period of 10 years. Insulin always need not result in weight gain. When you are practicing structured monitoring of blood glucose, SSMPG, and when you are carefully and when you are smart enough in titrating the dose of insulin, insulin will not produce hypoglycemia, and insulin need not produce. And in this study, you can see that not only the hemoglobin A1C has dropped, there was also a significant reduction in the total daily dose of insulin at the end of 1 decade, and there was also weight loss at the end of 1 decade. And this happens when you can avoid hypoglycemia by just providing the essential dose of insulin. And this has also appeared in multiple media along with the ACE meeting. So there are benefits. You know all the benefits, and I need not repeat all those benefits of early insulin initiation. in protecting the beta cells, and in ensuring the long-term efficacy in preventing the complications of diabetes. Why I am repeatedly showing these slides? There is a reason why we are exposed to some of these slides repeatedly, because you can discuss the same numbers and the same reasons with your own patients. The patients need not be that educated. But with basic education, you can start a conversation and you can extend the dialogue and you can discuss all these possibilities. This is why I am offering you insulin, because I know what will happen to you after 5 years. I know what will happen to you after 10 years. And that is exactly the reason why I am discussing the possibility of putting you on an analog basal insulin. And look at the reduction in the death which can happen. If I can reduce hemoglobin A1C by 1%, I can reduce the death in diabetes by 21%, myocard infarction by 14%. All these numbers can be discussed. The microvascular complications, retinopathy, neuropathy, and nephropathy, with 1% reduction, it comes down to 37% reduction in the complications. And these are known to us for many, many decades. But the only difference here is there are around 100,000 new doctors every year passing in India, MBBS doctors. So we need to repeatedly educate. We need to be repeatedly exposed to the education and the new knowledge. And not only with respect to the reduction in the complications, you know that every 30 seconds, 2 legs are being amputated. So you can discuss with the person with diabetes. There will be relatives in the family. There will be somebody known to the patient who could have underwent an amputation. With just 1% reduction in the hemoglobin A1C, the amputations are reduced by 43%. So all these possibilities, but these are all positive things. You are not discussing any negative things. You are discussing about the positive outcomes the patients can experience by starting insulin early. And by offering them with a basal insulin, you are also ensuring that there is minimal occurrence of hypoglycemia. This is 40 study which demonstrated minimal weight gain. When compared to premix insulins, basal insulins have got multiple other advantages. And many patients will ask you, can I be only on insulin with type 2 diabetes? Can I stop all the oral drugs? Can I be only on insulin? And that is the time when you can tell them there are multiple reasons for type 2 diabetes. There are multiple pathophysiological defects in type 2 diabetes. Apart from insulin secretory deficiency, there is insulin resistance. There is a defect in the renal tubule. So you have to be on 2 or 3, maybe 2 oral medications along with insulin. And insulin cannot be given alone. And that you have to repeatedly tell them. Basal insulin, although I am offering a glargine as a basal insulin, that cannot be alone given to you. It needs to be combined with 1 or 2 other oral therapies. So there are global recommendations. So I am not deciding on my own, my dear friend. I am deciding based on the recommendations made by global as well as the national scientific organizations. So this is our own beloved IDF, ADA, ACE. And if you are suspecting on your own efficacy, your own capacity on deciding on the dose of insulin, the beginning dose or the initial dose can be 0.1 to 0.0 units per kilogram to start with the basal insulin. So this is fairly a very safe way of starting insulin so that you are not inducing hypoglycemia. So 0.1 unit per kilogram body weight. Very small dose, or you can start with 8 units or 10 units of basal insulin, provided make sure that you are titrating, you are changing or modifying the dose of insulin at least twice a week or at least once a week. And there are other choices. There are other choices as well. Why not start on a premix insulin? Because that is another very commonly used insulin. But at the expense of weight gain, at the expense of a hypoglycemia. Because there are chances that you start the person on 10 units of a premix insulin, and on the 4th day, he might fall unconscious because of a hypoglycemia, and they will not come back to you. Because if you are starting them on a basal insulin such as glargine with very low instances of hypoglycemia, then there are more chances that the patient will follow up with you. Otherwise, you may even lose the person. And the other choice is going for an NPH insulin. Have a second thought. Should I be going for NPH insulin? NPH is fairly an old insulin. NPH is there for multiple decades all over the world. Of course, you can start her on NPH insulin, provided the priority is only the cost. But if you are considering the science, you are going back in the discovery. Because there are multiple other options which has come after the discovery of NPH insulin. And here we have started here on glargine, and we have started 0.1 unit per kilogram, and ultimately at the end of 3 months, we have gone up to 32 units. And we have been very successful as a doctor in bringing down the A1C from 9 to 7.4%. So very successful without any episodes of hypoglycemia, and she is using an insulin pen. So whenever possible, if you go through the discovery or innovation related to insulin delivery devices, that has also been a phenomenal innovation. So we have multiple newer innovations for delivering insulin. So offer them with an insulin pen, which is also cost effective, which is convenient. So whenever you are making a choice, make it comfortable for the person. And how do you decide on going to the next step in the management? So from basal insulin, if after a few months or if after a few years, if you feel as if diabetes is not controlled, that is a time when you have to introduce one more insulin. One more insulin, and that can be a prandial insulin. And this is the most scientific way of titrating the dose of insulin. If you are starting the person on a premix insulin, the person needs to match the diet with the insulin dose. Whereas in contrast to that scenario, here you are matching the dose of insulin with the diet that she is going to consume. So here, if you are uptitrating the dose of insulin, you can go up to 1 unit per kilogram, which is a very high dose for a basal insulin. And if in case the person cannot tolerate, if in case the person is experiencing a hypoglycemia, or if the postprandials are elevated, this is a time when you have to introduce a bolus insulin as well. Lovely picture, isn't it? So this is only to symbolize your love, your sincerity and commitment to your patient. When you are offering them an insulin, when you are offering them with one of the best, glargine is still the world leader in insulin, as one of the safest insulin. And this is how you can decide on a bolus dose of insulin. So you start with basal, and then you can start with, if necessary, 3, 4 or 6 units of a bolus insulin, such as Epidra, before the largest meal of the day. And if you want to do some little bit of mathematics, this is how you can do the maths. A dose based on the patient's weight will be 0.05 units per kilogram. And you need the support. You need to refer to the international guidelines. We have the American Diabetes Association strongly recommending a basal insulin, and then adding on to the basal a bolus. And then you have, I like ACE more than ADA because ACE is more scientific. ACE is more structured in creating the guidelines. So you can start with 1 bolus, then you can move up to 2 bolus dosages if required, and then finally you can establish a basal bolus regimen. Whereas the insulin dose will be minimal, optimized for only the diet the person is consuming. So I repeat, in contrast to premix, when you are using a basal or a basal plus, the dose of insulin is optimized only for the diet the lady is consuming. And if you are again concerned about how you are going to titrate the dosages of insulin, you have the guidelines, international as well as national. So these are all very simple guidelines. Ask the person to just measure the fasting glucose levels repeatedly or once in 2 or 3 days. And based on the fasting glucose levels, if it is above 180, you give approximately 8 units, or you can even give 4 units. So this is another simplified version of the algorithm from RSSDI ESI guidelines, where we were all there. And this is how you have to decide. If the fasting is more than 180, you can add 4 units to the existing basal. If it is more than 140, add 2 units. If it is more than 110, add 1 unit. Remember, you have to decide and you have to customize what is the required fasting target for the person, so that you are not inducing a hypo. If in case there is a hypoglycemia, you have to drastically reduce the dose of the basal insulin. So this is the take-home point. In India, we do have multiple choices of insulin now, but there is only one interchangeable basal analog insulin currently available in India. So I was speaking to my dear friend Ajit, and Ajit Pal Singh sir was telling me that all over the world, there is only one interchangeable basal analog insulin, and that is the definition. Interchangeable means one medicine can be substituted for the other, and this can be done even by a pharmacist in the United States. And this is done because the substituted or the changed interchangeable medication will have the same clinical effect, exactly the same clinical benefit in the given clinical scenario. And that is the comparison between the two insulins, the reference or the innovator glargine when compared to the interchangeable glargine, and that is from our own India, made in India. What is the difference? And this is what you can discuss further with your patient, or you can brainstorm on yourselves or with your colleagues. The huge difference in the cost, the huge economic difference the made in India innovation can make. And these are the take-home points. We need to be responsible. We need to be responsible as doctors practicing in India to provide the best. But in diabetes, I think time matters. I have only 40 seconds left. Okay, so time matters in diabetes. If you are waiting and watching, your patient is going to develop all those devastating complications. So let us be responsible doctors, offering the best at the right time for our patients with diabetes. Thank you very much, my dear friends, for the patient hearing.
We'll take question answers at a later stage.
Now the next talk will be given by none other than Dr. A.K. Das sir, who is well known. I think he doesn't require much introduction. Many of us are students of his, followers of his, and we follow the footsteps of sir. Sir basically is a consultant physician and endocrinologist, and at the Pondicherry Institute of Medical Sciences and New Medical Center, that is at Pondicherry. And sir is a patron of RSSDI. Sir is a co-chair of ICMR India B study, and sir is a chair of Diabetes in Young Registry and former national president of RSSDI and API, and sir is a former dean of Indian College of Physicians. Apart from it, sir was also a former professor and head of the endocrinology at JIPMER and PIMS. Sir, I warmly hand over the session to you, and the topic which sir will be dealing is in regards to time to move the needle, that is interchangeable glargine, the plethora of evidence. Sir, podium is yours.
Thank you very much, and my dear esteemed chairpersons and our very dear friends. It's a talk before the lunch, and I assure you I'll finish it before time. Dear friends, we just now saw from the two earlier talks, the basic tenet of the talk was that insulin is an imperative need at the appropriate time. And not to give insulin that particular time is no more acceptable today. There are two sayings which I have taken from Sanofi. They said two important things. They said, we start insulin late and escalate still later. That is applicable to all insulin therapy. We start late and escalate later. So the theme of the three talks that we have put in the program is to look into that and see how we can give most affordable, appropriate, available and accessible insulin to everybody in our country. Dear friends, I must tell you that insulin is a molecule which has a molecular weight about 5,800 kilodaltons. There are 5 characteristics of this insulin. Number one, it comes from the living organism, from the yeast or from whatever culture, bacteria or the animal cells. It is a comprehensive physicochemical structure which can be seen by the spectroscopy. And all the insulins so far has to be given parenterally, either IV, IM or SC. And they are very sensitive to temperature and also to the manufacturing condition. And finally, since they are proteins, they are also immunogenic. Dear friends, I work with the Government of India, and Government of India is very fond of biosimilars. I must tell you why. Forget about the field of diabetes. In the field of cancer, the biosimilars have taken over, and it has made the treatment affordable to everybody in the country. Almost all the anti-cancer drugs are biosimilars. What is a biosimilar insulin? A biosimilar insulin is basically a biological drug that is similar to an existing insulin. It can be similar to aspar, similar to glargine, similar to degludec. It is similar to one existing insulin, but cannot be considered an exact copy. Therefore, what you should do, you should compare it. You should generate evidences. That's my job today. You have to prove to the world, to the CDSCO or to the DCGI, to whoever the appropriate authority, that this drug is not exact copy of the original drug, but it is potent and it is equal in its action. And you know, there are different manufacturing processes, like we have different cell lines, we have the different protein source, extraction, purification, so the difference. Now, since they're derived from the living cells and done by biotechnology, they're very heterogeneous and also makes them very difficult to standardize. Therefore, there is a need for generating evidences to say that they work, which Jyoti beautifully said, that insulin has to be given and affordable insulin is in need of the time. And please remember, this is a tagline that Government of India accepts, that biosimilars are not bioidenticals. They are not biomimics. And as claimed by many, they are not biobetter. So they are biosimilars are biosimilars. They come to stay in our country and many countries of the world. I'll show you 39 countries where this has been accepted. They are biosimilars which does the job with absolutely perfectly. Dear friend, this is a slide which all of you know. I just want to put it here to say that, you know, there's a rising prevalence of diabetes, and the focus on the South Asian countries vis-a-vis world, you will find that 1 in 11 adults today are living with diabetes. The number of adult diabetes expect to reach 133 millions by 2030 and about 152 by 2045. 1 in 2 are still undiagnosed, and a very large mortality globally, and 700,000 and beyond, and about lot of money, $10 billion. And this is a very important slide, which was alluded to some time back. I must tell you that there's a clinical inertia in the real world for the treatment of type 2 diabetes, besides what Jyoti has described so clearly. You know, if you want, there are 2 types of intensification. To make oral drugs intensify from 1 to 2, 2 to 3, or to intensify insulin. Now, if somebody is on 1 oral drug and the H1C is beyond 7, to intensify to 2, we take 3 years. Just imagine. And we are a country where diabetology is science. We are a country where Department of Diabetology is established in 17 medical colleges today, 17 medical colleges. And the National Board is considering for a very particular course for diabetes. If the percentage of 2 anti-diabetic drugs and the H1C again beyond 7, I'm not defining how much beyond, we take 7.2 years to add the 3rd drug or change over to insulin. So there's a lot of insulin, the tablet inertia. But coming to the median time to intensify insulin, you look at if somebody is on 1 OAD and H1C is 8.7%, we take 7.1 years to change over to insulin from single oral drug. Even on the 2 oral drugs and the H1C of 9.1%, we take 6.1 years to change over to insulin. This is not my own data. This data from somebody from this part of the country living in the United Kingdom now, Kamlesh Khunti, and this is the data from 81,000 patients over a data link. So, you know, so this is a very important thing to say, that we have a lot of inertia in initiating insulin. Now, this I will not say so beautifully. My colleague has said, I will not throw this, but I want to draw attention to this particular sense. Beyond DCCT, beyond UKPDS, beyond ACCORD, beyond BADT, beyond any study, in 1985, BMJ gave a slogan, which is the last sentence of this slide, which was not in Jyoti's slide, so I wanted to project this. The insulin provides a great sense of well-being. So we are talking today glycemic happiness, euglycemic euphoria. So this well-being is given by insulin. You ask anybody, they will say you that. You know, we in South, Professor Mohan honors people who live 100 years despite diabetes. That's called full life despite diabetes program. Majority of them say they're on insulin. They have a great sense of well-being. We have to give a scientific data to the world, which we're doing today. Dear friends, I will not say this further to save time. You know, the H1C reduction by 1% gives you benefit which we cannot imagine. Death prevented more than 20%, micro complications almost 40%, and MI by 15%. This is a theme which has been discussed by my friends very well. I will not say this again. But dear friends, I will see that if you look at the low and the middle, LMIC and MMIC is the word that we use in the government sector. If you look at the insulin volume use, I'll just make a long story short to say that the majority of the global insulins comes from 3 companies. And they take 92% of the insulin used in the LMIC and MMIC. Only 8% trickles down to the companies that we have in our country, only 8%. Dear friends, if you look at the Access Diabetes Care, I'm not repeating what has been discussed again. I took out those slides. You will find that tens of thousands of type 1 diabetics who need insulin to survive, and 30 million beyond type 2 diabetics who require insulin do not have access to a reliable and affordable supply. 86% of type 2 diabetics are unable to access the insulin they need. This is Africa data from the Africa. And 63% households with low-income countries are unable to afford insulin at all. Dear friends, you have heard the name of Ban Ki-moon. Ban Ki-moon was the famous proverbial UN Secretary General. He was there for 10 years for the first time. And it was between 2007 and 2016. And that's the time when I was in the ministry. And we had a lot of interaction with him. I learned 3 things from him. It is in the record. Number 1, he said that he never gave the concept of Millennium Development Goals. ये सरकारी भाषा है, और sustainable development, all of us know sustainable development goal, MDG and SDG. The second concept he gave, he appealed to the G17 countries that they have to take care of the health and education of all the countries. The third thing he said, which is very prophetic for our discussion today, Ban Ki-moon's statement still resounds in our ears, and it's noted. He said, there's a great disparity in the treatment of diabetes in our country. He said there's a 10/90 global diabetes expense paradox. He said 90% of the entire expense for diabetes goes to 10% of the people. 90% expense, 10% people, that's the other side of the globe. Only 10% of the entire expense comes to the 90% people who are with diabetes. I think it was a very prophetic statement. He made this statement in 2015, and it is still true, still true. Dear friends, this is another statement. Excuse me for Sarkari statements. This is the talk by another person from Gujarat, Mr. Mandavia, to whom I report today. He is the Minister of Health. Now, he said in a meeting about 4 or 5 days back, the nation's health is moved by 2 issues. I don't know how it took it up. I've never expected. He said nation's health is moved by 2 things. One is research, innovation. I think it was prophetic. Maybe his talk was prepared by Rajesh Bhushan. Rajesh Bhushan is my secretary. I don't know, but he said this, very prophetic. No, 2 things are important, research and innovation. And he said that we must have the Made in India pride. That is, he has taken from PM. Now, I'll give one example. One biosimilar insulin, you know which one is this, brought down the prices of the new insulin. It was selling at 400 plus, it came down to 157, gradually went up, but it came down drastically in all the insulins. And also, if you look at the topic which Dr. Jyoti Dev just hinted and left for me to give the evidences, this Biocon's interchangeable insulin is again a made in India story, and is a remarkable insulin with a great quality, appropriateness, affordability, and some robust clinical data I'll present to you. Now, I will also very, very, very passionate to present this slide that you will find the price of insulin has increased over the years 3 times, from 2002 to 2013. Look at the price of the oral drugs. They're at the same or they have come down. They have come down today. Generic orals are for a song. So, the price of insulin has developed by 3 times. Therefore, we have to see whether this interchangeable glargine, we have enough evidence to use it, because you cannot use something which has no evidence. We practice evidence-based medicine, so my job is that only today. This has been shown by Dr. Jyoti. I will not show that. I must tell you that this insulin glargine, interchangeable glargine, has been approved in the major markets of the country. US FDA approval in 2020, EMA in 2018, and interchangeable designation, I'll come to that at the end of my talk. It came last year. It has been used in India from 2009. It has been used in Korea 2018, PMDA, Malaysia, TGA. It has been used in many countries in the world today. And look at the type of research and the evidence generation exercise has gone through. It has gone through global phase 3 trial for the type 1 diabetic. We call it InStride 1 for about 560 patients of 52 weeks tried in US, Canada, Czech Republic, Estonia, Germany, Hungary, Latvia, Romania, Slovakia, SA, and UK. And also it has gone through the trial in the type 2 diabetes, that's called InStride 2 in the US. It's completed, and many other countries. And it has also gone trial on the switching, because that was necessary for the approval, for certain approval by the US FDA and other countries. It has gone a switch approval, which I'll describe in a minute. That's called InStride 3 study. Apart from that, we have few short studies from our country and other countries, which I'll describe to you. One of the authors of the other study also is here in this meeting, and you will see what data we have from this. Dear friends, beyond that, I'll be very quick to add. They have gone to global, Japan, PKPD studies, the process change studies, etc. I have no time to discuss. InStride 1 described about the non-inferiority compared to the. So there are two types of glargine. I am not allowed to take the trade names. So therefore, to make the matters clear and non-confusing, I have put the trade names in the bracket, which is allowed in a talk. So we'll be comparing the efficacy and safety of this new interchangeable insulin glargine with the reference insulin glargine. This is interchangeable Biocon insulin is termed Bejalog. That will be first time and last time I'll be mentioning. And the reference insulin that we have is the insulin Lantus from the Sanofi. That's only time I'll do it with quote in quote, and that's where you will find it with the quote in quote. So it was first InStride 1 to show the efficacy and safety of Biocon glargine compared to the reference insulin glargine in type 1 diabetes, called InStride 1 study. Now, objective was to determine whether this Biocon glargine once daily is non-inferior. I told you we are not bio-better. Non-inferior to reference insulin glargine once daily when administered in combination, Jyoti said, with a mealtime insulin, main mealtime insulin, with insulin Lispro in these patients. This is a multi-center, open-label, randomized, open-label because it is given by the pen. They have to use the pen, so it was open-label. There was no blinding. A parallel group study, comparative phase 3 study. There were 558 type 1 diabetes patients. H1C was more than 9.5. And between 18 to 65 years, treated once daily insulin. The screening for 4 weeks, run-in for 6 weeks, then randomized 1:1, once to Biocon's insulin, other is the reference insulin, and followed up for 4 weeks. Now you will find that the HbA1c by both the insulins are superimposed upon each other. Can you see that? It's superimposed each other. It's almost similar at the week 12, 24, week 52, week 36, that's superimposed. Also the fasting glucose also superimpose each other. Therefore, it is shown here that the actual H1C and actual fasting plasma insulin are very similar. So the conclusion was the mean difference between the Biocon glargine and the reference insulin glargine was similar at weeks 24 and 52, no statistical significant difference, and levels of H1C for the patient receiving Biocon glargine and reference glargine decreased during run-in period. Both basal and the bolus insulin dose, Lispro and the basal insulin, remain the same in both the groups, and the hypoglycemia adverse effects are almost similar. Coming to type 2 diabetes, it was non-inferiority to in the type 2 diabetes. Again, it was 2 cases more, 560 cases, to determine whether this biased insulin glargine once daily is non-inferior to the reference insulin in once daily when administered along with the oral drugs in type 2 diabetes mellitus, multi-center study, 560 patients. Type 2 diabetes patients were about at least 1 year before screening. They had type 2 diabetes established, stable dose of an OAD for 3 months before screening, either insulin naive or they might be taking insulin glargine once daily before. Screening randomized 1:1, biosimilar insulin glargine given for 24 weeks, reference insulin glargine for 24 weeks, and followed for 4 weeks. And it was shown that the H1C over time, you see both the lines, the Biocon glargine and the reference glargine are almost similar. And the reduction in the H1C was minus 0.6, 0.66, statistical not significant, and it was a non-inferior to the, both ways it was non-inferior, and the mean actual glargine dose used over time was also very similar. Therefore, mean change in H1C baseline to week 24 and the change in the fasting plasma level were similar. Rates of hypoglycemia and other adverse reactions were also very similar. The third study was the switch study, which was looked at the efficacy, insulin dose, safety, and immunogenicity when people with type 1 diabetic mellitus switched between Biocon's insulin glargine and reference insulin glargine. I made it clear here. The patients were taken from the first study, inside one study, and they were in arm A or arm B. Arm B continued the reference insulin, the which I put in bracket here, Lantus, for the entire 36 period. The arm A, they first took the biosimilar insulin because they are already on the insulin, the reference glargine. So they for 12 weeks plus Lispro. Then after 12 weeks they were changed over to reference insulin, that is the Lantus insulin plus Lispro. Again after 12 weeks changed over to biosimilar insulin, which is Bezalog and plus Lispro. To make a long story short, it was found the robust design for adequate switch period. It was mandatory for getting a certificate from the periods, the 3 periods, and the change in H1C from the baseline to the week 36 with Biocon's insulin glargine was equivalent to reference glargine. So, dear friend, the anytime hypoglycemia was similar, that means side effects were similar, and the other adverse effects were similar, and also the immunogenicity data in both the insulins were similar. Dear friends, depending on these two data, the US FDA approved the first interchangeable biosimilar insulin product for treatment of diabetes, the first one to get in the world, and so that is our pride. The US FDA approved the first interchangeable biosimilar insulin product indicated to improve the glycemic control, and approval can provide patients with additional safe, high quality, potentially cost effective. The cost was shown by Dr. Jyoti. I will not put that again. So that's a great data. This has been also evidence from India for about chronic kidney disease patients. I have 20 seconds more. In 44 type 2 diabetes mellitus with financial constraints, it was changed over to interchangeable biosimilar glargine, and the evidences were minus 2.83 H1C reduction in 12 weeks, which is very significant, similar to the original innovator insulin, and therefore this is also a switch study, and this also showed it is beneficial. So, dear friends, I will change by saying that the many challenges with insulin like affordability, early insulinization, prevent complications, and rising economic burden can be answered to a great extent by this interchangeable insulin glargine. Thank you very much for patient hearing.
Thank you so much. Actually, we are running back 15 minutes. We are short of time. We'll take three questions. We have 3 speakers. Please come on the chair. Sir, come on the dais, sir. Navneet Bhai, sir. We'll take 3 questions if there are any questions from your side. I think everything is very, very clear, and probably we are having hypoglycemia.
No, I think there are 2 things, Bansi. One is called switching, and other is called interchangeability. In our country, pharmacists do not prescribe the drug. They have no power to change. So that is applicable only to the United States. But the switching is for HCP, like you and me. So it gives indication, authority, clinical evidence, and the burden of proof and approval from the DCGI that it can be used by the SCP as an interchangeable insulin.
That's fine. But in USA, why interchangeability we could get only for Biocon? Even before that, the glargine from the Eli Lilly was also available, and why they could not get it?
Because they could not produce those type of data, na? You have to give a switching data. Switching data. I think
don't think, because it's not available 15 years. I'm talking of Eli Lilly Glargine, which is.
Sir, can I add a point?
Yeah.
If you don't mind.
Yeah, please.
So to have the switching or the interchange approval, they have to do a clinical study to prove
That's
that.
what I'm telling you, no?
So in this, what we have done is Insight 3 study, what has been mandated by US FDA has been submitted to get the US FDA designation. So which the Eli Lilly did not do, so they did not get the IC approval, but whereas we went into the market and we got the study done, and on that basis where we have done the approval.
Dedicated some trial which US
The
FDA
Insight
had
3, what
asked.
Dr. Ashok sir spoke
It is
about.
switching study. From the type 1 diabetics, Instride 1 patients who was on the insulin lantus, they were given 12 weeks of reference insulin glargine interchangeable. After 12 weeks, they were again changed over to insulin lantus, like a double blind lantus. Again after 12 weeks, changed over to again
Switch over.
So these 4 switches happened, and these 4 switches showed to the FDA by the data that they are comparable. There is no adverse side effects. There is no hypoglycemia, no SAE, and that's why they got the approval. The switching study is very important, mandated by FDA to get the approval for the switch and interchangeability. Interchangeability doesn't apply to our country because we have not empowered pharmacists, but switching is our SCP. So we can switch whenever needed for a patient, like Jyoti showed 22,000 stock, expense saving. We can change at our level. We have the approval for changing over to this.
They did it for both the things, the type 1, type 2 in
Yeah,
both
both
the
the
cases.
things. Instride 1 for type 1, Instride 2 was for type 2, and the switching was mandated by FDA to be done.
I have a comment to make. I think the quality of the biosimilars are equally good as per the standard of that. But in our country, it is the availability and cold chain transport that makes us little skeptical about using this instrument.
I think that also has been mandated by the DCGI because there are checks and breaks to see the potency, and we have established an NIB in Delhi, National Institute of Biologicals. I think the potency of all the batches. Am I clear? I think Sabir from Novo is here. Sabir is here, and Praveen is here. All the companies, every batch has to undergo the studies at NIB, no? NIB, National Institute of Biologicals.
Submit the 3 batch samples to NIB, and we do also keep a reserve samples with us. Though the batch might be out of the market, but yes, we do keep that. So if there are any issues, then we analyze from the internal batch sample and produce a variability piece.
So it cannot get into the market without that, and that is, we have a full institute for that.
So, Dr. Praveen, am I right in telling that with all the available biosimilars, the biosimilar from Glargine, that is from Biocon, it has got the maximum clinical data available in terms of Instride 1. So Dasar has
So we
present
did
Instride
studies
1, Instride 2.
globally across.
So when compared to other biosimilar Glargines, yours is having the maximum data with you. And I know that it has been used in many parts of the world for more than 10-15 years.
39 countries
Yeah,
nowadays.
yeah.
So we have 2 incidents, RHA and also the Besalog, the Biocon's Glargine. So we have almost 59 countries across the globe for the Glargine, and almost 70 to 80 countries across the globe for RHI. That's where the data stands in.
And never been had any setbacks.
No, sir. No, as of
so
now.
far, so good.
Thank you, sir.
Thank you.
Thanks, Chairperson, and thanks all 3 speakers. We will have a few interesting things immediately post-lunch. How many of you know that India's first World Heritage City was Ahmedabad? It was declared in 2013, and hardly people know. And this World Heritage City, we are going to have our next year APCON 2023. So we will release short video. Madam will release. She is our Dean for Indian College of Physicians. And we will also have Professor A.K. Das and Shashank Joshi, who is the past president of API and very close associated with APCON and with me and with RSSDI. I'll be missing my teacher, my madam, Dr. Ashan Shah, who is the organizing chair of the meeting. But we have with us Dr. Navneet Bhai, and he will be with me along with some of my colleagues and friends from Ahmedabad who are actively involved with API, so that we will be releasing. But many of you may not know that it was the first Indian city which was declared as a World Heritage City in 2013, and that short video which we have created for Ahmedabad, and we'll be inviting everyone across the country, all parts of Gujarat, and everyone from Ahmedabad to be part of, who are medical practitioner, practicing medicine, physician, to be part of this great, grand, successful EPICON. Thank you very much. Now we have lunch. Lunch will be up to 2 o'clock, and we'll be sharp starting 2 o'clock with that video, and then we will move forward. For all faculty, we have on the first floor, there is a faculty lounge. And for the delegates, there is a lunch designated area also. Thank you very much, sir.
I hope the lunch was so delicious for all of you. Yes? Yes. So now it's time to move ahead for the next session. The next session's chairperson, just I would like to invite the first chairperson for this session. He's a by profession MBBS as well as MD and Doctorate of Medicine, consultant physician, and a life membership of Indian Medical Association, and immediate past president of APA. He's none other than Dr. Kamlesh Patania. I would like to request Dr. Kamlesh Patania to come on the stage. Thank you. Let's have a huge round of applause for the chairperson. Thank you. And second doctor, he is MD Medicine and PGDDM from United Kingdom, and consultant diabetologist in metabolic physician, Dr. Maulik Kinariwala. I would like to request Dr. Maulik Kinariwala to join the stage. Yeah. So thank you so much, both the dignitaries. Now session is over to you. I would like to request you to call the speakers on a stage with this brief introduction. Thank you.
Good afternoon all. For the first talk and newer insulin symposium, I would like to invite Dr. Kalyan Kumar Gangopadhyay sir. He is MD in 1996, and from 2007 to 2009, he is consultant in Diabetes University Hospital in UK, investigator in so many trials. Sir has won a prize in UK. He has so many national as well as international publication and book chapter 6. Sir, please, sir.
Thank you, Chairperson, sir. So, delicious food, उसके बाद अच्छा नींद भी होता है. So, my financial disclosure is this, but I've got an academic disclosure to make. So, you see, मेरे PSM और pathology में number कम आया करता था, क्योंकि all the lectures used to occur after lunch. So, after 10-15 minutes, I used to be in a different world. So, post-lunch session are the most challenging. So, I'll try my best to keep you awake so you can listen to Dr. Pathak's talk. So, this is I'm going to talk about real-world evidence. There are multiple real-world evidence, and then I will tell you a little bit about a few of my cases, because there are practical problems which occur. कि ऐसा होने से क्या करना है? This nowhere it's written in the books, nowhere is written in the guidelines, nowhere is written in RCTs. What is the next step? So IDEG-ASP is best suited. We know that it tackles both fasting and PP. PP is very important for us, given our lifestyle, given our type of food that we eat. And initially, Novo Nordisk had started it just twice a day, but I always had the viewpoint that it should be initiated first once a day for those patients, for most of the patients actually, and then we can escalate it to twice a day. So you've got multiple RCTs. It's one of the most widely studied insulin co-formulation, the only one. So you've got evidence from real-world evidence and RCTs. So real-world evidence is very important because RCTs में एक result आया, real-world में similar result आया, then we have full confidence in that molecule. If there is discordant, and mind you, there are a lot of instances in medical literature कि RCT में अच्छा है, real world में नहीं आया, real world में अच्छा है, RCT में नहीं आया. So if both support each other, then we have more confidence in the molecule. So there are multiple real world evidence. I'm just going to tell you about a few of them. So this is the first one. I think it's Dr. Kalra and the pointer is not working. It's Dr. Kalra and Manoshpatim Barua. I think this was retrospective observational study of patients with type 2 diabetes, whether they are on tablets or insulin, switching to IDEG-ASP for about 48 patients for about 1 year. Okay, so the HbA1c drop you can see is significant. Now the important thing is this was achieved at a lower insulin dose, and most of the real world evidence supports it. कि HbA1c drop हुआ, लेकिन insulin dose उतना ही रहा या उससे कम रहा. That's an important observation noted. So this was presented in ADA by Jyoti Dev. So type 2 diabetes, about more than 150 patients, duration of diabetes 11 years. So you can see again here, HbA1c drop quite significant, about 1%. There was a fasting blood sugar drop close to 40. There was no PP here, but for me, PP is also important, so I'll highlight some of the real-world evidence which suggests the PP data as well. This is another one which was presented in IDF, again more close to 300 patients with diabetes of 11 years and followed up for close to 1 year. Now here the PP is here. So if you say OHA only, so you can see the HbA1c drop is close to 2%. So OHA ले रहे हैं, tablets ले रहे हैं, अब आप insulin IDAS दिए हैं, close to 2% HbA1c drop. But look at the fasting sugar drop is about 45 and PP is close to 130. So that's relevant because if you just use a basal insulin only, you will get this, but you may not get this. So that's very important, that you get a big postprandial drop as well. But one thing of note, which I observed, and I'll tell you later on, that patients who are on insulin also get this. So this was another study wherein it was compared IDAS versus glargine U100 and versus glargine U300. So you can see here, the drop in the HbA1c was most with the IDAS. So about 15% drop in the HbA1c as opposed to 10 and 9 for 100 and 300. Unsurprisingly, you have got a big PP drop here, but you have also got an equally big fasting sugar drop. So you're tackling both fasting and PP with this. And as I said again, look at the insulin dose requirements. It is much less as compared to others. So that's the good thing about it, is tackle fasting and PP, and as well as you get the HbA1c drop. So the other thing is hypoglycemia. That seems to be in between U100 and U300, the hypoglycemia. Mind you, if you add a rapid-acting insulin, one would expect that there will be slightly more hypoglycemia, but there wasn't. So the ARISE study is one of the largest multi-center, multinational trial with IDAS. And here you can see the countries, Malaysia, India, Saudi Arabia, Australia, South Africa. So it was the physician's prerogative to start treatment with IDAS. Globally, there was about 1.4% drop, and for Indian patients it was 1.6%. The fasting sugar drop was about 50, globally as well as for Indian patients as well, so similar. Now, this is the important bit. So patients who were uncontrolled on OADs, you get about 1.9% drop in HbA1c. Who were uncontrolled on basal insulin, you get a slightly higher drop in HbA1c. That is important. So you would expect that somebody is already on insulin, और एक insulin तो चल ही रहा है, और क्या additional मिलेगा? So you get a bigger drop. And this comes at a much less hypoglycemia. So if you see this is non-severe hypoglycemia. So at 4 weeks before the study, starting the IDAS, this were the number of non-severe hypoglycemic episodes, which came down to 162, and later on it came down furthermore. Severe hypoglycemic episodes, look at the drastic reduction in the severe hypoglycemic episodes. So you're getting an HbA1c drop, you're getting much less hypoglycemia, and you're targeting the PP sugar as well. SMART study is another study by Jyoti Dev, patients who received IDAS. So again, insulin treated about 1.8% and OAD treated 1.7%. So it didn't matter really if you're on tablets or insulin, you would expect a similar drop in HbA1c with a lower dose but with less hypoglycemia. So change in fasting sugar was about 50. Change in PP breakfast was 82, PP lunch was about 74. Again, hypoglycemia. So as the time progressed, you get much less hypoglycemia. See, these were the events before starting IDAS, and this was 12 months, 1 year after starting. Severe hypoglycemia before starting is this, and at 12 months, virtually none. So I think starting IDAS in patients with type 2 diabetes, so if you ask me whom to start, would you choose particular patients? Now, the question of cost, of course, in our country will come up, and we have to weigh in. But first, what I tend to decide when I see a patient is that, and I want it for myself as well if I develop diabetes and have got HbA1c, high HbA1c, is what's the best molecule for me? So I will think that this is the best molecule for this person. Now, if the person can afford, I'll give it. Cannot afford, then I will look at alternatives, rather than finding out subgroups where I can use. But if you push me, the subgroups there are busy lifestyle, erratic food habits, mainly PP sugar is more, elderly patients, where, starting intensifying from basal to basal plus, you require 2 pens. Here it is 1 pen, which makes it much more convenient. So those were the real world evidence. So now I'm going to show you some real life, my cases, and the problems I had, and the mistakes I made. So the balanced view, if we look at it, what's the advantages? It addresses the PP sugar. So as an insulin initiator molecule, it addresses PP. Many cases, once daily dose might be enough. And if you want to intensify, you can intensify with the same pen. And you have got robust data, RCT, real world, thousands and lakhs of patients. But the downside, आपने शुरू किया, fasting ठीक है, PP बढ़ गया. Now, that's a real problem. I still struggle with a small minority of patients who have this. Now, if I increase the IDA gas, PP might come down, but fasting might drop below 70. So that is a problem. How to tackle that? Another problem was asked by one PGT to me. Sir, you are giving IDA gas before lunch and before dinner. So you're giving too close together. There will be stacking. Stacking means there will be hypoglycemia. So that's another concept which we have to clear. So let us come to two of them. But first, importantly, the importance, whenever you have to start insulin, this is what I tell myself and I tell my students as well, कि इंसुलिन शुरू करने के पहले पेशेंट का डाइट हिस्ट्री लेना बहुत ज़रूरी है. During weekdays, what does he or she take? During the weekends and holiday, what does he or she take, and what time that person take? That is crucial, as is highlighted in this case. So yeah, patient, I have not gone into great detail, otherwise it will cloud the main issue. So this was a 50-year-old housewife, homemaker, fasting sugar 220, PP 250 on OHS, sulfonylurea, metformin. Now, clear answer to this. अरे इसका तो fasting ज़्यादा है, PP का difference नहीं है, तो उससे basal insulin is the answer. Correct. So I started basal insulin. But when I started basal insulin, her blood sugars began to, fasting sugars came around 90 to 100, but she began to have hyperglycemia during the daytime. Mistake? My mistake. Why? Diet history not taken properly. So I did a CGMS. Now you see, this green zone is the zone where it should be. Now this is 6 o'clock in the morning, 8 o'clock in the morning. This is 8 p.m., this is 10 p.m. As you can see, during the daytime, blood sugars are nearly close to the green line. Something happens here and the PP sugar goes up and it stays up throughout the night. So whenever I do the CGMS, I read the CGMS data, I can understand what is happening, then I turn the result to the patient and I tell them, आप बोलिए क्यों बढ़ रहा है इस जगह में, आप मुझे जरा गाइड करिए. The patients themselves say, ये जगह में तो मैंने कुछ किया था, ये खाया था, वो किया था, इस जगह में मैं रोज यही खाता हूँ. Answer is there and you can target it. So what happened for this lady was, in the morning, बोले बच्चे स्कूल में जाते हैं, husband businessman है, चले जाते हैं, so I have a very small snack, tea biscuit. And lunchtime, nobody is at home, so I have very light snack, lunch. In the evening, everybody comes back and we have a big, hearty dinner. So that is the reason you are getting this spike. So how have I addressed it? I've just given a basal insulin. The basal insulin se kya hua? This fasting sugar came down, but the daytime sugars, it dropped below this range, in the hyperglycemic range. So what I should have done, taken a proper diet history first, then basal के साथ एक bolus जोड़ना चाहिए था to tackle this postprandial surge at dinner time, क्योंकि उसका problem उधर ही है. I cannot ask her to change her lifestyle completely. It's very difficult to change lifestyle completely. Easy for me to stand in this podium and say, जे आप एकदम अच्छे से only green vegetables लो और रोज 1 घंटा दौड़ो. So always is not possible. So you have to tailor it to the patient in front of you. So basal plus bolus would have been good for her. But I gave only basal. So I changed it to an IDA gas, which I directed I gave her before dinner, and that seemed to solve the problem. Now, the other problem is, in Bengal particularly, and it is probably applicable to rest of our country as well, weekday and weekend food, timing and type of food is completely different. So that's where the idea gap, if you take once a week, you can target it. So typical weekday working people, they take a big bowl of rice in the morning, lunch is usually very small, and dinner they come and have roti. And on Sundays, reverse. Breakfast is light, but lunch is very heavy. So if I write in the prescription, now if you see in the weekday, the surge, postprandial surge is maximum in the breakfast. And during the weekend, the postprandial surge is maximum at lunchtime. So if I write in the prescription, you take Rhizodec just before breakfast, तो वो Sunday को भी breakfast के पहले लेंगे. Then you will get hypoglycemia here on weekend, on the holidays. So I write in my prescription, working days, take it before breakfast, weekend, holidays, take it before lunch, explain to the patient. Takes not more than 1 minute. And that will solve most of your hypoglycemia problems. Then, next patient, and this is the last case, I think. So, premix 42 and 44. And patient was on sitagliptin, metformin, voglibose. HbA1c 8.333, fasting 133, PP is high. So here the problem is, fasting is okay, lunch PP is high, but the patient was having hypoglycemic symptoms before lunch. So even if I change it to IDA-GASP before breakfast and dinner, same problem persists. So what was the problem? Problem was the diet history. So again, light breakfast, patient was taking heavy lunch, heavy dinner. So I'm giving IDA-GASP here and here. So patient was getting hypoglycemia here. So that was the problem. So if I switch and give the IDA-GASP here and here, before lunch and before dinner, that will sort the postprandial surge, that will prevent the pre-lunch hypoglycemia from occurring, and that I will show you the result. With that, what happened. Oh, I don't have that, sorry. So with that, the patient's PP sugar seemed to normalize. He didn't have any pre-lunch hypoglycemia. So the question asked by my PGT, कि आप पास में दे रहे हैं long-acting insulin, so will it beget stacking? Insulin jump के stacking हो जाएगा, hypoglycemia होगा. So let me clarify that question, because this has been asked quite often. So if you see here, if you inject insulin, this is insulin level. So if I inject a rapid-acting insulin, insulin level goes up like this. At this point, sugar level is low because the insulin level is quite high. So then the insulin level begins to come down. So sugar is going up now. So insulin level would have come down right here. But after 2 hours, before the action was over of the rapid insulin, I check the blood sugar, अरे sugar तो बढ़ रहा है. Then I give another shot of a rapid-acting insulin. My aim was to get the insulin level here. But pushing down, at this level, the blood sugar is very high. So you will get yo-yo effect if you miss one dose. But for a long-acting insulin, if you miss one dose, it will only have a small jerk. Again, if you give double dose, the insulin level goes sky high here. This is the stacking effect occurring. Now, if you give a double dose, same dose again, you will have a very little impact because of the long-acting nature of the insulin. So that's the thing which explains the stacking. Now, PGT को समझ में नहीं आया पूरी तरह से, तो वो बोला yes sir. तो you can make out from the eyes नहीं, कि इसको समझ में नहीं आया. तो बोला तुमने सच बात बोलो, समझे? नहीं. तो कैसे समझाए? So that's why I hope you follow cricket. So I've given the example of cricket. So I'll tell you how. So this is Sachin Tendulkar. That's his batting average, 53.79. In the last match, so this is a long-acting basal insulin, Sachin Tendulkar. In the last match, he made 74 runs. If he had made 0 runs, his average would be 53.6. So see, there's nothing much difference. If he had made 200 runs, it will be 53.85, something like this. Not much difference. On the other hand, Shikhar Dhawan, when we first started, in his 3 matches, his average was 81. If he had made 0 in one of them, his average would have dropped to 46. So this is a bolus insulin. ये बात अच्छे से समझ में आ गई उनको PGT को. So I think the real world evidence which has shown is important. It should be similar to the RCT which is there. And I've shown you some snippets, some cases wherein I had difficulty in adjusting, and I've told you how best to go around it. If you know the PK/PD of the insulin, you can deal with it accordingly. With that, I end. Thank you very much.
Thank you, sir, for the nice talk. We will take question answers later on at the end of the whole session. For the next talk, I would like to invite Dr. Sanjeev Phatak, sir. Sir does not require any introduction. Sir will talk on achieving glycemic summary with newer basal analogs. Please, sir.
Thank you, Chairperson. Both of the colleagues are my very close friends. Thank you, Dr. Bansi and the team of Diacare. Thank you, RX Events, for giving me this opportunity. And I can see everyone awake, Dr. Kalyan, with very interesting talk you gave. And the final 6 you hit with Sachin Tendulkar and Shikhar Dhawan. So I'll be talking about whether to start basal insulin, because as per his talk, there is no scope of basal insulin now. But yes, there are some patients definitely who require basal insulin only and not bolus to start with. So my talk is centered upon achieving the glycemic symmetry with newer basal insulin analog. Of course, the insulin he talked about also contained the same basal insulin, but it was a co-formulation of a short-acting and a long-acting one. My financial disclosure, this has been a Novo symposium, and obviously the views which I will be presenting will be unbiased. So I'll also start with a case, 45-year-old gentleman. He is an engineer, diabetic for 6 years. His HbA1c is 8.8, and his fasting is 180, postprandial is 220. I'll not go into the details of other things because we are going to focus mainly on the glycemic control here. So you can clearly see that he has high fasting and slightly high PP, but of course if you control the fasting, his postprandial will come down. Let me tell you, Dr. Kalyan, that I had taken the full diet history and every PPBS was almost in the same range. So the dietary difference was not that great so as to influence his postprandial every time. Patient was already on 3 anti-diabetic agents, metformin 2 gram per day, glimepiride 2 milligram twice a day, and empagliflozin once a day. Now, how many of you will add a 4th drug here? 4th oral agent. Patient is not on AGI or a DPP4. No one. So, no, people should be very happy that everyone is agreeing for insulin. So, what next? Obviously, this patient requires, because patient is already on 3 OADs, not controlled, HbA1c is 8.8, that is about 1.8% above what we expect, at least 7%. His fasting is quite high, so insulin is the only choice. But according to ADA, before considering insulin, one should give a thought to GLP-1 analogs because they are also as efficacious or in some trials more efficacious than basal insulin. So GLP-1s should also be given a thought. Unfortunately, in our country, GLP-1 agonists are very expensive still. Though they are very good agents, many of our patients cannot afford and many of them cannot tolerate also. So the obvious choice becomes here, if GLP-1 cannot be given, it has to be insulin. The ADA also recommends initiation with basal insulin, but there is a mention about the co-formulation also there, as Dr. Kalyan already told you. Now, which basal insulin? The choice depends on patient-specific characteristics, cost, and number of other things. So, which factors should be considered before prescribing a basal insulin? Efficacy, obviously the first. Risk of hypoglycemia with similar efficacy. Glycemic variability, simplicity, and obviously cost. Now, if you look at the data from degludec, that is Resiba, you can see that there is a very good HbA1c reduction with the baseline of average of 8, 8.5 or 9. You can see an HbA1c reduction of up to 1.4, 1.6%, which is what we want in this patient. 8.8, we want about 7%. So the efficacy of degludec, there is no doubt, is very good. You can say at par with the other basal insulins, with some trials showing more efficacy, some trials showing equal degree of efficacy with all the basal insulins. When I mean basal insulins, we are talking about glargine U100, glargine U300, and degludec, where detamir is also a basal insulin but less popular because it does not last for 24 hours, and that is why less popularly used except in the pregnant patients. The second most important thing, or rather I would say the most important thing, is the risk of hypoglycemia with each insulin. And you can see from this slide that compared to U100 glargine, the risk of hypoglycemia with degludec is much lower. If you look at this BEGIN study, the overall hypoglycemia is 28% less. Nocturnal, which you are more worried about, is 49% less, and severe hypoglycemia requiring assistance or hospitalization is 86% less with degludec compared to glargine U100. If you look at the SWITCH-2 study, almost similar data, significant reduction in the degree of hypoglycemia or the risk of hypoglycemia. The DEVOTE, which was a cardiovascular outcome study comparing degludec and glargine, again there also you can see nocturnal and severe hypoglycemia almost 40 to 50% less. And the real world evidence, again as Dr. Gangopadhyay told, if you have both the evidences, the real world and the randomized control trial, you are more assured of the overall efficacy and safety. So in the real world also you can see compared to U100 glargine, that is Lantus, the hypoglycemia risk is 60 to 90% lower with insulin degludec. Very importantly, with higher HbA1c, the risk of hypoglycemia may be similar with all the insulins. But as close you go to 7, you can see from this slide that with insulin glargine, if you are closer to 7.5 or 7, the risk of hypoglycemic events increases very, very significantly. Whereas with insulin degludec, the risk does not increase, and that is the beauty of this insulin, that even if you want to up-titrate to reach the goal of fasting or HbA1c, you are not increasing the risk of hypoglycemia significantly. Though some risk always remain whatever insulin, whichever insulin you use, but the risk does not increase even if you are nearer to the target. And that is very important. Another analysis that came out from the DEVOTE cardiovascular trial was if the risk of hypoglycemia is high, or if the patient is at a high risk of developing hypoglycemia, with degludec, the cardiovascular events or the MACE events were much less. So in high risk people, especially people with established cardiovascular disease, people with autonomic dysfunction, or who had hypoglycemias in the past, they had much lower events compared to U100 glargine. So again, there is a case here that if the patient is high risk and if patient is developing hypoglycemia, he is an established cardiovascular disease patient, degludec definitely will have an edge over U100 glargine for this particular candidate. Let us talk about the CONCLUDE study, and it was a randomized controlled trial in insulin experienced patients, not insulin naive patients. And let us look at the hypoglycemia results in that. In the maintenance period, overall and the nocturnal symptomatic hypoglycemias, the overall hypoglycemias were not less, but the nocturnal symptomatic, as I told, it is very, very important, and the severe hypoglycemias were much less with degludec compared to U300 glargine. Here the comparison is with U300 glargine. And during the total treatment period, again, there was a statistical advantage with degludec compared to U300 glargine for overall symptomatic hypoglycemias, nocturnal symptomatic hypoglycemias, as well as for the severe hypoglycemias. So compared to U300 glargine also, degludec has shown superior, or rather better efficacy as far as the hypoglycemia is concerned. This is a real world study, and the hypoglycemia results in the real world study comparing degludec with U300 glargine, there also you can see that the rate of hypoglycemia as well as the change in proportion with hypoglycemia both were significantly lower with insulin degludec compared to U300 glargine. Everyone talks about the glycemic variability these days. I'm not going to talk a lot about that because the subsequent talk is on the glycemic variability with insulin degludec compared to the other insulin, the real world evidence. But if you look at the variability pharmacology wise, you can see that the area under the curve and the glucose insulin, these are all claim studies. If you look at this, degludec delivers equal amount of insulin every 6 hours. So whether it's in the first 6 hours, 6 to 12 hours, 12 to 18 hours, or 18 to 24 hours, there is hardly any difference, 23, 28, 26, 23%. Whereas with U100 glargine, you can see that 31 plus 29, that is 60% of the efficacy is within first 12 hours. In the subsequent 12 hours, the efficacy is only 40%. And that is the reason why U100 is associated with more variability compared to degludec insulin. And that is not much different with U300 glargine also. You can see with U300 glargine also, first 12 hours, the 55% efficacy is there. Subsequent 12 hours, it is only 45%. Whereas with degludec, all these 24 hours, the efficacy remains same. Again speaks for its low variability in the clinical practice. This is almost repetition of the same, that insulin degludec, you can see like Rahul Dravid, 50-60 runs in every match. And this is like Virendra Sehwag, 200 in one match, 0 in other match. And same thing for the insulin glargine 300 also. Why glycemic variability is more important? Because it is also associated with micro as well as macrovascular complications. Of course, we need larger studies to prove that. But this study, which was a randomized controlled trial, where superiority of degludec was confirmed comparing it with U100 glargine. You can see that the estimated treatment difference was significant, 20.6 minutes per day, in favor of degludec compared to U100 glargine. Both level 1 hypoglycemia, that is below 70, and level 2 hypoglycemia, that is below 54, were less in the degludec group compared to the glargine group. And the overall hypoglycemia rate was also less. This study, which was recently discussed at ATTD Barcelona just a few months back, the in-range study, where the patients were randomized to U300 glargine or degludec plus standard of care. And there also you can see that degludec versus U300 glargine, the time in range was 44 minutes more, time above range was 44.9 minutes less, and HbA1c was also slightly less. Though every criteria did not meet the statistically significant levels, but still there was a trend towards benefit with insulin degludec compared to insulin glargine 300. Finally, this simplicity. And this is very important. We know that all the basal insulins are simple to initiate because you do not have to do much modification in the oral antidiabetic agents. They can be given at any time of the day. Glargine U100 you need to give at fixed time of the day because the efficacy does not last for more than 24 hours. Actually, it falls short of 24 hours. But you can give it at any time. You can give it in the morning also. You can give it in the night also. U300, you have 3 hours flexibility. Whereas with degludec, you have about 8, 10 to 12 hours of flexibility because the efficacy lasts for almost 36 to 42 hours. And that is why it is easier to titrate also. And in a person who has erratic lifestyle, this has an advantage because you can always tailor the dose based upon the patient meal timings, or if he is traveling internationally, it will be even more advantageous. Because of less variability, you will also require less monitoring, and that may also translate into cost benefits. Though initial cost may appear high, but if the risk of hypoglycemia is lower, the monitoring requirement is lower, ultimately you are going to save the money and not going to spend more money. The flexible timing, the trials have been done with that. Whether you give it in the morning, next day you give it in the evening. Of course, we do not suggest this in the practice, but even if the patient is doing this with good understanding about his disease and lifestyle, this can also be practiced in a given patient. Whether this insulin is more adherent? Well, this study, the confirmed study, showed that the treatment discontinuation rate was lower with insulin degludec compared to glargine U300. The exact reason behind this is not known at present, but this was the result which was there from the confirmed study, that glargine 300 was associated with more discontinuation compared to degludec. I already told you that the time flexibility is there and the variability is less, so the strip requirement will be less. Moreover, with glargine U100, you will require about 10% lower dose. Generally, the experience and the studies suggest that if you are giving glargine 30 units, the requirement of degludec would be about 25 units, and the requirement of the U300 glargine would be about 35 to 40 units. So 10% more dose will be required compared to U100 glargine for U300, and 10% less dose for insulin degludec. That also is, in a way, cost saving. Finally, coming back to this case, everything went well. Patient was started with 10 units of degludec, and this is generally what we practice. We do not start according to the weight of the patient, and for degludec, this is the guideline recommendation also, start with just 10 units in an adult. Monitor the fasting values and up titrate the dose by 2 to 4 units based upon the fasting. And in this patient, you can see that with 16 units, finally the HbA1c from 8.8 within 3 months came down to 7.4 without any episode of hypoglycemia. Oral medications were continued. Obviously, when you start insulin, we need to cut down on the dose of the glimepiride. That we generally do from 4 to 2 milligram, and that was done here. Other OADs, including metformin and empagliflozin, was continued. Insulin was up titrated to 16 units from 10, fasting of 112, postprandial 174, and everything went well. HbA1c also came down, and very happily, no episodes of hypoglycemia. So I would like to stop here, and the subsequent presentation will be based upon the case discussion. Thank you very much for your very kind audience.
Thank you, sir. And after basically about what we received the things about the basal insulin, particularly second generation, by Dr. Sanjeev sir, as well as about the co-founder by Dr. Kalyan sir. Now we are going to move on the next part, and it's a case-based discussion. And for that, I am going to invite to Dr. Dakshata ma'am. Madam is from Mumbai, and she is a diabetologist, and she is a founder of the Home Diabetes Club. Almost is going to group of the more than 15,000 patients, and madam having a lot of more accreditation in her careers. Just over to you. And madam is going to deliver to talk on how we can improve the timing range with the autologous insulin. Over to you, ma'am.
Thank you, chairpersons. Thank you, Bansi sir, team DiCareCon, Dhruvi, Vipul, everyone, and everyone present over here, because after 2 giants, still everyone is waiting to hear me. Thank you so much. So basically, this is the centenary year of insulin, and we have so many landmark real-world studies and RCTs, but sometimes just one case, one case where we have started early initiation of insulin probably, and we are getting results in terms of not only fasting, post-lunch, HbA1c, but in terms of glycemic variability and quality of life. I think it really reconfirms our belief in that molecule. My PPT. Dr. Kishan, you have the PPT, right? You also have the PPT. So basically, this patient, Mr. Dinesh, he's a 64-year-old man. He doesn't believe in retirement, vanaprasthashram, and he has a very busy and active lifestyle. He's a businessman. He's diabetic since last 10 years. He's on 3 medicines. I think he's on sitagliptin, empagliflozin, and metformin. HbA1c is consistently 8. The figure where we always keep on giving 3 months, patient keeps on requesting, sir, 3 महीने के बाद आता हूँ, देखते हैं. And this is a patient who is now feeling lethargic, but at his age, he is working so actively, so now it is our responsibility also to support his lifestyle and give him good glycemic control and good quality of life. So these are the financial disclosures. Yeah, I forgot to thank Novo. Thanks, Novo. So we just discussed that 64-year-old gentleman, diabetic since last 10 years, fasting around 155. So here basically he's starting his day with high fasting, post-lunch 195, eventually A1C around 8. He's on 3 OADs, and then somehow he wants some good control, and he gets CGMS done as per his doctor's advice, and this is the CGMS profile. So you can see, I mean, the whole day, round-the-clock control is deteriorated. He's starting his day on a higher fasting, and he's a very active person. He's not in a sitting job. He's a technologically savvy person. If you see those green bars, these are the physical fitness apps, and he's continuously moving around, and his daily routine is quite active. Still, it's not helping us to get those PP peaks down and fasting down. So what can we do? So these are his CGM metrics. Just to summarize, that glycemic estimate is around 7.7, average blood sugar is around 175. Time in range should be, as per international consensus, above 70%. It is around 65.8%, and time above range is 31%, which is clinically significant to cause long-term complications. So this consensus says, we all are aware that TIR, that is time spent in range, should be more than 70% for type 1 and type 2 as well, irrespective of duration of diabetes and age of the patient. Time above the range can be allowed up to 25%, and time below range should be avoided. But patient's time in range is around 65%. So each incremental 5% increase in time in range is going to be very, very beneficial. It is clinically significant benefit for any type 1 or type 2 individual. So now what are the options available? We all were fond of basal insulin. Early initiation of basal insulin, bedtime, along with the cocktail of OHA, maybe after 10-15 years of diabetes. We know that half-life of NPH insulin is just 5 to 10 hours. So glycemic variability is going to be high. Duration of diabetes, duration of action is less, half-life is less, and it does have a peak. Then we have first generation basal analogs. We have detamir and glargine U100. Supposed to be once a daily dose, but we all know that half-life 12 to 19 doesn't last for more than 16 to 18 hours, max to max 16 to 18 hours. We have proved it on repeated SMBG and CGMS as well. And glycemic variability does come down because of the longer action profile. Then we have second generation, ultra long-acting basal insulin. For one is obviously U300 glargine, and then we have degludec. The half-life definitely is more than 24 hours. Many times it lasts, most of the time once a day dosing is enough, and glycemic variability is very, very low because of round-the-clock coverage and of course peakless action. So these are the challenges we had in the past, that insufficient basal insulin coverage, so we had to give multiple injections. In few patients, LADA patients or few type 1 patients, we had to, when there were no insulin pumps, we had to give basal thrice, because 2 basals were also not covering 24 hours profile. Need to resuspend, and we need to resuspend it properly. Education about resuspension is very, very crucial to avoid glycemic variability, and there is significant day-to-day variability. Now, what about first generation analogs? We were using, first generation analogs for quite a few time, but they are not truly once daily. They have very high variability. There has to be fixed time dosing. There is no flexibility in the timing. They are not truly peakless. And definitely nocturnal hypoglycemia remains a concern because of that peak in that basal insulin. Now, what are the merits of insulin degludec? Of course, we have to, compare with the competitors. So when compared with U100 or U300 glargine, there is significant lower within day-to-day variability, significantly better TIR, we all agree that, and lower time below range versus glargine U100. And this is very significant. The paper which was presented at ATTD in the range study, daily 45 minutes more time spent in the range. So you can imagine throughout year how much benefit we are going to have. So these are the few benefits when we compare degludec with glargine. So these are few results, we got the results very quickly. Started with standard 10 units of Tresiba, or degludec. Within 1 month, with gradual, increment in the dose, 14 units the dose was determined at 14 units. Fasting came down very quickly and smoothly from 155 to 116. A1C we have not repeated because it was just 1 month. And body weight improved. Mind you, patient had lost some, part of body weight because of poor glycemic control. There was positive weight gain of around 1 kg. And CGM profile also definitely did improve. Time spent in the range had improved. Glycemic estimate came down from 7.7 to 6. Average glucose to start with was 175, which dropped to 127. Time in range was 65, and which we could achieve as per international consensus of time in range. It came down, it improved to 71%, which is actually an ideal time in range. And time above range, which was 31, which improved till to 18%. So I think, just to summarize that we have so many landmark trials, RCTs, real-world evidences. So we have to be proactive in early initiation of insulin. And one step ahead, we have to be proactive by using ultra-long-acting early initiation of insulin. Thank you so much.
Thank you, ma'am, for delivering the insights of how we can take care of time and energy for our patients. And after that, I am going to invite Dr. Pratap Jethwani, sir. Sir is not requiring introduction, we all know. Sir is senior diabetologist, is practicing at Rajkot. And sir is also having a fellows in RSDDI and fellow Diabetes India. Sir is going to deliver a case how we can achieve the total control at a insulin initiation. Over to you, sir.
Thank you, Dr. Maulik, Dr. Kamlesh, for chairing this session. Thank you, Dr. Bansi and DIACARE team for making me part of this program, and thank you, Novo, for inviting me to be part of this panel. So I will be talking about type 2 diabetes and control on multiple OADs. How can we use, how can we use co-formulation for better glycemic control with less risk of hypoglycemia? So as part of this, the panel, this session is being sponsored by Novo. So this is my financial disclosure. So I will be talking about Mr. Patel, a person with type 2 diabetes and control on multiple oral anti-diabetic agents. This is the history. He is a teacher at a high school, 56-year-old male, 70 kg weight with BMI of around 24 and hip circumference of 94 centimeter. Pulse blood pressure very well controlled, and his eGFR is 88 ml per minute. Type 2 diabetic since 7 years, hypertensive since 6 years, dyslipidemia since 6 years, and symptoms of diabetic neuropathy since 1 year. So already on a number of medications starting from metformin to sulfonylurea, gliptin, SGLT2 inhibitor, rosuvastatin, telmisartan, cilnidipine, and pregabalin. In spite of these 4 drugs being used in optimal dose, still his HbA1c is increasing from 8.4 to 8.9 to the recent last HbA1c being 9.5%. He is reluctant and he has got a lot of psychological insulin resistance which requires a lot of counseling. Now, whenever we think of putting a patient on insulin, it is imperative to advise them about self-monitoring of blood glucose to see their glycemic patterns, and that will give you a better idea which molecule will be beneficial for that kind of patient. So here the fasting is 220, post lunch is 246, and post dinner is 312, and HbA1c is 9.5%. So classically, there is a fasting hyperglycemia and there is a post dinner very high glycemic peak, both which require address if you want to reach the tight glucose control of HbA1c less than 7%. So this can be achieved either with basal bolus, 1 peak of bolus, 1 peak of basal insulin, but then the patient will require 2 different pens and it requires a lot of education on part of the patient. But the same benefits of basal plus therapy you can achieve with a single peak of co-formulation, because you know that co-formulation, it contains insulin degludec, that is basal component, and rapid acting insulin analog, that is bolus component. So co-formulation 1 peak is almost equivalent to basal plus therapy. So here the counseling was done and insulin initiation, the patient was agreed for insulin initiation and the gliclazide was discontinued, and once a day IDEC-S or co-formulation was started with dinner to aim for total control, that is both fasting and post-dinner hyperglycemia, and 1 peak before dinner of 10 units was started, and the HbA1c came down to 9%, fasting decreased to 178, and post-dinner came down to 244, and the dose was adjusted depending on the self-monitoring blood glucose parameters, and further dose increased to 20 units, fasting came down to 146, with post-dinner coming down to 182, and ultimately the patient reached the target HbA1c of 6.9% over a period of 1 year, and this is the CGM data of the patient, 90% time in range, less than 5% above 250 milligram, and less than 5% below 70 milligrams. So this gives you a clue that this is an ideal candidate for co-formulation to be started, which will help patients to reach HbA1c below 7 without increasing the risk of hypoglycemia as well as hyperglycemia. So Mr. Patel in March 2022, after 1 year, is on IDEC-S 24 units, metformin, linagliptin, dapagliflozin continued. Rosuvastatin, which was prescribed in the dose of 5 milligram, was increased to 10 milligram, that is optimal dose. Telmisartan, cilnidipine, and pregabalin was continued. And at the end of 1 year, HbA1c is 6.9, fasting 106, post-lunch 124, post-dinner 152, and is having very good control of both fasting, postprandial HbA1c, and very good quality of life. So this was continued for this patient. So this was just a hypothetical case to give you an idea. Whenever you think that the patient requires both things to be addressed, both fasting and postprandial culprit is only with 1 meal, you think of co-formulation to be started in this category of patients, because 1 peak, very simple to start, very simple to adjust, and if required, as Dr. Kalyan has highlighted, very simple to intensify also. One may add 1 peak of rapid-acting analog for another meal if required. One may advance to twice daily co-formulation also, and one may go on to adding rapid-acting 2 peaks with 1 peak of co-formulation depending on the glycemic parameters. So this is very simple to start and very simple to intensify. Thank you very much.
Thank you, sir. And now I am going to invite to all the speakers, please come on the dais, because now the house is open for the questions. Dr. Sanjeev sir, Dr. Pratap sir, Dr. Kalyan sir, and Dr. Daksada ma'am. Please.
No one is awake, so no questions. sure, all of us made sure that. Yes, Dr. Rajesh. I knew this question was going to come, so I'll address it. So I did that. That's why I started with basal insulin. And so let Dr. Jethwani answer that. Why not an AGI? Why there was no AGI on board, which is a usual practice?
Yes, in that case. So you may use AGI, there is no problem with that. If you want to go with basal insulin, but if you see the baseline HbA1c, it is 9.5, 9.6%. AGIs will give you a reduction to the tune of only 0.5 to 0.6%. So you may combine basal insulin with AGI, there is no problem with that. That is another way. That is also a sort of, I will say, basal plus therapy, because you are giving basal and at the same time you are also targeting postprandial with the help of an oral agent. But it will not reduce HbA1c very well. That is the only concern.
So the simple answer is either you go for a co-formulation or basal plus AGI depending upon the glycemic excursions.
See, there is no problem with adding insulin, but you may have omitted sulfonylurea in your case.
Sulfonylurea
Was 1
omission,
milligram,
yes, has been associated with significant increase. So
You must have reduced the
we reduced the
cardiac
dose
risk
from-
of patient. He was hypertensive, I think.
No,
Your
sulfonylureas
patient-
do not
patient.
increase the cardiac risk.
But adding AGI will definitely reduce the cardiac.
Again, that's not, no trial has proven that, Rajesh.
Only drugs
None
which
of the
reduce
trials have-
cardiovascular
yes.
risk are either SGLT2 or GLP-1.
Glimepiride is as safe as gliptins or as bad as gliptins according to the Carolina. So sulfonylureas at least do not increase the cardiovascular risk unless there is an hypoglycemia event.
But I think when we are
Yes.
putting patient on a basal insulin, if HbA1c is very high, one can safely monitor their blood glucose, and if required, one may reduce the dose of sulfonylureas depending on case-to-case basis.
Yes.
But it is
So
not
what we
required
do
to
is, yes, Dr.
withdraw.
Urbanbe, what we do is we reduce the dose of sulfonylurea when we initiate basal insulin. We do not stop it. Correct me if I am wrong. There are so many experts here. Dr. Urbanbe. If sulfonylurea is already on board, I don't think that.
Yeah.
Yes.
Patient was already on sulfonide.
So in
Yes.
clinical,
Yes.
so in clinical practice also we see that patients are on acarbose or voglibose. But the postprandial control after introducing rhizotape, targeting one meal, the control is clinically significant. So I don't think,
So
it
the
is
savior has
comparable.
come. So.
Because of whom all of you are awake.
Right.
Yes,
Thank you for the wonderful sessions. My disclosure is that I'll be speaking in the contest between apples and androids. I'll be speaking apples. So there is a conflict of interest in this question. Now, it comes to Dr. Pratap. I just wanted to understand from your practice, have you noticed while you're placing the co-formulation once a day with the biggest meal of the day, many a times what I see is that I achieve the target fasting, but the prandials start going very low. In that scenario, what do you do? Because it's a fixed ratio
So
formulation.
that is the only disadvantage of co-formulation, that it is a fixed ratio and only one ratio is available. No other formulations are available like 25-75 or 50-50. It is only 30-70. So in that case, you need to ship them to a basal separately and bolus separately. That should be.
Or Supratik, you
So
can
it's
do
like a
a-
ready-made shirt. If it fits you, wear it. Otherwise, you go to a customized.
So you have raised an important point that fasting is high but PP is low. So in that case, what we can do is you can split it into two. So breakfast and dinner or lunch dinner. So that way you don't have that much of PP component there, and dividing it twice a day might take care of the fasting.
But then whether post-dinner
you
is
have
high
two
or
plates.
not, that also you
Yes,
have to take into
of course.
Thank you.
Yes, sir. I think either whichever suits the patient, both of the insulins, because the co-formulation contains basal insulin degludec. And degludec now has a cardiovascular outcome trial showing the cardiovascular neutrality compared to glargine, of course, not compared to the placebo. So I think whether you use Rhizodeg or whether you use Tresib or U100 Glargine, from cardiovascular standpoint, everything is same. Risk of hypoglycemia obviously will be there with any insulin, but the risk is lower with the new generation basal insulins. Dr. Kalyan, your comments.
So for cardiovascular, simple motto, less of hypoglycemia. So whatever you use, try and achieve least hypoglycemic incidence. That will be the main thing. So use the medications or insulin which gives you least hypoglycemia. So there is no particular insulin which is more advisable in cardiovascular. As Dr. Pathak said, it's the only trial with the insulin in CVOT is with degludec. So all you can say is that.
So one question to my co-panelist. I mean, it's a funny question actually. So when we are giving Rhizodec before dinner, post dinner is very well controlled and fasting goes down. Maybe fasting hypoglycemia. When we are giving Rhizodec before lunch or before breakfast, do we see lesser hypoglycemia next day in clinical scenario?
So you said giving
Shifting
Rhizodec,
in the early part of the day.
So shifting from dinner
Before dinner to before breakfast or before lunch.
will it cause less of hypoglycemia?
Yeah, because
so once daily.
Yeah.
Theoretically speaking, there shouldn't be, because the early morning hypoglycemia is due to the degludec components. It doesn't matter what time of the day you give. So as you said, the PP component then becomes relevant. So if you don't have that much of a PP rise with the dinner and you're giving it because the PP rise high with the breakfast, then that might cause less of hypoglycemia. Otherwise not.
Is that a tighter PP post-dinner control, that legacy is carried forward next day for fasting hypoglycemia? Is it like that?
Probably not.
So
because
in clinical practice?
Yes. So postprandial, the aspart moiety will take care of it. So it will last for 4 hours. So if you get the hypoglycemia, it should be around 3 a.m. So if you're getting it at 6 a.m. in the morning, it is because of the degludec component, not the aspart. Because with the aspart causing the hypoglycemia, it should occur around 3 a.m.
So before splitting, if we can just prepone the dose of Rhizodec maybe before lunch or before breakfast, if there is fasting hypoglycemia.
Then you have to tell the patient to have dinner at 8 o'clock or 7 o'clock. That sometimes it's a challenge to get it done.
I'm saying the preponing the dose to either pre-lunch or pre-breakfast.
Yes, see, if the degludec moiety causes the 6 a.m. hypoglycemia, I'm just giving a ballpark figure. So shifting from lunch to dinner won't take care of the 6 a.m. hypoglycemia.
That will require dose reduction in degludec.
I think we conclude the session. Thank you, sir.
Thank you.
जिंदाबाद रे रे जिंदाबाद रे रे अमदावाद रे 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 शक्लो बाज रे शाही मिजाज रे रे अमदावाद ऊंची ऊंची माटे छे आँख रे रे खोले पाँख रे रे अमदावाद बाबा जोड़ा जे बूंदो पानी रे के स्वाभिमानी रे रे अमदावाद ओ ओ ओ
I guess this performance deserves huge round of applause. That practiced well and that in harmony they have danced well despite of that hectic schedule in their clinics. So highly respectful performance given by you, all of you. Thank you so much. Once again, let's have a huge round of applause. So now, after this session, it's time to move ahead for the next session. Our next session, Chairperson Dr. Neel Sadhu, somehow he's not able to attend today's conference. He will come in the evening, but instead of him, Dr. Rikeen, I guess, he's available over here. So I would like to request Dr. Rikeen to come on a stage. And second chairperson for this next session, Dr. Ashish Gautam. Dr. Ashish Gautam, yeah, thank you so much. He is a professor of medicine, MD, FICP and FRCP, and FACP and FICPM, and head of a medicine department of RD Medical College, Banda, UP. So most welcome, sir, to Ahmedabad and DiaCareCon 2022. Session is hand over to you. I would like to request both of you to invite speakers with their brief introduction. Thank you.
Good afternoon, everyone. Now we are going to start a basal insulin symposium. Our first speaker is well-known diabetologist, Dr. Supratik Bhattacharya. He needs no introduction. He done MBBS, MD, MRCP, FRCP, FSC, FSCP, and FRSSDI. He has done MS in endocrinology and diabetes from London, and director of SKN Diabetes and Endocrine Center, Kolkata. He is also a consultant in Department of Endocrinology, AMRI, Satlelke and Apollo Sugar, Kolkata. He has done more than 30 plus international and national publications as a first author. Also author of the 5 book chapters. Special achievements are speaker at various national and international conferences, organizing chairperson at various conferences, part of the organizing committee of ACP IM 2021, Diabetes India 2021, RSSDI Defeat Diabetes Task Force. Also national scholar and rank holder in 10th board and gold certificate holder in A level exam. Please welcome Dr. Supratik Bhattacharya. Please proceed to your session.
Right. Thank you, chairpersons, for all your kind words of introduction, and a warm welcome to all of you. It's a pleasure being here, as always. Thank you, Dr. Bansi Sabu and the entire team of DiaCon for this wonderful performance, warmth, and hospitality, as always. So you heard just a while ago a similar session being presented regarding the second generation insulins. And we know that, just as we were saying, you have Android users and you have loyal Apple users. So it depends on what you want to choose. It's on you. As long as you have the affordability, we know that the second generation insulins are better than the first generation insulins. Again, just to clarify that any basal insulin does the job of bringing down the blood sugar, the fasting to the target levels, and in doing so, it achieves the target HbA1c. However, there are differences between the first and the second generation insulins in the term of flexibility, of timing that we had been talking about convenience, and also the safety profile, whether we are talking 24-hour hypoglycemia or especially nocturnal hypoglycemia. So with this context, this is going to be the summary of my talk. I'll talk about the clinical implications of glycemic variability and time in range. Again, something that you had been hearing about, and you'll keep on hearing about time in range and glycemic variability because these are the terminologies that we are talking about more often, and we are not satisfied only to have HbA1c on board. We know that there are fallacies, and 3 different individuals walking into a clinic having very similar HbA1cs might have entirely different time in ranges. So we are now focusing on time in range, and it has been advocated by many guidelines, especially ADA 2022 has incorporated that into their guidelines as well. And then again, one of the studies that we had been hearing about, in-range study, and this is what we are going to talk about because this is one of the studies that talks about the need for addressing the glycemic variability. So glycemic variability is a common challenge for the people with diabetes, And excessive glycemic variability and suboptimal time in range can significantly impact lives of people with diabetes. And we now have international guidelines, and I said ADA 2022 has incorporated regarding the time in range, and you had been seeing anyone with type 1 or type 2 diabetes should at least maintain a time in range more than 70%. So suboptimal time in range can have significant negative impact on the lives of people with diabetes. And we have seen that 10% drop in the time in range was associated with a significant increase in the frequency of retinopathy. So majority of the microvascular complications like retinopathy, microalbuminuria, neuropathy, all of them go up. And that results in a significant higher mortality, especially the cardiovascular mortality and also all-cause mortality. Now, international guidelines recommend time in range and glycemic variability as key matrices, and we said that recommendations of the International Consensus on Time in Range 2019 has advocated that a metric of glycemic control that provides more actionable information than A1C alone, and ADA 2022 especially says time in range is associated with the risk of microvascular complications and can be used for assessment of glycemic control. So this is the timeline, how it was incorporated. So initially by 2012, we know that time in range was defined, and finally by the time we get to 2022, we see that ADA says CGM as an important tool for hypoglycemia prevention. Glucose fluctuations are a process in time with two principal dimensions. We know that amplitude and time matters. And if you have a significant higher glucose levels throughout the day, that results in microvascular complications. Similarly, if you have a postprandial glucose surge, what we call MAGE, then the chances of a future cardiovascular event goes up very significantly. So we have very specific targets. So the glycemic variability or coefficient of variation, the target should be less than 36%. So all peaks may look good, but they are not. When you are talking about the peaks that come after a post-meal surge of glycemia, that doesn't look good at all. So it's not like Mount Everest. So you have to know that. So this is another very important study which shows that a postprandial surge or MAGE is a very important factor for a future cardiovascular event, and the risk is as high as that of a smoker. So you see in here, anyone who is having recurrent MAGE, you will be having an odds ratio which was very similar to a person who is a smoker. Again, understanding time in range for type 1 and type 2 diabetic patients, we know that we have defined that both for type 1 and type 2 patients, the target time in range should be 70% at least, with less than 30% being spent in hyperglycemia or time above range, and less than 5% being spent in hypoglycemia. Similarly, if it's an elderly individual, if it's a frail individual with a very high chance of hypoglycemia risk, then you can cut a little slack, and the time in range for these individuals would be around 50%. So how does a basal insulin effectively address the hypoglycemia, glycemic variability, and time in range? So glycemic variability can affect the peaks, so caused by the glycemic excursion or the post-meal, postprandial glucose surge. And basal insulin, what it does is, it goes and hits the base. So we know that we have talked about fix the fasting first, and basal insulin effectively goes and fixes the base, and that's how it mitigates the spikes. Basal offers also flexibility of using postprandial target OADs, as we had been talking about, whether it's the AGIs or the repoglinides, you can use that over on top of a basal insulin. How does it address the trough? So if you have a second generation basal insulin, which has a much flatter profile with very less glycemic variability, then we know that the hypoglycemia risk is going to be mitigated. So it's got much lesser risk than U100 glargine. For example, second generation insulins like U300 will have a much lesser incidence of hypoglycemia because of its flatter profile with U100 glargine. Similarly, U100, which still remains the gold standard basal insulin, will have lesser hypoglycemia risk as compared to a NPH. So this is exactly what happens. It goes and hits the base, and the entire thing shifts down. So we need to address the base first if we want to mitigate hypo or hyperglycemia. Similarly, look at this. This is NPH or a first generation basal insulin. You see, there's a lot of glycemic variability that comes. With the second generation basal insulin, so what would it do? If you bring down the fasting to the target levels, there will be significant number of hypoglycemic episodes that can occur because of the glycemic variability. With the second generation insulins, it has got a much flatter profile. So even when you bring down the fasting to the target levels, the chances of hypoglycemia is not as much. So it's visually very, very clear to all of you why second generation insulins, although same efficacy as that of first generation insulins, have much lesser risk of nocturnal or overall hypoglycemia. So there are various studies that have been done, whether it's the PKPD study in type 1 diabetic patients, or the various RCTs, or the real-world evidences that has been done in the type 2 diabetic patients, comparing U300 glargine versus IDEG. And it depends on how you do the statistics, really, and which platform you're speaking from. It really matters. But overall, we can say that, you know, it all comes down to your choice of Apple versus Androids, you know, like, so it's your choice. But one thing that I wanted to highlight about U300 glargine, of course, as we go along, it's got a smaller volume to inject. So that is quite convenient at times. So now coming to the in-range study, we had already seen this study a little while ago. I'll be interpreting that in a very different way. So time in range using insulin glargine 300 versus insulin degludec in type 1 diabetic patients, and it's a head-to-head randomized control in-range study. So study design was, it was a 12-week multi-center randomized active control parallel group open label study, and anyone who is an adult between 18 and 70 were recruited. Baseline HbA1c was between 7 and 10%. What was done? Initially screening was done, and there was an initial run-in period. And at this point of time, there was a 20-day blinded CGM that was done. And then they were randomized to either U300 glargine or IDEG, and they were followed up for 12 weeks. The last 20 days, again, there was a blinded CGM, and the primary and the main secondary endpoint was measured at the end of 12 weeks. So some interesting facts. During the titration period, U300 or IDEG 100 were titrated to achieve the target fasting self-measured, which was between 70 and 100, and mealtime insulin analog was titrated to achieve a 2-hour postprandial target of 130 to 180 while avoiding hypoglycemia. So primary endpoint, percentage time in range between 70 and 180 at the end of 12 weeks, and main secondary endpoint would have been the glycemic variability at 12 weeks. What are the other study endpoints? Descriptive statistics presented for other efficacy and safety variables, like, for example, change in A1C, percentage time above range, that is anything more than 180 milligrams per deciliter, and time below range, which was less than 70 at the end of 12 weeks. Safety endpoints would have been primarily the rates of hypoglycemia, whether it's nocturnal, or if you do it graded wise, less than 70, between 70 and 54, or less than 54. And severe hypoglycemia requiring third-party assistance, incidence of adverse events, and change in insulin dose. The baseline characteristics were well matched between the two groups. And of course, again, baseline characteristics were very, very comparable between the two groups, whether you're talking diabetic complications or the baseline characteristics. So the primary endpoints, time in range, non-inferiority was proved at the end of 12 weeks. So when we are comparing U300 glargine versus IDEG 100, we did see very similar time in range with these two second-generation basal insulins. Main secondary endpoint, glucose and variability or coefficient of variability, that was the secondary endpoint that we were looking into. And main secondary endpoint was met with non-inferiority being shown in the study between U300 glargine and IDEG 100. And other secondary endpoints were A1C change, a very little change was there, very similar changes from the baseline, only numerical differences not resulting in significance. Hypoglycemia anytime, 24 hours, again, very, very similar. And if you look at the event rate, again, slightly favors U300 glargine. If you look at the numerical incidences of hypoglycemia, anytime, it's slightly it's pretty much in the midline. There's not much of difference. Now, if you're talking about nocturnal hypoglycemia, again, very, very similar between the groups, maybe just numerical differences. And again, it's depending on how you analyze the data. If you look at the incidence, it slightly favors degludec. But if you're talking about event rate, number of events, again, it is in the unity line or slightly favoring that of U300 glargine. So the in-range study is the first RCT comparing second-generation basal analogs and U300 versus U100 glargine in type 1 diabetic patients. And we were looking into time in range as the primary endpoint. So the key takeaways from this in-range study was that non-inferiority was proved between U300 glargine and IDEG. Main secondary endpoint was met. That means non-inferiority for glycemic variability. And finally, when it comes to hypoglycemia and the safety profile, it was very, very similar between the two groups. Within day variability and between day glucose variability, so this was the objective of this study was to look into within day variability and intra-day variability. That means what happens in the various days. Again, within day variability and intra-day variability was very, very similar between U300 glargine and IDEG in type 1 diabetic patients. Strengths, prospective, multi-center, randomized, active control, parallel group comparative design, use of clinically relevant CGM matrices and blinded CGM has been allowed. The clinical properties of U300 glargine and IDEG 100 to be compared. And the limitation was that it was an open-level study design and longer-term CGM data collection would probably be more meaningful. So to summarize, use of continuous glucose monitoring allows a more complete assessment of the overall glycemic control and supports time in range. At present, there is no CGM literature on the use of CGM to compare between the second generation insulins. In range, a multi-center randomized active control parallel group 12-week open label phase 4 will collect CGM data over the 20 consecutive days from adults, type 1 randomized. Excuse me, can you please ask somebody to mute the music or close the door for us? I think it's in the other hall. Let it be. It's okay. So the same performance is going in the other hall, so it's okay. The study is designed to demonstrate that U300 glargine is non-inferior to IDEG in terms of glycemic control and especially time in range, and also matches in terms of safety profile and glycemic variability. So in-range study has achieved its primary as well as secondary endpoints in terms of time in range and glycemic variability. And again, so standing here with all the experience that I have from both these molecules, I want to highlight that U100 glargine is the gold standard. We still use it. We use it to get the patients fasting down to the control levels efficiently. Second generation insulins are for those who can afford it. If they can afford, you have two choices, either apples or Androids. It's your choice what you feel comfortable with. I'm an Apple user and I'll always be. And the pointers towards U300 would be, the flexibility of the dosing, so you need not take it exactly at the end of 24 hours. Second thing is, we talk about the convenience. And third, we talk about the safety profile, whether we're talking about overall a 24-hour hypoglycemia or especially nocturnal hypoglycemia, which seems to be much lesser as compared to the first generation insulins. And of course, as I wanted to highlight, that U300 glargine comes in 1/3 the volume, the same units, so you need to push less. And sometimes that is very helpful when the doses are higher. Sometimes limitation of these basal insulins is that you can't give more than 40 units or 50 units in one shot. In U300 glargine, you can give up to 70 units. So that remains a definite advantage with this particular molecule. So with this, thank you so much. And my co-speaker will take it from here.
Thank you, Dr. Supratik. I request you to stay in the hall. Probably we'll be having some couple of questions after the session. And for the next lecture, I request Dr. Suresh Damodaran from Coimbatore to please come over the dais. And he is consultant diabetes and endocrinology from Sri Ramakrishna Hospital, Coimbatore, and honorary consultant in the Dairy Food Hospital, Plymouth. He is vice president of Endocrine Society of the India and executive council member, Endocrine Society of Tamil Nadu, founder president of Diabetes Endocrine Thyroid Society of the Coimbatore, and currently appointed as a member of editorial board of British Journal of the Diabetes. He has several publications. I think we do not need to explain them. He's a very good researcher, and the publications itself shows the quality of the research. So I ask Dr. Suresh Damodaran to please come to this session.
Good afternoon, everyone. Thank you very much for the wonderful opportunity. I think I have to request Bansi to have probably dance after every talk, I think, isn't it? So music and dance after every talk will keep the crowd alive. That's one request for Bansi, probably, if he's around. And I like what Supratik has mentioned about, it's normally comparing apples and oranges, and I like the way that he presented as apples and androids. So my point is, I think whether you got a satellite connection or whether it's foldable, but the safety is important. So you can get one each other, you can compare it, but I think the safety aspect is the key thing in getting all these basal molecules. After all, we have moved a lot from human insulin in recent past because of the safety. I think mainly the hypoglycemia, I think time in range, the whole concept of what we've been discussing is around safety. So all the talks with hypoglycemia and weight gain, that is the range people think about new molecules and coming in. So, and that is the way we should think, and safety is the key. And we had a talk with Vinay just earlier about the BRIGHT study, and people are talking about no hypoglycemia. No, I think insulin does cause hypoglycemia. Which is the better one, and how you use it with other molecules, and what is the experience and knowledge what a clinician has got, and that will be implemented in the clinical practice so that the hypoglycemia risk is less. And that is the way to take issues, not just comparing one molecule to other and straight off saying this one in one forum and one in another forum. No, I think it is the safety, and that has to be concentrated. Now, my job is to have the translating science into practice. So what we got and what are the challenges we got. Now, we got four aspects that I'm going to discuss very, very briefly. I'm not going to take a lot of time on you. So impact, why insulin initiation is being delayed, and what is the right time to do the insulin initiation, and practical challenges what we face up and how to overcome it. And that has to be given. And when you say that you want to overcome it, what is the benefits that you're going to get by overcoming it? Now, previously, the pharma has come up with the concept of saying extremely early insulin initiation and everything. Probably that is not the way that I'm going to discuss. Probably that has got a different idea to it, but here, what is the right time to do it? Now, impact, there are a lot of challenges. The landmark is the first trial that to show longitudinal perspective. It's more of an observational trial, and it's a real world data. So 4 out of 5 people have got uncontrolled diabetes in India. I think less than 1 will take, 1 in 4 type 2s take insulin. A lot of barriers and things to overcome it. So once you delay it, there is a significant delay in the treatment intensification. So just going from one drug to another one is a challenge, and we have to take the patient's thing into consideration. So one patient will come up and say, "Doctor, I'm not interested to go on this thing," and you have to consider that there are a lot of physician factors and the patient factors comes into play as well. So it is not only easy job in a forum like this we can talk, and then you can't translate, because the clinician has got a lot of challenges from, I don't know, from NMC, from the patients, from the economic point of view, and relatives, and what setup you got, and a lot of other challenges. So it is not easy, but you have to know the science so that you can translate into practice. So poor glycemic control will lead to bad metabolic memory. We know from probably a VADT is the best trial that has been showed huge data about the bad metabolic memory. The veterans have been given all the facilities in spite of good control in the recent, they are not getting any benefit because they had a bad past. So that tells you a bad metabolic memory. So it is a vicious cycle. Oxidative stress, advanced glycated end products. I've done some work on it. So AGE, when the level goes up, the stiffness of the arteries goes up, and there are a lot of other challenges with hypertension, and quite a lot of other factors comes into play with renal and eye and other things. So, and collagen crosslinks and chronic diabetes complication is the eventuality. And once you want to avoid it, I think you have to go and control the glycemia. So this is the ADIC trial that shows that micro and macrovascular complications are very high if you delay the treatment. So what is the right time to treat and timely initiation of this thing? So what is the evidence? So if I say some concept here, what is the evidence to it? If you see the UKPDS 50,000 data, it's a very old trial. We don't complete our lectures by not quoting UKPDS, but it is a very old trial. You can see that has been taken up in 2002. Early insulin to oral agent monotherapy is maintained glucose level below the target in 6 years. So if you do early insulin initiation, the complication rate is quite less. So early initialization significantly improves the patient to achieve the goal. If you set up the goal and want to achieve it, now I think I'll come to that, but I think without technology in future, there is going to be a huge challenge for us. We live in a modern era, but we can talk anything about the cost, but people, the technology needs to be involved in future. I think Supratik has mentioned about time in range, but a lot of other things has to be incorporated in future. We will all see. So diet, OAD, and OAD with multi-drug along with insulin. So if you go for an early aggressive treatment and then you get a better result. But the cost is hypoglycemia. You have to consider that and keep that in mind, and chance of getting less hypoglycemia will be the smart way to do. So that brings me to talk about B-SMART trial. That is Bajaj in diabetic therapeutics in 2019, the publication. So you do with the basal ones. Previously, I remember the training days of mine when we have insulin workshop in Rutland and places like that in UK, where that insulin initiation has to be done only by the consultant, not by the general practitioners. But those are the days are gone. Just going for a basal insulin just as a startup, and then timely one, and should be injected at appropriate time, and that is the challenge. You have to inject in appropriate time. We got the molecules now. We can use 3 hours gap, so you can inject, and then you can inject within similar sort of time within 2-3 hours before and after. So basal insulin analogs provide that advantage of flexible timing, as I mentioned, and making it very, very simple and intrusive. And with the devices what we got, and it makes the life so much easier. Yes, the cost comes in, but I think you have to consider all that training, hypoglycemia, and I don't know, quite a lot of other things that educators and quite a lot of things has to come in if you use the traditional one. So glargine 300 is the molecule I'm talking about, offers more flexibility in the timing of injection that can be administered at any time of the day. So I think we had a discussion during the last talk where what are the OADs that has to be added and what can be deleted. Almost pretty much to me, if you are having a challenge with that in the tablets what you are maximally done, then you add a small basal dose. That's what you should do. And then once you're going for a basal bolus and everything, you can add and delete some drugs. That is my way of approach. And if you do it, and you won't go wrong, because you must have attained some sort of glycemic profile with whatever drug you initiated. And you add on a basal insulin, that will provide extra 1% or a 0.7% or a 0.8% you're looking for. And if you want to add on a bolus thing, then you can mix and match the drugs what you got. Glitazones, the main reason is when you start on insulin, there will be a weight gain, and glitazone already has got a weight gain challenge. So if you have glitazone, just consider stopping it. But on the other hand, if you want to use a small dose for insulin sensitization, for example, people can't tolerate a metformin and you're adding a glitazone to it, a very small dosage, keep that one by all means. But the weight gain is the only challenge. But SUs and everything, we had a discussion earlier. So benefits of early insulin basal support along with the oral therapy. Basal insulin is capable of providing the beta cell restoration and the microvascular complications. As I mentioned, when the A1C comes down, the complication reduces, thereby definitely you can achieve the health economics. You can reduce the cost to the patient in the long run. Early insulin had a lower risk of hypoglycemia and weight gain, which you've been listening to past 2-3 talks, and that is the main thing with the basal insulins. And the modern insulins does a wonderful job. So if you go for the modern insulin, the evolution of basal to this thing, the training days of mine, and we had, I remember the Lantus when launched, even the branding, the coloring, everything has come up with a lot of thinking. And it is like a bingo molecule for a very, very long time before all these molecules have come in. It is developed to overcome the short limitations, and early basal insulin with the NPH was the only thing before Lantus. And Lantus was a God-sent molecule during our training days for a very, very long time. Before that, we didn't have any molecule apart from NPH, and then the mixed analogs came in, but the basal insulin was flat insulin, that is the Lantus. And then glargine 300, I don't know whether you might have heard the molecule talk from the person who's invented the glargine 300. I think he was describing how it has been done. It is a drug with less variability. The glycemic excursions are very, very less, and more prolonged action of the drug will give a better sort of molecule to use when you need it. So the smaller volume can be injected, and smaller subcutaneous depot is produced when compared to the other molecules, and then the different absorption kinetics for a non-gradual releases happens. And then the distinct PK/PD profile, and that makes it a huge difference in the molecule as a whole. When it goes to a smaller surface area, you see the glargine 100 and glargine 300, the area is very, very less, and it is the same molecular structure, but the mode of protraction and metabolism makes it unique, so that the variability is less, and it is available for longer duration, and so you can use it in and around 3 hours. I'll come to that. The PK/PD, because of the more stable and prolonged action, injection timings can be flexible between 2 to 3 hours. Now, the better efficacy with lower hyperglycemia and weight gain, when you compare it with glargine 100, we are not comparing apples and oranges here. We are comparing apples and apples here, small apple and a big apple probably, and less weight gain when compared to glargine 100. And switching from the first generation basal to glargine, it improves the significant improvement in the pain score with the easy usage, and switching preference of the first generation to the 3U300 makes following scores: easy use, forced to inject, switching preference, and pain. Those people who have started using the molecule, the device itself has got a unique technology. And this is the advantages of generation 2. Gone Rajinikanth movie of Endran 1 and 2, the modern one, the generation 2 insulin has got a better efficacy and longer duration, and reduced glycemic variability, as I mentioned, and it can be easily titrated, and that's the main thing. So you got a 6, 8, or 10, you can just titrate it, and then patient satisfaction is just amazing. And the weight gain, you can get the patient confidence to you. I mean, if you start on a basal insulin, like 6 to 8 units, what they thought about insulin will go off, and patient will be in your side, and even if you consider a bolus insulin during one time, they won't say no to it. And that is the experience I got. So practical consideration, you can start as a 0.2 unit. So for example, if you got a 60 kilogram man, you can go for 10 to 12 units at any time of the day, and all OADs can be continued. We had a discussion about it already, and the duration is good, and the hypoglycemia risk is less. Any clinician or a GP can start it, and then you can titrate it based on the response. So as I mentioned, the device has to be good as well. I remember the AutoPen days when it's been launched with Glargine. This terrible when it's been used, and we had loads of challenges. The injectable goes in, it gets stuck, and there's so many challenges. People will bring it back because in Caucasians, we have to use long, very high dosage of 30 to 60 units sometimes as a basal insulin. And that time, AutoPen can't go more than 40 units, and it was a terrible pen. I think it's come a long way to what we got the 2-geo pen with less injection force, and even the volume can be accommodated more, and it is very, very easy to use. So it is a reusable pen, but it looks like a disposable pen, but it's a reusable pen, but it's got a dedicated cartridge storage, and it's the usage, it won't get any wasted, and that is one of the things. And then the pen dimensions are also, those who used will know very, very clearly. And as a doctor, sometimes we don't explain anything, but if you handle the pen yourself, you will know. Even the 1 unit adjustment is there, short dial extension is there, and also the one unique thing is about 450 units compared to 300 units each, this thing. It gives a psychological advantage. If you get a 10 units per day patient, then you can use it for extra another probably 15 days or so. So in summary, I'm not here to compare apples and androids here. But I think it's just to think the safety of any molecule what you're going to use, and I feel the basal insulin are the way forward if you want to titrate it along with OADs, and if you want to use the molecules, then the safer ones are all the second generation one. You got BMW to use, you got Audi to use, you got this thing, so you can choose what it is. And I know the cost comes here, but I think it comes with the safety advantage as well with hypo, and weight gain risk is less when compared to other molecules, and it is the A1C reduction and the glycemic excursions are very less. And I've just shown you in one picture with all the quite a lot of advantages of the generation 2 insulin. With that, I think my time is over. Thank you very much for the wonderful opportunity and for patient listening.
Thank you, Dr. Suresh Damodaran, for showing great benefits of second generation basal insulin. Now we are inviting our third speaker. We will have discussion at the end of the session.
But I still ask Bansi to have a dance with each program, you know. We will get better crowd.
I think it will be the last all, so it might not be audible. We are going to our third session. We are inviting Dr. Tejas Shah. He is a diabetologist and director at IVA Diabetes Care Center, Mumbai. Honorable diabetologist at SL Raija Fortis Hospital. Also diabetes care centers in Malad and Andheri. He is visiting faculty of fellowship in diabetology at D.Y. Patil Medical College, Navi Mumbai. Founder and president of United Diabetes Forum. Also organizer, scientific committee and faculty of CID from 2014 to 2021, and speaker at various national conferences. Also a practicing diabetologist since 23 years. So without wasting much more time, please, Dr. Tejas Shah,
thank you.
Proceed for session.
Thank you very much. Good afternoon, everybody, and a big thank you to dear Dr. Bansi and the entire team of Diacon. So my two colleagues have already started the session and spoken about the newer generation insulins. I am going to take you a bit back in time again and back to the basics a bit, because I'm going to talk to you mainly about the basal insulin optimization and moving towards a more patient-centric approach, particularly in India. So we know that type 2 diabetes is a progressive disease, and over a period of time, patients from starting off with lifestyle, starting off with oral medications, ultimately reach a stage where they require insulin at a given point of time. The problem again comes because even after taking insulin, we see a considerable amount of people remaining at an uncontrolled state. The average HbA1c at the time of initiation of insulin in our country is somewhere around 9 or 9.5. The average duration of years after patient starts insulin is somewhere around almost more than 7 years, remaining uncontrolled on 2 or 3 drugs. So the problem here comes is that there are gaps at multiple places. There is no clear-cut guidelines, particularly in India, which talks about the ideal way to start insulin, the ideal dose, the ideal titration methods, and the way to go about in intensification. And that's where the problem lies, because we remain at a higher level or we remain at an uncontrolled state for a longer period of time. So this is an overview of my talk, where we are going to talk initially about the how, why, and when or of insulin initiation, or how to start. Going on to the reality of titration inertia and how it exists, which is the best possible way to overcome this titration inertia, particularly choosing algorithms which are more simplified and more easier, and addressing the unmet need of titration algorithm complexities, and going on to a basal plus concept also, which can play a role, particularly to simplify the therapy for patients with diabetes. So let us first understand the how of basal insulin initiation in diabetes management. Again, as I told you, there is no clear-cut guidelines which tells us exactly how to start, but we need a way which is simple. We need a way which the patient can understand or comprehend easily. If you just tell a patient to start off with a very large dose and does not know further what to do for a month, it becomes difficult for these patients to continue a therapy also. The simple way to start off a basal insulin, as what has been recommended ideally, is either you decide in terms of your body weight, or and you decide in terms of unit per kilogram. So if the person's body weight is somewhere is around 60 kgs, if his A1C is less than 8, and then you can start off with around 0.2 unit per kg. And if the A1C is more than 8%, the recommendation is to start somewhere around 0.3 unit per kg. And subsequently, according to the weight, the dosage of insulin will keep on changing. Two important bodies had endorsed these views of insulin initiation, particularly in Indian patients. The one is the BE Smart expert opinion, and the second is the Delphi expert opinion. Both more or less recommends that the basal insulin regimen, which is the most widely recommended insulin regimen all over the world to start off with, you can start off with around 0.1 to 0.2 unit per kg, depending on the degree of hypoglycemia. And overall, the Delphi expert opinion also says that 8 to 12 units is the ideal way to start off. If you think of patient is at more risk of hypoglycemia, as it's like a more or less elderly patient, or more chances of getting hypoglycemia, you can also start off with a lesser dosage of 4 to 6 units per se. And then ask the patients to follow up at around at least 2 weeks after initiation for assessing the need for titration or to intensify the therapy further. Now let us understand the why and how of basal insulin titration. The fact is that titration inertia exists. The fact is that titration is a problem. The best possible time to titrate the dose is the first 12 weeks of after you start insulin therapy, is what has been recommended all over. That from the time of initiation to up to 12 weeks is the time when the maximum change in fasting sugar and the change in HbA1c is recorded if you titrate the doses well. 85 to 90% of the type 2 diabetic patients using insulin and oral drugs, and almost 80% of the patients who are using insulin are still not at a target even after you start insulin. It could be because of the progressive nature of the disease, it could be because of the comorbidities. But the fact is that the titration which does not happen, the intensification does not happen, is also one of the major cause for this. This is an interesting data which looks at, it was an interesting study. It is a sub-analysis done from a study called Aloha study. They grouped people into 4 different categories. It mainly looked at the assessment of change in fasting sugar and HbA1c in 4 different groups. One of the group was where patients had an A1C of less than 7, with the total unit of insulin that was started was less than 8.5 units. The second group was where the insulin requirement was more than 8.5 units to begin with, and the A1C remained at less than 7. The third was where A1C was uncontrolled above 7, and the dosage started was less than 8.5. And the fourth was when there was more than 7 and the dosage started were more than 8.5. The maximum change in sugar, the maximum change in fasting sugar and HbA1c that was noted was in the group 2. That means those patients where the dosage was initially that was started was more than 8.5 and the A1c maintained less than 7 showed the maximum drop in A1c, showed the maximum drop in fasting sugar. What it tells us is that it is necessary to start off a patient on an adequate dosage, not very less maybe, and necessary to monitor them over a period of time, that which gives us the desired effect much more earlier. The key problems regarding titration is that we do not again have proper guidelines. There are problems associated with the healthcare physicians as well as the patient to basically accept insulin therapy. This was an online survey done to determine how the acceptance is related to insulin initiation and titration. Interestingly, in this, 75% of the physicians said that they did speak about insulin initiation or titration or intensification to the patient in the first visit itself, but only 16 to 20% of the patients actually could record that they or remembered that they were told about this. What it tells us is that most of the time patients are not aware enough what they need to do after starting insulin. We in a clinic start insulin, give them a prescription, we teach them maybe, but we do not talk to them further about what needs to be done in the subsequent 4 to 6 weeks over a period of time. This is again a data from the NAN study. NAN study here compared patients who were in the from 2007 to 10 versus those with the same data in 1994 to 1998. There was an improvement in terms of blood sugar control. There was an improvement overall 50% reduction almost or 51% reduction in number of patients who achieved a good HbA1c. But the fact was that still there was almost 49 to 50% of the patients who remained at an uncontrolled state in spite of getting the best possible therapy or in spite of being on insulin also at a given point of time. This is an Indian survey, the IDMPS Wave 7 data, subgroup analysis, again looked at number of causes which were responsible for poor glycemic control. Lack of titration of insulin and the fear of hypoglycemia were the main two contributory factors here again, which showed that why patients remained uncontrolled in spite of being on good therapy or insulin therapy. Patient reluctance, unwillingness to consider basal insulin treatment, patients' non-adherence to existing medication regimens, inability to self-monitor blood glucose properly or at a given frequency what is recommended are the other reasons which are commonly there because of which patients don't titrate or patients don't follow the insulin therapy properly. So titration inertia is definitely a reality. It is there between us and we are the ones who need to overcome this inertia by talking to our patients more and making them understand what needs to be done. Progression of type 2 diabetes and increased comorbidities is again one of the cause. Despite the use of insulin therapy, larger studies have shown that in clinical practice, the desired glycemic control is not reached and suboptimal dose titration is mainly a key barrier in order to achieve or desired glycemic control. In terms of healthcare physicians, the reluctance by us to talk to the patients regarding this, the fear of weight gain, the fear of hypoglycemia, fear that it may have an impact on the quality of life are all the factors which are there in the minds of the patients as well as doctors who are treating this. Enough flexibility is not there sometimes in the kind of regimens we are using. Complex titration algorithms, if we teach our patients from the very first day, it becomes difficult for them. For a patient whom we are starting maybe on insulin twice a day or a basal bolus, and if you start teaching them adjusting all the doses from the very first day, they are not going to grasp them that easily and it becomes a problem to follow up over a period of time. And of course, lack of self-monitoring of blood glucose is again an important area. SMBG is sometimes not spoken about enough in our OPD practice. All patients on insulin needs to be on SMBG. That is a golden rule. And we need to talk to them. When you start insulin, we need to again tell them the importance of SMBG and why they need to do again and again if they're taking insulin. The other area which is again of concern is hypoglycemia. As my co-speakers have already shown how the newer generation insulins are safer, though they reach the desired glycemic control maybe in the same way, but the incidence of hypoglycemia is much lesser when it comes to these generation newer insulins. So the need to address this need of hypoglycemia is an important area. If you understand that hypoglycemia is a factor which is a deterrent factor to achieve the desired control. One episode of hypoglycemia actually pushes a patient back and much demotivates him to control his blood sugars much well. This is again an interesting data where they looked at patients, compared patients who had an episode of severe hypoglycemia from a survey done through a questionnaire. Interestingly, in this survey, they found out that type 1 diabetic patients actually had more incidence or more fear of hypoglycemia for mild to moderate. But when they looked at severe hypoglycemia, they found out that type 2 diabetic patients in fact had more than 80% for fear of hypoglycemia as compared to 60% in type 1. It tells us the importance of severe hypoglycemia and how it demotivates or pushes a person back. So the fear of hypoglycemia needs to be overcome. There is a decrease for the tight glycemic control, poor adherence of therapy, reduced willingness to intensify therapy, and overall compliance and adherence does go down when a patient goes into an episode of hypoglycemia. It also leads to intermittent snacking, it also leads to weight gain, which are all the factors which can again deteriorate our glycemic control. Two important studies again done here, where they have compared basal insulin versus premix insulin to look at the incidence of hypoglycemia. One of the studies here had patients on sitagliptin and was given glargine versus compared to premix insulin twice a day. More or less, the glycemic control was more or less similar in both the arms, but the risk of hypoglycemia was almost 4.5 times higher in the premix twice a day regimen as compared to the glargine regimen. The number of patients reaching HbA1c less than 7 again was similar, but the incidence of overall hypoglycemia, symptomatic hypoglycemia and nocturnal hypoglycemia all were much lesser in the glargine arm as compared to the premix arm. This is a head-to-head comparison again of basal insulin versus IDACAPS, again showed in one of the earlier presentations here. Again, this is a comparison between glargine 100 versus IDACAPS. In terms of efficacy, both were found to be similar. IDACAPS was non-inferior to glargine here, but in terms of hypoglycemia, there was an 86% higher overall rate of confirmed hypoglycemia with IDACAPS as compared to glargine 100 here. So when we talk about titration algorithms, it is important that we make these algorithms also much easier for our patients to understand. There have been some studies which have been done in the past like INSIGHT and LANDMAT and T2Target. They again all achieved the desired glycemic control. These were studies where the target of glycemic controls were much lesser. They tried to aim for a fasting sugar of somewhere between 70 to 90. They did achieve that, but it did result in a higher incidence of hypoglycemia and some amount of weight gain. So we need to again understand that our patients need something much more simpler. If you look at data from Atlantis and Goal A1C studies, Atlantis was a study where they looked at two different algorithms. One was a patient-centric algorithm where the patients used to self-titrate the dose, and one was a physician-induced algorithm where the physician used to call the patients weekly or 2 weekly and titrate the dose. And interestingly here, the arm where the patients did the self-titration, they could achieve their HbA1c much better. They achieved the fasting blood glucose much lesser, and the incidence of hypoglycemia was also much lesser. What it tells us is that if you teach the patients well, if you motivate them well, give them simple algorithms, simple targets to begin with, we can achieve the control in a much smoother and a better way with a simpler and a safer insulins. This is one of the Indian consensus which came out related to titration, where it gives a simplified approach depending on the blood sugar or fasting blood sugar level. Give them a target level of say between 80 to 130, anything going above 130 to 160, a 2 unit dose increment, or anything lesser than 80 will give a minus 2 units of insulin, which becomes much more easier. Titrate insulin based on the average of 3 most recent readings, and increase the dose once or twice a week if fasting is above the target. There are problems specifically to our country also. There are barriers for a patient to accept insulin. There are barriers to accept the disease. Low levels of awareness among both patients and physicians is there. Constraint on patient time and resources. The cost becomes a problem sometimes. Lower rate of adherence to therapy is there. Of course, there are other therapies which are given to the patients. They keep on learning this from other sources, and ultimately sometimes they drop out insulins also. So importance of SMBG needs to be taught to the patients, highlighted to them, make them understand why it is important to do blood tests regularly. There is a lack of structured patient education and support programs which needs to be more aggressively done and made the patients aware about education. We need to encourage our patients better for adherence to insulin therapy and support programs. And several trials have clearly shown that if we can titrate our insulin regimens better, it will be more effective over a period of time. So going on further from basal insulins, I'm going on to one step further. There comes a point of time where we know that a basal insulin might not be sufficient enough. A patient's blood sugar levels are still maybe not, or will not be at a control. The A1C might not be at target in spite of taking maybe around 30 units of insulin or more than 0.5 unit per kg per day. So that is the time we need to understand that we need to move on from one basal insulin to maybe we need to go further. What has been recommended again is, clinically we know that it has been recommended that we can either go to a premix insulin twice a day, we can go to a basal bolus regimen, or we find a way somewhere in between. A premix twice a day, we know that works well, but it does make a patient push into hypoglycemia at some point of time. The chances of weight gain are sometimes more, and it needs more it is a very rigid regimen per se. Patient needs to be cannot be very flexible in terms of his routine. When it goes to basal bolus, it is something which the patient should be motivated enough to take 4 doses a day, though it is the best way by which you can control the blood sugars, but the motivation and adherence needs to be there. So basal plus is a regimen which is also recommended by American Diabetes Associations and other associations. It is where we add a single dose of rapid acting insulin with the largest meal of the day, mainly to correct the postprandial surge that is happening, and we continue with the basal insulin at night time after dinner. What it does is that when we are trying to blunt the postprandial peak that is happening with the largest meal of the day with a shorter acting insulin, it overall helps to blunt the surge in blood sugar that happens following the larger meal, and thereby leading to a better glycemic control. This is an interesting study which was done called the proof of concept study, where they looked at initiating insulin glucin as a single dose with the largest meal of the day, and the patients were first given basal insulin for the first 3 months and then added glucin for the next subsequent 3 months. For patients who were uncontrolled, even remained at an A1C above 7 in spite of being on basal insulin. What it showed was that at the end of the study, those patients where addition of glucin was done, there was definitely an improved glycemic control. More number of patients achieved an A1C of less than 7, and there was no increase of hypoglycemia or weight gain seen in either groups or even in the patients where glucin was added. So mealtime insulin may begin or could be an easier way to start off when we are thinking of intensifying therapy from one insulin to other. A small dose of 4 to 6 units can be started off with, or depending on the blood sugar, postprandial blood sugar level, and a smaller dose of 0.05 to 1 unit per kg can be overall started off with. Last slide, please. So to end my talk, titration inertia is there, and it does exist due to a fear of hypoglycemia and weight gain, which leads to inadequate insulin up titration and poor glycemic control. A patient-friendly dose up titration strategies is needed with the basal insulins, which helps us to achieve the desired glycemic goal. Simplicity and convenience of once daily regimens with basal allows the patient better empowerment for effective insulin dose management in insulin settings. Progressive nature of diabetes may result in subsequent intensification of insulin treatment to achieve the desired goal. A rapid-acting and a long-acting analog per se mimics the endogenous postprandial blood sugar insulin secretion and helps us to control the postprandial surge as well as the fasting blood sugar better. And a stepwise intensification with glargine with a single injection of glucin can be considered as one of the therapies in clinical practice. Thank you very much.
Thank you, Dr. Tejas, for explaining benefits of titration of basal insulin. Only starting of basal insulin is not important. SMBG and titration is too much that important. Now please Dr. Supratik Bhattacharya and Dr. Suresh Damodaran come on the stage for our last session, question answer.
We can take couple of questions. Anybody? Please come forward. Yes, sir.
Dr. Sanjeev Pathak is there.
Sir, Apple and Android, sir. I think you confused everybody. It's normally comparing apple and oranges, and I think Sai has promised to bring apples next time with the small and big apples. Small will be Lantus and big will be Toujeo.
So, if glargine U100, Toujeo and Degludec and Rhizodec maybe, I'm speaking brand name because they are the only ones. If they are available at the same rates, what would you prefer, each one of you?
No. You can talk about apples. And come on.
Okay. So thank you for the question. So my response is, again, co-formulation is a basal plus. So we would not compare that when we are comparing, say, U300 glargine with IDEG. So the clarity is we are comparing two second-generation insulins. Now, what are the distinct advantages? So BRIGHT study was done and published in 2018 by Julio Rosenstock, and he clearly mentioned on the top that there are more similarities than differences. What was the glaring difference that came out? During the first 12 weeks of up titration of the dose, when the patient is most vulnerable, there comes the difference of reduced incidences of hypoglycemia with U300. Patient is fearful. This is the first time the patient is taking insulin, and if they undergo even a single episode of hypoglycemia, they will drop out. And you will never get that patient back on insulin again. So in that scenario, clearly U300 wins. Where else? We had already talked about probably one of the places where U300 clearly wins is the volume. So you're clearly giving lesser volume. So when you're going up the dose, here you can't use more than 50 units of IDEC at any point of time. You can use up to 70 units of U300. So again, a big advantage with U300. The third thing was slightly, I wouldn't say it's an advantage, but visibly if you have 450 units, to the patient it seems like you're using the same vial for a longer period of time as compared to that which has got 300. But as compared to efficacy, as compared to safety profile, time in range, U300 and IDEG are very, very similar. There are still certain differences in prices. I'm sorry to say that. One comes at a slightly lesser price as of now. Maybe they are going to match very soon.
Yes, sir.
In patients of chronic kidney disease, which would you prefer? Would you prefer Lantus 300 or Degludec? If so, why?
So I think again, when we are looking at chronic kidney disease, we are looking at avoiding hypoglycemia as a main concern. So I don't think there is any head-to-head study to compare patients with in chronic kidney disease. But as we know that U300 would definitely have a lesser chances of getting or a delayed hypoglycemia because of the mechanism of action, because of the there is no tailing effect, etc., which happens with U300. And therefore, that would naturally maybe be a better choice to be used in patients with chronic kidney disease.
I think with Degludec there is more protein binding. The mechanism of action is binding to protein. In patients of chronic kidney disease, they have less protein because of proteinuria, and therefore the more free drug is available. So chances of hypoglycemia are higher in patients when you use Degludec versus when you use U300. So that's the advantage. And that was exactly what was shown in the BRIGHT kidney study. We looked at these two molecules and said that this molecule is better and safer.
Yes. I think it's a very good point that has been brought up. And obviously, whether it translates from theory to practice, we do not know. But for me, I can share my experience. All my CKD patients are on Toujeo. So that is my clinical experience.
Thank you for bringing that up. But the point is, I think, coming back to the previous question, when you want to use the co-formulation, I'm sure every one of us uses, I use it. Now, when it comes to practicality, you use twice daily, and you always find that you have to use a rapid-acting one at lunchtime, and that is the challenge. So you might as well go for a basal bolus. So you can split the dose and give in a decent way rather than using a co-formulation and confusing. So when it comes to an area where the Rabbit-2 trial, like an inpatient one, or whether you got challenges like a COVID patient admitted with extreme sugar excursions with because of steroids and other infections which is facing up now with influenza B and I don't know, swine flu is coming up in Tamil Nadu in a big way. So all these infections, the excursions will be very high. So basal bolus will be the way forward compared to a co-formulation in that situation. But regarding the renal, it's a great point what Sar has mentioned.
Any more questions? Thank you, Dr. Supratik Bhattacharya. Thank you, Dr. Suresh Damodaran, and thank you, Dr. Tejas Shah, for this great session, Basal Insulin Symposium. Any question or any comments from audience?
We'll just stand and take a photo. Just stand there.
Thank you all the speakers. And thank you. Now we are moving to the our next session, which is a hot cake in current situation, diabetes and heart failure symposium. So I am inviting to please come on the stage Dr. Harshad Patel and Dr. Mukesh Ladda to chair the session and proceed.
He was the one who established the concept of the circulation and brought hemodynamics into picture. And Richard Lower was the man who said there are various manifestations of heart failure. And Raymond Wiesens, who was the French anatomist, described the complete picture of heart failure with edema feet in a patient of mitral stenosis. We all know diabetes is a very complex disease. And as seen by this Venn diagram, that you have heart failure, chronic kidney disease, type 2 diabetes, and atherosclerotic cardiovascular disease are all intertwined. And you can see by this Venn diagram. So 12 to 45% of the patients of heart failure have diabetes, 16% of the population of patients have diabetes, and we have 35 to 45% of the patient with heart failure have chronic kidney disease. So it's all intertwined and linked with each other. And if you look at the physiology of heart, we have 50 to 100 ml is the stroke volume, and 60 to 90 beats per minute is the heart rate. That gives you about 3 to 9 liters per minute is the cardiac output, and this can increase up to 20 liters in people who run, who have shivering or overeating, stress, sleep, infections, and so on and so forth. And this is generated for presence of diabetes itself, the risk of heart failure is very high. And this is the understanding of the heart failure in a patient with diabetes. On left, in patient with a type 2 or type 1 diabetic with the hypertension, cardiomyopathy, and the nephroneuropathy, and coronary artery disease and a microvascular disease, the risk of symptomatic heart failure is pretty high. On the right, you see patients of type 1 diabetes who have an increased blood sugar, and that itself causes the disturbances into the muscle activity, and that muscle myosin is exposed to T cells, which presents as a dysregulation of the immune system, presenting as the hyperemic response, and therefore damaging the muscles and having the autoimmune background to the manifestation of heart failure. And therefore, when you look at patients of heart failure and diabetes patients, we have the sex, for example, if you look at the preserved heart failure, which is very common in a female patient, reduced heart failure, reduced ejection fraction heart failure, common in male patients with a diabetic nephropathy and a coronary artery disease and hypertension, ultimately results into cardiac failure. I can see the picture on the top, the increasing the dimension of the left ventricle. And what is very interesting, those patients who have heart failure also have a decreased pancreatic dysfunction and having the insulin resistance, and therefore causing what is called the cardiogenic diabetes. So therefore they feed each other. The heart failure feeds the diabetes, and diabetes feeds the heart failure. And therefore, this was a presentation in European Heart Journal, and what it shows that the insulin resistance causes hyperglycemia, hyperglycemia causes heart failure, and heart failure causes insulin resistance. And what is the proof for this? They use the left ventricular assist device, and they reduce the patients of heart failure, they reduce insulin resistance, and they reduced hyperglycemia, telling us thereby that these three are interconnected with each other, they are inseparable from each other. So therefore, what was seen, that diabetes and heart failure are the two sides of the same coin, because both of them have sympathetic nervous system activity, they have increased renin-angiotensin system activation, and they also have increased neprilysin. And what is interesting, that these two are the drivers of the microvascular complications and a heart failure progression. We always been taught that it is the hyperglycemia which drives the microvascular complication, but it is the sympathetic stimulation which is the driver of the microvascular complication. And therefore, the heart failure and diabetes are both characterized by the increased distending pressure in the left ventricle and in the glomerulus. And you see, the treatment of them, both of them, is also similar. For example, ACE inhibitors used for both. The angiotensin receptor blockers are used for both. The MRAs can be used for both, and so is neprilysin inhibitors. So therefore, they share a common soil, and therefore they have a common presentation. And how this is possible? This is possible because the heart has a transporter called, and then cardiomyopathy. So therefore, it is the stimulation of sodium-hydrogen exchanger which is responsible for these microvascular complications rather than the hyperglycemia that has been taught to us in the medical school. And what is interesting is that cardiomyocyte does not have SGLT2 receptors. We all have beneficial effects on cardiac failure with using SGLT2, but interestingly, there is no receptor. How does it work? It works on sodium-hydrogen exchanger. In fact, there's a docking site for SGLT2 on NHE1, and that makes it act on the myocardium, and therefore get all beneficial effects of the heart failure with SGLT2 use because of the action on this particular transporter. So we have this association between diabetes and heart failure, which is a metabolic in origin. We know that increased free fatty acid, which causes sympathetic stimulation, which causes sodium absorption because of insulin resistance, and that causes hypertension, which is a risk factor for heart failure. And also, the increased free fatty acid causes deposition of what is called epicardial fat. And this epicardial fat is causing inflammation in the myocardium by producing the microvascular abnormality and therefore producing heart failure in these patients. What is the most important part of the entire metabolic understanding is what is called the metabolic flexibility of the myocardium. What you see here in this picture, that heart uses the fatty acid, glucose, branch amino acids, and ketone as a nutrient. But in patients of heart failure and diabetes, there's a high amount of free fatty acid I mentioned already. And a free fatty acid is a dirty fuel. It doesn't give that much of ATP as you expect to. You get only 2 ATPs molecules with 1 atom of oxygen when you use free fatty acid. You get 3 ATPs when you use oxygen. You get 3 ATPs when you use ketone bodies. So therefore, this is a dirty fuel. And when you have excess utilization of fatty acid, it causes accumulation of ceramide, which causes inflammation and therefore fibrosis and therefore heart failure. So this is the reason of metabolic flexibility which is causing heart failure. We all know about heart failure of patients with preserved ejection fraction and reduced ejection fraction. And you see in patients who have obesity, which is the main driver for the preserved ejection fraction, is because of the systemic inflammation, and there's an excess amount of advanced glycogen products, and also hyperinsulinemia, which brings about hypertrophy of the myocardium, and if we get preserved ejection fraction. As opposed to that, in patients with reduced ejection fraction, we have the excess amount of AGEs, and also there's a lipotoxicity, which is a component in patients with reduced ejection fraction, and for these patients have an increased amount of fibrosis produced by the fibroblast, and therefore they have a dilatation of the myocardium. So goes the heart, and so goes the kidney. And in initial part, when you have a neprilysin activity is better, then you have a diuresis, and therefore the patient can overcome the crisis. But when it becomes chronic disease or chronic heart failure, there's a more sympathetic stimulation that brings about retention of renin, and that brings about excess angiotensin 2, and that causes increased blood pressure, and therefore heart failure is more. We all know that the erythropoietin is produced by the kidney and is destroyed in patients of diabetes. Why so? Because it's produced in the proximal tubule by a specialized cell called fibroblast. And when they have excess of glucose coming in the proximal tubule, because overactivity of SGLT2, what happens is destroy these fibroblasts, and therefore erythropoietin production goes down. When you give SGLT2, it blocks the SGLT2 transporter, and therefore the glucose is no more absorbed, and there is no oxidative stress, and therefore these patients improve their hemoglobin. So eventually, whether you think patients have diabetes, obesity, and chronic heart failure, what is the problem? The problem is when you have hyperinsulinemia, adipose tissue expansion, accumulation of glucose and lipid intermediate products. And this causes suppression of autophagy, oxidative stress, and therefore decreased function of the tissue. And therefore, there's an upregulation of AKT and mTORC1, and downregulation of SIRT1, PGC1 alpha, and FG121. And this is the reason why you get heart failure in patients with diabetes. So therefore, if you summarize what I said so far, that diabetes causes inflammation, dyslipidemia, and chronic coronary artery disease. which causes again diabetic cardiomyopathy and heart failure. And we have stimulation of RAS activation, improper calcium handling, and autonomic dysfunction, which ultimately results into diabetic cardiomyopathy and heart failure. Atrial fibrillator begets heart failure, and heart failure begets atrial fibrillation. We know that there's a complex association between these two, and is again very common in patients of diabetes. Sleep apnea also increases the heart failure, both preserved and a reduced ejection fraction. You can see that 50 to 80, 50, 40% of the patients have the heart failure in patients who have the AHA score of more than 15, suggesting that these two can coexist together. There are many drugs that we use in patients of diabetes which can also cause heart failure. For example, the drug like DPP-4 I mentioned and insulin, TZDs can cause heart failure, but drugs like SGLT2 improve the heart failure. So therefore, knowledge of the drugs that the patient is taking is also very important. So in general, the diabetes, heart failure, and renal dysfunction is the vicious circle. They all together, they move together, and they act together. And heart failure is a progressive disease with a poor outcome. You can see in those life study and the renal study, the death rate is almost 6-fold compared to people without heart failure. And this is the classification which is given in what we discussed. The next speaker is going to discuss more on this. And this is the heart failure with reduced ejection fraction and preserved ejection fraction, widely reduced, and the improved heart failure, which are described based on the echocardiography. And to end my talk, the final words, this is from Milton Packer, who wrote in Diabetes Care that there's a strong bidirectional association between diabetes and heart failure. Heart failure is the most important, most preventable, and treatable cardiovascular complication of diabetes. A number of pathological mechanisms like hypertension, chronic kidney disease, coronary artery disease, and immune dysregulation do an important role, and use of glucose-lowering agents can influence the evolution and the progression of heart failure, both either favorably, unfavorably, years before their effects on the microvascular events. I want to emphasize this, years before their effects on the microvascular events, possibly through the actions on their common mechanisms. With that, I conclude my talk. Thank you very much for the patient listening.
Thank you, sir. Sir has taken back to our school time, medical school, and clearly shown that diabetes and the heart failure have clear association. Diabetes itself act through multiple pathway and affect the heart failure. And controlling the diabetes itself can decrease your heart failure symptoms. Now coming to the next talk, next speaker is our Dr. Anish Chandrana. He is a senior cardiologist from SIMS Hospital, and his keen interest in clinical cardiology, non-invasive cardiology, and has been pioneer in establishing PAMI in the own institute, and he is a former assistant professor at Institute of Cardiology and Research Center, Civil Hospital, and he has published a lot of papers in national and international journal and given more than 700 lectures to the medical student and practicing doctor at state and national level. So he has been a very regular exerciser, an athlete and a sport person from childhood, and has been a student of Vipassana. Believe in training body, mind and spirit to make the maximum out of life. So thank you, sir. And back to sir.
Thank you for those kind words. At the beginning, I would like to appreciate you all and Dr. Bansi and Diacare Con for not only putting up this good conference, but also getting me here to discuss about heart failure. I mean, we know that in last 2 years, or less than 1 year, 2 biggest society of the world have released treatment of heart failure guidelines, and we'll touch very important points out of all those which have been pushed forward. I'm sure many of you are aware about so many things, but I'm also sure that by next 15 minutes discussion, we can add something to your knowledge so that you can put into your practice right from tomorrow. So we all know that heart failure is basically signs and symptoms. So there are doctors perhaps who have a myth in their mind that heart failure has to have a relation with ejection fraction. So there is no relation of heart failure to ejection fraction. One can have heart failure at whatever level of ejection fraction, ranging from 5% to 65%. So heart failure basically is signs and symptoms. If you go to the olden days, Framingham criteria for heart failure, pedal edema, paroxysmal nocturnal dyspnea, neck vein distensions, crepitations, cardiomegaly, acute pulmonary edema, tachycardia, pleural effusion. So these are the signs and symptoms. But to make a diagnosis of heart failure more logical, more uniform, and make it more sensitive and specific, few things have been put in last 1 year. So symptoms and signs of heart failure caused by structural and or functional cardiac abnormality. So there has to be either structure or function of heart going wrong, and that has to be corroborated by at least one additional point. Either a patient should have elevated natriuretic peptide, which is a marker of elevated end diastolic pressure in the ventricle, or patients should have objective evidence that pulmonary or systemic congestion is because of the heart issue. So this is how simplified definition is. And we all know that staging of heart failure, that is stage A, B, C, D, was placed before 15, 20 years, but now we know it very well. Why staging? Staging gives us a sense that if you do not arrest the process at early stage, then there is a chance that patient will deteriorate and go to the next stage. So it will increase the sensitivity of physicians to treat the patient at a given stage. So stage A and stage B are the patients who never had symptoms of heart failure. Stage A means those patients who are at a high risk of heart failure. So if we can treat those risk factors at that stage, we can prevent heart failure. Say for example, somebody who is hypertensive, no left ventricular hypertrophy, no signs on ECG, no signs on echo, but just mild hypertension. So he or she may not have any symptoms, may not have any structural or functional cardiac abnormality, but he or she is at stage A heart failure. Stage B means you have some structural or functional changes which can be documented by echocardiography or some other test. So say for example, I am hypertensive, I have got left ventricular hypertrophy, so I am stage B heart failure even if I have never symptoms of heart failure in my life. Stage C is something which we commonly see, that is the symptomatic stage of heart failure, and stage D is a sort of advanced or end stage heart failure where you have to think on different lines. Now as I discussed, the heart failure has also been defined based on the signs and ejection fractions we got on echo. So those patients who have got ejection fraction 40% or less, that is generally most of the people appreciate as heart failure. That is called as HFrEF, heart failure with reduced ejection fraction. While people who have got 41 to 50% ejection fraction, they are heart failure, mid-range or mildly reduced ejection fraction. And then there are people who have got ejection fraction 50% or more, but still they have got heart failure symptoms and signs. And they have got certain additional evidence on echocardiography, like left ventricular increased mass or LA dilatation, etc. So they are the people who are having heart failure with preserved ejection fraction. Now these are not strict boundaries. A patient who has got HFrEF, ejection fraction 30%, might get treatment and improve to have ejection fraction of 45%. Or vice versa, a patient, him you see the ejection fraction of 45%, and then somehow because of some reason he may deteriorate ejection fraction and can go to reduce EF. So this is something which is important as far as classification is concerned. Various tests we need to do in a patient with heart failure. Very important point is BNP or NT-proBNP. So this is less well used by most of the physicians, so that's why I'm stressing this point. Please start using BNP or NT-proBNP. That not only helps to diagnose heart failure, but also gives you an idea about the gravity of situation and prognosis. Cardiac MRI is another point which has been less used, but it gives you a good idea about certain inflammatory storage or inflammatory disease leading to heart failure, as well as it also can give you idea about fibrosis of myocardium, inflammation and edema in the myocardium, some idea about viability of myocardium also. Even based on the need of patients, based on angina or positive stress tests, we can do angiography, and all these tests ultimately help the patient to get rid of heart failure. So number one, treatment of chronic HFrEF. Patients who are NYHA class 2, 3 or 4, ejection fraction less than 40%, we know that there are 4 important class of treatment. Initially it was ACE inhibitors, which is class 1. Nowadays, since ARNI, which is combination of valsartan and sacubitril, has a strong data that it improves mortality and recurrent admission much more than ACE inhibitors. So ARNI has replaced as class 1 indication for heart failure. So all the patients who can have access to ARNI should be on ARNI, but then the patients who cannot have access to ARNI can go to ACE inhibitors. Mind well, ARB is not an indication. If a patient is having serious adverse effect with ARNI and ACE inhibitors, that can be either angioedema or very severe cough. That's the only place for ARB. Otherwise, please don't write ARB in patients with HFrEF. Cardioselective beta blockers, bisoprolol, metoprolol, succinate, sustained release, and carvedilol are the beta blockers. MRS, that is spironolactone and eplerenone, are the approved drugs. We all know that, and this is a conference of diabetes where DAPA and EMPA are also approved treatment for heart failure. A new molecule which has entered in both of the guidelines is vericiguat, which has a novel pathway of action. It is improving the availability of cyclic GMP and AMP in the cell. So this is a drug to be given to patients once you are there with all the 4 basic pillars of treatment, and if patients still develop worsening of heart failure. You might have many patients who are on treatment and then they come to you with breathlessness. You might have to give them a shot of furosemide, Lasix or torsemide. Maybe patient gets okay, maybe patient is not okay, and you have to get patient admitted. So this is called as worsening heart failure. So there are patients of heart failure who are very stable. You might have seen in your practice, they are having ejection fraction of 30-35%, and for years together they are good and fine. On the other side, there are patients who keep deteriorating and keep coming back to you every 1, 2, 3 or 4 months. That is called as worsening heart failure, and that's where vericiguat is a molecule. But mind well, the first and foremost is you have to get the 4 pillars of the treatment, because 4 pillars are the drugs which have got superb data to reduce mortality and readmission rate. So ARNI, beta blocker, MR and SGLT2 inhibitors. Now there are certain important points as far as these 4 pillars are concerned. Number 1, try to initiate all of them on day 1, 2 or 3. Don't wait. Previously it was a story, it was a guideline that you have to first give ACE inhibitors, push up the dose, wait for a few weeks, then start beta blockers, wait for a few weeks. Now that is not the story. The most important reason is all of this drug, they start working in terms of reducing mortality, particularly sudden cardiac death, and reducing risk of admission in the first month itself after starting them. So when you start beta blocker, by 1 month also it has reduced the risk of admission and mortality. When you start ARNI, by 1 month there is deviation of the curve. So if you delay the initiation of any treatment, you are making a patient devoid of a medicine which has got mortality benefit. So you have to start all of them on day 1, 2 or 3. Second point which is proven in various trials is even at a smaller starting dose, they start showing the effects. It's not only that when you push up a dose of bisoprolol to 10 milligram per day, then only the effect starts. Even at 1.25 milligram per day dose, the effect starts. Same is with the ARNI. You start at a dose of 50 milligram half twice a day. If you believe that your patient has got borderline blood pressure, creatinine, etc., a very important point to decide about starting all this treatment and pushing that dose is you need to look at the patients very closely in terms of symptoms and signs, blood pressure, heart rate, kidney function, eGFR and potassium. You all know that these are the parameters by which you keep on building up the dose. You know that there are certain limitations as far as blood pressure is concerned, there are certain limitations as far as potassium is concerned, and there are certain specific contraindications of a given drug also. But if you believe me that if you as a physician is very sensitive that these 4 drugs, if you start them early, build up the dose to the best possible tolerated, you are cutting down heart failure mortality by 75%. Believe me, this is something which is game changer. What does it mean? If you reduce mortality by 75%, that means you have to treat 4 patients to reduce 1 death. This is something amazingly important. So if you in your practice, in a monthly base, you are getting at least, say, for example, 10 patients of heart failure, you put them on best possible medications, you are going to save 3 lives. So you have got a very easy, a very practical chance to be very effective and influential physicians in the lifestyle of a patient. And that's by building up the dose of these 4 drugs. Obviously, as I discussed, there are certain contraindications, there are certain points of concerns. You take care of them, but your primary focus has to give the drugs and build up the dose, not to give the drugs and reduce the dose. Because see, it's all the mindset with which a physician thinks. If you're too much afraid of various concerns and side effects, your inner being will tend not to give those medications. And that's where you are doing harm to the patients. So think that how can I build up the dose, and then you will be able to do that. Be positive on that terms. Second point, patients with heart failure, mid-range or mildly reduced ejection fraction. Now these are the patients between 40 to 50. That's where most of the trials have excluded them. All the trials which are done in patients with heart failure, initially if you look to all them, they all had ejection fraction less than 35 and 40%. So practically there are not many trials in which these patients' ejection fraction have been included, but you can extrapolate your knowledge, and that's why if you look to all these drugs in heart failure with mid-range ejection fraction, the class of recommendation is 2B, not 1. But still, I personally believe that they are all those patients who are going to get benefit. There is another group of patients which is called as heart failure with improved ejection fraction. A patient was there with you with an ejection fraction of 30%. You kept on giving the treatment. Now patient has ejection fraction of 45%. The question is, should I continue the treatment or should I stop the treatment? Class 1 recommendation that continue the treatment. Don't stop the treatment, because it has been seen that patients with HFrEF, they becoming totally reversed to the normal ejection fraction with structurally and functionally normal heart is a rarity. Patient may improve their symptoms, patient may improve the structure of heart, the LV dimension may come down, LA dimension may come down, MR and PA pressure may regress, but they never go back to normal heart, and that's why they have to be continued all the possible treatment. The third zone, HFpEF, heart failure with preserved ejection fraction. Mind you well, when ejection fraction is 50% or more, the entire gamut is different. It's not the same HFrEF like patients. It's basically not a disease of heart. That's where heart is getting affected because of a chronic, strong systemic inflammation happening in body. So that's where heart is getting victimized. There is not or nothing primarily wrong with the heart. It's something which is systematic. And that's why it's a difficult disease. If somebody asks me the prognosis of HFrEF and HFpEF, it is same. If a patient is admitted with ejection fraction of 30% and heart failure versus a patient is admitted with symptoms and signs of heart failure at ejection fraction of 55, both of them will have very poor prognosis. Their 5-year mortality is 70%. Unfortunately, HFpEF is not well recognized, and secondly, there are no class 1 drugs for the HFpEF. So if you have a patient of HFpEF who is admitted, his or her prognosis is worse than HFrEF because there is no treatment for that. Of late, recently some treatment has come. We all know that diuretic, initially you can give to offload the patient of volume of HFpEF, but mind well, if you are overzealous in giving high dose of diuretics, or if you continue diuretics for longer time, they will go to acute kidney injury very fast. So be very careful. SGLT inhibitors is the first drug. Through both of them, EMPA and DAPA have shown the data that if you give this drug to people with HFpEF, the composite endpoint of admission and mortality is reduced. There are other drugs like ARNI, also through Paragon HF, has some data that if you give this drug, so patient improves. So generally, HFpEF patients would need diuretic in a small dose, and then you can stop and curtail. SGLT inhibitors, ARNI, MRS, and if patient is not tolerating ARNI or has no access, you can go to ARB. A very important point, HFpEF patients, you should address other issues like CAD, hypertension, COPD, atrial fibrillation, obesity, anemia, sleep apnea, because they would have most of them with them. If you just keep treating them with these few molecules and do not address to those issues, they will not have any impact on the lifestyle. Now, additional medical therapies, ivabradine. Patients, you try to build up the dose of beta blocker to the best possible tolerated dose. Still, if the heart rate is more than 70 in a patient with HFrEF, start ivabradine, a very good drug. Vericiguat, I said that, build up the 4 pillars of treatment, but somehow patient worsens, you can start vericiguat. Same digoxin, poor man's choice, you can give, but mind well, the dose of digoxin has to be much lower, 0.125 milligram per day, not more than that. Be careful about age and creatinine. PUFA, it keeps on coming and going off, but that is your choice, it is to be. Potassium binders, you know that when you push the dose of ARNI or if ACE inhibitors, many patients do get borderline potassiums of 5.5. Now, should they be devoid of the beneficial effects of RAS blockade? The answer is no. You can give them potassium binders, but still the data is borderline. So it's your choice. They are not even so freely available in India. I'll take 1 minute more. Certain drugs to be avoided. Anticoagulation in the absence of genuine indication. Dihydropyridine CCB, diltiazem and verapamil, please never write when patient has heart failure. Please, please never write. Even it is rheumatic heart disease. I see many patients of rheumatic heart disease, they are on diltiazem and verapamil and they have got heart failure. So be very careful. Nutritional supplements and vitamin supplements, if there is no documented deficiency, Norol, class 1C antiarrhythmics, donadenoron, even your other is this pioglitazone, rosiglitazone, sexagliptins and NSAIDs. NSAIDs are worst drug. Your 50% patients of heart failure are always on NSAID for some days of life or maybe for all days. Ask them only one question, which painkiller do you take? And most of them are taking that. So get rid of them. So coming to sort of conclusion, ladies and gentlemen, heart failure is a complicated disease, devastating disease, and you need to have a comprehensive approach to deal with a patient of heart failure. Treat the cause, maybe CAD, valvular disease, good control of diabetes, blood pressure, rest when needed, avoid extra exertions, but a very regular exercise training program is a must for heart failure patients, water and salt restrictions, treat the comorbid conditions, give them vaccination for flu and pneumonia as a primary prevention. 4 pillars of treatment, again and again, the most important point. Think of other drugs, devices I didn't discuss because of lack of time, but in selected patients you can go for devices. And we also know that certain selected patients with mechanical complications, we have options like valve replacement and various surgeries. Thank you very much for your kind attention.
Anish, excellent presentation as usual. You're a master orator. Will take the question answer end of the symposium. May I invite Dr. Sudhir Bhandari from Jaipur to deliver a talk on SGLT2 inhibitor in heart failure.
Good afternoon. At the onset, I extend my profuse thanks to Dr. Bansi Sabu for having invited for this wonderful conclave. In fact, it's very interesting. We started innovating something for diabetes and it turned out to be a drug useful for associated heart failure. Since the cardiovascular prevention trials became mandatory for anti-diabetic drugs, I think a lot of good effects were known for the newer drugs. The biggest problem is that hospitalization because of the diabetes as a result of micro and macrovascular complication becomes bigger challenge, and lately the heart failure, once neglected complication, may be as common as coronary heart disease in patient with type 2 diabetes, and that was a newer complication which we started having this. Prevention and optimal treatment of CVD in this population will be the major worldwide health policy change during next decade, and hence we need to be very careful about. So far we didn't know about it, the higher incidence of heart failure in diabetic patient. The risk of heart failure is not influenced at all. Even if you have the very good glycemic control, patient continues to have issues of increased incidence of heart failure and hospitalization because of heart failure. The risk of vascular events that persist high to very high after intensive glucose control despite of attainment of near to normal A1C levels. It means we need to be very careful and observant in type 2 diabetic for impending heart failure. Type 2 diabetes has been considered as an equivalent of cardiovascular disease, and as such each type 2 diabetic patient should be treated as a secondary prevention patient. But the issue is that type 2 diabetic is not a ischemic heart disease which requires the secondary prevention, and hence equivalence of type 2 diabetes makes it emphatic that they need to be taken, they need to be treated like the primary prevention to prevent the impending heart failure. Burden of hospitalization for heart failure is very well known. The risk of death rises sharply when a patient is admitted to be hospital and in decompensated heart failure state. Secondly, in the days after discharge, patients with low ejection fraction heart failure are at high risk of dying at home after discharge, and each successive hospitalization is associated with greater risk of death in longer term. These are all the consequences newly observed in type 2 diabetic patient. If you look at this 1 year outpatient mortality with combination of medical therapy for heart failure, even if the patient who stands untreated, partially treated, there is almost 17% mortality. People with 2-drug diabetic patient not adequately controlled have almost 10%. And even with the 3-drug combination or the 4-drug combination, even including ARNI, etc., there is some incidence of heart failure in type 2 diabetic patient. All 4 foundational therapy classes should be trialed before routine addition of personalized therapies, which is very important, and hence there is a burning higher incidence of heart failure in type 2 diabetic patients. There has been multiple studies where SGLT2 inhibitors across the continuum of heart failure have been found to be effective in acute as well as chronic heart failure. Let me give you an example of a case history. 56-year-old man with type 2 diabetes for last 10 years
Anti-diabetic drugs, he's on metformin, sulfonylurea, DPP-4 inhibitors at maximal doses. Hypertension and dyslipidemia on high-intensity statin, ACE inhibitors and calcium channel blockers as per guidelines recommended. There's no history of CV event or heart failure, and HbA1c is 6.8, eGFR is 58. Since last visit, 8 months back, 2 kg weight gain. Now, weight gain is one of the very important parameter which is happening in the type 2 diabetic patient as incipient heart failure and decline in eGFR by 5 ml and rise in UACR of 20%. What should be the next line of management? Major concerns are maintain glycemic control, management of comorbid conditions, prevention of CV event, and prevention of further decline in renal parameters, eGFR and albuminuria. The possible steps you can take in this patient are protein-restricted diet, increase in dose of ACE inhibitors, increased dose of statins, add insulin, add an SGLT2 inhibitor with proven renal benefit and titrate other therapies accordingly. Heart failure drug treatment, there's a classical 4 drugs available, ARNI, MRA, beta blockers, SGLT2 inhibitors. The beneficial effect of dapagliflozin was consistent in patients on a beta blocker, that is MRA and ARNI. The hazards ratio for the primary endpoint was 0.7 as compared with the 0.74 in patient without an ARNI, which is very important. The novel mechanism of action of SGLT2 inhibitor in heart failure, probably all of you would know, and there is an altered adipokine regulation, there is a decrease in leptin levels, there is autophagy induction, improved cardiac ionic homeostasis, and improved myocardial emergencies. There is an increase in leptin levels leading to more of the cardiac fibrosis, decrease in the cardiac pumping action, and ultimately leading to the low ejection fraction heart failure. And SGLT2 inhibitors, by affecting all these mechanisms, brings about the increased cardiovascular outcome, which is a very well documented issue. An innovative multidisciplinary collaborative protocol to optimize SGLT2 use in patient with low ejection fraction heart failure is very important. The recommendations are optimize CV risk assessment, optimize CV risk factor management, ensure patients are on GTMT consisting of ACE, ARB, ARNI, beta blocker or MRA and target doses. And it is very important that we can use SGLT2 agents and doses with trial data and FDA approval status of low ejection fraction heart failure, which is there. The initiation of therapy in the stable patient long after decompensation often leads to delayed start of drug therapy, and patients are not well treated, especially after discharge, where a particularly high mortality and hospitalization rate occurs, and hence it has a great advantage even with the patient with heart failure discharged from hospital to prevent the recurrence of heart failure or readmissions. The key mortality outcome of multiple RCTs assessing SGLT2 inhibitors among patients with heart failure, there's been 14% relative risk reduction in all care mortality and CV mortality among patients with heart failure treated with SGLT2 inhibitors, which is so phenomenal. The hospitalization for heart failure results from recent CV safety trials of SGLT2 inhibitors, and it has been very well documented with all these SGLT2 inhibitors. The therapeutic target of pharmacological treatment in patients with low ejection fraction heart failure is inhibition of tubule glomerular feedback by SGLT2 induces a rebalance of adenosine-mediated dense macular response and inhibition of RAS activation. This mechanism drives the nephroprotection observed in heart failure as well as patients with a chronic kidney failure, and it is very important in addition to beta blockers, MRA, ARNI, or once the SGLT2 inhibitors are added. There has been a modification to the therapeutic algorithm for a patient with symptomatic heart failure with low ejection fraction following results from DAPA-HF. What a great trial it was, DAPA-HF trial, where diabetics and non-diabetics, when they were subjected to dapagliflozin, and there was a significant improvement in incidence of heart failure and the readmissions for heart failure. Individually or in the combination of ARNI and SGL2 are well tolerated. This is another good advantage with reduced rate of treatment discontinuation. So it can be very well coupled up SGL2 inhibitors with ARNI, which has been documented beyond doubt in congestive heart failure in case of type 2 diabetic. Despite the use of ARNI, dapagliflozin is a novel, cost-effective treatment option for refractive, low ejection fraction heart failure in Indian patients. And it has been very well documented that there has been a decrease in almost 69% in NYHA class. Pro-BNP goes significantly down almost by 91%, and left ventricular ejection fraction improves by 23.6%. What a documented improvement in the congestive heart failure in type 2 diabetic patient. Timeline of initiating guidelines directed medical therapy for patients admitted with low ejection fraction heart failure are very important. SGL2 inhibitors demonstrated efficacy as important fourth pillar of the treatment protocol. Together, this combination can add over 6 additional years of lifespan for people with low ejection fraction. It can be added at all the levels, and it improves the heart failure status, early discharge from the hospital, and prevents the readmissions because of heart failure. In Indian phenotype, 1/3 of North Indian patients with type 2 diabetes less than 50 years had a high risk of atherosclerosis. Asian Indians have more than 2 times prevalence of lean BMI in young onset type 2 compared to the white European. Hence, heart failure was another very major challenge. After discharge following an episode of acute heart failure worsening, high rates of rehospitalization and death have been recognized, and the term vulnerable phase of the heart failure syndrome was coined. And here SGL2 inhibitors plays a very important role, whether diabetic or non-diabetic, and we could prevent the readmission and rehospitalization of the patients. Benefits of SGL2 inhibitors on the risk of death and hospitalization in patients with heart failure accrue within days to weeks after initiation. So very fast to act, very effective to act, and very definite results we can see about it. The key priority in type 2 diabetic patient should be the implementation of multiple risk factor control from diagnosis using affordable glucose lowering therapies to reduce the increasing microvascular and macrovascular burden in patient without established acute CVD to advance early therapy. Hence, it is very important, and this need to be done. How SGL2 inhibitors improve the cardiac function, prevent the heart failure? This is a wonderful mechanism given here. It is metabolic and hemodynamic action, as well as it has wide range of physiological effect, decreasing from weight to the body mass, to reduce the atrial fibrosis, reduce the AF substrate, myocardial loading condition is reduced, it prevents the LA stretch, it reduces the PV volume and stretch. It's wonderful, a hemodynamic and a structural improvement in the cardiac function which happens, preventing the cardiac fibrosis and the cardiac pumping, which is very important. There's been a significant therapy effect of heart failure population and general population, and it has been found out that beta blockers bring about reduction to the tune of 44%. They have significant reduction, but SGL2 inhibitors have got wonderful advantage of matching, reducing the incidence of heart failure, and it can be recommended at all stages from beginning to the advanced heart failure. We can go for it. SGL2 inhibitors improve heart failure outcome in wide spectrum of patients. Widespread adoption of SGL2 inhibitor can considerably reduce the burden of heart failure in type 2 diabetic patient. And hence, there are some barriers to the uptake of SGL2 inhibitor in clinical practice, and proposed solutions are there, and which can be taken care of. Complexity of current guidelines pertaining to SGL2 inhibitor use, but improve the clarity of guidelines and provide further information on how and when best to apply. And all these reservations can be overcome with adequate selection of the patient and keeping note of it. There are recommendations for SGL2 inhibitors in heart failure guidelines. ESC says dapagliflozin and empagliflozin are recommended for patients with heart failure to reduce risk of heart failure, hospitalization, and death, which is proved beyond doubt. ACC also says that it can be used very safely along with the standard line of treatment, and Canadian guidelines also recommend it very strongly. There are multiple cases where there has been classical feature of heart failure in type 2 diabetic patient where can be SGLT2 inhibitors or GLP-1 agonists can be thought of. Now, this is a need of time that because of SGLT2 inhibitors are one which are very effective in the longer phase of type 2 diabetes. Type 2 diabetic patient starts with a 50% beta cell knocked out and become insulinopenic in due course of time, and hence these SGLT2 inhibitors are very effective in glycemic control, but added advantage of taking care of heart failure, which is very important. I'll quickly, just half minute more I'll take, sir, that this uncontrolled type 2 diabetes, despite metformin and EGFR, controlled type 2, like it can be combined in all the situation of classical type 2. I already talked about how effective cardioprotection mechanism as you inhibitor. Look at the number of the ways the SGLT2 inhibitors by physiological, the anti-inflammatory effect, the anti-fibrotic effect, they bring about the improvement in the cardiac condition along with the renoprotective effect they have. I'll just go to these are the multiple trials which has proved beyond documentation, EMPA-REG, CANVAS, DECLARE, VERTIS, SCORPIO, that yes, SGLT2 inhibitors have been preventing the new onset or preventing the recurrence of the heart failure, which confirms the benefit. They have the benefit in MACE, heart failure, in multiple trials and multiple, all SGLT2 inhibitors have proven. These primary prevention with diabetes and secondary prevention in diabetes has been documented very well with the SGLT2 inhibitors. Multiple studies have confirmed, and I'll just conclude that management of type 2 diabetes has moved from glucocentric approach to a patient-centric approach looking at long-term benefit. Drugs that offer additional non-glycemic benefits are being increasingly prescribed and recommended for type 2 diabetes. SGLT2 inhibitor have good clinical data to show primary prevention of cardiorenal involvement. Since diabetes is considered equivalent to ischemic heart disease, so though they deserve secondary, but they need to be treated as a primary prevention. Compared to GLP-1 receptor agonists, SGLT2 inhibitors can be prescribed orally even in patients with moderate body weight for long-term primary secondary prevention. The additional issue with GLP-1 receptor agonists like GI side effects, high rates of non-responders, need for injection and need for monitoring liver functions, probably SGLT2 inhibitors have a great advantage which can be thought of. So if you look into this, we need to recognize the occult or high incidence of heart failure in type 2 diabetics, and probably SGLT2 inhibitors becomes a drug of choice in the second part or the later part of type 2 diabetic, being an insulin-dependent drug. Probably it has a great advantage of preventing and readmissions of hospital and recurrence of the heart failure with improving all the ejection fraction to great level with the classical protection in the physiology and the anatomy of the myocardium. Thank you very much. Thank you.
Thank you, sir, for your nice presentation.
May I welcome Dr. Vijay, Dr. Anish to be on dais, so we can open the forum for question and answer. I have one question for Anish.
Yes.
What is your experience of SGLT2 inhibitor in setting of acute heart failure? And which molecule you will advise, and what is the present data or studies or trials? Please highlight.
A good point. See, if you look to the pivotal trials of SGLT2 inhibitors in heart failure, they took up the patients who were stabilized in acute decompensated heart failure. So somebody who comes to me with acute pulmonary edema, pedal swelling, acutely breathless, that is not the place and time where I'll start SGLT2 inhibitors. Give a day or two for dopamine, noradrenaline, get rid of extra water to some extent. And not, I say that the patient has to be totally stable, but at least patient is off inotropes and off IV diuretics. By 2 to 3 days, we can start a small dose of SGLT2 inhibitors. So not too late, not too early.
Can I add to that?
Yes, sir.
There's an impulse study which looks at the use of this molecule in the ICU and has shown a remarkable improvement in patients with sustained mechanical infarction and also having heart failure. And the entire approach came from the DARE trial, which looked at the COVID patients who were in the ICU where dapagliflozin was used and showed, of course, it was a negative trial, but did not show any worsening of these patients' condition because of the action on inflammasomes. And reduction of the inflammation was a major episode of the benefit of these molecules, and therefore they've been now used in the impulse study in the acute care setting. So I think we'll see in future these drugs can be used in acute care setting also.
Yeah, I mean, say point is, you are rightly quoting the trial. Point is like, see, many patients who come with ADHF, they do have abnormal and unstable sugars. Many of them do have some infections or sepsis. That is what we encounter. So if at all we want to start, we have to rule out those classical contraindications and then obviously.
And electrolyte.
I want to emphasize one point, that heart failure is never stable. We used to call a stable heart failure, it's never stable. Patient is progressively, relentlessly growing ahead. Therefore, the treatment should be always on. You cannot knock off the treatment. It should be continued forever and ever. I agree with you.
I think point is when patient acutely decompensates, that's where based on hemodynamics and other parameters, sometimes we might have to either reduce the dose or withdraw. Say for example, a patient who has been on 100 milligram ARNI twice a day, now is there with say for example, acute coronary syndrome, blood pressure is 90, creatinine is 1.9, potassium is 5.4. So that's what I'm compelled to. That's what I'm compelled to. Otherwise, I never wish to remove any of the drugs, never like to reduce the dose, would like to always build up. That is what I talked during my talk, that think of giving the drugs rather than not giving the drugs. But still, there are occasions, and I personally believe for RAS blockade, one has to be very dynamic in sometimes switching on and switching off. Otherwise, we can harm the patients in those acute, serious deterioration.
I think most of the cardiologists would prefer to start SGLT2 inhibitor once patient is stabilized, electrolytes were within normal limits, creatinine was reasonable, and they will want to start in smaller dose and gradually build up the dose. Which molecule you will prefer, EPA or DAPA?
Whichever company you're closer to. You can select that molecule. Both are safe, both are good. And there's enough data. There's enough data on both. The empagliflozin has a larger data than dapagliflozin.
Absolutely.
And therefore, if you want to really select cheese, a little bit in these two out, I feel that EMPA has an edge over DAPA, but both are actually good.
EMPA edge over DAPA, slightly.
Yeah, slightly an edge over that because of the more data on that, more study on that.
Any question from audience?
Good evening, sir. I would like to just know from you, sir, how we are going to treat the diabetic heart failure patient once patient is going to that's like the renal compromising, or patient sometimes with diabetic nephropathy in the line. They get diabetes with the HFrEF. Patient is already on SGLT2 and ARNI also. But now after monitoring, if EGFR is going to be disturbed, then how we are going to basically treat the patient for the future aspect, number one. And second question, basically how the ARNI you are going to consider in HFpEF patients. Because now we have data, but how we are going to basically see in your clinical practice?
A wonderful question. Like see, we need to go back to the point that whatever the cutoff EGFR in trials. So if you go to ARNI, the cutoff EGFR is 30, and up to 20 you can use cautiously. What do I mean by cautiously? A physician has to be careful to repeatedly go for renal function test, and patients should have adequate educational background to follow and comply to what you say. So I personally use ARNI in most of the patients up to EGFR of 20. Go to SGLT2 inhibitors, they have been tested EMPA up to EGFR of 20. So ARNI and EMPA or DAPA, whatever, I'll continue up to EGFR of 20. Once the EGFR has dropped to less than 20, I will not use. Again, a very important point is patient has to be compliant for blood pressure checkup, renal function checkup, and you should have as a doctor, some communication method available through whatever your assistant or colleague, where they can send you the data on blood pressure and renal function test at periodic interval.
I think the only objection of continuing ARNI is the rising potassium and the rising creatinine. If the creatinine does not rise more than 30% and the potassium does not rise, even the patient with high creatinine can jolly well continue because they are nephroprotective. They should be continued. There are a lot of, most of the nephrologists knocks away the ACE inhibitors RNA moment they see the creatinine rising or the potassium slightly climbing up. As he rightly mentioned in his talk, the K binders have come in a big way, and they've really been helping patients to continue these molecules because they've been shown, as he was saying, the guideline-directed medical therapy to reduce mortality to tune of 75% over a 5-year period. So therefore, it's important that all these 4 pillars of treatment should be continued in every patient. And the other obstacle that you see on the road can be managed by adequate attention and a periodic checkup of these patients.
Question is similar, sir. Patients are sometimes having fluctuating creatinine. Every 3 monthly patient come. Now creatinine is 1.8. After 3 months, creatinine is 2. And again, patient comes with 1.8. So when we have to stop this SGLT and RNA? Because patient sometimes falls below 20 EGFR and again comes, then we have say EGFR 30, 40.
EMPA kidney can be continued till the EGFR of 20. That much in the study EMPA kidney trial, they had patient enrolled into the study who had the EGFR of up to 20. So you can continue. When you have such kind of fluctuations of creatinine, you look for hydration in these patients. Many times they are also taking diuretics, so the hydration is a cause of concern. So look at the patient's treatment, look at the patient's diet, which could also increase the creatinine, and any acute setup. For example, if a patient gets 1 episode of diarrhea, his creatinine will jump. So it's not because of the primary kidney disease, it's because of the circulatory system which is affecting the kidney function. As I told you in my slide I showed you, 25% of the cardiac output goes to the kidney. So therefore, you need to know exactly what other factors which contribute to rise in the creatinine. It need not necessarily come from the kidney itself. And once you know that, then you can appreciate and continue these molecules. My idea of both of us are trying to say that please use these molecules rightly at the right doses so the patient gets the benefit, and don't get carried away by all these problems that you see on the way. You need to treat them.
I think one of the very important thing when you're treating this class of patient is finding out the other reasons for rise in the creatinine and the potassium. So what has been told that the diet deviations, the dehydration, if the patient has adequate amount of urine output, like if patient is showing 30 to 40 ml urine per hour with potassium taken care of, even if the EGFR is low, with a good outflow, probably it requires a lot of fine tuning. So whenever the creatinine fluctuations are there, probably associated factors need to be analyzed about the diet, dehydration, diarrhea. There's so many important things so that you can, and as far as the urine output is good, even at you can think of continuing these drugs, which is very important.
Anish, I have a question. Which drug will you prefer? Which molecule will you prefer among all SGLT2 inhibitors in setting of heart failure without diabetes, having normal A1C?
So a good point, like say I take both of them equally well. Now, if you go and look at the only particular trial of DAPA-HF or EMPEROR reduce, that's where DAPA-HF could show the reduction in total mortality, reduction in cardiovascular mortality also, while EMPEROR reduce couldn't show. But doesn't mean that it didn't. So we personally believe that directionality is same if you take DAPA-HF or EMPEROR reduce. So can be taken anything, but something which has happened is that there are molecules of dapagliflozin available by Indian companies which are low cost. So ultimately, many of my patients do end up taking dapagliflozin. Maybe one of the reasons is that they are easily available at a lower cost. But I personally am happy with both of the things. Point is, EMPA is also 10 milligram, not 25 milligram in patients of heart failure. So it can be 10 DAPA or 10 EMPA, and we are happy. Anything is on board, I'm fine, no worries.
Basically, it's a class effect.
I think whether you look at diabetic or non-diabetic, the benefit is only in the weight loss. That as you have a high glycosuria in patients who have diabetes because of the excess amount of blood glucose, that's the only difference so far as the outcome is concerned. So whether diabetic or no diabetic, both molecules work identically well. So there's nothing to choose, nothing to lose.
My next question is similar on this weight loss. Because many patients are underweight and many patients may lose some weight with SGLT2 inhibitors because diabetes plus or minus heart failure, SGLT inhibitor is a must drug. So how we handle situation who patients are already underweight or who are complaining of gradually weight loss? The relative is asking, you have too much weight loss.
Yeah, it's a good question. The weight loss depends on what's your set point. The hypothalamus has set point, so therefore the higher the weight the person has, the higher the weight loss. If the person is not very obese or not very, not very heavy, then the weight loss is not much. So it is not a contraindication to use this molecule in patients who are not heavy. There's a misconception again that this molecule is preferentially used people who are overweight, but this can be used to any patient, and the weight loss is only dependent on what the patient has a metabolic set point in the brain, and that will decide how much weight loss you can get. It doesn't go that every patient loses 5 kilograms, and no, not like that.
Any more questions? We are ending the symposium here, and I will thank all the speakers for
And
sharing
good interaction despite a small crowd.
Yeah. For nice interaction we have.
Oh, thank you very much. Thank you, sir.
Manthan, what next?
So very, very cognitive session from this all the legends, cardiologists. So let's have a huge round of applause. Yes, thank you so much. And now we are moving for the next session. Next session is going to chair by Dr. Rutul Goklani sir. He is basically consultant diabetologist and a managing director at AHC Diabetes Center, visiting consultant at JDPF Ahmedabad in type 1 diabetes management. So at present, we have a one chairperson available. I guess Dr. Sunil Gupta, he is our next chairperson, but he is not available. Soon, sir, once you come, he will join. So till that time, I would like to request Dr. Rutul Goklani, sir, to come on the stage. Yeah, thank you so much. And sir, there is some amendment in this next session. The speakers one will be Dr. Sandeep Mathur, speaker two will be Dr. S.K. Sharma, and speaker three will be Dr. Mayur Patel. So over to you. You are requested to give some brief introduction of the speaker and then hand over the session to the speaker. Thank you.
Thank you very much, Dr. Manthan, for kind introduction. And we have our first speaker, Dr. Sandeep Mathur from Jaipur, and he'll be talking on metformin in pregnancy and update. Dr. Sandeep Mathur, he is senior professor and head of the Department of Endocrinology in SMS Medical College, Jaipur. His area of interest is in molecular genetic. Previous slide, please, of introduction. So his area of interest is in molecular genetics of hormone and metabolic disorders, adipose tissue biology research, and his major achievements, if we see, he is recipient of Commonwealth Academic Staff of Fellowship in 2003, his Travel Award by AC, and in USA 2006. He has Merit Award by Government of Rajasthan in Republic Day, conferred by Honorable Governor of the state, and several other awards like Times of India and Economic Times Achiever Award. And he has many publications, around 51, and many research achievements. With this, I'd like the session to hand over Dr. Sandeep Mathur, sir.
Thank you very much, and thanks to organizers for double opportunity. First to speak here, and asking me to speak on a clinical topic. Otherwise, I always speak on basic biological topics. So double thanks. So I'm updating on use of metformin in pregnancy. Basically, the question before the clinician, shall we use or not? Is it safe or not safe? Is it good for the mother or not? And what clinical practice guidelines say? The background of my presentation, if you look into the basic pharmacology of this metformin, it looks on surface to be a worse drug in the sense, it is, there is a transplacental metformin is transferred from mother to the fetus. There is a transplacental transfer, and the levels achieved in the fetus are as much as in the mother's blood. It interferes with vitamin B12 and folate absorption. Not only this, inside the fetal cells,
it affects the basic function of mitochondrial respiration. That is very vital function for the fetus. It impairs one carbon metabolism. It inhibits nutrient uptake. We are creating artificial malnutrition. And on top of that, it affects gene methylation. Whole life planning of metabolism of the fetus is affected. I am not saying adversely affected. It is affected by this drug. The few data is also there. They are small for gestational age and the risk of cardiovascular risk in the fetus. Despite so much of negative background, metformin was used almost 40 years, 50 years ago, 45, 50 years ago in one center in the Cape Town. And with the experience of 5.5 years in 171 patients, they say glibenclamide and metformin appears to be safe drugs during pregnancy when properly used. At that era, we did not know much about the metabolic or molecular pathways of metformin on respiratory chain and other things. Now, in context of this clinical data, biological data is not good, pharmacological data is not good, but clinical data say, yes, it can be used because it was used. So, with that, now the option is we always treat pregnancy with the insulin. What are the metformin advantages? It's low cost, easy to administer, widespread use in lower income countries, accepted by patient, reduce maternal gestational weight gain, and reduce the number of infant born will last for gestation. These are the advantages. But it's had disadvantage, I already mentioned, crosses the placenta at a level equal to that of maternal circulation. A small subgroup of children exposed to metformin in utero have heavier in childhood. That means it's not the newborn is heavy, but in childhood they become heavy. And potential long-term effects on metformin on offsprings are still unknown. And compared to when compared to insulin, there's of course neither human insulin nor its analogs crosses placenta. It is unnecessary to consider metformin in pregnancy when a safe alternative is available. That is very important point. Why metformin? Because we have insulin and we can use it. Well proved, well safe, no problem. But there are disadvantages to the mother, not to the fetus, that there is a risk of gestational weight gain to the mother and of course hypoglycemia in the mother. What are the indications for metformin in the pregnancy? There are potentially 3 indications for metformin in pregnancy. First and important is in obese non-diabetic women. It is obese non-diabetic women in an effort to prevent GDM and other maternal fetal complications like your large for gestational age, premature delivery, this hypertension of pregnancy, preeclampsia. All these risks are there in the obesity. This obesity risk and obesity also has to be a risk of fetal abnormal planning and long-term complications of diabetes in the offspring in the later age. So this could be one of the potential indications for metformin. I will discuss what are the data on that. In women with polycystic ovarian disease, we treat them with metformin. And metformin is one of the treatment for the induction of ovulation. And it is successful. So patient is already on metformin and she conceives. Question whether to continue or discontinue metformin. That is an important consideration of clinical decision making. And of course, it can be used as glucose lowering therapy in GDM and T2DM patients along or in combination with insulin. And this can be as an adjunct, it can be alone also. So what is the impact of metformin on the mother? So the clinical trial evidences are available and some of the trials are related to use in the obese women non-diabetic. There are 3 trial results which I am highlighting here. That is, one was GROW trial. The second one was actually Empower trial. And this was metformin MOP trial, metformin versus placebo in obese pregnant women without diabetes. So I'm just highlighting very briefly. These 2 trials, first 2, showed initial some benefit in terms of, not significant in terms of gestational weight gain as well as fetus weight and risk of C-section. And this trial, there was not a major statistically significant difference, but there was some benefit in terms of patient developed GDM was little less in women treated with metformin, and there was no significant difference in the gestational weight gain when seen women receiving placebo. But when this medicine metformin was used in BMI more than 35, this trial, previous 2 trial BMI was less than 35, and dose was 3 gram. Here is the difference. Definitely there was an advantage. So in obese women, these 3 trial results suggest in obese patient, very obese patient, BMI more than 35, when you use a dose of 3 gram of metformin, definitely there is an advantage of reduction in gestational weight gain. There was also a reduction in the rate of preeclampsia and toxemia in those receiving metformin. And there was also no much advantage from the point of view development of GDM. So GDM point of view, it's not a good option. But maternal weight gain, gestational weight gain, as well as preeclampsia and toxemia point of view, it appears to be a good option. Now looking Cochrane database, that does not support. Even from the point of view of prevention of GDM in women who are obese, the Cochrane database, there is no evidence any intervention, including metformin, has any advantage from point of view of prevention of GDM. So just briefly summarizing is, in very obese patient, BMI more than 35, use of metformin in very high dose, that is 3 gram, has advantage mainly of lesser gestational weight gain, to some extent prevention of toxemia of pregnancy, and possibly no or minimum benefit from point of view of your development of GDM. So prevention of diabetes in pregnancy, metformin is not as good as it has been reported in prevention of diabetes in your PDM in a non-pregnant person. Now, there is one more trial, pre-MET, that is for looking for development of toxemia pregnancy with metformin. Unfortunately, results are still not open. So once the result comes, we will be able to say better whether it should be used for that purpose or not. Now, trials of metformin PCOD women in effort to prevent GDM. This randomized controlled trial, multi-center study, metformin was PCOD in first trimester of pregnancy. There was not much benefit. There was little less prevalence of preeclampsia, and also weight gain was little less. There one more study, that is PREG-MET2, and the pregnant women with PCOD, metformin treatment from late first trimester until delivery might reduce the risk of late miscarriage, preterm birth, but does not prevent gestational diabetes. So in PCOD women also, there was some benefit in terms of preterm birth, but in miscarriage. But when the data of these 2 trials was combined, then there was a reduction in preterm delivery from 8 to 4%. This was statistically significant. The finding was the composite endpoint, late miscarriage and preterm delivery. So it has definitely a positive effect. Large head circumference was seen, but it is not statistically significant, does not require cesarean section, extra cesarean section. And the reduction in primary endpoint was more profound in women with BMI more than 30. So in PCOD women who are more than 30, there is some benefit of giving metformin, continuing metformin, which was used or which can be given from the point of view of better maternal and fetal outcome, but no advantage from point of view of prevention of GDM. Now coming to the trials of metformin as a glucose lowering treatment GDM and type 2 diabetes mellitus in addition to insulin. Metformin was an insulin MIG study, and women with gestational diabetes mellitus, metformin alone and supplemental with insulin not associated with increased perinatal complication as compared to insulin. The women preferred metformin to insulin treatment. However, there was a less severe neonatal hypoglycemia and less gestational weight gain in metformin treated group. The mean infant birth weight was lower in the metformin group. However, this did not reach statistical significance. So there is a marginal benefit. And these trial results are basically depending on the sample size. So we should not take them as the final words. And in a randomized prospective study, this was a Spanish study, metformin treatment was associated with better postprandial glycemic control than, in very interesting point, for some meals, low risk of hypoglycemic episode, less maternal weight gain, and lower rate of failure as isolated treatment. Most obstetrician and perinatal outcomes, obstetric and perinatal outcomes were similar between the groups. So there is some marginal benefit. Now, PLOS One has published an actually RCT meta-analysis and conclude that metformin is associated with lower rate of macrosomia and large for gestational age mothers with GDM. This MPREG, the trial is progress, results are still awaited, so we can't say much about GDM use of metformin at the moment, but this trial result might give you better answer. Now this trial, that is MIGHTY trial, and MIGHTY trial randomized 502 mostly obese non-treated women with type 2 diabetes to either metformin or placebo, a dose of 2 gram per day. Women in the metformin group had a lower mean HbA1c, a lower total daily insulin dose, a less use of short-acting insulin, lower rate of birth by cesarean section, less gestational weight gain. Infant also experience lower mean birth weight, lower rates of extreme LGA or macrosomia, but higher rate of SGF birth. So it is apparently same pattern of results are there. So in summary, the metformin use is associated with in terms of less maternal weight gain, reduced insulin doses, and may be particularly benefit with small insulin resistant patient, lower rate of infant with macrosomia and large for gestational age, and the risk of small for gestational age. Now, what is the effect on offsprings? I told in first slide, metformin has so many metabolic effects, mitochondrial effect, this your methylation effect and everything. But good part is that metformin goes into the fetus through placenta, but does not enter the cells. So metformin transporters are not developed in the fetus. That is the beauty of metformin. That's why we are comfortable in using metformin. So this actually case control congenital anomalies database of some 15-20,000 persons. They compare metformin exposed, non-exposed group. There was a marginal difference in the increased risk of pulmonary valve atresia, but significant association was not more than would be expected by chance. So as far as the embryopathy and congenital malformation is concerned, metformin, so far there is no good data to say it is unsafe. Because medicine goes into the fetus circulation but does not enter the fetus cell. So don't worry about embryopathy. In fact, this systemic review and meta-analysis also said there is no significant increase in the embryopathy or congenital malformation, genetic, non-genetic both. Now, what are the effects on orphaning when it is given in the later part of the life? I already mentioned fetus-related parameters like their birth size and all were reduced. Even fat amount was also reduced, and there are so many studies in literature. And what more important is that at 7 years of age, when offerings were followed, metformin exposed, unexposed, there was no difference in offering measurement. There were minor differences. But at 9 years old, metformin offerings were larger by measure of weight, arm and waist circumference, waist to hip ratio, BMI, tricep fold thickness, DEXA fat mass and lean mass, MRA abdominal fat volume. So what happens? Metformin use in intra-abdominal, there is a trend. I am not saying there is a clear-cut data or very large data, but there is a definite trend. Some fetus parameters are smaller, good, healthy from vascular metabolic risk point of view. But when they grow to the age of 9 years, now the data emerging, there is an adverse. So small fetus, intrauterine malnutrition we all talk about and vascular metabolic risk or metabolic syndrome in later life, the same type of pattern of trend is emerging here also. This is one of the reasons we have to rethink about use of metformin in pregnancy. So here is then again a meta-analysis. Metformin treatment for gestational diabetes alters the postnatal growth trajectory compared to insulin treatment. Child exposed to metformin compared to insulin in the womb tend to be born at significantly lower birth weight but heavier in infancy and higher BMI by mid-childhood. It is known that children who are born small and then undergoes catch-up growth after birth are at increased risk of developing cardiovascular disease and type 2 diabetes later in life. It is important to understand whether this increased risk applies to children whose mothers are treated with metformin during pregnancy. So here is these results are shown here. So what clinical practice guidelines say? ADA guidelines say that randomized double-blind controlled trials comparing metformin with other therapies for ovulation induction women with PCOD syndrome have not demonstrated benefit in preventing spontaneous abortion or GDM. So they say from that point of view, it is a useless medicine. However, due to potential growth restriction and acidosis in setting of placenta insufficiency, metformin should not be used in women in hypertension and preeclampsia or at risk of intrauterine growth. They say that if there is a risk of IUGR, patient is hypertensive or developing eclampsia, don't use metformin because there is a risk to the mother because of acidosis rather than risk to the fetus. And they say that yes, there are some women with GDM requiring medical therapy who due to cost, language barriers, comprehension, cultural influences might not be able to use insulin safely or effectively in pregnancy. Oral agents may be alternative in these women. So they say you may use when nothing else, you're left with no option but you have to use something, then you can. metformin after discussion with patient and known risk and need to more long-term safety data of springs. AG, American College of Obs Gynae, they say on the same lines, ADA guidelines, that if there is no other option, but of course, metformin is one of the options. Actually, national guidelines for diagnosis and management of GDM in India, Government of India, published in February 18, they say metformin can be used when after fetus age is more than 20 weeks. After 20 weeks, they allow use of metformin. In fact, they say metformin should be the first line drug. Is it based on some good data or just some expert view? Because in my best opinion, search of literature, there is no robust data from our country to have such recommendation, but at least they allowed us for the, I think, cost reason. Similarly, what ICMR guidelines say, after metformin in GDM study, many centers have started using metformin as first line in GDM. However, more data needed in India. I think they are very balanced opinion. We need more data in our country to recommend metformin as a treatment of choice. Recently in 2022, two authors in a systematic, in a review article have some suggestions. These are suggestions, these are not guidelines. That in obesity, pregnant obese women, consider very obese women, BMI more than 35, to minimize the weight gain. A small evidence base does not appear to affect infant size at birth. Personalized decision with risk and benefit, particularly long-term fetal outcome and patient side effects, should be discussed with the patient. So it should be with discussion with the patient. Only in very obese patient you can use metformin, but with consent of patient. In PCOS, consider continuing, especially in those with BMI more than 30. Metformin reduce the dose of actually maternal weight gain during pregnancy. In type 2 diabetes, in patient already on metformin, consider continuing throughout pregnancy, however, stop if there is evidence fetus being short for gestational age. Then you have to stop. Consider initiating treatment obese women who are insulin naive. Just last slide has come, actually, this is the last slide. And consider initiating treatment in obese women who are insulin naive, and consider adding it those who are large dose of insulin to reduce it. So, to conclude, metformin can be used with calculated risk in potential long-term risk of metabolic health of offsprings in women with severe obesity or those require high dose of insulin or uncontrolled diabetes despite high dose of insulin. What is most important that we need our population-specific data in any definitive opinion. So, I can't give any definitive because we don't have any population-specific data. Thank you very much for your kind attention.
Yeah, thank you very much, Dr. Sandeep Mathur. And I feel we'll have a question after both the sessions. Yeah, thank you. So may I take this opportunity and honor to invite Dr. Mayur Patel. Sorry? Dr. S.K. Sharma, okay. For the same topic of Dr. Mayur Patel. May I invite Dr. Sharma? Okay, yeah. Dr. S.K. Sharma.
Here,
I'm sorry, I did not see
you. You are looking at Purvi, so I am in different
Oh, that's great.
Purvi.
So nice of you. So over to you, Dr. S.K. Sharma. Yeah, thank you.
So, my slides. Can you put my slides on, sir? So I am replacing Dr.
May I have the slides of Dr. S.K. Sharma, please?
So my job will be to look into the management of diabetes during pregnancy in type 2 diabetic patients. So slides.
Let me introduce Dr. S.K. Sharma, a very, very senior. Oh,
no problem.
Okay. He's a very senior endocrinologist of the country, and I feel if you start from the first, second, third, he must be in first 10 in seniority who are active now in the country. He has done his DM from PGI Chandigarh. He is practicing since almost more than 3 decades. He is a professor of medicine, Mahatma Gandhi Medical College Sciences, and 26 research publications. He is being chairperson at various organizations across the country. He has been awarded various orations from the platform of RSSDI, from BHU, and many other awards to his credit. And he was awarded the Distinguished Service Award from RSSDI again. And his name has also been published in various leading national newspapers as, for the award as well as for the public awareness. Over to you, Dr. S.K. Sharma. He's going to speak on update on type 2 diabetes in pregnancy, clinical outcome and pathophysiology. Over to you. Thank you.
Thank you, sir. Thank you, Dr. Gupta, for your kind introduction. I am thankful to Dr. Bansi and his team for inviting me here as a replacement to Dr. Urvi. So, dear friends, we all know that the burden of diabetes in India is huge. And similarly, when you look at the epidemiology of hyperglycemia in pregnancy, similarly, you find a huge number of patients developing diabetes or they are diabetic patients who are having pregnancy now. So, hyperglycemia in pregnancy is used in our country. And another important point is that now the pregnancies are delayed because girls are now going for studies and then marriages are late and then they go for their job, etc. So, pregnancies are going later and later, and you find that as the age is increasing, hyperglycemia incidences are also increasing. But whenever we have diabetes in pregnancy, you have to differentiate whether it is a pre-existing diabetes and now the lady is pregnant, or the diabetes was first time identified during pregnancy. In this pregnancy, what we label as gestational diabetes. So today I am going to discuss mainly the pre-existing diabetes and now the lady is pregnant. So what are these pre-gestational diabetes point to consider? And here you find that the pre-conceptional counseling is very important. Glucose control during pregnancy is very, very important. You have to manage labor in these patients and of course postpartum consideration. So it is very important message here that whenever you are dealing with any lady of you can say pregnancy, childbearing age, then you have to discuss this point out that if you are planning pregnancy, then you should be having a pre-pregnancy counseling, because most of the time these ladies may be having so many other conditions and they may be on many of these oral anti-diabetic drugs, and we usually stop all these drugs and most of the time we shift the patient to a intensive insulin therapy. Otherwise, these patients will have many problems. So pregnancy, even in a normal lady, is having a very diabetogenic, you can say, profile. There is insulin resistance, there is hyperinsulinemia, and in the starting of this pregnancy in a normal person, you find that glucose profiles are going down because of hyperinsulinemia. But ultimately, when the placenta is of good size, it starts producing large amount of placental hormones like HPL, cortisol, progesterone, etc. And these all are, you can say, diabetogenic, and they lead to increase in insulin resistance in these ladies. During pregnancy, as the pregnancy is continuing and progressing, you find that there is a excessive anabolism during feeding and catabolism during fasting, which are exacerbated and progressively increasing, and these are going till the delivery is there. If you compare GDM to pregnancy in a lady who is already diabetic, you find that right from the beginning of conception, there is a hyperglycemic burden there, and organogenesis, which is occurring in the first 8 to 10 weeks of pregnancy, is now affected as compared to GDM only, where the GDM is developing after in the second half of pregnancy and organogenesis has already taken place. So congenital malformations are not there in GDM as compared to a patient who is pre-existing diabetic and now pregnant. There are teratogenic processes in diabetic pregnancies like increased production of oxygen-derived free radicals, abnormalities of myoinositol, arachidonic acid metabolism, abnormalities in the basement membrane components, and zinc metabolism is abnormal. So here you can see that the early pregnancy, there is a organogenesis till 8 weeks or so. And most of the time we see that organogenesis occurs early in the first trimester before the women first reports to antenatal clinic. So most of the time our patients are coming very late, and by that time they may be having uncontrolled hyperglycemia, but Here, important point is that because of this huge burden of diabetes and hyperglycemia, they may have organogenesis defectiveness, that is teratogenesis or congenital malformation. So uncontrolled diabetes during the stage increases the risk of major congenital malformation. These are some of the examples of malformation like caudal regression syndrome, spina bifida, neural defects, cardiovascular defects, and renal agenesis, etc. Caudal regression syndrome is the most specific abnormality what we see in our diabetic patients. And here important point is that as the HbA1c is rising, you find that the structural or teratogenic abnormalities are continuously rising. So if the lady is having a HbA1c of something like 10%, the chances of congenital malformation may be to the tune of 10 to 15% or higher. So indicating that before the pregnancy, if the lady is going for a tighter control, then probably she is going to have a very good, you can say, outcome. So why all these things are happening? Because many of these, you can say, products are transferred across the placenta, like glucose, amino acid, ketones, and triglycerides are transported across the placenta going to the fetus, but insulin and glucagon are not transferring across the placenta. So once the patient is having hyperglycemia, mother is having hyperglycemia, there is because of decrease in insulin and high glucose and other, you can say, amino acids and lipids transfer to the fetus, and these leads to increase in insulin secretion from the fetal pancreas. So fetal pancreas is now ready after 10 weeks of pregnancy. So you find that after 10 weeks of fetal life, the pancreas start producing insulin, and then in the presence of high amount of inflow from the mother, you will have huge amount of growth, increased growth, which leads to macrosomia in this fetus. So effect of this fetal hyperinsulinemia because of excess amount of glucose transfer to the fetus will lead to increased growth of insulin sensitive tissues. You have accelerated skeletal maturation, you have increased hepatic glycogen deposition, delayed pulmonary maturation, and delayed switch from the fetal hemoglobin to adult hemoglobin. And all these things are important because in this type of scenario, there are more of stillbirth, neonatal hypoglycemia. Once the fetus is delivered and sugar profiles are not controlled, fetus is having high insulin level, and suddenly the supply line from the mother is stopped. Now fetus is having high chances of developing hypoglycemia. And of course, if the fetus is having continuous good supply of nutrient and with hyperinsulinemia, fetus will have fetal macrosomia. So you know these fetal macrosomic features like fat shoulder, short neck, big cheeks, red skin, etc. And the effect of this on diabetic, you can say babies who are on mothers are diabetic, maternal insulin does not cross the placenta, but fetal insulin production begins at 8 to 10 weeks. High maternal blood glucose, high fetal blood glucose, high fetal insulin levels ultimately lead to macrosomia. And insulin is a very important anabolic hormone. It's a very potent growth hormone type substance. So effect of this uncontrolled hyperglycemia on neonate. So there will be hypoglycemia after the delivery, respiratory distress syndrome, hyperbilirubinemia, hypocalcemia, polycythemia, traumatic delivery because of large size of the fetus, and many more. So you find that there are maternal implications and fetal implications if the mother is not well controlled as regards glucose profiles is concerned. In addition to that, there are vascular complications, infections, etc. And in long-term fetal outcome, if you see after these offsprings are, you can say after a few years, they will be having obesity, hyperinsulinemia, and there is increased chances of developing hyperglycemia in these patients also, in these offsprings of mother with diabetes. In the mother, if the patient is having long duration of diabetes, she may be having retinopathy, nephropathy, and other cardiovascular, macrovascular complications, which may all deteriorate if the patient is having uncontrolled hyperglycemia during pregnancy. So pregnancy deteriorates most of these complications, and we have to look into the contraindications to pregnancy in this type of diabetic patients, where there is significant ischemic heart disease, there is proliferative retinopathy, significant reduction in estimated GFR, severe gastroparesis, and uncontrolled diabetes with HbA1c of more than 10% or so. So ultimately, the last, you can say, effort is good control of glucose level in the mother can significantly reduce the adverse pregnancy outcome in our diabetic patients. And this is one of the most important cornerstone of modern diabetes in pregnancy management. So management lines are like pre-pregnancy counseling and controlling hyperglycemia during pregnancy, and of course post-pregnancy control is also required. Pre-conceptional care is very, very important because we have to discuss the timeline for the pregnancy. So pregnancies should be planned pregnancies, lifestyle advices, folic acid supplementation, appropriate contraceptive advices so that you can time the pregnancy, and full medicational review. Many of these patients may be having hypertension on ACE or ARBs, which has to be stopped during pregnancy. They may be on statin. Statin has to be stopped during pregnancy, and you have to supplement folic acid, look at the thyroid profile of these patients also, and you have to look at sugar profile of these patients also. And with that, educate the patients and the partner. Self-monitoring of blood glucose, which is very, very important during pregnancy, has to be emphasized, and good control is to be emphasized just before pregnancy. If the HbA1c is less than 6.5, the chances of good pregnancy outcome will be there. Access regarding fundal examination and serum creatinine. And most of the time, we switch the patient to insulin even before pregnancy, start of pregnancy. So most of the time, once we have preconceptional counseling, we shift the patient to a intensive insulin therapy, and basal bolus therapy is considered to be the best there. And in this initial evaluation of pregnant women with diabetes, now the patient is diabetic, the patient has to have self-monitoring of blood glucose, adjust insulin regimens according to the sugar profile, check for diet, exercise, and HbA1c. And what are the targets which we should be achieving? A fasting of less than 95, a 1 hour of less than 140, and 2 hours of less than 120 milligram. And low dose aspirin in many of these patients after 12 weeks of gestation is recommended. There are many things which we have to look at. First trimester, like very important is menstrual history to date the pregnancy, blood pressure recording, weight measurements, optimal glycemic control, HbA1c, retinal examination, renal function, and counseling for the risk of congenital malformation, and ultrasound for fetal viability and dating and anomalies. Similarly, in second trimester, we will be looking in most of these things again, and now is the time for checking for preeclampsia, polyhydramnios, urinary tract infection, etc. in these patients, in addition to all those things which we are doing in the first trimester. And again, in third trimester, you are going for echo of these fetus to look at congenital malformation also, in addition to all those things. So fetal surveillance is very, very important in these patients. And here you have at 11 to 14 weeks, a early scan is required. Then 18 to 20 weeks, again, a detailed structural anatomical scan is required. And then, of course, 28 to 36 weeks, a serial growth scans are required in these patients. And in late pregnancy, if additional complications are present, non-stress testing or modified biophysical profile are to be looked into in this type of patients. Patient may require early termination of pregnancy, and here you have to look at maturation of the lung. And here people are giving beta-methasone, and we know that beta-methasone will lead to increase in hyperglycemia. So whenever these steroids are given for next 3 days or 4 days, you have to give additional insulin doses to cover the hyperglycemia caused by these steroids. We have to have a dietary modification, exercise planning, targets are given to us which are very tight. Insulin is the therapy of choice. As we discussed, there are so many pros and cons of either metformin and glibenclamide. So we usually prefer insulin therapy in our pre-existing type 2 diabetic patient, now pregnant. So insulin is given as an intensified therapy. That is, basal bolus therapy is considered to be the best. Role of continuous subcutaneous insulin infusion with the help of a insulin pump is now gaining popularity. There are many advantages. Tighter blood control, blood glucose control will be there, but there are some minor disadvantages also. Therapy, oral therapy, we just discussed in the last. Important point about the timing of delivery is that if you are delivering too early, then respiratory distress syndrome and prematurity is the problem. If you are going for late delivery, then probably stillbirth, what we say late intrauterine demise of the fetus and macrosomia are the concerns. So timing of delivery is very, very important. If the patient is well controlled on very little amount of insulin, and you find that throughout the pregnancy things are okay, then usually we say that 38 to 40 weeks of pregnancy, it is okay. But anything which is happening, which is bad for the fetus, then probably we go for a delivery at 38 weeks. So vaginal deliveries can be done in this type of patient. Cesarean sections are only required according to the obstetric, you can say, point of view, rather than that every lady who is diabetic and undergoing a cesarean section. Intrapartum consideration again, because we want, just 1 minute, we want tighter control during labor also, because if the blood glucose are very high, fetal blood glucose will be high and fetal insulin level will be high, and just after the delivery, neonate will develop severe hypoglycemia. So we have to have tighter control. Neonatal care is again very, very important, and particularly hypoglycemia are to be prevented in this newborn. That important point, which is very important point. So key messages are that diabetes is a major medical complication of pregnancy, and diabetes in pregnancy is associated with risk of mother and to the developing fetus. Diabetes complicating pregnancy is more common in India because age of onset of diabetes is younger, and now the pregnancies are occurring at a later age, and over diabetes in pregnancy should be managed as pre-existing diabetes. Preconceptional care is required. Supplement of folic acid. Just last few lines. Pregnant women management of medical nutrition therapy should be individualized, and we should have tighter options, very good control, and ultimately these pre-pregnancy diabetic patients have so many other complications to be looked into, and ultimately women with pre-existing diabetes should have ultrasound scans frequently required, and timing and mode of delivery in pre-existing diabetes are very, very important pointers to be considered. Thank you very much.
Thank you very much, sir, for wonderful talk. Now we have next speaker, Dr. Mayur Patel, sir. Dr. Mayur Patel is Chairman and Chief Diabetologist at Swasthya Diabetes Care, Ahmedabad, and All India Institute of Diabetes and Research. He is practicing diabetologist since last 37 years and Chairman of IDF recognized Center of Excellence in Diabetes Care and Center of Education. He has done some tremendously good projects like Stop Diabetes, Conquer Diabetes, Save a Leg, and Make My Life. He is a WHO recognized member of a Global Diabetes Compact Forum, and he is awardee of 2016 Director General Health Services of India, Government of India, and he has Medical Excellence Award of International Business Council 2019, and a Bharat Seva Ratna Award by International Institute of Education and Management in 2019. And he is 101 Fabulous Quality Leader in the world by World Quality Congress 2019. And he has given many oration awards like in API, RSSDI, and APG. With this, I'll hand over the session to Dr. Mayur Patel, sir.
So, good evening, friends, respected chairpersons, my co-speakers, and friends. It is indeed a great pleasure for being with you. I am thankful to Dr. Bansi and his team, and I congratulate them for the grand success of this DiaCareCon. Today's my topic is strategies for improving pregnancy outcome in women having hyperglycemia. The hyperglycemia in pregnancy in women between 20 to 49 years of age by IDF region, you can see from 9.5% to 26.6%. Especially this is Southeast Asia, one of the highest prevalence of hyperglycemia in pregnancy. And the most important thing is 1 in 6 live births occur in women with some form of hyperglycemia. And out of this, 84% of which are due to GDM. I'll be covering more GDM rather than type 2 and pre-existing type 1 diabetes because my previous speakers have already mentioned about that part. What could be the best outcome? For short term, no neonatal complications and all parameters appropriate for gestational age. And the most important is on the long-term outcome, prevention of NCD in mother as well as her offspring. Unfortunately, the adverse outcomes for the fetus are still very common despite significant advances in the glycemic control for pre-existing type 1 and type 2 diabetes. In GDM, despite standard treatment, large for gestational age still occurs. Now, what is the pathogenesis of hyperglycemia in pregnancy and its consequences? Most important is due to maternal hyperglycemia, the glucose crosses the placental barrier, and as a result, there is an increased fetal glucose, and then in turn, increased fetal insulin. And this leads to changes in pancreas, muscle fat, blood vessels, liver, as well as heart. And probably these changes may lead to overweight, type 2 diabetes, insulin resistance, blood pressure, and declining cognitive functions in adult life. Most important is these changes are preventable. If you look at the implications, according to risk and prevention of type 2 diabetes in women and with gestational diabetes, women with history of GDM are at increased risk of future diabetes, predominantly in type 2 diabetes, as are their children. Transgeneration transmission occurs, and the most important is GDM may play a crucial role in increasing prevalence of diabetes and obesity. Nicely covered by Dr. Sharma, effect of maternal fluids on fetal and offspring development. The hyperglycemia in pregnancy leads to, due to deficiency in insulin, and as a result, there is an increase in plasma glucose, amino acids, and lipids in the mother. This crosses the placental barrier, and as a result, there is an increased mixed nutrients in the fetus, leading to increased insulin and then macrosomia. In neonate, it may lead to hypoglycemia and other complications. In adult life, in male as well as female, it will lead to obesity, and in male, IGT and female GDM. And this both leads to diabetes in later life. Most important is this hyperglycemia during pregnancy. Again, this leads to GDM and diabetes in later life. So this diabetes begets diabetes. You are what your mother ate. If you look at the maternal fluids, it has impact on child, adolescent, as well as adult life. A very good study in utero exposure to maternal hyperglycemia increases the childhood cardiometabolic risk in offspring. And the maternal hyperglycemia in pregnancy is independently associated with offspring's risk of abnormal glucose tolerance, obesity, and higher blood pressure at years of 7. The cardiometabolic risk continue to increase throughout the adolescence into the adulthood. In adolescent offspring, of women with GDM show increased adiposity and adverse cardiometabolic profile in the earlier onset of puberty among girls, and increased fasting plasma glucose and HOMA-IR levels among the offspring of mothers with GDM may be explained by this programming effect of hyperglycemia in pregnancy. In adulthood, GDM lead to chronic insulin resistance, beta cell failure, dyslipidemia, inflammation, and endothelial dysfunction. As a result, type 2 diabetes, cardiovascular disease, and metabolic syndrome. Professor V. Sheshai, considered as a fatherly figure in GDM, recently has been awarded Padma Shri for the same. His work on GDM and pregnancy, hyperglycemia in pregnancy, he says GDM is the mother of NCDs. Now, what could be the strategies? Strategies for improving pregnancy outcome in women having hyperglycemia. Strategy 1, universal testing. According to International Association of Diabetes and Pregnancy Study Groups, universal early testing in population with high prevalence of type 2 diabetes. Indian women have increased 11-fold increased risk of developing glucose intolerance during pregnancy compared to Caucasian women. And among ethnic groups in South Asian countries, Indian women have the highest frequency of GDM. And according to United States Prevention Service Task Force, they recommend all women should be screened for gestational diabetes even if they are having no symptoms. In the year 2018, the Ministry of Health and Family Welfare, they published the guideline for diagnosis and management of GDM. But before that, Dr. Sheshia, he published an article in JIMA regarding GDM Indian guidelines. According to him, because there are many controversies going on regarding the screening test versus diagnostic test, first 1 step, 2 step, fasting, non-fasting, 50, 75, 100 gram glucose. So he simplified a single step procedure with single glucose value. 75 gram glucose is given to the pregnant lady irrespective of their fasting condition. And after 2 hours, if glucose level is more than 140, then it is considered as hyperglycemia. And this single step procedure to diagnose abnormal glucose tolerance in pregnancy is rational, cost effective, and causes negligible inconvenience to the expected mothers. I will not go in details of this methodology. The important part is, again, International Association of Diabetes and Pregnancy Study Group, they said in future clinical practice, simpler, more cost-effective strategies that do not require performing an OGT in most pregnant women may be developed. Till then, this single-step procedure, which is Make in India, is the best. We should not let the best come in the way of good. Again, WHO recommended in year 2013 this single-step procedure. In 2017, FIGO, that is Federation of International Gynecologists and Obstetricians, they also recommend all pregnant women attending health facilities will be tested for hyperglycemia using a single-step procedure. Strategy 2, the ideal week for screening. The usual recommendation is 24 to 28 weeks, but early screening for glucose intolerance and care could avoid some diabetes-related complications such as hydramnios, fetal anomalies, and preterm births in women with gestational diabetes. A very good study conducted by Dr. V. Sheshia, he says GDM manifests in all trimesters of pregnancy. Out of 4,151 pregnant women, 741, that is around 18%, had 2-hour plasma glucose equal to or more than 140 milligram percent and identified as GDM. If you look at the prevalence of GDM in different trimester, out of 741, 121, that is around 16%, they had hyperglycemia detected before 16 weeks. 166 women, that is 22%, they detected hyperglycemia week between 17 to 23 weeks. and rest 61%, they detected after 24 weeks. The most important part is, again, out of this 121, 6 women, that is around 5% of this 16%, they had 2-hour plasma glucose more than 200, that suggesting overt diabetes. Another good study by Dr. Seshia, they studied 11,000 women, and they concluded that manifestation of GDM in the early weeks of gestation is common. If you look at, out of all GDM diagnoses, 31.5% they detected in first trimester, 42.2% detected in second trimester, and 25.3% detected in third trimesters. It is important to note that fetuses are exposed to increased amniotic fluid glucose before 12 weeks of gestation, suggesting that metabolic perturbations are underway before diagnosis and that earlier screening and intervention may be warranted. Strategy 3, GDM management, lifestyle management. Well-known medical nutrition therapy at least for 2 weeks in women having GDM and along with the lifestyle modifications. Studies have suggested that GDM can be prevented by lifestyle intervention. The Finnish gestational diabetes prevention study, RADIAL, they concluded a moderate individualized lifestyle intervention reduced the incidence of GDM by 39% in high-risk pregnant women. These findings may have major health consequences for both mother as well as child. Another study, diet and exercise programs effective in preventing gestational diabetes. Pregnant women who participated in diet and exercise program had a greater gestational diabetes risk reduction and also had less weight gain and reduced number of births by cesarean section. The fourth strategy, the pharmacological therapy. Although majority of the cases could be controlled with diet and exercise, but still a considerable number of subjects end up requiring pharmacological therapy. Metformin, nicely covered by Dr. Mathur, it has been now permitted for the use. But till date, insulin remains the safest choice for the treatment of GDM. And availability of insulin analog and continuous subcutaneous insulin infusion, that is CSII, for the management of hyperglycemia during pregnancy have improved both maternal as well as fetal outcome. The most important part is insulin is advised if fasting is more than 90 milligram percent and 2-hour post-meal glucose more than 120 milligram percent with medical nutrition therapy. If you look at the prevalence of diabetes during pregnancy in women according to their birth weight, which is very important, a very good follow-up. If you look at over here, if the weight of that particular woman during birth was between 2.5 to 3.5 kg, then chances of developing hyperglycemia in pregnancy was less. And if it was less than 2.5 kg or more than 4.5 kg, then the chances was very high. Therefore, the goal is to obtain newborn babies with birth weight appropriate for gestational age, a step to prevent offspring developing diabetes. If you look at the target blood glucose level, fasting should be between 80 to 90, PP should be between 110 to 120, and mean between 95 to 105 milligram percent in order to achieve birth weight between 2.5 to 3.5 kg. Strategy 5, postpartum prevention of NCD in the mother. Again, it is advisable to screen lady postpartum at 6 weeks and 6 months. And which test? Again, the GDM diagnosed with the single step procedure, same test can be utilized for the screening for postpartum hyperglycemia. And if you look at this study, lifestyle modification studies, step to prevent GDM to diabetes, higher lactation intensity and longer duration, about 10 months, were independently associated with lower 2-year risk incidence of diabetes after GDM pregnancy. Another good study, low carbohydrate diet scores and long-term risk of type 2 diabetes among women with a history of GDM, a prospective cohort study. They concluded among women with a history of GDM, a low carbohydrate dietary pattern, particularly with high protein and high fat intake, mainly from animal sources, is associated with a higher type 2 diabetes risk, whereas with the animal or plant source foods, it is less significantly associated with the risk of type 2 diabetes. Strategy 6, postpartum prevention of NCD in her offspring. It actually starts with a healthy pregnancy. It has been observed that low birth weight and large for gestational age birth weight is associated with, in the adult life, elevated risk for obesity, diabetes, hypertension, and CVD. And it has impact on intergenerational transfer of risk. So maternal health, the link to the NCD epidemic. Therefore, if you are looking to prevent NCD, preventive measures against NCD should start during intrauterine period and continue throughout the life from early childhood. GDM offers an important opportunity for the development of testing and implementation of clinical strategies for NCD prevention. The most important positive observation, GDMS is preventable. Small as well as large gestational age are preventable. Offspring obesity is preventable. GDM to diabetes, type 2 diabetes conversion is preventable. What we require is optimistic approach. It is Albert Einstein most complicated problem in this universe has a simple solution. We have one test, 75 gram glucose of oral glucose in the fasting or non-fasting state. One value to diagnose GDM, 2-hour plasma glucose more than 140. One target monitoring 2-hour plasma glucose should be less than 120 milligram%. Again, Professor Seshia is a member of Technical Advisory Group of GDM, Ministry of Health and Government of India. The timely action taken now in screening all pregnant women for glucose intolerance, achieving euglycemia in them, and ensuring adequate nutrition may prevent in all probability the epidemic of diabetes and CVD. Thanks for attention.
I feel wonderfully you have actually depicted each and every point through your 6 different strategies of improving the outcome. And outcome is not just the neonatal outcome, but also the future prevention of diabetes amongst the offspring of diabetic mother as well as the mothers per se. So now we have the 5th panel discussion, and may I request all the panelists, may I request Dr. Sandeep Mathur, Dr. S.K. Sharma, and Dr. Mayur Patel. And can we have few chairs there, or they will be just... Yeah. So may I request Bansi Bhai to join me here, and...
In this panel, the Sunil should be there. He is currently president of DIPSI. I will be moderating it. And with this, our coordinator from PSG, he is also very active member of Diabetes and Pregnancy, Dr. Rutul. So now let me start the panel discussion. So if anyone have any comment or question, that is most important. So let us have one photograph. But one thing which I would like to say here, Dr. for S.K. Sharma Sahab, he had really created a big awareness as far as diabetes and pregnancy is concerned. I know it very well because in Rajasthan, not only in the major cities of Rajasthan, He had gone to even the district headquarters and had done multiple such programs. And similar type of program Dr. Rutul had also started in our Gujarat. Now he is going across the state of Gujarat, and in each district he is contacting the local gynec society along with the physician, and we started a program. It is online, offline, and offline he is doing fantastic program in each place. Recently he has conducted at Himmatnagar with more than 100 gynecologists and physicians who were there at that time. So, it is interacting both the specialty together. We know that many of the physicians and diabetologists, they think that they know about this, but when we are doing interacting program along with the gynec society, it really works very well. And people are very much interested to understand more and more about diabetes and pregnancy issue. If anybody wants to make any comment, I'll be more than happy. Mayur bhai, we were, before some time, we were in our RSSJ executive committee and past president. I was praising you that, somebody had written that RSSJ, and I have written that this RSSJ logo is given by Dr. Mayur Patel. It was in our RSSJ annual conference in 1997, if I remember it rightly, or 98, yes, 97, I passed out in March. And I became member also in the same year, because just now I am finishing my 24 years of membership of RSSGI, and he was also very active and a student of Dr. V. Sasaya sir, and very actively involved in diabetes and pregnancy study group with this.
Mayur has also given very important points that how to prevent these things. So all those 5 points which were very, very important points. Sorry, 6 strategies, sorry.
Sunil, you want to make any comment as a president?
I feel breastfeeding is one more important thing which could have been one 7th strategy, or maybe the postnatal. Yeah, you said this. Yeah, that is so. That is important part. I feel we have to have a lot of awareness in breastfeeding. Longer is the duration of breastfeeding, higher is the benefit of prevention of metabolic syndrome in these mothers as well as obesity in these children, offspring of diabetic mother. So we have to have important carry-home message from all these presentations, if Bansi Bhai allows me. One is that every woman coming to the ANC clinic should be screened for hyperglycemia and pregnancy, maybe GDM or pre-existing overt diabetes. So, because out in India, almost every 4th or 5th woman is likely to have positive. So one is that. You may adopt for DIPSI criteria as Government of India guidelines, 75 gram glucose, irrespective of the time of the meal. Just give, ask the patient to sit, take 2-hour test, more than 140 diagnosis. Out of them, 70 to 80% will be managed only on medical nutrition therapy. They may not require any drug. Rest of them, many of them may be given metformin because it has been allowed and approved by the Government of India after 20 weeks of pregnancy. Rest of them may need insulin therapy in addition to metformin, or if you have a contraindication for metformin, if someone has told about the contraindication, I feel you have told about metformin contraindication, hypertension, preeclampsia, placental insufficiencies. You are supposed to be cautious, and metformin is contraindicated. Rest, all of them may be given. Of course, then 3 gram, I am not very comfortable in Indian population. 3 gram of metformin for prevention of GDM should be taken with caution because our patient may not tolerate, especially in pregnancy. So that's another thing. So once you have diagnosed it, second is you have treated it. Postnatal follow-up is utmost important. Unfortunately, postnatal follow-up in our country, rather globally, is very, very poor because we don't have any structured registry of gestational diabetes. And me and Bansi Bhai now trying to think on these lines very aggressively, and then possibly in future we'll have that. So GDM rest, if we will have a postnatal follow-up more carefully of these women who have become normal after delivery, because 50% of them are likely to become trying diabetes in next 5 to 15 years. So that is another thing which we need to do that. And of course, I talked about breastfeeding. And a preconception counseling and care is utmost important. The periconceptional HbA1c is more correlated with the neonatal outcome than the HbA1c at the time of diagnosis of GDM. You got to this point? The preconception, at the time of conception, the HbA1c is more correlated to the neonatal outcome than when you diagnose GDM and treat it. So, yeah, and that is why we should try to achieve less than 6 is ideal preconception, less than 6.5 is acceptable, less than 7 is only in the case of type 1 diabetes who have higher risk of having hypoglycemia. So, ideal figure is 6, but acceptable figure is 6.5 preconception. Remove all contraindicated drugs in type 2 diabetes pre-existing, remove statins, remove AC inhibitors, ARBs, save drugs for hypertension, no drug for lipid lowering drug when you are planning pregnancy. And every young childbearing age person should be a potential candidate for preconception counseling. Don't presume that I have 2 children, so I will not have a 3rd child. I feel we have to be aggressive in addressing them because 90% of pregnancies are accidental pregnancies. साहब गलती से हो गया, एंड गलती से हो गया वाला जो कार्यक्रम है ये हम लोगों के लिए बड़ी तकलीफ।
2 महीने के बाद बता रहे हैं।
हाँ, गलती बता रहे हैं 2 महीने के बाद, तो तब तक उसको स्टैटिन भी चालू रहता है, ग्लिमिपराइड भी चालू रहती है, किसी किसी को पायोग्लिटिजोन भी चालू रहता है, एंड दे आर ऑल हैविंग, दे डोंट हैव एनी सेफ्टी डाटा अवेलेबल. प्रैक्टिकली पायोग्लिटिजोन हैज बीन फाउंड टू बी टेराटोजेनिक. So we have to be ultra careful, and preconception counseling care will start in the country only through awareness, for which I feel he is the right person to talk on awareness, mega awareness across. Yes.
Small comment on in addition to what Dr. Gupta has said, it is a common mistake that if lady is having normal hyperglycemia in the first trimester, people are not repeating in 2nd or 3rd trimester. So once it is normal, try to repeat in 2nd. If it is normal, try to repeat in 3rd trimester. There are chances that this patient may develop hyperglycemia in later part of the pregnancy. Again, he has said lactation can be extended up to 10 months. So it is associated with lesser chance of developing type 2 diabetes.
Thank you very much, sir. Yes.
Sir, I have heard about from Dr. Sisaiya from Goa. He said that obese ladies delivered the baby later on likely to develop infertility if the male. What is your opinion about this?
Obesity.
Obese girls producing children, male children, they are likely to become infertile. Chances are high, 60% like.
I feel there is one paper, but there is no Indian data that is far sure.
Dr. Sisaiya said it. Goa.
Sir, I feel we'll have to cross-check this, that the male child born to a GDM mother is likely to have infertility.
Non-GDM also.
Non-GDM mother. I feel we'll have to cross-check this.
Obese ladies. So it means that I suggest every girl about 20 to reduce weight to keep the child safe. There
is direct correlation of obesity and infertility. There is no doubt on that. But whether it's 60% or what I feel we'll have to, all of us have to.
Numbers we have.
It could be environmental rather than the transmission. Environment means a lady is obese, she is not aware about the lifestyle modification, diet and exercise. It may lead to obesity in her baby or boy.
It's for both. If I may add, there's a study on that. Obese or overweight mothers, if they give birth to whether sons or daughters, they may have future risk of infertility, irrespective, compared to their non-overweight or non-obese mothers. So it's actually known.
Is it 60%? That's what
60% is questionable.
We need to see that paper in detail, but it's a published data. Thanks.
So,
I feel
so thank you very much, Sunil Gupta sir. He has been so supportive from very first day. Because of him only, I have been inducted in DIPSI as well as a governing council member. And with the support of Dr. V. Seshia sir, we have started awareness programs. We can't say it awareness programs, but we can call it crosstalks with gynecologists. And this is under the banner of Pregnancy Study Group, the meeting that we are doing since last 3 years. Now we have started it in different districts
of Gujarat. First, we started with Junagadh. We have Dr. Deepak Chodasma here. Then second program we did in Himmatnagar. And third program that we are going to do in Rajkot now. So we'll have crosstalks with gynecologists and we'll have diabetologists and physicians from the same district, and we'll be spreading awareness of DIPSI, how we can prevent diabetes, not only about preventing complications in gestational diabetes, but preventing diabetes. It is the first step of that controlling gestational diabetes or hyperglycemia during pregnancy, or whatever we talked about, like obesity can cause infertility, and such issues can be tackled very well if we have good awareness throughout the country. So, and next program of PSG that we are planning in Kolkata. So we are going out of Gujarat as well, and DIPSI is wholeheartedly supporting from very first day. And thank you very much, Sunil Gupta sir, for this thing.
I feel with this we declare, sir, we declare this session is concluded. Thank you very much for your patience, system.
So thank you so much, all the legends, for delivering such a elaborative session for gestational diabetes. Let's have a huge round of applause for this, all 5 of them.
Yes, sir.
Thank you so much. And our next session, we will begin on 7 o'clock. There will be some bio break we are going to take. And next session is very, very excited. Do not forget to attend it. That is a detach accelerator program, and sharks will be there. So what is that exactly? You will came to know on 7 o'clock. There will be session, will begin on 7 o'clock and will end around 8:30. So with this, we are begin for our bio break. Thank you so much.
Many of you, I don't know about that Ahmedabad is a first declared World Heritage City from India. It was in 2013. I know now you know it. And this year in 2013, after 10 years, after 1 decade, we are going to have our one of biggest meeting of physicians, which is going to happen in 2023 from 26 January to 29 January at Ahmedabad, and where we will be having more than 10,000 physicians from all across the country. I just want to show you one video which we have made for Ahmedabad city as a heritage city to show, and at the same time as an Epicon 2023 to invite everyone. So I request AV team to start that video till that this partition get open. So requesting Neelam, if you can have that video. Yes. It is a video of 2 minutes only. Please see. And those who are from Ahmedabad, please see all those locations also if you have not seen.
India when it comes to diabetes technology. So this platform was curated, and Dr. Bansi Sabu happens to be the founder, and myself, me and Dr. Rakesh, they are the co-founder of this DTech. We organized very successful DTechCon. This was the online conference, which was attended by more than 6,000 doctors. Out of these 6,000 doctors, 3,000 were totally from out of the India, and more than 50 global faculties actually participated in that conference. So this conference was one of the most successful event which happened of late in the field of diabetes and technology. So with this background, so all of you know what is a startup. Startup is an idea which comes into someone's mind, and they start building on that to bring some solutions which can be disruptive, can lead to a measurable change in some problem area. A lot of people, they are now having innovative ideas. They want to implement these ideas. So we invited applications on the forum of the DTech from the startups, and we received almost 50 applications for the startups. From the startups, our committee screened these applications, and we selected 9 participants for this DTech Accelerator program. So these 9 participants are going to make their live pitches in front of all of you, and in the presence of the esteemed sharks, which will be introduced by Dr. Bansi Sabu. And this is a live program going live on DocTube. So whatever commitment, whatever presentation, this is totally live. And this is something which you can correlate with the Shark Tank, which you have seen in the TV, and of late it has become a very, very popular program. So without taking too much time, I will request the founder of DTech, Dr. Bansi Sabu. I welcome him with a big round of applause for him to introduce the sharks.
Thanks, Amit. The word which is given to all those digital technocrats is a digitonians by Dr. Shashank Joshi. It was really, the last year when we have done our DTechCon, he asked me that this is the right word which he had coined at the time of inauguration itself. Thanks, Shashank. Now, can I have the first slide? So we have with us Mr. Aman Mehta. He is the Executive Director, Torrent Pharmaceutical Company. He is a Bachelor of Economics from Boston, University of Boston, and MBA from Columbia University, New York. He believes in creating a culture of innovation, empowerment, and possesses a commitment to creating a long-term sustainable business. Aman has a pleasant disposition, sound commercial acumen, and creative problem-solving skills. Torrent turnover is more than 8,000 crore, and I request Aman to come here on the desk. Aman Mehta. We have with us the next slide, Dr. Nayak, Mr. Ganesh Nayak, because if I will say doctor, then he will say, no, I'm not doctor. The Ganesh Nayak spreads international operation of Zydus. He's an executive director of Zydus Group. He also oversees the joint venture companies and consumer products business of CHI. With strategic insight and business acumen, he has also played a key role in several MSA deals and alliances. Now I request Mr. Ganesh Nayak to come on the dais. So you are on the second, in group B. Yes. The next, we have with us Mr. Nirav Mehta, who is a director and co-founder of Corona Remedies, promoter and executive director of Corona Remedies, project management. He is an expert in marketing, financial management, product launch, client retention, and implementing policies, cost control, fastest growing pharma companies of India. I request Mr. Nirav Mehta to be on the desk, the last one. Sorry, in between I may say some doctor word also. As usual, how we announce. The next we have with us Mr. Jakshesha. So not Dr. Jakshesha. He is the chairman, managing director of Sevi Infrastructure. He is the president of Credai. He is the brain behind the changing landscape of Ahmedabad. He is the chairman and managing director of Sevi Infrastructure and Limited. I request Mr. Jakshesha to please on this side, from the A. The next we have with us Mr. Gagan Atreja, who is the President, India Business, Aris Life Sciences. He is experienced professional with a demonstrated history of 3 decades working experience in pharmaceutical industry, skilled in business management, customer relationship management, and marketing management, market planning and business planning. Can I have the pleasure of inviting Mr. Gagan Atreja, the second side, please. The next we have with us Mr. Kamlesh Patel, CEO of West Coast Pharmaceutical Works Limited. He is a close friend of us, Mr. Dr. Kamlesh Patel, over next to Nirav Bhai. We have with us Mrs. Farida Hussain. She is the Chief Marketing Officer of USV. Can I have her slide for the next? But I think many of us know Farida very well, one of the fastest and one of the biggest company in diabetes field, Mrs. Farida Hussain from Mumbai, Chief Marketing Officer, USV. Next slide. We have with us Dr. Shashank Joshi, Padma Shri, Chairman of International Diabetic Federation from Southeast Asia. He is an eminent endocrinologist and diabetologist. He is honored by the Government of India in 2014. He is a Padma Shri, and he is currently the chair of International Diabetic Federation from Southeast Asia. Dr. Shashank Joshi. Big round of applause for Shashank. We have with us Mr. Namit Chugh, who is investment professional and ex-management consultant focused on healthcare sector in India. Prior to joining W Health Ventures, he worked as an associate at Low Capital, where he had made investment across sectors such as healthcare, insurance, and financial services. He worked closely with entrepreneurs in their journey to scale up the ventures. Over to please welcome Mr. Namit Chugh. I think last one. Namit, you are the, yes. We have with us Dr. Jyoti Dev, a technology man from India. He is a diabetologist, endocrinologist. He is also editor-in-chief of an International Journal of Diabetes and Technology. He is a managing director of Jyoti Dev Diabetes Research Center, Kerala. Dr. Jyoti Dev. Next. We have with us Mr. Gautam Chopra, who is a founder and CEO of Beto. Gautam is a co-founder and CEO, digital health platform for chronic condition management. Prior to Beto, Chopra worked in Europe for 7 years with Lufthansa Group. He is an alumnus of Indian School of Business, Hyderabad, holds a bachelor degree of technology in electronics communication from University of Leicester, UK. Mr. Gautam Chopra, please. We have with us Mr. Viranchibhai Shah, who is a Managing Director of Saga Laboratories, Chief Managing Director. Viranchi Shah is a Saga Laboratories Chief Managing Director. He is a National President of Indian Drug Manufacturing Association. His focus is on team building, introducing digitally driven new technology in pharma. Please join the last group. The next, yes. So we have with us Mr. Bhagwat Dhingra. He is a founder of Medisays, by the doctors, for the doctors, with the vision of upscaling healthcare professionals with latest medical knowledge from national and international experts, poised to become largest healthcare professional network in the India. I request and I welcome Mr. Bhagwat Dhingra to come on the stage. Now, yes. Now I request Dr. Manoj Chawla, our co-founder with Diabetes Technology DTech Accelerator. Over to Manoj.
Thanks, Banshi. Let's hear it, guys. Are you excited for this evening's program? Right. Let's hear it for the sharks. Are the sharks ready to bite? Right. RX team, can I have the fish bowl for the sharks to start biting? So, quickly, the format is we have 9 startups that have been selected by a jury to be here today. Each of these startups will be given under 5 minutes to make their pitch. We will move along with the jury teams to question them, to ask them as to why they are here. And the moment any particular individual from the jury team is interested in that particular venture, there will be a shake of hands, which we will look forward to. And then the shark and the startup will take it out away from DiaCareCon, but keep us posted about the development. So we look forward to many more shake of hands today, this evening, between the startup and the sharks. But remember, all the startups here, it's under 5 minutes. And beyond that, we'll have a few minutes of questioning and grilling. Time permitting, we will open it up to the audience also to ask some interesting questions. And many of you here are pretty wealthy, and if you want a stake in the company, you will get your chance to make a pitch as well. And we invite you to come ahead on the mics here when the opportunity arises. So let's get the ball rolling. As they say, every brand needs to tell a story. And to begin with the first story, we invite Artelius as the first startup to come in front of the sharks. Can we have the Artelius slides up there? We request you to introduce yourself and go for the pitch within those 5 minutes. Over to you.
It means 4 minutes, 30 seconds.
Can we have the slides up there?
Hello, everyone. I am Girish Somanshi, one of the co-founders of Artilus, an AI-based company. And we largely deal in ophthalmology, and we are starting to venture into diabetology, and this is our effort that I'm trying to position in front of all of you over the 5 minutes that I have. So Artilus, we basically are dealing in a space that we have carved for ourselves, we are trying to carve for ourselves, which is the preventable blindness space. What we are trying to do is bring the power of robotics and AI. Is that okay? Thank you. What we are trying to do is bring in the power of robotics and the power of AI to try and solve this one major issue that India is facing. One of the major issues that India is facing, that is preventable blindness. Next slide, please. Okay, I did that. So quickly, what is the share, what is the market that we are operating in? We have a TAM of 8,700 crores, a SAM of about 3,000 crores, and what we are actually operating in right now is about 1,300 crores. What we require is investment to ensure that we are able to scale up and try and reach out to the SAM. Why now? The category tailwinds are in our favor. The first thing is there's a need. There's about an economic burden of about 89,000 crores that India is facing only because of preventable blindness every year, based on an Orbis extensive report created by Orbis. 88% of that is preventable. How is it preventable? By early diagnosis, and that is where we want to play a small role, a squirrel's role in that objective. There's good amount of acceptance now. There's an improved amount of awareness. There's good amount of disposable income. HCPs and hospitals need innovation, and we are trying to bring in innovation, digital innovation. Commitment. India has committed to eradicate preventable blindness, and recently preventable blindness has become a part of the UN SDG. So there is obviously a lot of impetus that is coming on this particular space, and we are trying to ensure that we are at the right place at the right time. The first product that we have, I'll quickly tell you the products before I come into the diabetes section, DR section. We've built the world's most economical and the only portable OCT. While OCTs generally cost about 40 lakh plus, we've bought this in 13 lakh rupees, and that is something that ophthalmologists are liking, and this is something where we are getting good traction. We are in fact not able to supply the kind of demand that we are generating. Not a great news, but give us investment, we'll be able to supply all of those. So it's a made in India product with Indian parts and Indian expertise. Another good thing that I would like to mention out here is Department of Telecommunications has been running a 5G hackathon project, competition rather, and we have been shortlisted in the top 10 of this particular competition out of the 1,000 plus competitors that participated. And this is the second product, which is a ready to market product that we have, which is a deployable, ready to deploy multi-axis portable stand on which any ophthalmic device can be set up. So a doctor sitting in a city can actually screen people sitting in the rural areas and with just a joystick. So I'll come to the main part, and that is the DR screening. When we talk about DR screening, even diabetics who are visiting a diabetologist clinic today are not all being screened. That's one of the major challenges that we have. It's not the lack of intent that is a problem. The lack of resources and lack of logistics is the issue. The inadequate patient compliance, optometrist required to click a fundus image, a good fundus image, skill and motivation of the optometrist, darkroom setting most of the times, the screening time, the quality of image, the requirement of an ophthalmologist, high cost of screening, time required for report generation, and portability of conventional devices, especially if somebody has multiple centers. So these are a few challenges that we identified, and based on which we have come out with these two products, hardware and the software. The hardware that you see on the side there are two fundus devices that we have, which are completely automatic, completely robotic. I'll come to the features of the hardware in the couple of slides. That is a completely operator independent fundus device that we have. Plus what we have is something called Drishti, which is our AI, independently developed AI, which has a sensitivity of about 96 to 98%. Papers have been presented even at international conferences.
Referable AI has a sensitivity of 100%. We don't miss any referable AI. There are 21 retinal abnormalities that can be identified with a fundus image, and we are working on all of those. In addition to the DR, we'll have 20 more abnormalities that will be identified with just one fundus image click. So this is all it takes: capture with just 2 clicks, analyze with just 2 clicks, report is generated with just 2 clicks. There are many advantages of offline AI. What we are also doing is something called an explainable AI, where we will be able to understand where exactly issues lie. Currently, what are our achievements? We've got 94,000 plus people who have been screened, most of them in rural areas, thanks to the offline functioning of Drishti. We've got many awards, thankfully. Top 10 competing finalists in DOT. US CDC has asked us. Sorry? Right, sir. Oh, time has expired. So what we are... Thank you so much. This is my last slide then. We are bootstrapped. We are already generating revenues, bottom line positive, strong products, and we've got good products in pipeline and a highly secure supply chain. What we are asking for is very interesting. It's a new concept. It's a new experiment. We are asking doctors to invest in us. And what we are asking is not a lot of money. We are talking about small investments. We want about 50,000 rupees, 1 lakh rupees, 2 lakh rupees being invested in the organization. Why do I want that? Is because tomorrow when I actually go out there asking for larger funds, I want them to see that doctors believe in the products that we have.
Thank you. Thank you.
Thank you so much.
Over to the sharks.
Yeah, right. Sorry.
First table.
Hello. So I understand. Anyway, fantastic. The product is fantastic. Congratulations. I know that there are similar, maybe 2 dozen products available globally.
Yes.
And I went through the specificity, the sensitivity. And according to you, it detects not only retinopathy, but also glaucoma and some other...
Not right now. We are working on that product. About 6 months is the timeline that we will...
So how is it different from the existing products? What are the major differences?
I will come to that. So the 2 main things, and the overall product that we have is based on the hardware as well as the software. It's not just the software. Why do I say so? Is because the device that we have, the hardware that we have, captures a 12 megapixel image. It's a large image that it captures. So the AI is able to function way better as compared to functioning on any other image, because all the others have generally a 3 to 5 megapixel image. So there's very little likelihood of the AI missing out on any abnormality. That is part number 1. Part number 2 is the explainable AI part. So I have had experiences where the HODs, even HOD of a particular hospital, ophthalmology department, could not identify that there was an abnormality in the image when we zoomed it in fact, the doctor from his team zoomed it in and to show an abnormality. So humans are liable to miss out on some areas and unlikely to accept something which an AI has told them. Just because the AI says so, I will not accept it. But if the AI shows me where the issue is...
Two questions. One is, how long this is existing? Number 2, are you able to offer this at a reduced cost when compared to the competitors?
So, okay, interesting. So first of all, we've been existing in the market for about 4 years now in terms of the AI. As a company, 7 years, close to 7 years. In terms of the cost, we give it out for free. So the AI goes out free along with the hardware. We don't generate revenue out of the AI.
What is the cost of the hardware?
The cost of the hardware is 7 lakh rupees.
7 lakhs.
Yes.
And is your product patented?
The product features are patented, yes. The product is patented, yes.
Can anybody copy
No,
it easily?
they cannot. Nobody can.
So question.
Yes, please, sir.
So you are a very good retinal photographer. That will
Yes, I
get
do.
replicated very easily. What is novel in you? And what is the validation? Because your RCTs are not there in place. You have some abstracts in some publications. So you have a long way to go, but ultimately any imaging company will outbeat you.
Unlikely, sir, because as I said, one is, yes, I'm a good photographer, but at the same time, I create really nice profiles as well. So what I mean by that is, it's not just the hardware, sir. It's not just the image. It's the AI which operates on that particular image, which is my selling point. And I give it out for free. That is a major advantage that I provide. Doctors love the AI, love the hardware. But along with that, when they get the added advantage of an AI, which has a sensitivity of over 96 to 98% and 100% sensitivity on the referable cases, that is what makes the deal sweeter.
So, Girish.
Yes, sir.
I have just 2 points. One
Yes,
is,
sir.
Dr. Jyoti Dev mentioned that you have competition. So what is
Yes,
your
sir.
USP? And the other is, who will be your primary target audience? Will it be the ophthalmologists or
I'll
the
come to that.
diabetologists?
Right. Wonderful question, sir. Thank you so much. In terms of the competition that we have, let's put it in 3 different terms. Anything below 7 lakhs is a low-cost device. 7 lakhs and around that will be a mid-range, and the next device that we have is immediately a 15 lakh plus device. Okay, so there's nothing between a 7 lakhs and a 15 lakhs. So these are 3 sets of devices that we have. As compared to the sub 7 lakh segment, we have many advantages. One is the usability. This is just a 2-touch device, only 2 touch on the touch screen, and the device captures an image. So you don't depend on
any
operator.
interest? This will go on. Any interest in a handshake?
Short
Any of you?
Otherwise,
Before I move to the next one, anyone?
Yes, sir.
First of all, product is brilliant. I have
you so
only
much,
2
sir.
questions to ask.
Yes, sir,
What
please.
is the cost per click on the eye? You're talking about 2 clicks and the results are there. So what is the cost per click? And number 2, you're talking about 7 lakh, and we are targeting tier 3 and tier 4 cities. So 7 lakh and tier 3, tier 4, is it not going? So these are my 2 questions.
Right. So pardon me if this is something that came out as my communication. What I'm trying to do say is 2 different things. One is in terms of usability, the customers that I'm looking at is clearly metros and tier 1 cities. I'm not looking at tier 2 and tier 3 for direct sales. What I'm doing is, with a lot of government support, we are doing a lot of camps being conducted in tier 3 and tier 4. That is where government wants us to go out there and conduct camps for them, which will be paid on a per click basis.
Girish, when it comes to cost of 7 lakhs or 15 lakhs, it's definitely inhibitive. So are you also looking into OPEX model, or it is only a CAPEX model?
Exactly where I need support of the doctor sitting here. Honestly, right now we are into ophthalmology. Okay, our major business is ophthalmology, where they don't see a lot of benefit of the AI. AI is a good to have tool there. Now getting into diabetology, where we give a very precise and a very accurate AI, that is where the pricing model has to be worked out. Honestly, we don't have a pricing model right now. There are a number of doctors today also, and some are sitting here as well, who have asked me that I exchange my device for your device and give me at a discounted price. That is how I love your device.
So Girish, I am willing to put some money in this.
Wow, thank you so much. Wow. Wow.
So we have one shake of
No, but I want also my doctor community to invest with him, because that is the idea.
Exactly.
That this is something that we can be shareholders in this.
Exactly.
If you can be here, let's have the first shake of hands and this thing.
Wait, sir.
So as they say, Girish, thank you. Artelius, thank you. As they say, money may not solve your problems.
I understand.
But money may solve your problems. Right?
Absolutely.
So, Mithun.
Bang on. Thank you so much. Thank you, everyone.
So, thank you. That was a brilliant start. We request Group 2 to pick up a chit to see which company. Shashank, sir. Whichever one person to pick up.
Yeah, paper plane.
Paper plane.
Yeah. So, can we have guys from paper play come up, please, and let's have their slides.
So while paper plane is coming up, I would request paper plane 4.5 minutes, 30 seconds, 5 minutes. Make a pitch within that 5 minutes, and we'll request when the sharks are asking, give short answers, and they can always have more in the interest of time later on. Is that it?
Also can show just interest.
Yeah, it's just interest. There's no commitment.
Because you can have one-to-one meeting also tomorrow morning if you want, because otherwise we will not able to finish all 8.
Fine.
Yeah. Good evening, everyone. Good evening, Sharks. My name is Devansh Saroop. I am the co-founder and CEO at Paperplane. And at Paperplane, we build WhatsApp clinics for small clinics and hospitals to allow them to grow and scale their medical practice on world's most favorite messaging app. So before we move forward, let's just look at a couple of challenges that a doctor faces during their regular day of course. Doctors effectively, if you think about it, have no control over patient experience pre and post consultation. Whatever control they have is during the consultation altogether. Their offline and online appointments are never in sync. More or less, they are listed on multiple platforms, multiple inbounds are coming to them. 90% of post consultation interactions happen over WhatsApp, which leads to a very scattered information. And the last 2 points, I'm clubbing them together. A lot of these doctors are looking for marketing bandwidth, that they're investing money in it, but there's no bang for buck. There's no return on investment, and they end up partnering with local vendors in local cities which have no structured operations. So how does Paperplane come in this? How do we solve for doctors? Paperplane provides personalized branded digital clinics on WhatsApp. Every doctor gets to have their own digital presence on top of WhatsApp. What we have done is we have automated patient engagement by creating virtual receptionists using AI on top of WhatsApp directly. There's seamless online and offline connectivity. So now the doctor has flexibility of taking a teleconsultation via WhatsApp itself. The app and the product also acts as a lightweight CRM tool for the doctor's team, receptionist. Anybody can intervene and basically have a conversation with the end customer or the patient under a clinic's brand and header. And we also provide marketing bandwidth and SEO optimized website to help doctors establish their own direct to consumer brands. So essentially, what are we selling? We are selling digital clinics with virtual receptionists on WhatsApp, coupled with brand building capabilities to empower doctors to start and grow their medical practice on the world's most popular messaging app. What do the patients get out of it? Now, flipping the whole equation, looking at it from a patient's perspective. Patients get access to one-tap 24/7 appointment booking via WhatsApp, 24/7 access to their prescriptions, old reports, everything on WhatsApp. There's obviously remote consultations. The best part about the platform is it picks up any sort of input done by the doctor and reminds the patient when the next appointment is coming up, when they need to take their medication, all in vernacular language support. We have basically empowered doctors to reach out to the next billion users in India using vernacular language support on WhatsApp. So here's a brief description of the platform. Here's what the patients see. Here's what the doctors see. So the Paper Plane team has been working with each other for the past 4 years. We have had significant product building experience. All of us are college. We recently graduated college and raised our pre-seed round. The market opportunity for this is huge. We'll come to the market opportunity at the end of the slide. Our business model is simple. We are a B2B SaaS company charging doctors for an annual subscription fee. Here is a couple of competition analysis. As you can already see, customer love is building for us. We have close to 17,000 doctors that are already onboarded with us. We have managed more than 20,000 patient interaction and completed more than 40,000 appointments since our 6 months of operation. In terms of our existing fundraise, we are already backed by Cornerstone Venture Partners and 100x.vc, and we're looking to raise another round in the next 9 months. Why now? We have seen an onset of massive digitization in healthcare altogether, governmental push due for ABHA integration, the cost reduction in WhatsApp API altogether that is done by Facebook itself, because Facebook is allowing developers to build unique experiences for new customers on top of WhatsApp. And of course, efficient CAC to LTV ratio that proves that Indian consumers and Indian businesses are willing to pay for software now. So looking forward to any other question that the panel might have.
Devansh, just 2 key questions. Your entire model is based on the fundamental of engagement and retention of the patients.
Yeah.
So can you throw me some light on actual KPIs for engagement time, DAOs to mouse, and especially your cost of acquisition?
Understood. So our monthly active users in terms of doctors are around 800. In terms of our regular conversation numbers, we are managing. In terms of our appointment numbers, we are managing close to 1,000 appointments a week, and the cumulative number of conversations that we have already handled is close to 15 lakhs.
Just tell me simply, what's your DAO to MAU ratio or on the patient side?
On the patient side, so we'll have to go back and check the number. I do not have the numbers right on top of my head.
How do you track engagement? Like, what is the key metric for you to track engagement?
On the doctor side, on the patient side?
Tell me both.
On the doctor side, we track it by the amount of activity that a doctor does on the platform, amount of appointments that are going in via a platform, and the amount of prescription that a doctor is writing via a platform, and the average time of the use of the software.
And what's your CAC?
Our CAC is somewhere around 90 rupees.
Yes. So for a doctor,
carry on.
Devansh, when it comes to your model, you know that there are a lot of local players.
Yeah.
And how you will offset that? That is the one question. Second, you are asking 12,000 rupees annual fees from a doctor.
Yeah.
Being in this industry, I find many times it's very difficult to get money from doctor.
That takes guts. So
Rightly said so, sir. But again, so I feel here is that if the product has significant value to the customer will always end up paying. And that is what we have proven. We are already a revenue generating company. We are already generating 3 lakhs a monthly recurring revenue, and we just started. So what we are seeing here is that we are able to offset a lot of costs that doctors are already pushing out to local vendors and reducing that cost to around 50%. I'll just give you an example. Doctors already spending around close to 30,000 to 40,000 on average in a tier 2 city just for marketing. We are reducing down that cost to close to 50%, giving more value-added service to that doctor. So that helps us engage with doctors better, help us scale up further.
Okay, thank you.
You had a question. So the doctors that
started using the app in the first month. How many of them are still using? What's the retention on the number of doctors?
As of right now, we've got retention number close to around 90%. We are yet to see a massive drop off. Why that, and I also explain why that happens is because of the regular marketing content and the regular sort of engagement nudges that we give out to doctors. It becomes a very natural way for the patient, because the patient is already interacting on WhatsApp, and for a very natural way for doctors to interact with the patient and use the software for operational as well as clinical purposes.
Have you pressure tested this model? Because you see, you'll have to classify the doctors on the ABC analysis. And those doctors who are in the A grade or category, they would not like to be, it will be a hassle, you know. I mean, every time the patient wants to talk to him on a video. Like today, patients who have a close equity or relationship with the doctor, they do that. But that cannot be done by all these patients. And if a doctor has 50, 100 patients a day, I mean, I don't think the class A doctors would like to indulge in any such initiative. So have you pressure tested that, or is the target audience only B and C to begin with, and later on will be A?
So the target audience is spread across all the categories. What we have built inside the product is, in a way, is that when certain tickets rise up to a certain extent, when the patient excruciatingly needs a doctor, that is when the platform nudges the doctor to intervene. Otherwise, any staff or the AI can take over and keep on the conversation going on. It depends. We have classified it that way.
So the WhatsApp model which you use, tomorrow WhatsApp closes down, what will happen to you?
We can immediately port to any other messaging app. Indians are very accustomed to messaging. We can port
go to
Telegram. Signal, Telegram, any sort of open. If the APIs are open, we can probably integrate that in the next 24 hours.
But I would echo what my good friend Dingraji said. You know, getting money out of doctors is near impossible. And staying them for more than a couple of years is also very tough. And I recommend everybody digital detox. So this is going to make their toxicity for their retina.
Completely with you, sir. But at one point of time, e-commerce was probably non-prevalent in India. Right now, we are ordering TVs from Flipkart. So yeah, I guess India is moving towards a point where everything is becoming digital. We are bullish on that.
So Devansh, for me, I think you're on to something. Sorry, man.
Any shark showing interest gets the benefit. Any shark showing interest.
I personally think you're on to something. I would really love if you're willing to sort of focus this more on solving for operational issues for doctors rather than clinical issues. And second, definitely you have to figure out a model which does not require doctors to pay for. And I think there are plenty which you can work on.
So Gautam, we are interested.
So Gautam, we are definitely. I would be definitely interested to explore different kinds of collaboration as well as potentially.
Okay. Do we have a half handshake here? Do we have any handshake? Full half?
Full half.
Right.
So Devansh, I'm also excited about this particular project, and so I would also like to understand it more, and maybe we could meet up and
Great. Okay. And Farida will make sure that the doctors are not paying for it. So don't.
That is all of us will make sure the doctors don't have to pay for it.
Okay. So a couple of handshakes and a quick question from Dr.
Just two quick questions. How do you maintain the records? Like if you want to go back in time and see what the doctor and patient conversation was, that's number one. And number two, patient confidentiality in WhatsApp, as we know, is an open messaging app and all of that. So those two questions are very important as a doctor.
So I'll answer the second question first. WhatsApp, in an essence, is not an open platform. It's an end-to-end encrypted platform where even WhatsApp cannot view the data, at least legally, that is what they're telling you. They cannot view the data while the conversation is happening. In terms of the confidentiality, we have a very comprehensive, lightweight EMR solution that we have built from ground up because we are engineers by background. We ended up building the whole stack all by ourselves rather than using a vendor, and that is how we have ended up building Paper and integrating it with a friendly, easy-to-use UI.
What about the record? Like, how do we go back in time? This is patient history. Whatever conversation your AI answers, still it needs to go on the patient's medical
Exactly.
file.
Short
answer.
So the AI right now is not, no AI in the world right now is equipped to replace doctors. What we can do is give out nudges and give out certain explanations. Post that, a doctor has to intervene. And that is what we promote.
Handshakes. Let's have the handshakes.
No, I do have a question. I do have an important question.
Yeah.
So medical information needs to be on a HIPAA server, right?
Yeah.
So you are piggybacking on WhatsApp?
Yeah.
So how do you, what is the cloud platform that you're using?
We're using AWS and we are HIPAA compliant.
You are? No.
Yeah.
Wait.
Yeah.
Are you on a HIPAA server?
Not right now.
Okay, that's really what I wanted to ask.
Yeah.
Thanks.
Okay. Krishna bringing up
I think
devaluation.
Vinay, quick question.
Okay.
Yeah.
Vinay, quick question.
1 second, I'll just take up a question there, but yeah.
Everything sounds pretty good, but is it been approved by NMC? Will the NMC accept it?
Yeah. In fact, my company, I myself did an article under the Paper Plane brand explaining doctors that NMC has started scrutinizing aggregators. people who serve up doctors in a menu to patients. We are not a aggregator company. We provide independent. We are a software vendor to doctors.
But are the patient treatment on WhatsApp been approved by the NMC?
For them and the handshake.
So let's have 1.5 handshake.
So,
Come on, Devan.
Neelam, my mic needs to be on.
And can we have a photograph with the two sharks in
Right.
between? So how
Friends,
many
we do
handshakes
appreciate your
having?
questions, and
2.5.
there will be many.
3 handshakes.
All those making the pitch will be around to answer all your questions. Unfortunately, in the
Okay.
interest of time. Yes.
What?
And would request all the sharks, you've probably gone through the profile of the companies. Let's ask questions first if you're directly interested in the product. So next one is Diax Clinic. Let's have the guys from the Diax Clinic.
So can we have the Dice Clinic? Please come.
Yeah.
This is it. Yeah. Start.
All right. So we are 3 founders with parents with diabetes. We might come across as the typical IIM doctor team, but we know how this affects a person. We know if a single medicine gets added, they get demoralized. Everyone tells them what to do, what not to do. And this is the empathy with which we started this journey with. It is not just our parents. Diabetes in a way can be linked to 80% of India's blindness across different diseases. It is the #1 cause of kidney problems, the #1 cause of foot amputation. 80% of this could have been avoided with just early screening at primary care level. That's where we come in. We empower primary care givers, GPs, endocrinologists, diabetologists, to take charge of their existing patients' early diabetic complication screening needs by establishing micro clinics across eye care, kidney care, feet care, and subsequently cardiovascular care. How do we do it? So we provide the devices, we have our own AI algorithms, and we have a platform through which they can provide reporting and not just detect disease. They can longitudinally track the progression of the disease. We have explainable AI. It's not just a picture which is presented to the patient. Our AI talks, it highlights the reason why it takes a call. We do this across multiple diseases in eye care, and similar work is happening across feet care and kidney care also. So this is the model that we want to take to doctors. We don't charge doctors anything. We work on, so to say, a revenue share model. So all the doctors out there, we would love to work with you. And my presentation is not just to the investors.
Did you change that now? About charging the doctors bit, or was it always?
No, we were never charging the doctors. So 8 doctors signed up today because we were never charging. So my investors are also this side, not just this side. And we are a deep tech company. We were born out of software. We were not born out of hardware. We work with multiple vendors. We help them create low-cost devices. Like in eye care, we're actually coming out. We're working with a vendor who works with ISRO, DRDO, and they're coming out with a 1.25 lakh fundus camera. It is a handheld device. So imagine where could this go? There are places that you need bigger machines, but a small machine could go a lot of other places. We're doing this across different categories. In feet care, we're managing ulcers. So this is the R&D pipeline. So it's all deep tech that is coming out. Market sizing, there are close to 5.2 lakh doctor entrepreneurs. Entrepreneurs who are running their own clinics. We want to support you. We want to work with you. That is the target market. Why are we here? It's very simple for you guys. This is a pitch mostly to you guys. We have all the right intentions, technologies. We want to work with you. Please see, meet us. And apart from that, we're looking for advisory. In terms of fundraise, we're looking to do a small seed of 1.5 CR with which we could cover up a couple of clinics and prove our model. We just are getting into our GTM. We have the commitment for this, but we would love to see if there could be something more strategic that could come, which could make our journey from 2x to 10x. We'd be very open for that. I'd like to dedicate the rest of the time to questions.
Brilliant.
I just
So,
Excellent
it's a
pitch.
revenue model because you mentioned this is not charging clinics.
Yeah.
So.
No. So, sorry if I misconstrued that maybe. The revenue model is that we do not charge clinics for the devices. We work with OEMs on a rental basis and we lease it out to the clinics. So let's say you go to a clinic, a GP clinic, for just 500, you could get screened across complete eye care, feet care, kidney care, and the doctor may charge around 800 to 900. Currently, test price would vary between 3 to 5,000 in Mumbai. So we look for a minimum number of business which is sustainable for us. Like doctors are entrepreneurs, we are also entrepreneurs. So we would work individually with each doctor, looking at what kind of patient clientele they have.
Or to the shark?
No, strategic investments from the shark.
Sure. So we go
But I want to use maximum opportunity.
Right.
So just help me talk about your AI a bit more. You mentioned the hardware part is clear to me, but how are the reports generated? What is the technology that you're using? That is first question. And second, let's say a doctor charges 500. How much do you get? Because you have leased the devices to the doctors, right? How are you making money? Is it on a per patient, per test basis?
Okay, I'll cover the AI part first. So we have published a study with AIMS Jodhpur, and this has been verified on 2 independent data sets, close to 4,000 patients. Our AI accuracy is at par with senior super specialist, around 92-93%. And yet, in this model, there is telemedicine. There's still a doctor involved. Future, we'd scale it only with AI, but initially to build the credibility, there's a doctor involved. In terms of economics, I might have again made a mistake. We price the charge to doctor at 500. He will mark it up at 800 or 900. Like I told, in Mumbai, this would go between 3 to 5,000, but we want to keep it low cost.
You know,
we get 500. So 500, maybe around 50 patients, 25,000 a month. Out of which we share around 10 to 12,000 with our OEM partners.
This is really a brilliant product, and a company like us, who have been very focused into diabetology, will be interested into advisory, investment, and all stuff of things.
Thank you so much. I just want to also add one more thing. Along with the brilliant company Artilus, we are also one of the top 10 companies being assessed by CDC for our AI algorithms.
Excellent. Right. So we already have a handshake here.
One more handshake.
One more handshake. So let's have both of you there. Right?
I would love some hugs also. So come on, show some love, people.
Sure, I think congratulations. I think one thing, beyond the revenue generation from your AI platform, you are also making a lot of commission from your partners, right?
Yes.
So you have that revenue model also in place. So you have a primary and a secondary model of revenue
No,
generation?
actually we share revenue with the partners. So in case of the OEMs, we collect 500 from the doctor.
And that's an open thing or a close?
Sir, could you explain that?
So for example, you can buy your retinal thing from anyone. So you are
Yes.
customizing the solution for that individual doctor?
Yes, so the pricing will be customized. The reporting structure would be customized. We don't want to work with every vendor.
I am not so sure what you're saying.
Sorry, sir. Could you please explain the question? I'd love to.
So see, you have multiple, you are aggregating multiple reports and you have multiple vendors you're handling. So
in iCare, it's just one.
No. So the IT platform is different, but you have multiple, you will buy a fundal camera. So is your fundal vendor common or is it open?
Just
is it
one.
open or closed?
Our AI works, so the validations we have done is across all machines, but we chosen one because they can provide the
So
a
it's
very
closed-
low-cost
so
model.
my question was, is it open system or a closed system?
Currently, it's closed, but we can license out our IP to make it open. So we're doing the worldwide study only for that reason.
Handshake.
Thank you. Let's have the.
If I understand it correctly, your software is compatible with a range of equipment
Every
that
device.
already exists with the doctor.
Yes.
Correct?
Yes, we could just go as in our software also.
So after all this questioning, are the
No,
sharks
we are
changing their
actually
mind?
launched. We just launched at DIX today. So in 2 hours, we got 8 sign-ups. So I'm looking forward to more doctors signing up after this.
Brilliant. So let's
have
have
some
that
handshake.
handshake here with the 2 investors, entrepreneurs, advisors. Right? Brilliant. Right?
Can we have a photo together?
Let's have that photo up, please. So they say there was never the right moment to start, but probably it is the right moment to start for all of us. let's go on to the next one. And before we do that, Mithun, I wanted to ask all of you here, how many of you are confused with the terms that they are saying? GAP, NOC, MAO, DAO. It's like sitting in a class which we never understood. Doctors, how many of you are understanding this language? Right? Can there be a startup to explain this language to us, poor guys who don't understand finance? Think about it. Mithun.
Yeah, okay. On that note, let's go on to something that we know about. So let's call on Go Pills to make their pitch here. Go Pills, please come on stage. She's coming all the way.
Okay, let's hear it. How is it going so far for all of you this evening? Right? You all are liking it from the back? Shall we stop it here? Shall we move on to finish the show?
How is the Josh?
How is the Josh?
Sorry. Good evening, everyone. This is Manisha. I run GoPills. GoPills works on the pain point of non-adherence to treatment, something which impacts all healthcare stakeholders, doctors, pharmaceuticals, not just the patients. So what we do is we use conversational AI to help patients manage their treatment journeys seamlessly with improved health outcomes. So the pain point really is that the minute a patient gets diagnosed, there's stress of a diagnosis, there's stress of managing a medical condition, the medication that comes with it. The condition could be one singular condition or multiple conditions. And then you have an overburdened healthcare system with a poor doctor-to-patient ratio. Sometimes doctors, despite best intents, are not able to do justice. A not-so-literate population, geriatric population, which does not understand the impact of missing dosages. People just stop leaving their medicines because, they feel well. Chronic care is long, and non-adherence levels are very, very high, range from 76.7% to 48% across specialties. For hospital and doctors, poor outcomes impact their reputation, credibility. For pharma, it leads to massive loss in terms of revenues due to non-adherence, unfulfilled prescriptions. So the opportunity really lies in patient engagement solutions that help with seamless habit forming, solutions that fill up the education gap, tell patients what really happens if you miss medication, even if you're feeling well. Patient retention solutions which sort of cover up the care gap and connect patients back to their own caregivers, own doctors, labs, diagnostics, take load off the doctors, help with better patient management. So what we really have is digital interventions using conversational AI. We soft nudge patients and tell them to have their medicines as per their prescription. In case they don't have their medicine, we follow up and say, why is it that you didn't have your medicine? So if the patient says, great, I'm having my medicine, fantastic. That's a job well done. And if the patient says, no, I'm not having medicine, we really seek out and say, why is it that you're not having your medicine? Is your medicine over? If it's over, let me connect you back to your pharmacy, who can sort of help you with, a high-ticket medicine purchase. If it's over, if you're not having it just because you forgot, okay, then maybe you should have it because, it's anyway going to impact your health. And maybe we inform, we inform caregivers, families, help book appointments with doctors, and we educate. So the secret sauce is really the local interactions. Most conversations that people have today, most services that are built are in English or Hindi. We reach out to users in regional languages, Gujarati, Marathi, Rajasthani, you name it, and we can do it. We do not require any app downloads. There are no app installs, so subsequently no uninstall as well. So service runs seamlessly from the background. We interact, we engage, and we educate. The user experience is guided, which helps patients have their medicines on time, helps booking with appointments, buying medicines. There are missed dose alerts, there are follow-up loops, and there's data and insights for all stakeholders based on their requirements. So how this works is pretty simple. We have a backend CRM integration. We get the data, the service runs from the background. We interact, engage, educate, and based on the data, we collect, analyze, and track. We manage complete program implementation. We are able to run custom programs for pharma companies. It's implementable across specialties. So the customer segments identified are pharma. As I pointed out, we help fulfill the pain point, of loss of revenue, loss of sales because of unfulfilled prescription. For the government, since healthcare is infra spend, reduction in spend. For others, it's a value-added service for patient retention, better outcomes, which lead to better reputation. For corporates, it's healthier employees, more productivity. For insurance companies, when patients take medicines longer, there's less ED visits, less claim payouts. So the go-to-market is pretty simple. We're focusing on employee benefits, pharma and health insurers, already nearly onboarded a health insurance company, in deep talks with pharma companies as well. So the plan is to onboard 2 startups, 2 corporates by Q3. And for pharma, we're working with key opinion leaders. The service is offered free to the patients as a value-added service by the doctor for the patient's benefit. So I'm here to seek deployment opportunities because most of you are from pharma companies, the sharks, and looking to raise 1 million. We've raised 100K already. This is what the numbers look like, 25 crores. If we get a little support from your side, these are based on guess estimates. Corporates have thousands of employees. We look at just 5,000 employees plus for just 5 companies in the first 1 year, and that leads us to our, our goal. And yeah, so, sure, sir. 8 crores. Sorry, I'll need more.
1 million is how many crore
time.
rupees? 8 crore rupees.
Yeah.
Okay, fine. Yeah, the sharks, please.
Sure, sir.
One quick question. When we are developing an app, it is very difficult. It's almost impossible to make sure that there is drug compliance. Very difficult. So here, for example, if a person is having 10 medications per day,
yeah,
and how will you ensure that they are consuming all these medicines?
So, the patient has to do an entry. We're trying to reach out to,
So
to a solution.
They're doing it themselves.
Yeah, so you have to input and say that, yeah, I had my medicine, but it's divided into schedules, right? So, for example, you could do a morning schedule, afternoon schedule, evening schedule, night schedule. Or, you can use computer vision and say that, okay, this is my medicine strip and I'm actually consuming that.
Because
So, we're trying to reach there, but
drug
that's not where I
compliance
am
is
right
something
now.
very difficult to document. So do you have any specific reminder for different medications? Any particular way by which you are going to remind the person if the person is not consuming that particular medicine? Because that is the only reason why you are having an app.
So we ask, sir, so we are asking, are you having your medicine? And
So,
if the patient
Manisha, can you
says
speak on the
yes,
mic so benefit for everybody? Can you just
yeah.
speak on the mic?
So if
Thank
the patient says, yes, I've had my medicine, we record that as a positive response. If the patient says, no, I've not had my medication, we record that as a negative response. But we're trying to reach there with a computer vision product. We're working on it, where you can actually see that, is the patient actually having the medicine on, reading the strip and saying that, okay, this is where I am and the medicine is actually getting
Video
consumed.
enabled.
Yeah,
Video
Manisha,
enabled.
Yeah.
Manish.
Okay.
I have one question.
Sure, sir.
Yeah, I'm sure you know that non-compliance is one of the major issues as far as the mortality is concerned.
Yeah, absolutely.
Now, there are many such products available in the market. If you see, there are many such products, but still compliance has really not improved. The major issue is geriatric patients. So
Also
I have
low
two
literacy
questions.
levels. Yeah,
I have 2 questions. One, what's the difference you are creating in your product? What's the differentiating factor? And second, how would you address geriatric patients with such kind of software?
So the service runs via voice. So for low-income patients in geriatrics, we have a voice solution. And for the higher, the more literate patients, we have a WhatsApp solution. Because, for geriatrics, WhatsApp really doesn't work. The voice works. So we do a speech-to-text conversion, and then we are able to record responses. And I said, as I mentioned, that we are working on the computer vision bit, where you're able to actually see the action of the patient and then record the response.
But how would you address, in spite of many products being available in the market, still the compliance has not improved? I mean, there's no data suggests that there is an improvement in compliance. So how do you address?
Actually, data suggests that digital interventions improve compliance by 30%.
But Manisha, what he's asking is that there have been, the problem is large and it's well understood. There have been plenty of products. Why will your product, what is in your product that will be a breakaway from whatever existed before?
So I don't think anybody has ever worked on a local language interaction product so far. That's number one. Number two, nobody has ever worked on computer vision because that really makes it seamless. You can actually monitor the response. And then, the way we are educating the patients in between saying that, okay, if you're not having a diabetes medicine, this is what happens to you. If you're not having your thyroxine, this is what is happening to you.
Go for your pitch if at all.
Who's,
Questioning will
just
continue.
last question, who's in the team, like beyond you, who else is there?
We are a bunch of techies beyond me.
No, bunch of techies solving
and a
for
few
computer
doctors.
vision, vernacular, as well
Yeah.
as engagement.
Yeah, so data
There's
science.
no specialists for these yet.
No, so we have one person each who sort of, sort of looks at that. Sure, sir.
Mike, sir.
It's a very good initiative. Have you done some dipstick studies? Because I'll
Yes,
tell you,
sir.
this point which Gagan raised, it's not a question of motivation. It has to be exhortation. And I know it, I've been a diabetic for the last 28 years, and so is my wife. Motivation doesn't help. It has to be exhortation. So in your voice interface, how will you address that? And no, bottom line, what is your success rate from whatever is your experience in the last few months or years that you have
Sure. So,
done this?
we've run pilots, and the pilots have shown 30% improvement in adherence. We ran it for CML patients, where imatinib is actually
On the flip side,
given
I would say 70% is the failure rate.
So it led to an improvement in 30% of the patients. 30% better compliance is what they experienced over the pilot that we ran.
Thank you.
Any handshakes or any other
So
questions?
I think, it's still very early days for you, Manisha, with this product, but we would be willing to explore the pilot opportunities and every other interest that you might support.
That's very, very helpful.
Let's have that handshake here.
There's a question.
I
from the
just have a
doctor's
small
mic.
suggestion.
Yeah,
There is an issue about compliance. So what I would suggest, instead of follow-up, if you can move to the proactive model and offer or partner with the pharma companies and offer NFC tags or something, so that any age person, anyone can just tap and deliver the feedback that they have taken the medication.
Suggestion well taken. Thank you so much.
Let's have the handshake here.
Thank you. So wonderful. The sharks are biting a bit, but they are hugging and handshaking much more. So these are friendly sharks, rather dolphins, I must say. Right? Right.
Smithfit. Somebody from Smithfit.
So while Smithfit is coming, in the interest of time, what we will do is we'll finish the shark questions and then we will take the audience questions. Otherwise, we are it will get a little bit overlapped. Over to you.
So Smithfit gave that feeling that coming up for awards. 3 of them have gotten the awards, so they've come up. They're Smithfit, all yours.
We sure hope so. Good evening, everyone. We are Team Smithfit. Let me just quickly introduce myself. I'm Harshad. I have with me Raj and Shachi, who are a part of the team. Smithfit is a digital diabetes management solution. We have an app-based solution that looks at 5 parameters for diabetes management, which is sleep and relaxation, nutrition, mental health and self-awareness, medication adherence, and fitness. And the way we enable this, these 5 parameters, is through our coaching team that handholds our users throughout their journey. The coaching team consists of a psychologist, a nutritionist, and an exercise or a yoga coach. And we do employ a lot of data. We are integrated with Apple Health, Google Fit, and we also employ Abbott CGM to record blood glucose data. And all our technology base runs on the back of this data. The team behind the solution, unfortunately, our founder, Mr. Sujit Chakravarti, couldn't be here. He had to travel abroad. But this is the team that is behind the solution. We are also fortunate enough to have Dr. Bansi Sabu and Dr. Manoj Chawla and Professor Yajnik as our mentors who've helped us come up with the solution.
Conflict of interest.
Yes, for sure.
I just realized that.
All right. Here are some of our impact metrics. Raj, would you like to take them?
So we've had impact with about 77% of our patients basically have seen improvement in estimated HbA1c in the span of 2 weeks. In the case of patients with uncontrolled diabetes, we've had a reduction of almost 1.4% reduction of estimated HbA1c. We just recently completed 50,000 coaching sessions with our nutritionists, health coaches, and exercise coaches combined. And largely we've covered up patients in across 57 cities across India. As a few key highlights from that point of view. And from an impact metrics perspective, basically we've seen an A1C drop for our uncontrolled uncontrolled patients. Basically, we've seen a drop of 1.4% in estimated HbA1c, and for controlled diabetes cases, we've seen an average drop of 0.5% in 2 weeks as well in the same estimated HbA1c.
Because we are short of time, we would like to go into the impact metrics in further detail in a private conversation perhaps. So all in all, we have developed, we believe, what we like to call a full stack solution, wherein we base our analytics on data. We use that data to provide personalized plans to our users, which are enabled by expert coaching. They use personalized nudges to develop adherence to these plans, which are constantly monitored, and that is what together delivers the health impact that we just spoke about. This is, I think, one of our differentiators, and again, I would like to go into details of this further. We touch upon different aspects as far as health and wellness is concerned. It is not just a focused diabetes management program, but our platform can also be used for general health and wellness management, and which is why we are tapping into multiple channels to take our solution to our users. So we are partnering up with doctors, clinics, we are partnering up with corporates, also certain digital platforms and elder care solutions. So there are multiple different channels that we are tapping into to take our solution forward. This is the last slide. Like I mentioned, we are an overall health and wellness platform. So there is a myriad of solutions that we offer to our customers. It is, a comprehensive set, as we like to say, and I would like to throw the floor open for any questions. Thank you.
So when it comes to data,
Okay. Sharks are fighting. Shark is the one here.
is your data properly clinically substantiated? Because I think this 77% in 2 weeks, etc., to me seems a little bit too far-fetched. Anyway, we have experts sitting right here to my left and to my right.
Sure.
Maybe they should comment on this.
You need to do proper RCTs. I mean, I also work, do some science for one startup, which is not a startup anymore. It's evolved in the US. We are doing in Cleveland Clinic. In India, we have done RCTs. We have published them in ADA. You need to do consistent research. This looks like quasi-science. In your matrix, you have put Ayurvedic supplements there. I mean, if you come to me and say Ayurveda and all, Bansi is going to promote Ayurveda and Manoj is going to promote Ayurveda, God bless them.
I would just ask her, how much you charge with the patients? Is it a monthly price, bi-monthly, or what charges you
So
have?
the app itself is free for use, which is the basic platform. So if you're just looking for general health and wellness, you can just download the app and start using it. You will be assigned a coaching team. If you want to go for a diabetes management program, it ranges from around 9,000 to 12,000 for 3 months.
For 3 months.
For 3 months.
So my question is that it's more of a app downloading by the patient, and then everything is more physical. You are creating a lot of paraphernalia, support to the patient.
Yes.
So don't you think scaling of such solution will be difficult?
Your CGM cost is included in the 9,000?
Yes, it is.
So
we provide one
CGM.
one CGM for the 3-month program.
So there are a lot of hidden costs in this.
Yes, because like sir rightly mentioned, there is a coaching team that is dedicated to every user.
And you
There
are
tech
every
costs.
3 months.
So it's a
What type of funding are you looking at? Because you didn't give us any financials. So you look to be very well funded.
Make your pitch, Team Smithfit, make your pitch. What do you want from the Sharks here?
Manoj, you're not allowed to speak. You have a vested
I'm just in the interest of time. I realize that I'm a mentor on that.
Farita has a question. You had a question.
No, you can answer.
Sure. So we are looking for strategic partnerships as well as funding. So we would love to take that offline. And we are funded. We are pre-Series A funded company. So we would love to take this to the next round.
Smithfit, as a mentor, let me tell you in the slides, somewhere when Shashank pointed out Ayurvedic medicine, in the same slide you also had glucometers written, which is actually a brand. It should be glucose meters. This is for everybody here. The word is glucose meter and not a glucometer. Any Sharks interested?
So,
yes.
I am conflicted, so I'll stay away, but happy to exchange tips.
Definitely.
Yeah. I was about to say the same thing. We are investors in B2 and Gotham, so for those reasons, I'm out.
Sure.
Yeah. Okay, so I had 2 questions. You used the words nudges. Yeah, so what do you all use? Do you all use a science, behavior economics to kind of nudge the patients, or it is just kind of sending, you have not done this, so you kind of, WhatsApp messages or something kind of?
It is a combination of both, depend on the type of journey we are looking at. So there are certain static nudges that go generally to the entire population. And wherever a person is on a structured program, we have a highly structured 90-day program for diabetes management. So according to the kind of inputs that they are giving on the app, they are nudged in the right direction.
And why do you think one of us should invest in your venture when there are so many others available?
You're definitely right. There are a few people on this dais as well who are in the same space. It's just that this is a category creation exercise at the moment. You know, sky is the limit. So there's a lot that can be done. Also, I think the approach that we are taking in terms of approaching multiple channels.
That's what it is.
One question.
Any shark interested?
How
Yes, sir.
many download up to today?
We have more than 5,000 users till.
5,000. How much active?
Sorry?
How many are active?
Active. How much active?
Our monthly active users are around 1,000 users per month.
And are you generating revenue by online selling and everything?
Definitely, yes.
How much revenue?
So that I think we would like to
discuss
offline.
Okay.
Yeah.
Is anybody interested? Half handshake. This thing. Anybody here?
No,
None
I
of the
just
sharks.
want to, I just want to, I just
Okay,
want
you
to
have a
inquire.
handshake. Come on.
Okay. Right. Moment you said offline revenue, Sahib samjhi gaya. Right. Offline revenue. We'll discuss that. Right. So done. Okay. Here. This is. It's coming here. The next one. You all have to pick up. Yeah. Please. Anybody? Please. Yeah. Please.
So well done. You've got a handshake. Who's the next?
Thank you. Thank you. And the next one, Daya Happy.
Daya Happy. So we have Daya Happy
Going
coming
well
up. Your slides up.
Hi, good evening everyone, and my name is Anurag and I am the founder of Daya Happy Health. Should we connect? The whole objective behind Daya Happy Health is to help people move towards reversal. The story is, it was me and my family who were diagnosed with diabetes type 2. We moved towards remission and reversal, and that is what has inspired me to start this company. Along with that, I have Dr. Kaumudi who has joined us as a co-founder to help us in this vision, plus Dr. Banshi Sabu who has always supported us from the very beginning, even before we had anything in our hand. We all understand the magnanimity of diabetes. It's a very, very big problem. And the very basic premise that we are holding on is that the current setup, infrastructure setup, because of doctor-patient ratios, the food habits that people have, and the kind of challenges that we have, this problem is constantly growing and moving way ahead. We don't want to move to a level where this 80 million becomes 150 million. And if we really want, and if we reach to that level, the country will not be in a very good state, and we don't ever envisage that to happen. What is the solution? It's pretty simple. Help people prevent from being diabetic, A, or reverse people from, if they have already been detected from diabetes. We already have some research published regarding reversal where people have talked about reducing the carbohydrates to in the range of 55%, which is pretty tough, especially in the Indian dietary regime. If we do a very simple maths of the way the Indians are eating and the way we are very dependent on our staples, we'll be very easily hitting 65 to 75% of carbohydrates. And it's very, very difficult to solve this problem. We all love, and India is a very geographically motivated country. Every region has their own staples, and it's very tough to solve. We have been trying to solve it in a very simple way. We've got two kinds of business models. One, where we have developed a range of products called as Adore Health as a brand, where our products are a point-to-point replacement to the high carbohydrate products that typically we Indians eat, where we are reducing the carbohydrates in the range of close to 30 to 80% depending on which product we are dealing with. These products we are trying to work with doctors, complement the care that they are already giving in their clinics. We are seeing a lot of work that is being moved in reducing the carbohydrates. Either we or some other company will do. We, with the help of sharks or somebody who could push us in that direction, to be that company who will be inside working with the doctors to complement them. There's another model of ours which we are starting tomorrow, where we would be working directly with the patients using our own clinic setup. It will be a physical setup, plus also a remote smart kind of program where we'll be helping people move towards reversal with a very clear focus towards dietary and lifestyle modifications. We envisage to start around 100 clinics in next 5 to 7 years. Tomorrow, we are inaugurating our first clinic. We had done a small observational trial which we had published in JOD. We almost reached, the trial was very focused towards dietary carbohydrate reduction. We achieved almost 82% patients who came in the non-diabetic range of 6.7, 2.34 HbA1c drops in 3 months period. The weight loss was average 9 kgs. Triglycerides improved. We also saw improvement in GGTB. It was a multi-centered trial which we had published in JOD. This is just a small journey with some small feedback and the way people are improved their health. We are competing in a very, very competitive space. We have tried to work with doctors. It's a very, very tough way to really sell products inside a clinic. We are a very small company, and that's where we seek a very strong strategic help here with some sharks. We are competing with medicines. We are also competing with some mega companies. Day-2 is obviously one of them who is having their own care program. And we are trying to move in that journey. This is absolutely thank you. And I'm open to any questions that is coming from the floor.
So in the interest of time, I'm interested in your food.
Yeah, we've got
brands.
range of products in the form of atta.
Yeah, so we can meet up
Happy to
and
connect and share the products.
The space is really very interesting.
Yes, sir.
Now the question is how you maintain the patient motivation, because that's the missing link. There are many products in the world and the globe, is the world and in the India, but the patient motivation is the
200% agree, sir. The problem with India, the way we realized, it's the love of plate structure and the love of geography in which they are. And if we really replace their problems, like the high carbohydrate stuff, with products which are almost similar in taste and texture, because we love our taste, we love our texture. You're a khakra eater. You can't leave your khakra. But if you give your khakra, which is almost 60% less in carbohydrates, 4x of protein and 4x of fiber, you may eat it if you like the taste of it.
And the cost of the product is as
No. The cost obviously goes up by close to 3x to 7x depending on what the product is.
3x to 7x.
But if you look at the monthly expense of how much you're increasing, that ranges between 500 to 1200 on an average.
And then what is the gross margin which you have?
As of now, it's pretty high. We would love to bring it down. We work in the range of 80 to 50% gross margin range, depending on the product.
How much?
50 to 80%, depending on the product that we have.
I would love to
No, we want to improve our economies of scale. We feel we can bring the MRPs down, what you are saying. As of now, obviously the procurement, the way we are doing our raw material procurement, because of which we have our MRPs higher. We want to bring the MRPs down, plus we also bring the cost, our own cost down, which would obviously keep the margins intact.
So I would love to know the science behind all this, because you have done some science work.
Yes, sir.
And secondly, in that science program in which you publish a paper, were your food solutions also
Yes,
there?
sir, we were actually.
And that food solution is a partner, or is it your own?
We manufacture our products, and the science was focused. The paper has been mentioned that we have used a replacement.
So it's a proprietary.
It's our proprietary product.
So it's like it's a proprietary food solution with a management program supported by tech. Is that what you're saying?
Yes, something similar, but very honestly, sir, food is not something which is patentable. So we can't commit, and being very honest and transparent, it can be re-engineered by a lot of companies.
Fair. And is it keto?
Not really. We have a keto range. We also have a low carbohydrate range.
So that's what I saw there.
Yeah, we have a keto range. There are people who are focusing on that.
Gagan has a question.
Yeah, I have a question. Like, I just saw your presentation and even earlier one also. You're talking about diabetes reversal.
Yes, sir.
But what's the vision you have in your mind? It is just taking the advantage of, because patients are increasing in our country, or there is some vision behind it?
I started it because of my own encounter, and even before these papers published, we started working in 2019. Interesting fact was, we went to doctors and told that carbohydrate reduction karna chahiye. There's a lot of research. Now, thankfully, it is coming from the doctors directly. So the now market is opening, and it is giving us a good opportunity. Maybe for us, somebody bigger, somebody would be doing this.
So as a startup, what vision you have in your mind?
So when I started, मेरा simple सा vision था, I don't want my second generation to become diabetic if I have been detected with diabetes. Now with working with diabetic and the kind of outcomes that we're delivering, that vision has become much, much bigger, where we want to at least reach, we don't want India to move to 150 million diabetic in 2040. We want to stop it to the state that wherever we are right now.
So if I can ask quickly, sorry. Maybe there's a gray zone where at least I don't feel conflicted yet, but choose not to answer if you don't feel like. But the care program that you have, it's based around your food products, so you have a nutritionist and food. So foods are an essential part of that
food would be
care program.
Essential part of it. Food would be essential, but not always the most important pivotal.
Okay. And the reversal clinics, etc., that's something that you're starting now.
Tomorrow we are inaugurating.
So you haven't done that. How much of sales do you have on the food business, and where all do you sell?
We sell through doctors online also.
Are you selling on Amazon or Flipkart?
Yes.
How many units or how much of revenue generation?
Tomorrow morning we can discuss.
So I would be keen to explore that part.
Sure.
Do we have any
last
question?
question.
I think
how many
I would like to explore it further.
Okay,
So
Gagan is
we can
interested
sit
as well.
and discuss about that.
Two handshakes and
later on.
Yeah, we have 9 months to 12 months shelf life.
I have a question. How many physical clinics do you want to set up, and how are you thinking about ROCEs in a physical setup? It will take years to scale up,
So
right?
it's very absolutely right question, and we thought of starting an online program similar to what a lot of players are playing. But we started talking to a lot of customers of their own, of a lot of competitors who are there, and one of the biggest factor that is missing is building that trust. See, so not everybody is tech savvy, and yes, scalability with technology is there.
We have 3 handshakes, boss.
आप भी करेंगे अभी. And so the trust factor that a online or the physical setup brings, an online setup really finds it very tough to.
How many centers do you think are required? Like, what's your business vision, right? As
Yeah, we would be. So I want to have a 500 clinic setup chain.
Okay, on that note, we'll close that. Let's have the handshakes. Well done.
Okay, great job. So,
Great job.
a lot of sharks making
Correct.
Anurag from Daya happy
Anurag.
tonight, right? Anybody else wanted to have a handshake? No, right? So we have Farida's there, right? So,
So I think he should have, well done.
excellent. So how many of you doctors sitting here this evening are also thinking about becoming entrepreneurs? Having a startup?
Open.
Some more hands, come on, this should be inspiring. What are
Open
you doing
matrix,
day in
please
and day
come on
out in the
stage.
same clinic? Okay, so getting money is not so difficult. Bansi will make sure that there are investors around you, right?
Sir, you said that startups can give doctors some lessons as well. Can we charge them for it or?
No,
Doctors don't
doctors
pay.
don't give money.
The take-home message from this evening is
Doctors don't
doctors
give money.
don't pay. Please remember that. Right?
I think Anurag should have put a slide size of his previous size and now size when he is used this. Over to the next.
So this is open mid-air, right?
So, good evening, everyone. My name is Deval Karya. I'm from the Indian Institute of Science, Bangalore. And we are a bit early stage than what you've seen so far, but nevertheless, we feel what we have to offer is something promising. So I am the co-founder of OpenMedDev, and what we are offering is the InsuFlow pump, which is an affordable insulin pump for type 1 diabetic patients in resource-constrained settings. My professor, Dr. Manish Arora, and I are the co-founders of the project. And our team is small yet well-rounded. We have an electronics lead and a regulatory affairs lead, and we're looking to expand that further. We've set up partnerships with small MSME manufacturers to help us scale the technological development. Coming to the clinical need aspect, I'll just briefly cover it. Everyone's aware of the burden of type 1 diabetes. And it is a chronic condition which requires patients to be administered insulin throughout their life. And insulin pumps and to the extent insulin pumps plus CGM forming an AP are the gold standard for management of type 1 diabetes. But in countries like India, where cost is a primary withholding factor, this has become a bottleneck. So as per the latest Diabetes Atlas, right now there are 2.3 lakh patients that have been identified in India with type 1 diabetes. I'm sure the number must be much higher than this. And only less than 2% is the penetration in terms of insulin pump adoption. And despite this, the market right now is more than 80 crore rupees. And what we've seen increasingly through a lot of research papers is that a small percentage of type 2 diabetic patients will also be eventually recommended to adopt insulin pumps. Now, coming to what makes our pump different and what makes it novel, most pumps actually work on the syringe pump principle. There's a simple screw and nut that pushes a plunger and you deliver a drug. Now, what happens is the way you push that screw forward, that makes it very expensive. Those are miniature motors. What we tried to do is through our novel mechanism, we made the entire system actuator agnostic. So I can use a 300 rupee toy motor and give you the same accuracy, or I can use a 20,000 rupee high-end medical grade motor and give you the same accuracy. I can go even further and yet guarantee you the same accuracy of delivery. And the other key novel aspect of our device is that we are compatible, or we are working towards making it compatible with the open source artificial pancreas ecosystem. We've followed all industry standard design documentation, quality management systems, risk management systems, and our accuracy results have been recently published in the Journal of Diabetes Science and Technology, and we are at par, if not better, with commercially available devices. These are some photographs of our earlier device prototype. Coming to the pump in numbers, right now our pump cost without the economies of scale is roughly 30,000 rupees. And obviously it may vary a bit once we develop and improve the TRL levels. But compare this to the base level models that Medtronic is now offering, which is 3.6 lakh rupees. and he only includes. So
That's the new one, 680. What you're talking about is the earlier models.
And the other key advantage that we offer is the compatibility with the open source existing artificial pancreas ecosystem.
They will all believers here in the pump therapy. So I think that part of it done. Let's make your pitch. What do you really look forward?
Yes, sir. So looking at the competitive landscape right now, Medtronic is the only player in the market. It's a monopoly. And even in the Western markets, despite a lot of options being there, the high cost of a pump is one of the major withholding factors to adoption. And we see tremendous market potential at this moment in India because of increasing awareness, rising number of patients, and lack of options being the primary drivers. So coming to our business model, at the moment, the novel mechanism that we have, we intend to license parts of it for use in other geographies where we are not interested in jumping in. But for the Indian market, we wish to work with the larger players and take the device to market with them. We also intend to make parts of a device, top-level device data open source so that the open source community can test, iterate, and point out flaws in the device. And this mechanism that we've developed also helps us bring in other drug delivery systems that can have applications in other clinical areas.
I think time.
Right, so last slide. So at this point, I just want to reiterate the clinical need we are trying to solve, which is to ensure that treatment that is needed for the patients is not withheld because of costs.
So I think.
Deval, congratulations. I think I follow you very closely.
Thank you, sir.
I also sit on the board of directors of IDF, and IDF would like to support you.
Thank you so much.
So I would push your case in Brussels to get you boarded because I hate monopoly. The cost of pump is completely prohibitive for mass people, and unfortunately, India has become the type 1 diabetes capital of the world. And the numbers are exploding exponentially. It's not just diagnosis, it's actually the de novo disease going up here. And there are 7-8 geographies, if you see the IDF Atlas, and the new one is just going to come out now.
Yes, sir.
This is something which, personally, as well as at IDF, I would be happy to partner and pitch with you.
Absolutely.
And I would like to get you more entrepreneurs involved because type 1 diabetes is an unmet need.
Yes.
And I think this cost-breaking thing is, we are very proud of your work. Get it validated. Whatever help you need, we are willing to work for you pro bono.
Brilliant product, let me appreciate this product, your brilliant product.
Thank you so much.
Only have one question.
Yes, sir.
Is the design patent you have?
It's a patent, yes. So it is currently with our institute because it was my master's thesis project. So yes, but we have patents filed for all our inventions.
And then roughly, can you tell me about your gross margin per pump?
So I don't have estimates of how much it will cost to manufacture it, but the number I'm quoting of 30,000 rupees INR of BOM is without economies of scale. So we expect that to be even more optimized.
See, you seemingly have a winner. Now, do you really need to express your interest or intention on a platform? I'm sure
really need the
there are
money
so
is what
many
he's
there are so many big players in the pharma industry. I'm sure many of them would directly like to work with you and participate. You don't need this. It's a big ticket item you have.
But have you ever done a clinical trial? Tested the device in human beings?
No, sir, not yet. So to give you a brief idea of the timeline, so far we have tested only in lab as per all IEC testing standards, and we found that results to be accurate. We have an animal trial planned very soon.
Yeah, why I'm asking you is
Yes,
among
sir.
all the medical devices used by patients, insulin pumps are resulting in maximum number of deaths due to errors.
Yes.
So we need to test and make sure that this is safe.
Absolutely, sir.
Because many people have innovated and they have failed in insulin pumps. So the first thing you have to do is you have to test it in animals and then in humans.
Yes, absolutely.
Yeah.
So we are
Very
going with
essential.
all.
Devan, I think you have a wonderful product. Congratulations to
Thank
you.
you, sir.
So we would like to work with you on this.
Sure. Thank you so much.
Excellent. Okay. So we have the shark. What we would also like to announce is...
So many of you are interested to work with him. I know it is the doctors, industrialists, pharma industry people, and he has really a unique product. But one thing I would like to... oh yes, from many of them from audience also. That's great. So big round of applause for Deval. One thing I would like to hear announced from Diacare. Every year there is a advanced technology and therapeutics meeting, a TTD meeting at Europe. This year it is at Berlin, and he wants to go, and from Diacare we will support his travel grant and his stay for ATTD. So that's what we can do, as he has to show Indian products at an international platform, and that is what we wish for, and we want him to go in Europe, and we from Diabetes Technology, everybody of us would like to also be partner with him.
D-Tech as an organization is also announcing support for Deval's product, and we would invest as well
We
as
will
we move
invest
ahead.
as well.
Right? Okay. Thank you. Wonderful. So everybody is excited. The sharks are excited.
Let's bring
Are
on
the-
7 Sugar on stage, please. 7 Sugar, come on stage.
Are the sharks hungry for the startups of our food? I think we have 2 more to go.
मनोज, ये इससे पहले अनुराग ने तो मेरा बैंक बैलेंस खत्म कर दिया यार। मैं बोला डॉक्टर से नहीं लेंगे, दोनों ने ले लिया। चल 7 Sugar.
Good evening, everybody. Thank you for giving me this opportunity here. 7 Sugar is about completely diabetes management solution. And this has come through after several of your colleagues who have spent time using our platform, helping us become better and better with several iterations. So my title is, empowering doctors to deliver superior clinical outcomes. And this becomes important, when you're doing at scale. Next slide. How do we move to the next slide? Okay. Here is the team. I'm the co-founder. Dr. Abhijit Bograj is another co-founder. Then we have Satish, who's our CTO. The problem we're addressing, is well captured, by a LinkedIn post by the doctor, right? Compliance is the key. And it doesn't matter what kind of advanced medication we throw, unless, there is compliance from terms of diet, physical activity, medication, the outcomes are not going to be better. And that's the problem we are trying to solve. Basically trying to assist the doctor to improve patient compliance and also regularize patient engagement and build long-term relationships. And this is something that we have gotten, based on our interactions with the doctor, many times, during discussions. And we want to do all of this without extra burden of time because, we want to make sure that the doctor spends only 4 minutes with his consultation time. This is the platform that we have built. The platform captures all the necessary parameters that are important for treating diabetes, which includes your, the food, your lifestyle parameters, your medication, as well as your vitals. And there's a lot of analytics that we do, and we share a report that goes to the team of doctors, caregivers, which will say a doctor, a dietitian, could be a nurse, could be a diabetes educator. And we are able to provide a coordinated care because if the dietitian is making changes to the diet plan, the doctor is also aware of it at the same time. And the report goes to all of them, and they're able to deliver better care because the report identifies, what are the interventions that have to be made. If the fiber content is low, or if the physical activity is not there, what are the things they have to suggest and advise to the patient. And here is what we envision, there is a consultation that happens at the doctor clinic, and then we provide post-consultation advice to the patient what he has to do, and then before he goes to the next appointment, again we try to help him out so that when he meets the doctor, there is a very nice report that talks about his lifestyle related data in addition to just the lab related data. Lab related data will give you HbA1c, other types of parameters. We also want to give a lifestyle report along with that. The two combined, we believe, is a very powerful tool to address care, address interventions. So some of the things that we have done unique, we can analyze macronutrients just from a simple photo. Patients take a photo of their meal and we analyze everything from the back end for macronutrients and calories. It's very highly customizable because a lot of our doctors see type 1 diabetes patients, type 2. They see gestational diabetes patients. They see patients who are going to surgery. They see PCOS. They see obesity-related patients. So we have a platform that actually tailors to all of these needs. We also have done integrated chat within the platform so that this chat can happen in a very secure environment, and the chat can be priced by the doctor if he wants to bill the patient for reaching out to him on during off hours. And there's complete privacy. There's no leakage of data to any third party, so that's another guarantee that we provide. So we can do protocol. As I said, it personalizes to doctor practice. And the thing is that you can run this on the cloud or you can run it on your server that's sitting in your office. So the entire platform, along with all the features, is available to the doctors. Our impact so far, we have seen about 1.7% reduction in A1C over 3 months. Many thousands of patients have been served. We have had more than 250,000 meals posted on our platform, so we really understand what kind of food that diabetes eats and how to analyze, how to coach them. And so
Adi, great product. Would you want to get to your pitch and what do you really want from the sharks?
Yeah. I just want to talk about only one point here. We have addressed all of these issues. For gestational diabetes, we just launched a product on WhatsApp to manage gestational diabetes patients. We have actually managed the treatment compliance on WhatsApp, and this has been picked up by WhatsApp incubation team to help us out to scale this. So I just want to make that announcement here. I'm looking to get help from doctors to adopt this platform and also get investment from both doctors and investors.
Have you done any science on the team?
Yes.
Have you done any science on the gestational diabetes product?
We have onboarded 30 patients and we have seen better compliance, and 2 of our patients have actually delivered. So the interaction happens almost on the mic so that. So the interaction happens almost on a daily basis. They're posting meal photos, they're posting their glucose levels, and we are analyzing if they're in range or not. And then whenever possible, we provide diabetes educator advice on WhatsApp to tell them what changes they have to do.
Any questions?
But I got, have you done any science on it? This is what you're saying is what you have done is on 30 patients you have done and tried it out. Have you done any original science on this?
It would have been done by the doctors, because we just brought the platform in doctors.
Do you have any
Not
evidence
yet,
for your product yet?
not
Okay,
yet.
that's what Dr. Shashank
Not
is
yet.
asking. Sharks, any interest?
Any
questions?
Yeah, okay.
To handshake with him for the GDM product.
Okay.
ICMR, NIN.
Yes, NIN, yes.
It is validated.
Yes, well, we use NIN data for estimating calories for the gestational diabetes mother. What is the calories that she needs?
Some
Yes.
people are already doing this thing.
Okay, could be, it could be one of them.
Okay.
Any other?
Yes, go
For
for
your nutritional tracking, do you take the pictures and is it is there a diabetes educator sitting at the back or is it NLP or what do you use?
Both. There's an AI that identifies the carbs and the protein. It identifies the main items, carb items.
Only for a specific food because Indian plate is quite complex.
Yeah. So we identify 3 or 4 things, and then the diabetes educator picks up rest and then analyzes the rest. So it's done partly. For example, we can identify varieties of rice. That doesn't matter. But then diabetes educator confirms it, and then the calories estimation happens right away.
I think there are some parts where we have significant overlap with you.
Yeah.
But definitely on this nutrition part, if you feel that we can collaborate, then
Definitely, we are open
keen.
to have. In fact, a lot of other.
See, I'm prompted to ask this question by the esteemed doctor sitting next to me. See, I'm a diabetic. I know. If I eat an omelette in the morning, my blood sugar after 2 hours is 130, 145.
Correct.
I eat 3 idlis, it goes to 190. I
That's
eat 2
right.
vada pavs, it becomes 240.
That's right.
So I know it. I mean, why do I need such PhD level, analysis
Sir,
of
sir,
micro data analytics?
Sir,
I
not all
know it.
patients are not like you, sir. A lot of our patients, generally do not know, what causes diabetes. They think,
No, but these doctors will tell him. No, from where did I know? I don't consider myself
sir,
to be highly
I'll tell you,
evolved
sir.
or educated. It's just pure common sense.
Agreed
But
very
you know
much.
what it is.
Agreed very much. When they say, doctor, sir, I only eat so much of rice. What they eat rice, when you see the photo, is very different from what they tell the doctor. They don't understand what is portion size. So that's where we come in to educate, a cup of rice is so much. So we have the portion size.
Educating people is not easy. That's why
No,
I use
well,
the word.
that's reason
it is
photo-
not motivation, exhortation. And if you know the meaning of
I
exhortation.
think that's some great round of questioning. Let's hear it for the
Yeah.
team here.
Just
Yes.
Farida has a question.
Farida has a question.
How many patients have you enrolled?
About 4,000, 5,000, more than 5,000 patients have gone through the program.
And they go for a limited period of time?
Correct. Correct.
So
They
about
go-
3 months.
Yeah,
So
3
I would
months.
love to, interact and see how we
Please.
can take it.
Okay, great. So 2 sharks are ready for
Yes, CGM is integrated into the data report.
handshake
yes.
with Adi and so Dr. Shashank Joshi, Gautam and Ms. Farida Hussain. All 3 would like to have a handshake with Adi. Jyoti, you want to put in some money? No? Right? Excellent. Many congratulations. Right? May we invite MedTel, the final startup for the evening.
Okay, we have the last contestant up here.
The team from MedTel.
Team from Hetel.
Okay, good.
So they're coming here, they're going to
Right,
make
so
a pitch.
By the time Team MedTel is coming, friends, all of you who stayed back till late this evening, let's hear it for all of you in the audience who really sat back and encouraged all these startups. So a big round of applause for all in the audience. And of course, for the sharks who've been hungry the entire evening, but biting a bit and having some grilled fish at times. So over to the last contestant there.
Thank you. We are Team MedTel. Metal was started in 2017-18 by 3 doctors and 1 techie. So I, Dr. Soumyakant and Dr. Lalit and Dr. Timiresh and Ajit run the company. We are a remote patient monitoring and population screening company. We'll start with half of our pitch for 2 to 3 minutes will be a video, and the next 2 minutes would be our pitch. Can we have the video, please? Yeah, thank you. We connect 60 plus IoT device to our proprietary platform. You will find 60 plus parameters on one single solution. It picks data automatically from point of care IoT devices. We are disease agnostic, but mostly work in NCD, diabetes, hypertension, and cardiovascular disease screening and patient monitoring. Patient can be registered, and the moment any test is done, system captures the data. We are connected with US FDA, European CE and CDSCO certified devices. And we want to build a galaxy of connected devices, sensors, wearables. Devices will come and go. What we do is data collected and building health analytics on it. Longitudinal data patient monitoring, which helps the patient, doctor to get all coordinated data on the go, and analytics run on it. So it helps gestational diabetes, COVID patients with comorbidities, and hypertension and severity. Yeah, over to our pitch.
Metal?
He still has a pitch to make.
Okay,
Of course. It's not now.
Yeah, so I will keep it very short and we'll provide a synopsis. What problems we are solving? First, we are solving chronic disease monitoring, basically diabetes, hypertension, and cardiovascular diseases. We have connected a lot of the best of the IoT devices that are from the manufacturers. We don't make devices. We connect the devices because we believe devices, sensors, wearables will come and go. We will keep connecting wearables, sensors, and devices in the IoT space to our platform. Our platform will collect data from all these devices automatically. Not only it will collect and give you descriptive analytics, we are building a predictive analytics and digital therapeutics on it. And it's what we are solving the problem of non-operability, and we are providing a seamless, we provide a data which can be assessed by the doctor, patient, and patient attendant, or the policymaker in a very data protected manner. So you see the IoT kit. What we build is a connected care platform and health analytics. So it's the entire smart health monitoring and telediagnostic and digital therapeutics. You have a tele platform in it. We sell it into one-to-many, one-to-one. One-to-many is, it's a proper B2B where we sell to doctors, polyclinic, insurance companies, and pharma companies. Also now we are into bigger government projects through our partners. One-to-one, we are entering into home monitoring. Next. Next slide, please.
You can do your slides from here.
Okay, market opportunity we all know. I will focus on the revenue. Devices, we basically trade and charge a 10 to 15% on that.
Please wrap up in 30 seconds.
Yes. Our revenue is the software. We give it in a SaaS, 85% margin. Also, there are consumables used by devices. That's a huge market for us. All devices, as I told, we are now getting into home monitoring through Alexa or a hub-like device. Next. Yeah. So these are the numbers of our traction. Last year, our GMV was 2.5 CR. This year, we have a pipeline of 20 CR. we have 40 B2B
to wrap up.
clients.
Right. Atal, make your pitch. I think you've
Have
already
your
shown
pitch,
your
it's
product.
already
Yes.
sort
We
of
go over
done.
to the sharks.
Let the sharks ask the
So this
question.
is your last opportunity. Any of you empty basket yet? This is your last
We are
chance.
raising our pre-series A of 10 million from this month. We already have a soft promise of 3 to 4 million from health VCs and VCs in general, but we would want strategic investment from the dignified people sitting here, and we want
They're
to...
called sharks.
Okay, sharks. Okay, question.
So I think it's a wonderful platform and device what you are creating. We being at Medisage, we are for the doctors, by the doctors, and we already have more than 1 lakh doctor on our app, and almost 7 lakh doctors being served by us over a period of 2 years. So what are the possibilities in terms of, getting this all doctor who has downloaded a Medisage app? Can it be integrated B2B, and thus doctor can see all the reports of the patient on the app?
Yes, they can. And another reason is Anurag is I am Lucknow alumni, so we together can make it big.
Okay.
Yes, we can do. We provide white label customized device platform as well as the kits. So these are our patient diabetic kit made for one. These are the doctor kits. Platform entirely white label customized as per the client. If it's a pharma company, it's a different thing. If it's a poly